Doctors, we are live.
Okay. Good morning, everyone. Now, may I request Dr. Durgesh to start the proceeding? Hello, Dr. Durgesh. Dr. Durgesh, unmute yourself otherwise. Dheeraj, am I audible?
Good morning. We'll be starting free paper sessions on BOA and Maharashtra Ophthalmic Association on behalf of it. Today we have esteemed judges, Dr. Dheeraj Balvi sir, Dr. Ashok Madan sir, and Dr. Smita Singh ma'am. So with the permission of the judges, we'll start this session. Okay.
Yes. Go ahead.
So we have first speaker, Dr. Rutvi Parmar Singh. Is she ready? Rutvi ma'am.
Yes.
Dr. Durgesh, are there any rules framed?
We have first speaker, Dr. Rutvi Parmar. Ma'am. Ready?
No, time bound. What is how much
Sir,
time?
we have allotted time of 6 minutes plus 2 minutes.
Okay, 6 plus 2.
Sir, 6 minutes plus 2 minutes max.
Okay, right. Go to slideshow.
Good morning, everyone. Am I audible?
Yes, go ahead.
Okay. Good morning, everyone. I am Dr. Rutvi Parmar from the MNJ Institute of the Ophthalmology, Ahmedabad, and I'm going to present a study of posterior segment intraocular foreign body at Tertiary Eye Care Center. It's not working.
Dr. Parmar, go to slideshow. You are not on slideshow. In the bottom. Again, start sharing the screen and go to slideshow. Go to slideshow now.
Yes, but sir.
Go to slideshow, it will start. नीचे में है ना मैडम, बॉटम में? हाँ, राइट साइड में.
So there is.
Right side, check your pointer. It's there on the lower side, the third icon.
हाँ, वहाँ करके देखो.
वो कंप्यूटर जैसा जो बना हुआ है ना, that is slide show
No,
start.
no, ma'am, there is no.
In the bottom, there's a yellow icon. Bottom.
Yes.
Try clicking on from the beginning at the top left.
Yes, yes. Hmm. inaudible करिए. नीचे नीचे तुम्हें
I think you can start presenting, even you can manually move your slides. Slideshow from beginning, ये जो दिख रहा है ना, you can start. Just below the Microsoft icon. Yes, from beginning. Yeah, left side. Yeah, start. Yes, that's good. Now you can start speaking.
Good. Good morning, everyone.
I'll just request everyone to unmute yourselves except for Dr. Rutvi.
Good morning, everyone. Am I audible clearly?
You are audible, but lot of disturbance is coming.
Ma'am, I think she's logged in from 2 devices. That's why there's so much sound.
Rutvi, please log out from one device. Just only the device which you are using, please keep that. Otherwise, we can hear only echo.
Hello, good morning, ma'am. Am I audible?
Yeah, you're
Good
audible.
morning. Yeah, please continue.
Sorry for the disturbances, all this. Myself, Dr. Rutvi Parmar from the MNJ Institute of Ophthalmology, Ahmedabad, and I'm going to present a study of posterior segment intraocular foreign body at Tertiary Eye Care Center. Introduction. Ocular trauma is an important cause of the blindness and ocular morbidity in young working population. According to the Birmingham Eye Trauma Treatment System, penetrating injury are the mostly associated with the intraocular foreign bodies. Intraocular foreign body mostly account approximately 1/3 of the open globe injury and mostly involve posterior segment. In developing country like the India, where the young population is the main source of the economy for the families, they may get injured while they're working. Most of them work without the personal protective equipment. So this is a serious problem that affects the socio-economy of the country. Purpose. The aim of our study was to describe the epidemiology, visual outcome, prognostic factor of the posterior segment intraocular foreign body injuries in a tertiary eye care center of the Western India. Materials and methods. The hospital-based retrospective study was carried out on 11 eyes of the 11 patients attending a tertiary eye care center from January 2020 to the December 2020. Data collected were age, gender, laterality of the patient, use of personal protective equipment, characteristics of the intraocular foreign body, day of presentation after injury, visual acuity, intraocular pressure, street lamp examination, fundus examination was done, and imaging like X-ray, CT scan, B-scan, ultrasonography were also noted. Post-operative visual acuity and post-operative complications were also noted. Ethical clearance and informed consent of the patient obtained. Result. All patients were male and all were injured by the working without personal protective equipment. According to the age distribution, most of them range between 20 to the 40 year and mean age was 27 year. Right eye affected in the 36% cases, where the left eye in the 64% cases. Mean duration of the presentation was 11 days. Considering the characteristics of the intraocular foreign body, shape of intraocular foreign body was irregular in most of the 73% cases, while the sharp in 18% and round in 9% cases. Size of the intraocular foreign body varied from 2 mm to 5.3 mm by measuring the largest diameter of the intraocular foreign body. Location, mostly 55% in the vitreous, while the 36% in the retina and 9% in the sclera. It was 91% in metallic and 9% stone. Penetrating site of the intraocular foreign body through the cornea in mostly 64% cases, and sclera 27% and corneal sclera in 9%. Preoperative localization was done by X-ray in 63% cases. Mostly posterior ocular intraocular foreign body injuries associated with 73% cases with the vitreous hemorrhage, while other hyphema, iris injury, lens injury, and retinal injuries were also seen. Preoperative vision of the affected eye range from only perception of the light to the 6/36 and postoperative range from perception of the light to 6/80 on the Snell's visual acuity chart. Here we can see that preoperative visual acuity less than counting finger near face in more than 50% cases, while more than 6/60 visual acuity gain after the intraocular foreign body removal in more than 50% cases. Intraocular foreign body removal was done in each patient with pars plana vitrectomy. Post-operative complications, traumatic attack was developed in 55% of the cases and vitreous hemorrhage in 80% cases. Retinal detachment in 27% cases, which was the largest single cause of the blindness, while the other complications like subretinal fibrosis, macular scarring also developed. This is the fundus photo of one of the patient. At the time of the presentation, there was a metallic foreign body nasally to the disc with subretinal fibrosis. After the intraocular foreign body removal with the pars plana vitrectomy, at 1 month and 2 months, there was a subretinal fibrosis with surrounding laser marks were present. Discussion. Penetrating ocular injury with intraocular foreign body result in a severe visual loss. Several reports describe the management, but there is a limited literature available on the epidemiological aspect. Similar to our study at Hong Kong by the Candice C.H. Liu also shows high male predominance, work-related injuries, only 10.5% had eye protection, and mostly intraocular foreign bodies were metallic. Several tools to remove the intraocular foreign bodies are external and internal magnets and foreign body glue. Pars plana vitrectomy can be the first choice for the patient with IOAB and posterior segment. Experimental studies have confirmed the effectiveness of the pars plana vitrectomy in treatment, especially prevention of the tractional retinal detachment. Size of the intraocular foreign body and intraocular foreign body location closer to the macula, poor the visual outcome. So reattach the detached retina before the macular involvement can salvage the vision. Hemen et al. And Tarek
1 minute left.
also suggests that retinal detachment was the crucial factor for the poor visual outcome. In our study, 40% of the patient with poor visual outcome also had the retinal detachment. Conclusion. In spite of the curfew in the Gujarat during COVID-19 pandemic, penetrating injury with intraocular foreign body result in a visual morbidity, especially in the young working population. This study concludes that larger the size, sharper the shape, pre-existing or secondary retinal detachment, vitreous hemorrhage, poor the prognosis. Education needs to be given to the industrial worker regarding use of the personal protective equipment like the face shield can prevent the lifelong consequences. Emergency treat and early operative management also favor the better visual outcome. These are my references. Thank you for giving me this great opportunity and sorry for the previous disturbance.
Thank you, ma'am. So our next speaker is Dr. Tulika Ghoshal. She can continue. Is she ready?
Yes, I am.
Yes. Sorry, sir. You can start your presentation.
Could the other person, Dr. Rutvi, please stop sharing her PowerPoint?
Dr. Ruthvi, can you please stop sharing?
Thank you.
We have, sir, actually 2 minutes for question and answers. So with the previous speaker, we can have 2 minutes for question and answer sessions.
I just want to ask one question to Dr. Ruthvi.
Yes,
Dr.
ma'am.
Ruthvi there?
Yes, ma'am.
In how many % of cases did you find retinal detachment?
Ma'am, 40% with a poor visual outcome. When out of 11 patients, there are 3 patients after the intraocular foreign body removal. There was a delayed retinal detachment.
And how were they managed?
Ma'am, by the with the repeated vitrectomy.
Okay, and then how long was the follow-up for them?
Ma'am, 3 months maximum. So this is a limitation of my study because some patient maximum at least 3 months follow-up.
Okay, and what was the visual recovery in all those 4 patients which had?
मैम एक्चुअली कुछ ज्यादा विजुअल एक्टिव गेन हुई नहीं है उसमें इवन आफ्टर द रिपीट विट्रेक्टोमी.
What was the visual outcome in all of them? You can name them.
Okay, ma'am, actually within counting finger near face maximum.
Okay. Okay, so the take-home message is that. What is your take-home message then?
That's more than enough.
Thank you. What is your take-home message then? That if you are finding that if retinal detachment occurs and it's such poor prognosis in intraocular foreign body, what will your take-home message be?
First of all, ma'am, educate the people about personal protective equipment because it leads to visual morbidity.
Okay.
And second, mostly early treatment, at least emergency treatment for the primary closure. And second, as early as possible, vitrectomy.
Okay, thank you.
Thank you, ma'am.
Any other questions, sir? Any other questions, sir? We can move to next speaker then.
Yeah, please go ahead with the next speaker.
Yes, sir.
Good morning. I would like to thank the BOAMO Summer Focus Virtual Symposium for this opportunity. I am Dr. Tulika Ghoshal and my topic is Unmasking the Maze of Neuro-Ophthalmology for Optometry Students. I have no financial interests. Neuro-ophthalmology is a challenging topic to teach optometry students. For teachers finding a simpler way to explain complex conditions like supranuclear gaze palsies was an extremely uphill task. While teaching neuro-ophthalmology, they complained, "These topics are so difficult to understand, ma'am," was a common refrain. My students were crying out for help. I had to try something. The purpose of this study was to see if a novel technique of teaching supranuclear gaze palsies, SGPs, especially horizontal gaze palsies, with simple flow diagrams improve learning in optometry students. Materials and methods: design a single center retrospective study. SGPs was taught to the students in the standard way from the textbook and a written test taken. SGPs was again taught by the same tutor to the same group with the additional aid of some simple flow diagrams and a written test taken. The data was then reviewed and assessed. According to the standard method of teaching, horizontal gaze palsy occurs due to the lesion of the horizontal gaze center in the PPRF, which causes ipsilateral horizontal gaze palsy with an inability to look in the direction of lesion. However, in the novel method of teaching, supranuclear control of ocular motility looks much easier and becomes more interesting with the aid of simple diagrams. For example, in horizontal gaze palsy, a lesion of the PPRF causes ipsilateral horizontal gaze palsy with an inability to look in the direction of the lesion. According to the standard method of teaching, a lesion in the medial longitudinal fasciculus, or MLF, causes internuclear ophthalmoplegia, INO. The eyes are straight in primary position, defective adduction of the eye on the side of the lesion with nystagmus of the contralateral eye on abduction. Novel method: a lesion of the MLF causes it to malfunction, so the ipsilateral third nerve nucleus also malfunctions, causing defective ipsilateral adduction, and the contralateral sixth nerve nucleus is also affected, which causes defective contralateral abduction. Results: simple mean comparisons on the average test scores in the two exam treatment conditions were conducted. A one-tailed t-test revealed that these students scored significantly higher in their exam after the novel teaching. The p-value is much lower than 0.01, indicating that the results are significant at 99%. This study in optometry students shows a statistical superiority of using a novel method of teaching, horizontal gaze palsies, over a standard didactic method where p is less than 0.001. Students also mentioned a subjective improvement in understanding the topic taught after the novel method of teaching. They could independently work out the clinical deficits in different gaze center lesions from the diagrams without resorting to rote learning. Discussion: this study compared two teaching methods, the standard didactic method and a modified novel method for teaching horizontal gaze palsies in neuro-ophthalmology to optometry students. Despite studies on new teaching strategies, practical methods to improve the teaching experience are not common. Teachers need specific and practical methods to help them improve their teaching. Novel ways of teaching are now coming to the forefront. Educators introducing new teaching methodology must evaluate the outcomes of these experiences. Study limitation: improvement in test scores may be due to reinforcement of teaching. However, feedback of subjective improvement suggests otherwise. Visual learning is one of 5 main types of learning styles according to the VARC module: visual, auditory, reading, writing, kinesthetic, and multimodal. Advantages of visual aids: they help store information longer, make communication quicker and simpler, partially by removing language barriers, aid better comprehension, act as stimulators for emotions, drive motivation, unsuitable visuals equals unhappy learners. Conclusions on teaching methods. Didactic lectures alone are no longer adequate for training. Simple practical techniques must also be considered and incorporated. Novel practical methods should shorten the learning curve.
You have 1 minute left.
Thank you. My study gives an insight into the fact that the simple novel technique should be used to teach neuro-ophthalmology. It could also be adapted to teach other topics. These are my references. Thank you. Please stay safe.
Thank you, ma'am. Any questions from judges side? Any questions, sir?
I just want to ask one question,
Yes,
Dr.
ma'am.
Tulika.
Yes, ma'am.
You have a very interesting study.
Thank you.
I just wanted to know that when you say traditional teaching, was it classroom face-to-face teaching, or was it what
Yes,
kind of teaching?
it was classroom face-to-face teaching.
And the other one was also face-to-face?
It
Both
was
were
also, yes, it was also face-to-face, but I use these simple flow diagrams along with that, the standard way.
And this was before the pandemic.
This was just before the pandemic, yes.
Do you think that keeping a real life patient or maybe a clinical scenario would also help in this?
Absolutely, ma'am. Absolutely. Practicals are always much better than just theoretical.
So some kind of blended learning can also help here, I think, when you
Yes.
think. Very interesting, and your point was very clearly made. Thank you so much.
Thank you very much, ma'am.
Any other questions, sir, from your side? Okay. We have our next third speaker, Dr. Harshita Sharma. She is not well
Thank you.
today, actually. Yeah, yes, thank you, ma'am. So our next speaker will be Dr. Bhagyashree. Our topic is single point fixation in IOL CTL Max complex. Dr. Bhagyashree Mishram. Ma'am, you can load your slides.
Hello. Hello, am I audible? Hello.
Yeah, yes.
Yeah, you're
You're
audible.
audible. You can load your slides, ma'am.
Yes, yes, sir. Sir, are my slides visible? Hello.
No, it's not
Hello.
visible. No, it's not visible.
It's not visible, sir. Just a second. Hello.
Hello.
Yes, ma'am. Go
Yes,
ahead.
sir. Now are the slides visible?
Yes, ma'am. Go ahead, please.
Okay. Yeah, sorry for the delay.
Just,
Very good morning.
Madam, just wait 1 minute. Dr. Durgesh, this topic is not on this the list which is given to us.
Yes, sir. Yes, sir. As I said earlier, Dr. Harshita Sharma is not well today. So instead of her, we have another speaker.
Achha, no, but the topic is also different.
Yes, sir. Speaker is different, so topic is also different, sir.
Okay.
Sir.
So on
Thank
the I mean to serial number 3rd, this topic is to be considered.
Yes, sir. Yes, sir.
Okay, take.
Very good morning, all. This is Dr. Bhagyashree. I am currently working as a bonded candidate at BMCI Hospital, Mumbai. So my topic is a single point fixation technique in a subluxated IOL back CTR complex. I have no financial interest. So my case history is a 67-year-old male who came with the chief complaints of sudden onset diminution of vision and glare since 1 month. He has a history of left eye cataract surgery done in 2015 with a very good post-op vision. There is no history of trauma. There is systemic illness. He has a history of stroke and interstitial heart disease 3 years back, for which he is getting treated. So on clinical evaluation, left eye vision is finger counting 3 meters. This is annihilated vision. On a pinhole, he is improving to 624 parts. With a best corrected vision is 636 parts with -2 spherical and -5 cylindrical component. Keratometry values were within normal limits. Other eye evaluation was completely normal. So on examination, there is a 7 o'clock to 2 o'clock hours of subluxation of IOL plus capsular tension ring and posterior chamber back complex with the posterior capsule cells, and the superior edge of the IOL CTR back complex was completely visible. Other eye, that was a right eye, has a nuclear sclerosis grade 1 without any zonular weakness, and both eye posterior segment was within normal limits. So our diagnosis was, this was a 5 clock hours of subluxated IOL back CTR complex with an intact posterior capsule. So now what's next? So we have to keep all the options. So what options we had was explantation of IOL plus CTR back complex, and then followed by a suture fixated IOL or a iris claw lens implantation. Or we can try as a 2-point fixation of a IOL with the same IOL CTR back complex in C2 with the creation of a Hoffman pocket, or just prescribe a best corrected visual acuity. So now this many options. So what do I choose? So many options. What's next? So there is always a mentor. So what, she is the one who keeps guiding us, keep coaching us. So she suggested, let's try something different. Let's fix this IOS CTR back complex to a single point with just a 10-0 proline suture and try centralizing it. So can that work? And we can always bury that knot under a scleral tunnel itself without creating any Hoffman pocket. So when you have options in ophthal in a surgical field, you choose all the options available. So 10-0 proline suture, double-ended straight needle was kept ready, 26 gauge needle, cataract instruments, scleral port, trocar, cannula, and infusion. And standby lenses, as we had planned, was iris claw, suture fixated IOL, a 3-piece IOL, vitrectomy, and intravitreal instruments for any complications. So here is a picture of, we started with a conjunctival peritomy, which was done nearly 180 degree. We marked 2 incisions, 2 ports where we were gonna construct our scleral tunnels. And with the help of a crescent blade, we created scleral tunnel, which was hardly 2 mm in measurement. So I have drawn this schematic. So we had passed our 26 gauge bent needle from this scleral pocket, scleral tunnel, which we had created, and 10-0 proline needle was proceeded. And we had passed the same through the IOL back CTR complex. Here, taking into consideration that we have to pass through the eyelet of the haptic. And this way we had centralized the bag in the center, and the knot was tied under the roof of the scleral tunnel, and it was buried inside the scleral tunnel. So here is a video. We are making first the infusion cannula is put and our infusion started. Now here is our scleral pocket which we had created with just a 2 mm crescent blade. That's it. That's the only width of the it is a normal scleral SICS tunnel, and the needle is past 26 gauge, and here is the 10-0 proline which is passed through the haptic eyelet and a back complex, and it is proceeded outside. Then another second pass, the second needle was proceeded through the side port, and here the needle, if you can see, it is above the iris and the back complex, below the iris, above the back complex, and then we have passed the 10-0 needle, proceeded it outside. The plane has to be a single plane, and with the help of a push-pull, we remove the 2 sutures.
We have 1 minute left.
And the push-pull was, with the help of push-pull, we buried the knot inside the same scleral pocket. The scleral, it's not a pocket, it's a tunnel, scleral tunnel. So our results on day 1 post-op IOL with the best corrected vision of 6/9 parts with -1 and -2 cylinder at 114 degrees. And here is a mid-dilated pupil, and he was started on 1% predacetate and nepafinac eye drops. So our take-home message is, instead of an extensive surgery, we successfully a minimally invasive, a conservative approach with a good post-op outcome. Whenever we are planning an IOL fixation, better to do with passing a needle through the aptic eye, as it gives a very good support and a fixation is better and the bag is preserved. To avoid any trauma to the bag, never pass the 26 gauge needle through the haptic bivalve. Always proceed with a 10-0 proline needle only. Instead of a Hoffman pocket, we attempted through a small scleral tunnel and buried the knot under the roof of the tunnel. And very important thing to learn from our experience, be ready with everything. Even after thorough pre-op evaluation, intra-op management can always change. Hence, be ready with all the options and everything. These are my references. Thank you.
Thank you, ma'am. Any questions from judges?
Dr. Mishra, was there any vitreous in front of this IOL subluxated area?
No, sir. That was a very good thing that there was no vitreous prolapse. Posterior hyaloid face was completely in place, sir. There was no vitreous prolapse.
Was it confirmed even after, I mean to say, the putting the IOL in place by putting triamcinolone?
Yes, sir.
But because that was not shown in video.
Yes, sir. Actually, because of the time limit, sir, I have fast forwarded a lot of steps in the video, sir.
Okay, good. Take.
What are the complications you had anticipated?
Either the whole IOL back complex may go into posterior segment, or there can be a vitreous prolapse. Or we will have to, if it is if there was no fibrosis to support at the other end, then we had planned to explant the complete IOL and then do a vitrectomy and then put in secondary IOL.
A very common complication can be bleeding also. Hyphema can occur.
Yes, ma'am. Okay.
That can lead to vitreous hemorrhage.
Yes, ma'am.
Okay. Any other questions, ma'am? Sir? Okay, we have our third speaker, Dr. Gunjan Tomar.
Screen so that I can start sharing.
Yes.
Thank you.
Good morning, all the judges. Good morning, Dr. Durgesh.
Good morning, sir.
Sorry for delay. I was in other hall.
Good morning.
Good morning, ma'am.
Hello.
Dr. Bhagyashri, I think you have to mute your mic. Dr. Bhagyashri. Yeah. Dr. Gunjan, the slides are visible. You can start the presentation now.
Yes, sir. Very good morning to everyone. I'm Gunjan Tomar. I'll be presenting my paper on the topic to study the pattern of ocular mobility in school-going children in Western Uttar Pradesh. Ocular mobility is defined as a spectrum of eye disease which include both visually impairing and non-visually impairing condition experienced by a population. Poor vision in childhood disturbs performance in the school as well as imparts negative influence on the upbringing of children. School children have been affected by numerous eye disorders. Uncorrected refractive errors are one amongst the major reasons responsible for the visual impairment as well as for the eyesight loss. Uncorrected refractive error and vitamin A deficiency are seen as two considerably preventable cause of blindness among younger age group. Other ocular mobilities affecting school-going children include conjunctivitis, trachoma, staph blepharitis, and etc. The control of blindness in children is considered a high priority within the WHO Vision 2020 Right to Sight program. School eye health services is an utmost important part of school health services where children could be screened, aiming evaluation of diseases including refractive errors, squint, myopia, trachoma, etc. In view of the fact which says 30% of blind people in India have lost their vision even before their 20s, it becomes immensely important amongst young population to detect and treat ocular morbidity as well as vision disturbances at its earliest. The initial signs pointing toward visual impairment include pain in the eyes with redness, watering, along with headache. These complaints made by the child at times may get ignored by parents because of their absence of knowledge and awareness, predominantly amongst rural population. The practices aiming to take care of pediatric eye problem must be made to take place at first possible with interventions at all three levels, that is primary, secondary, and tertiary eye care centers. With this thought, our study was aimed at estimating the pattern and frequency of numerous ophthalmic disorders and to obtain inclusive data in primary school children among Western Uttar Pradesh with this motive of preventive blindness and timely detection as well as management of ocular diseases. My aim was to study the pattern of ocular morbidity in school-going children in Western Uttar Pradesh, and objective is to estimate the pattern and frequency of ocular morbidity among urban and rural school children of age 5 to 15 years. The study was cross-sectional observational study conducted in Department of Ophthalmology, Tirthankar Mahavir Medical College, Moradabad, Western Uttar Pradesh. The study was conducted for a period of 1 year from 2018 to 19, and all the school-going children between age group of 5 to 15 years were included. 1,000 students were enrolled, 500 from urban and 500 from rural area. Now, under inclusion criteria, school-going children between the age group of 5 to 15 years of either genders were included, and non-cooperative children in the consent which could not be obtained from the school authorities were excluded. Methodology. Eligible schools were identified in both rural and urban area. Consent were taken from school principal. Team of doctors and optometrists visited the school on the decided date, and the school children were examined under the following points: visual acuity, extraocular movement, anterior segment evaluation, and cover test. Children not improving beyond visual acuity of 6/9 and found to have some ocular disease were referred to higher center. Coming on to the results, age and gender-wise distribution of study population, there were 505 males and 495 females. The study population included 447 subjects from 5 to 10 years and 553 from subjects from 11 to 15 years age group. Among subjects from rural area, there were 50.9% males and 49.1% females belonging to 5 to 10 years of age group, and 52.5% males and 47.5% females belonging to 11 to 15 years of age group. Now, among subjects from urban area, there were 48.9% male and 51.1% females belonging to 5 to 10 years of age group, and 49.5% males and 50.5% female belonging to 11 to 15 years of age group. Coming on to the ocular morbidity among study population, it was reported among 305, that is 30.5% subject, and the incidence of ocular morbidity has been significantly more amongst female as compared to males. Distribution of ocular morbidity among different age group, the incidence of ocular morbidity has been significantly more among 11 to 15 age group as compared to 5 to 10 years of age group. And the incidence of ocular morbidity has been significantly more in the rural as compared to the urban. That is, in the rural is 31.5 and in urban in 29.4. Now, distribution of ocular morbidity according to location and gender. Among subjects from rural school, the prevalence of ocular morbidity was significantly more among females as compared to males. That is 36.2% in females. Now, among subjects from rural schools, the incidence of ocular morbidity was significantly greater in female, that is 31%, as compared to males, which is 27.9%. But the difference was statistically insignificant. Now, distribution of various types of ocular morbidity according to location, refractive error was found among 188, out of which 92 was from rural and 96 from urban, followed by convergence insufficiency among 29, allergic conjunctivitis among 22, blepharitis also among 22, and vitamin A deficiency among 18, followed by bacterial conjunctivitis, and amyloid.
You have 1 minute left.
Yes. Squint and sty among 3 each, chalazion, congenital decrocystitis, foreign body, insect bite, pseudophrygia, and so on. Conclusion, the result of our study suggested that the screening of school-going children for eye problems must be performed regularly, as well as it must be utmost prime works of the school health program for the same. For the same, school teacher must be oriented as well as trained so that they can identify commonest ocular morbidities in the school-going children so as to refer these children for timely management. They must as well convey awareness about eye-related hygiene among the school-going children. By this way, we can minimize the prevalence of preventable factors leading to blindness in school-going children. These are my references. Thank you.
Thank you, ma'am. You can stop sharing your slides.
Yes,
Meanwhile, judges can have questions.
Dr. Tomar, the amblyopia was common in which age group?
Sir, 5 to 15 years. 10 to 15 years, sir, sorry.
That's why I'm asking whether it was really more common in 5 to 10 or 10 to 15.
10 to 15, sir.
Okay. You have not mentioned about the squid basically. Squintosis.
Yes, sir, I have mentioned, sir, in the table.
But ptosis you have not mentioned. You have mentioned the ptosis also?
Yes, sir.
Okay.
Sir, I can start screen sharing again. It was mentioned in the slides.
Okay. No, it's okay. It's okay then.
Sir.
You have not done refraction. Are you aware of certain devices which you can do auto refractometer portable, which you can take for vision screening of the children in the school itself?
Ma'am, what we did was we took the Snellen's chart with us. Ma'am, we didn't take the
What
auto
about the
refractometer.
people? Your age group which you addressed was how much to?
Ma'am, 5 to 15 years, which we divided into 2, 5 to 10, and then 10 to 15 years.
Okay. What about small preschool, that nursery age group? Can you do that? Are you aware of any portable auto refractometers? There are many devices now which have come and which are very efficient, which can pick up squint.
Yes, ma'am.
Which can pick up amblyopia, which can give you the refraction also. So that will be much more efficient way of screening than actually doing torchlight and this examination.
Yes, ma'am.
Okay. Thank you.
Thank you, ma'am.
Any more questions, ma'am? So, Dr. Hiteshi Jain, ma'am, you can load your slides and go ahead with your presentation. Yeah, your slides are visible, ma'am. Go ahead.
Dr. Hiteshi, please unmute yourself.
Hello?
Yes, ma'am. You are visible, audible, and your slides are visible. Go ahead, please.
Good morning, everyone. I'm Dr. Hiteshi Jain. The title of my topic is Evaluation of Optical Coherence Tomography-Based Macular Morphology and its correlation with visual acuity following a successful scleral buccal surgery. So, as we all know, visual complaints such as poor visual recovery and metamorphopsia may be commonly encountered post-operatively by patients who have undergone retinal detachment surgery, even after the retina appears to be successfully attached. Damage to the macular structures during due to retinal detachment leads to this incomplete visual recovery. There are several studies which demonstrate photoreceptor apoptosis, especially after retinal detachment has occurred. These subtle changes in the fovea may not be picked up very easily by indirect ophthalmoscopy or slit lamp biomicroscopy, for which optical coherence tomography proves to be a very attractive tool. I'm sorry, my slide is not changing. Just 1 second. Yeah. The aims and objectives of my study were as follows. Mainly to study the types of structural changes which are observed in the macula using an optical coherence tomography post successful scleral buckle surgeries, and to correlate the postoperative visual acuity with the morphological changes which are observed. We did a prospective observational study of 30 eyes in 30 patients. The only patients with fresh RRD were included in the study, and the macula must be attached in the immediate postoperative period. We studied them for a period of 3 months, and we followed them up immediately post-op on the 15th day at 1 month and 3 months. For OCT, we used a Zeiss Series HT OCT. So the results demonstrated 4 main types of morphological changes on the macula. The most commonly seen was ellipsoid zone disruption, which was 66.7% in both macula on and macula off groups. The next, the second result, which was demonstrated, was that majority of the patients, which was 72% patients with macula off or RRD, developed more than one macular change on OCT, and this was statistically significant. And all the patients with macula on RRD developed only a single change on OCT. The other result that was demonstrated by a surgery was patients who had only one structural macular change postoperatively had undergone surgery earlier. The mean was 9 days, than patients with more than one post-op change. The mean was 16 days. The post-op BCVA of those operated earlier from the onset of symptoms was better and statistically significant than those operated later in both the groups of patients. So in discussion, it is a well-established fact that not all patients of RD attain optimal BCVA in spite of an anatomically successful RRD surgery. Our study exclusively took a look at patients who underwent scleral buckling surgery. There were 4 main changes which were observed, of which ISOS junction abnormalities were most common. This was similar to a study conducted by Cho et al., in which 40% of the patients showed ISOS junction disruption. Our study showed that patients with macula off RRD developed multiple morphological changes, and this was similar to a study conducted by Lin et al. Our study showed that the patients who had only one structural change post-operatively had undergone surgery earlier as compared to patients who had multiple changes. There was a case series conducted by Sridhar and Flynn with no conclusive results with respect to this parameter. There aren't many studies that I came across in my review of literature which highlighted this parameter. The post-operative BCVA was better if the patient was operated. Hassan et al. Showed similar results. It all showed no statistical impact on final BCVA if the patient was operated earlier. So in conclusion, patients undergoing RD surgery may not attain complete visual recovery owing to the presence of microstructural macular abnormalities, which may not be easily picked up by us while indirect ophthalmoscopy. OCT proves to be a new and promising tool that should be used generously to detect such changes. We should keep an eye on, especially on macula on RRD patients, because they may present to us later in view of their milder changes.
You have 1 minute left.
Yes, thank you. Even such patients may not attain complete vision of 20/20. These are my references. Thank you.
Thank you, ma'am. You can now unload your slides.
Yes, sir.
Stop sharing.
Yes, sir. I've stopped sharing.
Questions from judges? Any questions for previous speaker?
Which OCT, Dr. Hiteshi?
Hiteshi Jain.
Yes, ma'am.
Which OCT machine was used for this study?
Ma'am, we used a Zeiss Cirrus HDOCT machine, SDOCT machine.
Which generation? Cirrus is also now.
Ma'am,
It
I
was-
had mentioned the version in my slide.
I'm asking you right now.
Yes, ma'am. It was the version was 10.0, ma'am.
Okay. So what is the resolution of this machine? Because it's very important that when you're using OCT, you should see which resolution to compare. You know the
Yes, ma'am.
resolution?
Ma'am, no, I am not sure of the resolution of this machine.
Okay, thank you so much.
Thank you, ma'am.
Any more questions, ma'am, sir? So Dr. Radha Mathur, go ahead and start your presentation.
Yes, sir. Good morning to one and all. I'm Dr. Radha Mathur, and I will be presenting a paper on the study titled Evaluation of Macular and Retinal Nerve Fiber Layer Thickness in Unilateral Amblyopic Patients using Optical Coherence Tomography. Amblyopia or lazy eye is a common cause of preventable monoocular vision loss in children and young adults, and is defined as unilateral or bilateral decrease in the best corrected visual acuity caused by form vision deprivation and or abnormal binocular communication without any organic cause to correspond with the visual loss. It transpires during the period when the neuronal network between the retina and the cerebral cortex is developing and maturing. So it is often developed during the first 2 to 3 years of life, or sometimes up to 8 to 9 years. The common risk factors for amblyopia are premature birth and small for gestation age. Other factors include maternal smoking, drug or alcohol abuse during pregnancy. Unilateral amblyopia has two main types: an isometropic amblyopia, which occurs due to a difference in diffraction of minimum 1 diopter or more between the two eyes, and second is strabismic amblyopia, which occurs due to a constantly unaligned optical axis. Other forms include ametropic amblyopia, stimulus deprivational amblyopia, and combined amblyopia, which is a combination of anisometropic and strabismic forms. At the end of gestation, there is a fast decrease in cell density of a retinal ganglion cell layer, as well as a decrease in axonal count of the optic nerve. So if amblyopia affects the process of postnatal decrease of ganglion cells, then the RNFL may be thicker than the normal eye. Macular hypoplasia and underlying structural abnormalities can be one of the causes for bad prognosis for treatment outcome. Therefore, macular thickness in amblyopia needs to be investigated in detail to improve the treatment outcome. There are several methods to evaluate the RNFL thickness, but OCT has become extensively popular for assessing optic nerve disorders by precisely and reproducibly measuring RNFL thickness. There are several conflicting reports in literature on whether the RNFL thickness and macular thickness vary in unilateral amblyopes in comparison with the normal fellow eye. And very few studies have been done on Indian population evaluating these correlations. Therefore, we have done this study with the aim to evaluate the macular and the retinal nerve fiber layer thickness in patients with unilateral amblyopia. The study was carried out during January to December 2019 with a sample size of 94 patients diagnosed with unilateral amblyopia. Subjects of either gender between 18 to 45 years of age were included, and those with unilateral amblyopia with a difference in visual acuity of at least 2 lines between the normal and amblyopic eye on Snellen's visual acuity charts were enrolled for the study. Patients with any significant ocular or systemic conditions affecting macular or RNFL thickness and those with any history of ocular trauma or surgery were excluded from the study. A detailed ocular and systemic history was taken. The best corrected visual acuity using a Snellen's chart was noted. IOP with Goldman applanation tonometer was taken. Anterior segment was examined with a slit lamp. Fundus examination was done under mydriasis. Those fulfilling the inclusion and exclusion criteria were enrolled in the study. The RNFL thickness and macular thickness of both the amblyopic as well as the normal eye was measured using OCT Cirrus HD. Data was recorded and analyzed with a probability value of 0.05, which was considered significant. In our study, we included a total of 94 patients. Among them, 60 were males and 34 were females. The age distribution was maximum in the range 21 to 30 years. Out of the 188 eyes, 94 were normal fellow eyes with normal visual acuity, and 94 were amblyopic eyes with visual acuity ranging from 6 by 12 to 6 by 60. The mean central macular thickness was 245.94 micrometers for normal eyes and 242.19 micrometer for amblyopic eyes, with a p-value more than 0.05, which showed no statistical significance. Similar results were obtained in studies done by Yaker et al. And Wong et al., but these were limited to only anisometropic hyperopes. The mean average macular thickness was 271.4 micrometers for normal and 278 micrometers for amblyopic eyes, with a p-value of 0.02, which showed highly statistical significance between the two. A study done by Dickman et al. Showed similar results, but only among strabismic amblyopes. Another study by Firat et al. Also reported higher macular thickness in amblyopic eyes, but was not statistically significant. In our study, the mean RNFL thickness was 90.2 micrometers in normal eyes and 88.6 micrometers in amblyopic eyes, with a p-value of more than 0.05, which was not statistically significant. A study done by Andalib showed similar results. Contradictory results were reported in a study done by Repka et al. Among unilateral, strabismic, anisometropic, and combinational amblyopes, which showed thicker RNFL. A quadrant-wise RNFL evaluation was also done, but no significant difference was seen among amblyopes and corresponding fellow eyes. The limitation
You
of a
have 1
study,
minute left.
the limitation of a study was that the sample size was confined to only 94 amblyopic cases, which did not allow segregation of patients into groups according to the type of amblyopia. Absence of control group to represent a reference to avoid any alterations that may occur to the normal fellow eye in patients with amblyopia. In conclusion, our findings of markedly thicker macula in unilateral amblyopes suggest that although amblyopia primarily affects the visual cortex, it is also a process that leads to secondary changes at the retinal level, which is an important concept for further studies. However, RNFL thickness does not show any corresponding outcomes with amblyopia and actually is thinner in amblyopes. The cause behind this can be racial differences or some other yet unknown factors. So further studies are warranted to establish retinal changes in amblyopia and to determine whether retinal involvement has any effect on response to amblyopia therapy. Thank you.
Thank you, Dr. Radha Mathur. You can now unload your slides.
Yes, sir.
Meanwhile, judges can have questions.
Dr. Radha, what is the difference between the macula of two eyes in a normal person also? Thickness? Normal? Hello?
Yes, sir.
Okay. Now, you suppose we treat these amblyopic patients.
Yes, sir.
What will be the effect of that treatment of amblyopia on this, the thickness of this RNFL and macula? So suppose we treat the patient if by occlusion or any other therapy. So
Yes,
what
sir.
is expected then?
Sir, as it is a developmental condition, so I don't think there will be much of a change.
If suppose we, because you have taken the the age, you have included the adults also, no?
Yes, sir.
So if suppose we treat the amblyopia
Yes, sir.
by some method and there is some improvement, will it make any changes in the thickness of the macula and RNFL on OCT?
Sir, I don't think there will be any significant change.
Why then? If suppose vision improves, then why should not be there be a? Okay. Why foveal thickness was not taken into your study? Why macula? Instead of macula, why not foveal thickness and RF and RNF thickness?
Sir, I have taken central macular thickness and average macular thickness separately.
Because fovea and macula, these are the anatomical and physiological and functionally both are different.
Yes, sir.
Okay. Anyway, no problem. Thank you. Good.
Thank you, sir.
Any other questions?
Yeah,
Mita,
I would just like to know that have you taken the type of refractive error and amblyopia, the relation of that with the macular thickness?
No, ma'am, not in my study.
Because we do expect that according to the refractive error that macular thickness changes, correct?
Yes,
so
ma'am.
I think that should also be part of your study.
Okay, ma'am.
Thank you.
Thank you, ma'am.
Dr. Prashansa Thakur, you can start your presentation.
Yes, sir. Are my slides visible, sir?
Yes, ma'am. Go ahead, please.
Yes, sir. So, good morning to all and respective judges. I, Dr. Prashansa Thakur, I am a fellow at Cornea Refractive Surgery in Narayan Nethralaya, and today I'll be talking about impact on ocular surface health by protective masks during COVID-19 pandemic. So, the emergence of the COVID-19 pandemic has literally changed the fabric of the society. It has led to compulsory wearing of masks, which has caused increased reports of dryness, discomfort, and inflammation. So, now there are increasing reports about mask associated dry eye, and this is one of them written by Suresh Pandey. So it talks about the causes of dry eye and the possible solutions. But questions like what is the type of dry eye associated with mask use, what are the effects, and what are the probable treatment approaches still left unanswered. So, what are the effects of mask continuous overwear? It not only leads to altered respiratory parameters, but since the expelled air is escaping through the upper border of the mask, it caused enhanced evaporation of the tear film, and also it led to hypercapnia since the exhaled air has 90 times more carbon dioxide than the atmospheric CO2. So the research question here was to assess the impact of mask on ocular surface. Are the mask associated ocular surface changes different from dry eye, and what is its impact on clinical practice? So this itself defined the purpose of our study, which was to assess the effect of mask wearing for long hours on clinical parameters, ocular surface, and molecular factors. This was a prospective cross-sectional study conducted from November 19 to 20. We included all the healthy eyes with no ocular morbidity and excluded all the subjects having any history of chronic topical medication, contact lens wear, dry eye, and history of ocular surgery. Ours being a research driven institution, we already had samples from 12 subjects, healthy volunteers, and in the pre COVID era, who had no history of any mask wear. We did the Shermer's T-BUT and OSDI scoring and optical quality analysis system and LipiView imaging, and finally collected their tears and wash samples. We chose to go ahead with the same cohort, now exposed to COVID-19 pandemic with history of more than 8 hours of mask wear. We subjected these patients with the same set of tests and finally collected their tears and wash samples. So, what were the results? We found out that the OSDI scoring was significantly high in the post mask era, which was a telltale sign of discomfort. But what was more interesting was that the Shermer's and the T-BUT values were high as opposed to the low values which are normally seen in other types of dry eye. So, what are the factors driving the discomfort in spite of the normal tear film metrics? So, for that, we analyze the tear film samples. This is how we normally process the samples. After collecting the tear samples, we store them in biorepository at minus 80 degrees Celsius. And then they are, while processing, they are eluted in 0.1% of phosphate buffered saline mixed with capture beads and detection antibody and subjected to flow cytometry where molecular factor analysis is done. For wash samples, we add 0.1% of paraformaldehyde solution for stability to the sample and then transport the entire assembly to lab at 4 degrees Celsius to centrifugation and then do flow cytometry where we can quantify the specific percentage of cells. So what all parameters got affected post mask wear? What we found out was along with OSDI, factors like interleukin 1 alpha, 1 beta, leukocytes, T cells were significantly high, whereas antinociceptive factors like VEGF-A, interleukin 12, and other factors like interleukin 6, 8, beta cells were significantly reduced. So what is the impact of hypercapnia on the ocular surface? For that, we did a small experiment where we took into consideration two cultures. One was human corneal monolayer cell culture and explant culture and exposed them to two different types of carbon dioxide environments. One was normocapnic containing 5% of carbon dioxide and the other was hypercapnic containing 20% of carbon dioxide. What was interesting to note was the cells which were exposed to hypercapnic environment showed reduced osmolarity. So what were the causes of increased Shermer's and T-BUT values? For that, when we analyzed the tear fluid samples from the subjects, what we found out was there was increased production of mucins in the post-mask era as opposed to the pre-mask era. These increased mucins helped in improve tear film dynamics, thereby leading to increase in Shermer's and the T-BUT values. And the similar results were seen in corneocellular limb explant culture when they were exposed to hypercapnic environment. So what we deduced from our results was that the type of dye which is associated with mask was not of the routine hyperosmolar type, but is of hypoosmolar type. So when we subject these eyes having mask associated changes to any surgical intervention, we find delayed wound healing. And if not understood that the type of dry eye is hypoosmolar type and we treat with conventional medications, they can lead to non-response. There is also increased risk of infections as the aerosol droplets cling to the ocular surface more effectively. There is increased pain
You
since
have
there
1 minute left.
Yes. Increased pain because of increased metalloproteinase 9 and decreased TIMP. Discomfort because of the imbalance between the pro-nociceptive and anti-nociceptive factors, and increased possibility of ectasia because of degradation in the collagen matrix. So what our study finally concluded and adds to the literature is that long periods of mask wear causes alteration in the ocular surface, and that the tear molecular factors which were observed were very distinct from the other types of dry eye. And before undergoing any surgical procedure, the ocular surface issues should be addressed. It also guides us on the rationale for the treatment of hypoosmolar dry eye, and that we should be extra cautious before doing any medical or surgical intervention as it can adversely affect the treatment outcomes. Thank you for your patient listening.
Thank you, ma'am. Any questions from judges side? Any questions from judges side? No, so we are good. So it was a very wonderful session. Thanks to all our speakers. On behalf of BO and MOS, I would like to thank our esteemed judges for their valuable times and request our judges to kindly share their mark sheets on WhatsApp group, or you can mail it to Dr. Sumit Lahane, sir. Thank you.
Thank you all the judges, and I must thank you. I must thank Dr. Durgesh for conducting it very smoothly. Also, we appreciate all the participants who presented, because I spoke to most of them, and many of them were on the COVID duty, had COVID before, and they adjusted their duty and still came for presentation today, which is commendable. And as a MOS, BOS scientific committee, and from all the judges, we must applaud them that even in this difficult situation, managing their own work and COVID duties, they could come and present here, which is really commendable. And thank you all the respected judges that they gave their time and had a very elaborate discussion and guided our participants regarding their studies. Thank you so much, Madan sir. Thank you so much, Smita ma'am. Thank you so much, Manjunath sir.
Thank you so much for invitation.
Yes, sir. It's 10:15, and we.
Thank you.
We hand over the hall to the next session in next 10 minutes. Thank you all for joining.
Thank you so much.
Good morning, Sarika ma'am.
Good morning, Dr. Sumit.
Ma'am, sorry, I forgot to send one mark score sheet there. I just shared on the group, ma'am, the scoring.
Right, I got it.
Yeah. Guru Dasani sir also has joined. Good morning, Guru Dasani sir. Good morning, Manjunath sir. Good morning, Chaugule sir. Sir, mute him, mic तुम. Yes.
Dr. Sumit. Am I audible?
Yes sir. Voice थोड़ा कम है. थोड़ा है.
Okay. Yeah. Is it okay now?
It is better sir, but I'm getting.
Hello.
Yes sir.
Yeah, it's okay now.
It's okay sir, but little low. You can take your computer
I'll
little
speak
close to
loud.
your face. Yeah, then that will be better. Good morning, Manjunath sir.
Good morning.
So, Dr. Sumit,
Yes, ma'am.
as we just received the score sheet right now, what I'll do is I'll fill it in rough.
Will do, ma'am.
I'll have some time to send it to you, right?
Yes, ma'am. Yes,
Afterwards?
ma'am. You till evening also you can send, ma'am. There is no hurry.
All right.
Later in the
Okay.
day only we will mail, because we have to compile all the 8 sessions winners, and then we will mail
Right.
them personally.
Okay. All right.
Yes, ma'am.
Thank you.
Thank you, ma'am.
Are the speakers logged in?
I'll try and connect with them, those who are not joined. Just give me a 5 minutes. Good morning, Mania sir. Ranjit Mania sir also has joined us.
Good morning, everyone.
Good
Should
morning,
I start?
everybody.
Should I start with
One
my
second.
presentation?
Now, 1 second. Good morning, everybody. Welcome to session 14 of free papers of BOA MOS webinar. I'm Dr. Vidyasagar Chaugule. I'm a moderator for today's session. Are all the speakers there? Is Dr. Ankita Sihag there?
Yes, sir.
Dr. Purva Kher?
Yes, sir.
Dr. Mansi More,
Yes, sir.
Dr. Jinil Bhatt,
Yes, sir.
Dr. Sneha Kukreja,
Yes, sir.
Dr. Mili Arora.
Yes, sir. Good morning.
Yeah, good morning. Dr. Nishika Jain.
Yes, sir.
Yeah, fine. Very good. At the outset, let me first introduce our judges. Our judges for this session are Dr. Manjunath Patil. He is a professor and HOD of Department of Ophthalmology, Ashwini Rural Medical College, Solapur. He is also pediatric ophthalmology as a specialist. Dr. Sarika Gadekar from Aurangabad, cornea and refractive surgery consultant, professor, Professor, Department of Ophthalmology, MGM Medical College, Aurangabad, and Dr. Bhavisha Gurudasani, Associate Professor, GMC Medical College, Akola. Let's start with the presentations now. Is it okay with the judges?
Yes. Yes.
Yes.
Yeah. Each speaker will have 6 minutes for their presentation and 2 minutes for discussion. Shall we start with Dr. Ankita Siha?
Yes, sir.
Yeah.
Good morning, everyone. I'll be presenting a case of herpes zoster ophthalmicus with corneal perforation, which is a rare manifestation. Introduction, herpes zoster ophthalmicus, which is known as shingles. It's a viral disease characterized by unilateral painful skin rash with radicular pain in one or more dermatome, distributions of the fifth cranial nerve, that is trigeminal nerve, and it commonly manifests as eyelid lesions, corneal disease, or uveitis, which can entail a myriad of long-term sequelae. Typically, it occurs in older adults, but can present at any age and occurs after reactivation of latent varicella zoster virus, which is present in the sensory spinal or cerebral ganglia. Etiology, reactivated varicella zoster virus from its dormant status in the dorsal ganglion cells of the CNS. From there, it may travel along the neurons to the sensory axons of the skin to form vesicular lesions. Risk factors are virulence of the varicella zoster virus, immune status of the host, age more than 60 years, racial factors, recurrence, prolonged illness, and chances of myelitis and vasculopathy are more in immunocompromised patients. High risk of varicella zoster virus is present in HIV patients. General pathology, varicella zoster ophthalmicus is a double-stranded DNA virus in the herpes simplex virus group. It is due to activators, herpes zoster ophthalmicus is due to activated varicella zoster virus. Pathophysiology, reactivation of the virus from its dormant state in the sensory ganglion, which leads to replication in the nerve cells, and then shedding of the virions from the cells that are carried down the axons to the skin served by that ganglion. The local immune response is responsible for blisters or ocular inflammation. Perineuritis is responsible for intense pain along with the nerve distribution. Paresthesia and segmental pain can be present before the onset of rash in that area supplied by trigeminal nerve. Aging, immunosuppressive therapy, and psychological stress are the factors responsible for the activation. In my case, a 65-year-old diabetic male hailing from Malana village presented to the OPD of Malana with a complaint of fever since 12 days, burning sensation on forehead and around the left eye since 12 days, vesicular eruptions on that area of the face since 10 days, discharge in the left eye since 10 days, diminution of vision. He was complaining diminution of vision since 10 days, which was followed by sudden loss of vision since one day. History of presenting illness. Patient had low-grade fevers 12 days back, which was associated with headache, tiredness, and malaise. Pain and burning sensation on the left side of forehead and around the eye was present. 10 days back, eruption of groups of vesicle on the left side of forehead, left upper eyelid, and nose associated with itching and pain was present. Redness and mucopurulent discharge from left eye along with decreased vision, which was followed by sudden loss of vision since yesterday was present. Past history, there is no history of long-term illness, decreased appetite or weight loss. There's no drug history or known drug allergies. A patient had a history of chickenpox at the age of 12 years. Patient doesn't have any history of similar episodes of eruptions in the past. Family and social history, he's married and lives with wife and has 2 children and all are healthy. He doesn't have any addictions. He works as a farmer and belongs to a middle-class family. On examination, visual acuity in the right eye was 6/12, and in left eye, PL positive and PR inaccurate was present. On external inspection, erythematous skin with groups of flesh-colored vesicles with crusting on left side of forehead, left upper eyelid, along the lid margin, side and tip of the nose was present, which is suggestive of Hutchinson's sign. The lesions were localized to the distribution of first division of trigeminal nerve. Bilateral ocular motility was normal. Pupillary reaction in the left eye, we couldn't appreciate the reaction. On slit lamp examination, conjunctiva, right eye is normal. In the left eye, hyperemia was present. Cornea, in the left eye, perforation with the iris prolapse was seen. Sensation could not be appreciated in the left eye, and it was normal in the right eye. Anterior chamber was normal in the right eye and collapsed in the left eye. Lens was cataractous in both the eyes, and fundus in the left eye could not be visualized, and in the right eye, it was within normal limits. This is the picture showing corneal perforation with iris prolapse, along with mucopurulent discharge, along with edematous eyelids. Investigation: patient was tested for viral markers and found to be negative for all the markers. Management: the patient came to the OPD with the 12-day history of his herpes zoster ophthalmicus. Patient was evaluated and investigated, and he was
1 minute left.
You have 1 minute.
Okay, sir. And he was
Yeah.
immediately started on oral acyclovir, 800 mg 5 times per day. And on slit lamp examination, patient had a corneal perforation with iris prolapse. Patient was advised penetrating keratoplasty at higher center where corneal transplant is available. Discussion: herpes zoster ophthalmicus occurs in 20% of chickenpox affected individuals, and reactivation of virus occurs between 50 to 90 years of age. Patient presents with prodromal symptoms like malaise, fever, erythema. Ocular involvement occurs in around 50% of the patients. Ophthalmic complications include lid scarring, paralytic ptosis, conjunctiva, conjunctivitis, etc. Corneal involvement may be present as punctate epithelial keratitis, deciform stromal keratitis. Corneal anesthesia is profound in this case and often leads to recalcitrant neurotropic ulceration, which further leads to corneal perforation. Treatment modalities include oral acyclovir, which is given for 7 to 10 days, and it has to be given within 72 hours of onset. Eye ointment acyclovir 3% can be given for 5 times daily, along with topical cycloplegics. Surgical modalities include penetrating keratoplasty. Conclusion: the management of herpes zoster usually involves a multidisciplinary approach aiming to reduce complications and morbidity. This case highlights the importance of an early referral of all patients with herpes zoster ophthalmicus to the nearest eye center. The treating doctor should be aware of all its associated potential vision-threatening complications, which, if not promptly detected and adequately treated, may even lead to a total loss of vision. Thank you.
Judges can ask questions.
Sorry, ma'am, you're not.
That's
Ma'am, I can't. Sorry, you're not audible.
Okay. Some other judge can ask a question, I think.
Ankita.
Ma'am, I can't hear you.
Can you hear me, Ankita? Can you hear me, Ankita?
Ma'am, would you please repeat the question? Sorry.
No, I haven't asked a question yet. Some other judge can ask if you hear me well.
Dr. Ankita, Dr. Gurudasani will first ask you a question.
Ankita,
Yes, sir.
The patient presented you at the 10th day. Do you rule out any inadvertent use of steroids or home remedies at home that
Yes, sir. I did ask him the history of any medication. He went to a local practitioner, but he doesn't have the. He didn't give me the history of using steroids from that place.
any home remedies?
No, sir. No history of any home remedy.
Okay.
Dr. Ankita,
Yes, sir.
did you read madam's question? It was, what is the prognosis of the transplant?
Since it's a neurotropic kind of keratitis, so prognosis will not be that good. There'll be chance of transplant failure because of the neurotropic keratitis.
Improve prognosis.
Ma'am, by giving the oral antiviral, we can reduce the viral replication and we can reduce the viral. Ma'am, you're not audible. Sorry. This is done to cover the wound so as it can help in re-epithelialization, which can help healing the perforation better.
Our next speaker is Dr. Purva Kher.
Morning, sir. Thank you.
Dr. Purva? You can start.
Very good morning to everyone. I'm Dr. Purva Kher. Thank you, BO and MOS, for giving me this opportunity to present my case titled Evaluating the Role of Retrobulbar Amphotericin B Injection as an Adjuvant Modality of Treating Rhinoorbital Mucormycosis in a COVID-19 patient. A 49-year-old male who was admitted in the ICU for COVID pneumonia gave history of swelling around the right eye since 2 days. There were no other ocular complaints or no significant complaints in the other eye. The person was a known diabetic with uncontrolled sugars being treated on steroids and also being treated for hypertension and schizophrenia. On examination, the general condition was poor, the vitals were stable, and he was maintaining saturation on BiPAP. On ophthalmic examination, vision in both eyes was finger counting 3 meters bedside with PR accurate. However, in the right eye, there was lid edema along with lateral restriction of extraocular movements and absent sensations in the distribution of trigeminal nerve. There were no remarkable findings in the left eye. ENT reference showed a black eschar in the right nostril and crusting in both nostrils, along with a palatal ulcer which was present. HRCT thorax was typical of COVID pneumonia. The KOH mount, however, was negative for fungal elements, but IV amphotericin B was started by ENT in anticipation. Patient systemically improved in the next 2 days, and CT scan was done immediately. CT brain showed chronic small ischemic vessel changes and age-related changes. On CT orbit and PNS, as we can see, there's bilateral pansinusitis along with attenuation and thinning of cribriform plate and other bones. In the findings in the orbit were suggestive of right side orbital cellulitis. Ophthalmic reassessment was immediately done, and as we can see, the vision in the right eye is deteriorated to PL positive, PR inaccurate bedside. There was conjunctival congestion and chemosis in the right eye, along with a fixed mid-dilated non-reactive pupil and restriction of EOMS in all gazes. On fundus examination, a CRAO was present and absent sensations which were noted earlier. In the left eye, however, now we can also see the restriction of extraocular movements laterally with absent sensations in the periocular area. The nasal swab culture report now showed growth of rhizopus species. Patient was taken up for FIS and simultaneous retrobulbar injection was given in both eyes as patient had given negative consent for exentration. As we can see in the post-operative day 1 in the right eye, along with conjunctival congestion and chemosis, a yellowish tinge was noted in the conjunctiva. Other findings on ophthalmic examination was similar to the pre-op findings. Sadly, the patient succumbed the next day to his illness. Coming to the discussion, mucormycosis is an invasive lethal fungal infection, the most common species being the rhizopus and the mucus species. It has various forms of presentation, most common being the rhinoorbital cerebral mucormycosis, which starts from the sinuses. Now, why is it that the disease which was once rarely seen is now so commonly seen across all states of India? The main culprit of this is the increasing number of COVID-19 cases which have been injudiciously treated with steroids, especially in diabetics, leading to uncontrolled sugars. Use of other immunomodulatory drugs like tocilizumab, use of unsterile water and oxygen humidifiers and contaminated masks has also been postulated. Mutants of COVID-19 virus, they are more transmissible and replicate faster, hence leading to a longer duration of treatment. Now, what are the indications of retrobulbar amphotericin B? It can be given in early disease, especially when the vision is unaffected. In cases where progression of the disease is there, while the fitness for surgical debridement of the patient is still in process. In cases of bilateral involvement, it may be given as a last resort, or if the patient is systemically unfit for any kind of surgery. Advantages are that it has better local penetration of the drug with lower systemic toxicity, minimally invasive, and a globe-sparing procedure. In a recent article published by Dr. Santosh Honawar sir, he has also recommended the use of retrobulbar amphotericin B in early orbital disease along with sinus debridement. 1 ml of 3.5 mg amphotericin B is given through a separate syringe preceded by a local anesthetic in the intraconal space. It has a few local adverse effects, commonly being increased orbital pressure and the most deadly being orbital compartment syndrome. I did a comparative analysis of our study with other two studies, one published by Mustafa et al. And another by Christine Hirabayashi et al. As we can see, the vision at the time of giving retrobulbar injection in the other two cases was much better. The total number of injections in our cases was only one, as the patient succumbed soon after. But in the other two cases, 2 and 6 respectively injections were given. A significant visual improvement was noted in the other two cases. Also, along with systemic amphotericin B, other antifungals like micafungin and capsofungin were also given in those cases. Now, what are the challenges that we are facing today in treating mucor, especially in
1 minute.
COVID-19 patients? Thank you, sir. Angioinvasive nature and fast spread of the fungus lead to a high mortality rate. KOH mount is dependent on technique of collection and may be negative in up to 50% cases. Rampant use of steroids as seen in COVID patients and management and control of diabetes in COVID-19 has been a real challenge for the physician. Long duration of treatment and poor compliance of patient. We as tertiary care hospital usually receive patients who have poor systemic conditions or in the advanced form of the disease. High cost of drugs also adds to all the other challenges. In conclusion, I'd like to say that in cases of COVID-19 positive rhinoorbital mucormycosis, intravenous antifungals, reversing the patient's immunocompromised state and glycemic control, endoscopic sinus debridement immediately are the mainstay of treatment. However, as ophthalmologists, we should be highly vigilant and identify and pick up warning signs like periocular edema, regional pain, sudden diminution of vision, ptosis, redness, facial pain, etc. at the earliest in COVID patients. A low threshold for starting amphotericin B, especially retrobulbar ampho, should be present. None of the studies reviewed in literature mention the exact timing and dose of retrobulbar injections, and there is a need for further research in this case. However, with the knowledge that we have currently, it should be tried as an adjuvant in early disease prior to exentration in COVID patients. These are my references. Thank you, sir.
Dr. Purva,
Yes, sir.
what is the earliest sign of orbital mucormycosis?
So the patients have presented with various signs, sir, like even congestion or just simple conjunctival congestion or chemosis, which has later aggravated.
One more question.
Yes, sir.
Why there is sudden emergence of orbital mucormycosis suddenly at present? We are treating COVID-19 patients since last 1 year.
So in last 1 year, the highest cases which was seen in a day was up to 2 lakhs. However, there have been increasing number of cases which have seen up to 4 lakh cases per day has been seen this year, sir. Also, the mutant which is there is more transmissible, leading to higher number of cases. And injudicious use of steroids even for mild COVID-19 has led to increasing number in this second wave, sir.
Any other questions? Till that time, Purva, you can stop sharing your screen and the next speaker can share the screen.
Yes, sir. Thank you.
Any other questions for us?
Dr. Mansi More.
Yes, sir. So may I start?
Yes, you can start.
You can start, Dr. Mansi. Yeah.
Good morning, everyone. Myself, Dr. Mansi More. I'll be presenting a case on persistent hypertropia following modified Nishida for a monocular elevation deficit. I would like to thank you, BOA and MOS, to give me this opportunity to present this case today. My patient, 48 years old female, came with the complaints of drooping of right upper eyelid since birth, decreased vision in the right eye since childhood, and history of ptosis surgery done twice in early childhood with no records were available. She was nil systemic by illness. On examination in the right eye, patient's unaided vision was 660, which was improving to 624 with plus 1.25 DSP, and a near vision of N12 with plus 1.75 addition. In the left eye, the patient's vision was 618 parts, which was improving to 66 with plus 1.50 DSP, and a near vision of N6 with plus 1.75 addition. In the extraocular movements in the right eye, there was -4 limitation of elevation, and in the left, they were full and free. Pupils in both the eyes were central, circular, and reactive to light. On modified Krimsky's test, in the right eye, there was 45-degree right hypertropia with no esotropia or exotropia seen. This is a 9-gaze photo of my patient, where in the primary gaze, we can see there is hypertropia present, and also there is elevation deficit, limitation of elevation in all the other gazes. So on ptosis evaluation, there was severe ptosis obscuring the visual axis, loose papery skin was seen, a frontalis overaction was present, poor to nil levator function, and an anterior posterior segment was unremarkable. So the diagnosis of my patient was a right eye congenital monocular elevation deficit with a moderate amblyopia with severe ptosis. On ocular investigations, the IOP of the patient was 14 millimeters of mercury in both the eyes. SAC was patent in both eyes. Forced duction test for inferior rectus was positive, and a forced genetic test for superior rectus was faint with no tuck felt. No diplopia charting was done as the patient didn't have any diplopia. MRI was done, which was within normal limit. It was done to rule out any acquired causes of MBD. Now, the plan of action was squint surgery followed by ptosis. FDT or FGT decides the surgical plan. So the forced duction test for inferior rectus was positive, and therefore inferior rectus recession of 5.5 mm was done. A modified Nishida was planned, and the correction obtained with the modified Nishida's procedure was 30 prism diopter, and in conjunction with the inferior rectus recession was around 40 prism diopter. Because it's a small series, the average correction needs to be refined with a larger series. Now, this is the methodology where a modified Nishida was done with a limbal incisions taken, a medial rectus and the lateral rectus muscle were identified, non-absorbable 5-0 ethibond suture used with the 1/3 fibers of the horizontal muscle anchored at the equator axis on the sclera in the superotemporal and superonasal quadrants 12 mm behind the limbus. This is the surgical procedure. Now, on post-op day 1, patient had small exodeviation with the flick hypertropia. Elevation had significantly improved to -2 from -4. Ptosis was present. Patient was put on antibiotic steroid eye drops and asked to review after a month. So this is the clinical photo of my patient on day 1, where we can see the hypertropia has been improved. On a follow-up day at 2 months, a post-op residual hypertropia with 14 to 16 prism diopter was seen. At 5-month post-op, a 16 to 18 hypertropia with elevation limitation being -3 was seen. Now, this is a preoperative and the postoperative picture of my patient, where in the preoperative, we can see there is hypertropia, and a postoperative, there is improvement of the hypertropia, which was observed. A monocular elevation deficit is actually a failure in elevation of all the gaze positions of the paretic eye. It is currently classified into 3 subtypes according to the findings of the force reduction test, force generation test, elevation saccadic velocity, and Bell's phenomena. So type 1 is a restrictive form with the positive results on the FDT for elevation, normal elevation force generation test, elevation of a saccadic velocity, and the absence of a poor Bell's phenomena. Type 2 is a paretic form with a free force reduction test, a reduced elevation of a force generation test, and a saccadic velocity, positive Bell's phenomena, which is seen in a supranuclear palsy. Type 3 is a combined form. Now, these are the surgical management of MED, the options available. First is an IR recession, where we get a correction of 3 prism diopters with 1 mm IR recession, helps to improve the poor Bell's phenomena. NAPS procedure can also be done, which gives a correction of 21 to 55 prism diopter with an average of 38 prism diopter. It's a well-established surgery. The demerits have been discussed later. We can also do a IR recession plus NAPS procedure, which will give a 28.6 prism diopter correction. An augmented NAPS procedure gives a correction of 30 to 40 prism diopter. It's a surgery of choice as it gives better results than NAP, and there is no need of resurgeries. A modified NAPS procedure allows the correction of a horizontal deviation with untouched inferior half, or a vertical recession or a resection can be done, where we do superior rectus resection plus inferior rectus recession. It spares the horizontal muscles for future division of horizontal deviation. The exact amount of recession and resection is not described. That's the demerit of the vertical recession. Now, the drawbacks of NAPS procedure: there is no grading in the correction with NAPS. There is large variability in the amount of correction obtained with this procedure. The tendency to drift towards
You have 1 minute.
Correction of horizontal deviation becomes difficult, and the transverse muscle is already maximally stretched, which makes resection impossible. Now, discussion: why was there residual hypertropia in my patient? It was due to the knot slippage. Now, ways to tackle hypertropia is a superior rectus plication with the same eye, a contralateral superior rectus recession with the Faden procedure. We can undo Nishida and plan modified NAP, or a monorectus transposition with a foster augmentation can be done, or a resection of inferior oblique of the affected eye can be also done. We took the patient back to the OT, and a monorectus transposition with a foster augmentation was done, where the patient showed improvement. On concluding, a modified Nishida procedure is simple to perform. It corrects vertical deviation on par with established NAPS procedure. It involves no tenotomy or muscle splitting. It is a reversible surgery with less traumatic to the eye, making it useful procedure in cases of MED. That's the references for my study. Thank you.
Dr. Mansi?
Yes, sir.
What do you think? Which procedure is better, modified NAPS or modified Nishidas, in comparison to results?
So I think modified Nishida is a better procedure.
Which is feasible?
Modified Nishida is also feasible procedure. That's what I think.
Okay.
Okay, the next pick. Any more questions, judges? Any more questions?
Sir, we can continue.
Yeah. Next presenter is Dr. Jinil Bhatt. You can start sharing.
Good morning, everyone. Am I audible?
Yes, you continue.
Okay. I'm Dr. Jinil Bhatt, first year resident of Ophthal, and I'm going to present Fueling the Fire, COVID-19 aggravated rhino-orbital mucormycosis manifesting as orbital apex syndrome with retinal artery occlusions. So COVID-19 infection, a multisystemic inflammatory disorder, invites other comorbidities to play along. As if our battle against COVID wasn't enough, rhino-orbital mucormycosis seems to be hitting an additional blow. COVID-19 infection, its treatment, resultant immunosuppression, and pre-existing comorbidities have made patients vulnerable to secondary infections like mucormycosis. Black fungus, as it is popularly known, causes an invasive fungal infection occurring in diabetic and immunocompromised patients Although we are not sure about the exact pathophysiology of interaction of the virus with the mucor, rhinoorbital mucormycosis is characterized by vascular invasion with hyphae infarction and necrosis of the tissue by an acute or subacute course. Co-infection with COVID may aggravate it, leading to orbital apex syndrome with arterial occlusions requiring multidisciplinary treatment. The fungi colonizes the sinonasal mucosa and enters the orbit through ethmoid and maxillary sinus or via the nasolacrimal duct. Ocular involvement often presents as an orbital apex syndrome and rarely as retinal artery occlusions. Mucor presents as external ophthalmoplegia, proptosis, ptosis, visual loss, chemosis, and other symptoms, while retinal artery occlusion, a rare manifestation of rhinoorbital mucormycosis, presents as an orbital apex syndrome with an incidence of 16 to 20%. This is attributed to the direct infiltration of central retinal artery by angioinvasive fungal infection from the orbit. My aim is to study the ocular involvement in COVID patients diagnosed with mucormycosis infection, focusing on the orbital apex syndrome and retinal artery occlusion at a tertiary eye care center. So, my being an ongoing cross-sectional observational study performed at a eminent Western Tertiary Eye Care Institute has a current sample size of 16. And after taking the consent of the patient who visited our OPD or who were referred from COVID hospital, the demographic data, ocular and systemic complaints were noted. A specific note was made about the systemic illness, including diabetes mellitus and the hyperglycemic index of the patient. Detailed history about the COVID infection and its treatment was taken. We noted the visual acuity and intraocular pressure wherever possible, and anterior segment and fundus evaluation of the patient was done using slit lamp biomicroscopy with 90 diopter lens. In non-ambulatory patient, bedside examination was performed by torchlight and binocular indirect ophthalmoscope using 20 diopter lens as per the status of the patient. Ocular movements of the patients were noted. So, of the many cases, I would like to present this one case, which is a representative of my sample. He shows the clinical signs of lead edema, chemosis, and proptosis, while his MRI image shows periorbital inflammation and involvement. On fundus photograph, it is depicting of central retinal artery occlusion, and when the sample was sent for culture, microbiology reported septate hyphae, which was suggestive of rhizopus fungus. So what the ocular signs we observed? Mainly, we observed lead edema in almost all the patients. Ophthalmoplegia was present in nearly 90% of the patients, and almost two-thirds of the patient had profound visual loss. Retinal artery occlusion was seen in almost 56% of the patients, as compared to 16 to 20% in non-COVID patients noted by other studies. So my observation is we had a good turnout in OPD of mucor cases. Almost 78% of the cases were more than 50 who had suffered from retinal artery occlusions. We had 25% of mucor cases which were females, and in of all the samples we noted that three-fourths of the patients, three-fourths of the males were more affected by retinal artery occlusion. So although this being majority of unilateral entity, we also noted some bilateral cases. Majority of the patients were suffering from diabetes, and of them, almost three-fourths of the patients had poor glycemic control with HbA1c more than 8. So our study of 16 patients noted that signs of rhinoorbital mucormycosis had aggravated when it occurred with COVID-19 co-infection, which was even more in diabetics. So in discussion, I would like to say that lead edema, ophthalmoplegia, and profound visual loss were the most common signs in majority of our subjects. OPD patients were a little more than referral, which might be suggesting of an increasing awareness about the disease. Old age and male gender were probably the non-modifiable risk factor, and bilateral cases, although rare, but should be kept an eye upon. As Dr. Selman reported a case to warn of the possibility of COVID-19 in his study by triggering diabetic ketoacidosis, which could predispose an invasive fungal infection, our study had similar observation. As Dr. Muthukrishnan noted, retinal artery occlusion and orbital apex syndrome in mucor cases in immunocompetent patient, we noted its fulminant form in COVID-infected patients. Orbital apex syndrome, a common feature of mucormycosis, might be exacerbated due to COVID treatment, specifically in diabetic patients. As noted by Dr. Lahanesar et al., presence of diabetes or altered glycemic profile increases the risk, while our study had a similar observation. Whereas most of the studies showed a male preponderance, our study has almost one-third of its sample as females. So we would like to dare suggest an hypothesis that we cannot rule out the fact that COVID infection being a coagulative condition and mucormycosis being a vascular invasive pathology by itself might be increasing the risk of ocular artery occlusions. The limitations of our study was due to the COVID being a new identity. Cases were difficult to trace or follow up, and this we had a small sample size. So I would like to conclude saying that orbital apex syndrome and retinal artery occlusions are dreadful ocular involvements in COVID patients with mucormycosis. Their early detection and timely management can play an important role in saving these eyes and reduction of morbidity and mortality. So we would like to send home a message that ophthalmologists are an indispensable soldiers in this war against COVID, and their coordination with other medical disciplines might change the scenario to a life-saving one. The COVID tide might settle, leaving behind debris of rhino-orbital mucor being one of them, which would require immediate attention. These are my references. Thank you. Hello?
Jinil,
Yes, sir.
you talked about early intervention. So
Yeah,
yes, sir.
in your study, don't you intervene early in any case?
Yes, sir. We do intervene in early case, but initially, while I started my study, I noted that most of the cases were from reference. After the awareness was so, while the patient presented to us, they had almost lost the visual prognosis to no PL, and total ophthalmoplegia was noted in them. But now, due to this ongoing awareness, even a simple periorbital swelling brings the patient to us, and early treatment is started.
What are your indications now to intervene early? So
Sir,
we have only one modality, that is retrobulbar injection amphotericin B.
Yes, sir.
In which cases you are giving?
Sir, we have a protocol of sending MRI orbit and paranasal CT scan in all the patients suffering from periocular lid edema, and after culture biopsy for fungus. And as soon as the fungal report comes, we start with peribulbar injection of around 3 mg per 2 ml.
Yes, we should not wait for progression. We should intervene early so that we can
Yes,
get
sir.
better results.
There was a question from Dr. Gadekar madam. She has asked that, did you notice any common factors in bilateral disease, Dr. Jinil?
In bilateral disease, the thing which I noted was that they had a glycemic index of more than 11. HbA1c value they had of 11, and they were on long steroid treatment, and most of them were on BiPAP or on constant oxygen and were admitted in the hospital.
Okay.
Hello?
Any more questions, judges?
No, sir.
Okay. The next presenter is Sneha
Thank you, sir.
Kukreja. Dr. Sneha?
Yes, sir. Just say.
Yeah, you can start. Yeah.
Good morning. Myself, Dr. Sneha Kukreja, first year resident. I would like to thank BOA and MOS for giving me this opportunity to present the case. My case is multifocal intraocular lens in children with unilateral cataract, a boon or bane. An 18-year-old girl came with complaint of diminution of vision in left eye. She had a history of left eye cataract surgery with multifocal done 5 years back elsewhere. Prescribed glasses elsewhere with several follow-ups, but was not compliant with glassware. On examination, in the right eye, she had clear lens. Left eye, well-centered diffractive IOL was present with PC opening. IOP was within normal range. On fundus evaluation, she had 0.3 to 1 cup disc ratio in both eyes. On Bird's 4 dot evaluation, she had left eye suppression. Stereopsis, 400 arcs second with pseudo-flight test. She was diagnosed with posterior molar cataract in left eye with vision 624 and was advised cataract surgery, which she underwent elsewhere in October 2014. A multifocal IOL Vayner plus 23 diopter was put as per records. In 2015, when she came for follow-up, she had developed myopia, slight myopia, requiring 0.5 steer in right eye, and left eye She was unaided 624 and improving to 69 parts with 0.75 spherical and 0.5 cylinder at 160, near vision being N6. In 2016, her left eye correction required was more, 0.25 spherical and 0.5 cylinder at 160, improving to 69. And this time her near vision was N8. In 2018, her left eye correction was in minus 4.5 spherical and minus 1 cylinder at 160, improving again to 69. And this time she required near vision glasses also around plus 2.5. Her unaided near vision being N18. So there was a myopic shift of around minus 5 spherical diopter with also need of near add in the multifocal eye in a span of 5 years. Why multifocal was chosen for her? Limitations of some monofocal IOLs in children with unilateral cataract are probably limited depth of focus. Monofocal IOLs cannot provide clear vision for distance and near. Monovision techniques may be helpful, but some patients but involve sacrifices in binocularity, and reading spectacles are required. Some review of literature show that multifocal IOLs being effective in pediatric age group, with up to only 2 children requiring, in this particular literature, 2 children requiring additional near correction. The queries that need to be addressed when choosing IOLs. As this patient was 12 years old at the when cataract surgery was done, she was chosen. She was probably treated like an adult, and these factors were considered. Centration problems, as this was considered. IOL power calculations, she was probably treated as adult, so the emetropia was targeted. Use of silicone oils, since Rayner was used, which is an acrylic IOL, so it was a better option, and centration problems were also not present there. Embryogenic effect of multiple overlapping images in case of multifocal IOLs is present. Then there is decreased contrast, tolerability of glare, that needs to be considered by choosing. One diopter of uncorrected corneal astigmatism may impair image formation in a multifocal system. Posterior synechiae also to be considered. Now, proper IOL power is difficult. Benefit from multifocal optics, the postoperative distance diffraction should be very close to emetropia. There is formation of multiple images in multifocal IOL, so it may prove to be a stronger embryogenic stimulus than ordinary optical defocus alone. Will decreased contrast sensitivity also present in case of multifocal IOL further contributes to amblyopia. Glare is again a recognized drawback of multifocal designs. Queries as such, was she an ideal case for multifocal? This totally depends on the operating surgeon. However, as care should be taken in case of pediatric patients. Did the multifocal achieve the goal it was?
You have 1 minute.
As the multifocal IOL's purpose is to not require refraction, in this case, this was not achieved. What next for her? There are a palette of available options. Prediction of myopic shift per operatively should always be considered, and targeted refraction is always 0. Take-home messages, caution should be used when considering the insertion of multifocal IOLs in children outside of research protocols, especially in children who are at risk of amblyopia. Corneal astigmatism should be considered greater than 1 diopter in the surgical eye, can cause further disruption of images. Associated ocular pathology present, such as corneal or iris abnormalities, uveitis, or microphthalmos. Caution should be taken in cases of traumatic cataract, lens decentration, pupillary abnormalities. Converting these considerations will convert the potential advantage of multifocal optics into a liability. Thank you.
Dr. Gadekar madam has asked, hello, Dr. Sneha.
Yes, sir.
Yeah, Dr. Gadekar madam has asked, how much refractive error do you get for each millimeter increase in axial length?
For each growth for about more than 2.5 diopter. 1 mm increase causes 2.5 diopter.
Okay. The next presenter is Dr. Millie Arora.
Yes, sir. Good morning, sir.
Yeah. Go ahead, doctor. Share your screen. Hello.
Hello. So could you see my screen? Hello.
Yes, continue. Yeah.
Yeah, you can start, doctor.
Okay, thank you, sir. Good morning. I'm Dr. Millie Arora, and I'm a second-year ophthalmology resident, and today I will be presenting Perinaut syndrome. My case, an 18-year-old girl presented to the OPD with chief complaints of acute onset of binocular diplopia, especially on waking up from sleep when looking up and down. The duration of the diplopia was since 1 week. There was also left-sided headache and left eye pain associated with the diplopia. There was no history of projectile vomiting, transient visual obscuration, diminution of vision, or photophobia. There was also no history of trauma or any other prior medical conditions. Neurological symptoms were absent. For ocular examination, for the right eye, my patient's best corrected visual acuity was 6.6 with minus 1.25 cylinder at 180, and left eye being 6.6 with minus 1 cylinder at 10 degrees. Anterior segment for both eyes were normal. Posterior segment was normal. On demonstrating EOM, there was minus for elevation restriction and minus to depression restriction in both the eyes. Pupils demonstrated a light near dissociation. There was also characteristic convergence distraction nystagmus present and a Collier sign present, which is bilateral lid retraction. This was the 9-gaze photo of my patient, which demonstrated orthophoria in primary gaze and a minus for depression, minus for elevation restriction and minus to depression restriction. This is a video that I'll be showing of light near dissociation, wherein there is no reaction of the pupil to light. However, there is reaction to pupil to a near reflex. This other video showing the extraocular movement restriction, especially convergence and elevation and depression. As you can see, there is a restriction of movement, especially up gaze and down gaze. After which an MRI an MRI of brain on orbit was advised to the patient. MRI brain revealed a tiny acute non-hemorrhagic infarct in left half of the midbrain involving the pre-aqueductal gray matter. MRI orbit showed no significant abnormality. Thereby, a prompt referral to the neurology department was done, such that the patient received the prompt treatment. The neurological department investigated the patient thoroughly. Thereby, the basic investigation, including the CBC, ABG, chest X-ray, ECG, 2D echo, CSF analysis, was normal. There was also a thrombophilia screening taken place for the patient, which was also within normal limits. COVID RT-PCR was done for the patient, which was also negative. And autoimmune profiling was done for the patient, which also came out to be negative. The general condition of the patient was fair, and the systemic examination was within normal limits. Thereby coming to a diagnosis of Perinaud syndrome with a midbrain infarct. So the treatment advised to the patient was low molecular weight heparin and antiplatelet agents. There was improvement in depression after 2 weeks, but elevation limitation had remained. Patient could not afford prism therapy. Since there was no improvement, since there was a lot of improvement, no surgical intervention was needed. Further follow-ups were only by telephonic conversation. When the parents reported marked improvement, there was non-compliance of follow-up due to scare of COVID-19. Now, coming to the discussion of Perinaud syndrome, also known as a dorsal midbrain syndrome. This syndrome has characteristic features of upgaze palsy, defective convergence, light near dissociation, lid retraction, which is known as Collier sign, and convergence retraction nystagmus. Etiology being in children, aqueduct stenosis, meningitis, pneumoloma; in young adults, demyelination, trauma, AV malformation; in elderly, midbrain vascular accidents and mass lesions involving the preductal gray matter and posterior fossa aneurysm. Meningitis, tuberculosis, or sarcoidosis should be ruled out. Pathophysiology. Now, why are we finding this upgaze palsy? Upgaze palsy occurs because of the involvement of the vertical gaze centers. These vertical gaze centers are in close proximity to the superior colliculus. The vertical gaze centers being rostral interstitial nucleus of the medial longitudinal fasciculus and interstitial nucleus of Kajal. Convergent distraction nystagmus is the other characteristic feature, which is characterized by an irregular, jerky nystagmus associated with convergence and retraction of both eyes, especially on attempted upgaze. Why this is happening is due to damage to the supranuclear fibers, which have an inhibitory effect on the third cranial nerve. So, since there is damage to the supranuclear fibers, there is constant stimulation of the superior rectus and the inferior rectus, thereby resulting in retraction of the globe. Now, one more characteristic feature, which is light near dissociation, happens due to poor pupillary constriction to light, but preserved constriction to convergence, like we saw in the video. This is because the pupillary light reflex fibers synapse at the pretectal nucleus and then pass to the heading vespal nucleus of the same site, and the contralateral side through the posterior commercial, making them susceptible to external compressive effects of mass lesions. It's thought that the fibers for the near reflex are located more ventrally, thereby spared in Perinaud syndrome. This is the diagrammatic demonstration of all the anatomical features and their close proximity. Investigation and treatment for this patient is neuroimaging, serological investigation, treatment of underlying etiology, presence in case of binocular symptomatic diplopia. Bilateral inferior rectus recession can also be done in presence of abnormal head posture. To summarize my case, a classic presentation of dorsal midbrain syndrome. Characteristic triad was seen. Since all the investigation and evaluation was normal, etiology being embolic stroke of undermined source. Thank you.
Thank you, Dr. Mili. Dr. Gurudasani, any questions?
So, in your case, you were satisfied with the neurological evaluation? Was it done by a proper neurophysician or?
So we also did a basic evaluation as an ophthalmologist. Then we referred the patient to the neurology department, which carried out a systemic neurology evaluation, which came up to be within normal limits. However, its MRI revealed the infarct.
You don't investigated her for torch infections. Toxoplasmosis can be a cause for this condition.
I couldn't hear your question, sir.
Toxoplasmosis can be a cause for this condition. You haven't done torch, investigated for torch.
Yes, sir, could have been a possibility, but there was an infarct would have been a more possibility. That's why we went ahead with an MRI, because it had to be a very prompt decision and management had to be very prompt. So we first went ahead with an MRI and referring to the neurology department, which could actually manage the patient.
My worry was, as you told, that the patient lost follow-up, that she was completely neurologically evaluated or she lost follow-up?
No, sir, she was evaluated, sir. Neurologically, she was evaluated definitely, but ophthalmically for a longer follow-up, that was a little difficult because of COVID-19, sir.
Okay.
Yes, sir.
Okay, our last presenter is Dr.
Thank
Nishika
you.
Jain. Yeah. Thank you, Dr. Milia.
Yes, sir. Good morning, everybody. I am Dr. Nishika, first year resident. I would like to thank BOA and MOS to give me this opportunity to present my case. I'm presenting a case of type 3 Duane's retraction syndrome managed with lateral rectus recession with Y split. My case is a 10-year-old girl with complaints of outward deviation of right eye since birth, with gradual progressive diminution of vision in both eyes since past 3 years. No history of diplopia or glasses or patching or any surgical history in the past. There were no other systemic complaints or family history of squinting. Her pre-op 9-gaze picture shows us there is 10 degrees of exotropia, which increases on elevation, grade 4 upshoot on attempted adduction, and decreased adduction in the left eye. On examination, she had abnormal head posture of right face turn of 15 degrees. On sensory examination on word 4 dot test, fusion for distance was present. 100 arc second stereopsis on Titmus fly test. Hirschberg test showed 15 degrees of right exotropia. On alternate cover test, primary deviation of 20 degrees exotropia, and on secondary deviation, 30 degrees of exotropia. On ophthalmological examination, her extraocular movements showed -3 limitation of abduction and -2 limitation of adduction in her left eye, and narrowing and severe upshoot and downshoot on adduction. She was diagnosed by left eye exotropia type 3 Duane's retraction syndrome, narrowing of palpable fissure on attempted adduction associated with severe upshoot and downshoot. Surgical correction was planned. On forced duction test, she was strongly positive for lateral rectus. A lateral rectus recession of 8 mm with Y split of around 20 mm vertical separation was done. The splitting of lateral rectus muscle lessens the lateral slippage of the muscle and recession reduces the torque. Post-operatively, patient had correction of head posture. She was orthophoric for distance and near, and there was complete disappearance of vertical shoots. Here we can see she was orthophoric and there was complete disappearance of upshoots and downshoots. Surgery. Other surgeries that are available are lateral rectus recession of the affected eye for exotropia and globe retraction, lateral rectus periosteal fixation for exotropia, abnormal head posture, and adduction. Introduction. Duane's retraction syndrome is a restrictive type of concomitant strabismus characterized by limitation of adduction or abduction due to abnormal paradoxic innervational impulses to horizontal recti, narrowing of palpable fissure and retraction of globe on adduction, occasionally accompanied by upshoot or downshoot due to co-contraction of horizontal recti with globe slippage under a tight lateral rectus. It's a type of congenital cranial disinnervational disorder. Huber's classification showed that there are three types. Type 1, adduction more limited than adduction. Type 2, adduction more limited than abduction. Type 3, both adduction and abduction are limited. The other non-surgical treatments are correction of refractive error, treat amblyopia, presence of small abnormal head posture. Indication for surgery are large angle primary gaze squint, significant face turn, disfiguring retraction of globe, up or down shoot on adduction. Y split. The overshoot of the globe in adduction is believed to be the result of a bridle or leash effect caused by a tight rectus muscle that slips over or under the globe as the eye adducts. Y splitting of lateral rectus is used to treat upshoots and downshoots. The lateral rectus is split horizontally in half from the insertion, spreading the muscle around 20 mm apart or more, depending on degree of exotropia in primary position. Our patient improved with lateral rectus recession and a Y split of lateral rectus, thus proving the effectiveness of this procedure in type 3 Duane's retraction syndrome. Here we can see that the lateral rectus was split 20 mm apart and was sutured 8 mm behind the insertion. These are some literatures that proved the effectiveness of Y split with lateral rectus recession. Thank you.
Dr. Nishika,
Yes, sir.
was there any abnormal head posture in this patient?
Yes, sir. Right face head turn, sir.
Okay.
Ma'am, the pathophysiology is still unknown. Most of them say that it is due to the abnormal innervation to lateral rectus because of the sixth nerve. So because of sometimes the third nerve supplies both the lateral and the medial rectus, and that's why it leads to co-contraction.
Hello.
Yes, ma'am.
Yeah. Any questions, judges?
No, sir.
Yeah. Madam Gadekar has asked a question, Dr. Jain. Do you know myogenic theory?
Myogenic theory of autoregulation, sir.
Yeah.
Myogenic theory of autoregulation, it states that it's like an intrinsic property of blood vessel. It's more specific to vascular smooth muscle, and it regulates the vascular tone in response to the intraluminal pressure.
Okay. Thank you, Dr. Nishika.
Thank you, sir.
Yeah, we are finished with our presenters today. I thank all the presenters for their excellent presentations. And I also thank the judges Dr. Manjunath Patil, Dr. Sarika Gadekar, and Dr. Bhavishya Gurudasani. Thank you.
Thank you,
All,
sir.
yeah. Judges, they will mark the points and hand it over to the BOA members. And I think we'll end the session now. Give it.
Thank you, sir.
Yeah.
Thank you.
Thank you, ma'am.
Thank you, sir.
The next session will be starting by 12 o'clock.
Hello. Hello. Sai?
Yes, doctor. Yes, doctor.
Technical team, can you please help Dr. Pankaj Shah with the case?
One second.
Hello.
Hello. Yes, doctor.
Hello, sir.
Yeah.
Sir, I think Dr. Pankaj Shah is having a problem with voicing. He's not able to. He's unmuted. He's still not able to speak. Can you please?
Yeah, we are able to hear you now.
Yeah. I think you are muted from your end.
No, doctor. I think you wouldn't have joined audio. Now it's audible.
Now it's audible, no?
Yeah.
Okay. Thank you.
Welcome.
Good morning, Dr. Penke, sir. Welcome.
Good morning. Are you hearing me?
Yeah, yes. Can hear you.
Yeah. Okay.
Dr. Atnur sir has also joined, I think.
Yeah, he has joined, I think.
Yes, hello.
Good morning,
I'm here.
sir.
Very good morning.
Welcome. Dr. Pankaj Shah here.
Yeah. So nice to see you.
Waiting for Dr. Uday Mohite. Has he joined?
I don't think so.
We have in all 8 free papers to be presented.
Yeah, right. Am I audible?
Yeah.
Is there any problem in the network or anything?
No, I don't feel.
Okay, take.
I think everyone was muted previously. There was some issue. Maybe the previous session is ended earlier.
Because I can't hear you properly. The voice is breaking.
Good afternoon, everyone.
Hello, good morning, Sumit.
Good morning, sir. Sir, I just spoke to Uday Mohite, sir. Sir said there is some electricity issue and his phone issue. He's trying to connect, but he's not sure about the joining.
Okay.
So then we would continue with the permission from the respected judges. Penke sir and Atnur sir, if you permit, then we can start the session right now itself also. Sir.
Yes, start.
Yeah.
Start.
I think.
Yes, sir. Over to you.
Yeah, we can.
Good afternoon, all of you. I welcome you for this free paper session. We have judges with us, Dr. Uday Mohite, Dr. Sudhir Penke, and Dr. Virendra Atnur with us. As rightly now said by Sumit, maybe there is some issue with Dr. Sudhir Penke. He will join. Dr. Uday Mohite, he will join shortly. I will introduce both our judges. Dr. Sudhir Penke, he is a professor and HOD of Government Medical College, Yavatmal, and he has a Best Teacher Award in 2010. Dr. Atnur sir has worked in Government Medical College, VM Medical College, Solapur, and he is into private practice now. And he always wants to say that he remains a student of ophthalmology since 30 years. Dr. Uday Mohite is also professor and HOD of Government Medical College, Latur, and he's been a chairman of Board of Studies of MUHS. So I welcome you all, and let us start with the first paper. Dr. Chetan Bhaviskar, are you there?
Yes,
Dr.
sir.
Chetan?
Yes, sir. Yes, sir.
So please, he will be presenting a paper on describe a case of anterior nodular scleritis preceded by anterior uveitis, probably due to SARS-CoV-19 viral exposure with similar presentation like VZV viral scleritis. You may start, please.
Yes.
I request the next speaker to be ready, Dr. Punit Devi.
Is my screen is visible?
Yes.
Good afternoon, everyone. This is a case of nodular scleritis, probably due to associated with the SARS-CoV-19 virus and infectious and immune-mediated process, a case report. So in this study, we described the case of uniocular nodular scleritis in the 33-year-old female with a previous episode of anterior uveitis in the same eye 6 months back. A probable diagnosis of autoimmune variety of the scleritis was established through the exclusion criteria and a previous exposure of the SARS-CoV-19 and the presence of COVID-19 antibodies without any history of any vaccination. So scleritis is defined as any inflammation of the sclera, which broadly classified as the anterior and posterior. Anterior is subdivided into diffuse, nodular, and necrotizing. Immunologically mediated disease are the main disorder associated with the scleritis, which in which the systemic involvement and other are restricted solely to the eye in the organ-specific autoimmune disease. The infections are the important but less common, occurring in 5 to 10% of the patient presenting with the scleral inflammation. Within the infectious agent, the varicella zoster is the most common virus often implicated. The role of SARS-CoV-19 virus well implemented for the immunogenic reaction over the most of the research published till now, and the direct invasion and the host immune reaction to the virus are the most pathophysiological mechanisms which are already proposed. The individual case of the infection scleritis with SARS-CoV-19 exposure, which improves after immunosuppression and the anti-inflammatory treatment, supporting the immune-mediated hypothesis after the ruling out the active SARS-CoV-19 infection throughout the treatment. So this case of 33-year-old female, which came with the chief complaint of pain, redness, and intermittent discharge since last 2 weeks. There is no other relevant history, but there was a history of the anterior uveitis in the same eye, which was treated 6 months back, and which was also associated with the respiratory tract infection, to be specific. External eye examination was normal. Both eye, lid, cornea, anterior chamber, lacrimal apparatus, even fundal examination was normal. Visual acuity in the right eye was 6/12. Conjunctiva shows the congestion in the bulbar conjunctiva and the palpebral conjunctiva. There is hyperemia, chemosis, and small congested nodules on the perilimbal area with a reduced corneal sensation, and the photophobia was present. Slit lamp examination showed spine keratic precipitate, iris pigmentation on the anterior capsule, and the atrophic areas on the iris, which shows the previous episode of anterior uveitis. All relevant investigation done with the current scenario, and rapid antigen for the COVID test also done. P scan done to rule out the posterior scleritis, which came normal. Rest all investigation found to be negative, including the SARS-CoV-19 rapid antigen. But the SARS-CoV-19 IgG antibodies, which are the S1 protein specific, titer came more than 20 index, showing the recent COVID-19 infection with the antibody formed, since the patient was not vaccinated yet. So treatment started as a topical moxifloxacin, prednisolone, and atropine and timolol. Oral medication also started with the prednisolone with a tapering dose, and the ibuprofen and the acyclovir started as 800 mg for 5 days. Post 2 weeks, there is no reduction in signs and symptoms regardless of the treatment given. So we continued the prednisolone with the tapering dose again. So post 2 months, patient present with the resolution of the pain and the congestion, but dense bluish hue on the circumferentially. But surprisingly, we get the lower down. With the lower down the antibody titer for the SARS-CoV-19 at that time of resolution, which was 1.15 index. Further assessment for the treatment, mostly for the post-vaccination follow-up, to see the any antigens flaring up the same symptoms or not. So, in current case of anterior nodular scleritis presented as a reddish and tender scleral nodule, this clinical picture was indistinguishable from the immune-mediated scleritis. In our case, the patient presented anterior uveitis with a diffuse keratic precipitate preceding the scleritis. This uveitis probably associated with the herpetic viral disease, but which was not supported on the PCR on presentation. Though the SARS-CoV-19 antibodies were detected with the ELISA and CLIA, shows the patient was exposed with the SARS-CoV-19 very recently, and the aggravating eye symptoms in the same post-uveitic eye. Infectious scleritis most
You have 1 minute left.
SARS-CoV-19 likely triggered an immune response that accounted for the inflammation. The viral-induced autoimmune reaction is thought to be linked to the release of sequestered self-antigen after viral-induced tissue damage and molecular mimicry between the viral and cell peptide. This phenomena involves the immune complex vascularitis of the eye. The clinical resolution of the scleritis using the anti-inflammatory therapy argues in favor of underlying autoimmune process. On the other hand, the detection of SARS-CoV-19 exposure and high titer of antibodies strongly support a probable relation between the infection. So conclusion, it is a critical for the eye care profession to maintain the infectious etiology of the differential on their in differential diagnosis. This report suggests that the case of nodular scleritis after negative varicella zoster, one should think about the exposure of the SARS-CoV-19 virus may also present as immune-mediated component. And ELISA and CLIA are the valuable technique. Patient consent was taken with appropriate patient consent forms, and these are my references. Thank you, sir.
Hello.
Hello.
Hello. Chetan, can you hear me?
Yeah, yes, sir. I can hear you.
What made you think that it is because of the COVID-19 infection rather than a sequelae of a herpes zoster uveitis?
Actually, sir, patient presented after 2 weeks of his symptoms, and patient had a history of any cough and cold, but patient not reported to any hospital. So we did antibodies, and antibodies came huge, like more than 20 in this patient. So shows the recent COVID infection and flaring of the same symptoms.
It might be incidental finding. Anybody, most of the people or those who are having URTI now will come up with a positive antibody titer. So what links the scleritis to COVID?
Sir, in the
you said it's an infectious etiology of COVID.
Yes, sir.
So is there anything to substantiate that claim?
Sir, actually, we did varicella zoster PCR also for the same patient, which came negative. So, and the other reports also came negative. So we thought of like it can be induced by any COVID related antigen.
But you said the corneal sensations are reduced.
Yes, sir. At the time of patient when presented, that time it was might be a super infection with the any bacterial infection also.
No. Reduced corneal sensations you can't explain by bacterial infection.
Corneal sensation was reduced by the same patient.
Okay, because all the history suggests of herpes zoster, and suddenly you say it might be because of this COVID.
So it is a most probable differential diagnosis for the if the varicella zoster is coming negative.
Okay. So it's a immunological reaction or an infection of COVID?
There is immunological reaction, I feel, because of patient showing the more of antibody titer, and patient was negative on the COVID test, which we did. And the next time when patient having the relieved from the all redness and congestion and any other problem, that time again we did the antibody testing. Then the titer was very less than the previous one we found.
Okay, because acyclovir was given. Why acyclovir was given?
So at that time we was like in the both diagnosis we are considering it can be due to varicella zoster also, or COVID-19 was the probable most probable differential diagnosis. So we don't want to miss this varicella zoster etiology in between. So we gave as the empirical acyclovir for 5 days to the patient.
Okay. Suppose it's a COVID infection. How does COVID affect a tissue? Means suppose it's a scleral infection by COVID virus. How does COVID virus act? What is the pathophysiology? Nobody knows exactly how it is.
The COVID virus relate with the more of giving a more similarity between the herpes zoster virus also.
So it causes inflammation and then vasculitis and vascular occlusion.
Yes.
There are three things. One is inflammation. Second is occlusion of the vessels. So are there any signs of vascular occlusion here?
Yes, sir. Scleral involvement was huge in this patient. After relieving the symptoms, the patient was having the bluish hue and shows the thinning of the sclera.
Okay. What are different types of scleritis, anteroscleritis?
Nodular scleritis, any diffuse type of scleritis, then necrotizing scleritis,
so you should get a necrotizing type of scleritis in case it's a. You can think on those lines actually. Okay, okay, it's okay. Any other question by the other judges or moderator?
Dr. Penke, sir, any questions from your side?
Yes. See, are you hearing me, Dr. Chetan?
Yes, sir. Yes, sir.
Now you are treated this patient on viral herpes zoster.
Yes, sir.
All treatment given by you to treat this patient is a viral etiology of herpes zoster. And now you are saying that it is in COVID. So how you can differentiate it?
Sir, actually, it was more of similarity between the viral antigen like herpes zoster.
No, it is not, sir. It is not proved that COVID-19 will be this acyclovir will be helpful.
No, sir, it's not proved, but as a we was like considering as a varicella zoster also in the second differential diagnosis in that main important diagnosis. So we thought of giving the acyclovir together with this.
Okay, but you are treated. Okay, very good. Try to that say that it may be a COVID. It may be a COVID. Possibly it may be a COVID, but you are treated this patient on the line of viral etiology, means varicella zoster.
Yes, sir.
Yeah. Okay. Thank you very much.
Thank you.
Okay, thank you.
Can we move on to the next presentation?
Yeah, please.
So next, Dr. Puneet Devi. Paper presentation will be on effect of cataract surgery on macular thickness in diabetic patients. Dr. Puneet.
Sir, am I audible?
Yes, yes.
Yes.
So my slides are visible?
Yeah.
Yes.
Thank you, sir.
Please go ahead.
Yes, sir. Good afternoon, everyone. Myself, Dr. Puneet. Today, I would present paper on effect of cataract surgery on macular thickness in diabetic patients. India has estimated 8.7% diabetic population in age group of 20 to 70 years. WHO has labeled India as diabetic capital of the world. It estimates that there will be 370 million diabetic people by 2030 worldwide. Diabetes causes both micro and macrovascular complications. Diabetic patients are 2 to 5 times more likely to develop opacification of lens at an earlier age. Up to 20% of all cataract surgeries are performed in diabetic patients. Cataract surgery may cause rapid acceleration of retinopathy, induce dysbiosis, or lead to macular changes such as macular edema. Macular edema is one of the most common cause of visual loss after uncomplicated cataract surgery nowadays. Altered concentration of angiogenic factors and disruption of blood-retinal barrier after cataract surgery may aggravate maculopathy. Aim of my study is to study the effect of cataract surgery on macular thickness in diabetic patients. My objectives also included to assess the worsening of macular edema in diabetic patients with pre-existing macular edema, to study the correlation of macular thickness with grade of diabetic retinopathy. This is prospective comparative study. Total 200 subjects, 100 diabetics and 100 non-diabetics were enrolled for the study period of 1 year. The data was collected in Microsoft Excel sheet and was analyzed with IBM SPSS Statistics Software 23.0 version. Probability value of 0.05 is considered as a significant level. Inclusion criteria. We included all patients with cataract of either gender above 18 years of age. Study group included a known case of type 2 diabetes mellitus, patient having fasting plasma glucose more or equal to 126 milligram per deciliter, and 2 hours postprandial plasma glucose more or equal to 200 milligram per deciliter. Control group, patient with no past history of type 2 diabetes mellitus and fasting plasma glucose less than 126 and postprandial blood glucose less than 200 milligram per deciliter. We excluded patient with any complication during cataract surgery, patient with any ocular or systemic condition that can cause macular edema, patient with any ocular trauma, patient with history of vitreoretinal surgery or glaucoma surgery in the same eye, patient with presence of retinal or choroidal disease other than diabetes in the same eye, patient with history of treatment of DME or PDR within 6 months prior to surgery, patient with any ocular or systemic illness which will hinder fundus examination and OCT examination, patient not signing informed consent. Methodology. Patient selected for cataract surgery after fulfilling inclusion and exclusion criteria were subdivided into study group having diabetic patient with cataract and control group containing non-diabetic with cataract. Informed consent was obtained. Detailed ocular and systemic examination, systemic history was taken. Cataract surgeries were performed by experienced surgeons. Pre-operative and post-operative investigations included BCVA, slit lamp examination of anterior segment, slit lamp biomicroscopy of fundus using plus 90D lens, IOP measurement, dilated fundus examination. Study group patients were evaluated for fasting and postprandial glucose level and HbA1c level wherever required. OCT by Cyrus HD OCT for macular thickness evaluation was used for pre-operatively and post-operatively at 1 month and 3 months. Follow-up of the patient was done at first week, 1 month and 3 months. In our study, age of the patient enrolled ranged between 41 to 89 years with mean age of 61 plus minus 10 years. Diabetic group had 47 males and 53 females, and non-diabetic group had 53 males and 47 females. We observed that 24% diabetic group had NS4 and 20% had PSC with NS3, but only 3% non-diabetic had NS4. This difference is highly significant. Sheffers et al. In the study found similar results. Pre-operatively, diabetic mean BCVA according to log MAR was 1.25, which improved to 0.43 at 3 months post-op, but non-diabetic achieved better visual acuity, improved from 0.67 to 0.11. Zen XY et al. Had a similar results. 20 patients with diabetic retinopathy had pre-existing CSME and worsening was observed in moderate and severe NPDRs. In our study group, we observed that after 1 week post-op, no progression in retinopathy grade was seen, no development of CSME in any new subject. But after 1 month post-op, 8 eyes with moderate NPDR developed CSME, 6 eyes with severe NPDR developed CSME. In control group, 5 eyes developed CSME. Mean CFT in diabetics increased from 263.88
You have 1 minute left.
Yes, ma'am. 287.06 post-op 1 month and decreased to 242.60 post-op at 3 months. Whereas in non-diabetic, mean CFT increased from 220.13 to 243.06 post-op first month and decreased to 228 at 3 months. This finding was significant. Zen XY et al. Found a similar result. We concluded that cataract surgery causes significant increase in macular thickness 1 month post-op in both diabetic and non-diabetic. Cataract surgery does not contribute to progression of stage of diabetic retinopathy. A positive correlation was seen in macular edema preoperatively and in post-op at 1 month, and at 3 months post-op, a declining trend was seen in the incidence of CSME. These are my references. Thank you.
Okay. Can you hear me?
Yes, sir.
The OCT readings were taken pre-op as well as post-op.
Yes, sir.
So in case there is a significant cataract, how could you take the OCT readings in those cases?
Sir, there was only one patient in which fundus OCT and the fundus examination could not be conducted. And after cataract surgery, we found that there was no diabetic retinopathy changes in that patient.
Okay. But here we are talking about the macular thickness.
Yes, sir.
The title is Effect of Cataract Surgery on Macular Thickness. So you should have a pre and post macular thickness reading in every case.
Yes, sir. Out of 100 subjects, only one patient was there with diabetes, in which we could not assess the macular thickness.
Was that patient excluded?
Yes, sir.
You are saying that one patient had.
So that patient was included after cataract surgery.
Why? Why that patient was included? The title says that effect of cataract surgery on macular thickness in diabetic patients. So, okay, forget it. So, which OCT was used?
So it was Zeiss OCT.
So what kind of OCT?
So Cyrus HD OCT 500, which was which is spectral domain OCT.
Okay. What are the other types of OCTs?
So other type of OCTs include one So spectral domain OCT is the most the TopCan OCT is also there.
No. This one is spectral domain. Do you know any other like time domain or swept source?
Yes, sir.
What is the difference? Okay. Oh, forget about it. What is Ewing gas syndrome? Okay. Okay, sir. Penke, sir, any questions?
Yeah. You have said that preoperatively you had seen some pathology in the diabetic eye.
Yes, sir.
Yeah. So you treat the diabetic eye pathology before the cataract surgery or after the cataract surgery?
Sir, patient which had taken any treatment for diabetic retinopathy prior to 6 months of the surgery, we have not included those patients.
No, sir is asking if the patient is having significant macular edema, whether you treat that edema before surgery or after surgery.
Sir, after surgery.
No. How? Why do you know how will you classify the significant macular edema?
Yes, sir. Sir, if there is edema, retinal thickness within 500 micron of the center of the macula, or if there is exudates which are within 500 micron meter of center of the macula, or retinal thickness outside 500 micron, or if there is a retinal thickness one disc area that is around 1500 micron meter or larger.
What is the treatment of ischemic macular edema, diabetic macular edema?
So we will give NSAIDs and we will observe it, and if it is not improving, then we can proceed to.
He is asking ischemic macular edema, the one with lots of non-perfusion areas. Okay, what is the role of intravitreal VGFs for treating macular edema in relation to cataract surgery?
Cataract surgery after
There is a
cataract
patient. The question
Yes,
is,
sir.
there is a patient who is having macular edema who is also having cataract surgery. Is there any role of anti-VEGFs in this case?
Yes, sir. So VEGFs are released after cataract surgery. So these inflammatory mediators, they when they are released into vitreous and retina, they causes vasodilation and they disrupt blood retinal barrier. So anti-VEGFs, they are helpful in such cases.
These are given after cataract surgery, during cataract surgery, or before cataract surgery?
So in our study, we have given it after cataract surgery.
Okay.
Thank you, sir.
Okay.
Can we move on to the next presenter?
Yeah, we can go.
Good afternoon, everyone, sir.
Yeah. Dr. Geetu Niruba.
Yes, sir.
You will be presenting on pathognomic chorioretinal lectin in ARKT syndrome, correct?
Yes, sir. Sir, I could not share my screen. Okay, sir. I could now, sir. Sir, is my screen visible, sir?
Not yet. Yeah, it's visible.
I'm going to present a case report on ARKT syndrome. A 22-day-old of newborn female is referred from the pediatric department to a department as a case of ARKT syndrome.
Is it a full screen?
Yes, sir. It's a full screen, sir.
She's presenting on mobile, I suppose. Sir. Can you keep
Okay.
hold your mobile horizontal? It might become
okay,
larger for us.
Okay, sir.
Yeah, that is better. Yeah.
Continue, please.
Okay, sir. A 22-day-old newborn female is referred from the pediatric department as a case of ARKT syndrome for fundus examination. The antenatal period is uneventful. The child was born after a normal delivery with to a G1 para1 live 1 24-year-old mother with history of parental conservativity. At 19 days of life, she was presented to the pediatric department with abnormal movements of the upper and lower extremities. On examination, the child was found to have an spastic extremities with an axial hypotonia. An EEG was done, which showed a hip submit pattern, which is characteristically seen in infantile spasm. Investigation was done, and investigation showed a normal serum calcium, electrolytes, TSH, and creatine phosphokinase. MRI brain of the child was done, which showed the following features. It showed a complete corpus callosum agenesis, colpocephaly with a porencephalysis, asymmetry of the cerebral hemispheres. And this is a T1 axial plane, which showed a colpocephaly, which is a prominent occipital horn of the lateral ventricle with a porencephalysis, which is hyperintense on T2. And this is a sagittal image, which showed a agenesis of corpus callosum with a periventricular heterotopia. And this picture shows a morphed cerebral asymmetry. A fundus photo of the right eye of the child showed a multiple normal disc with a multiple chorioretinal lacunae around the disc with retinal areas of depigmentation. The fundus photo of the left eye showed an optic disc coloboma with a choroidal coloboma with a multiple chorioretinal lacuna around the disc with retinal areas of depigmentation. So discussion, Riccardi syndrome is an X-linked dominant disorder, and the hypothesis is that it's due to the skewed mutation in the short term of the X chromosome in utero, and this syndrome is almost always seen in the females because it's lethal in the males in utero. And but some cases have been reported in the male children with an additional X chromosome like a Klinefelter syndrome. Though this hypothesis, so the hypothesis is that it occurs, it's as a sporadic pattern in embryology. There is also few reported cases which showed an inherited pattern. So this is the inherited pattern. Only the females are affected and the males die in utero. And this is the triad of Riccardi syndrome. It is characterized by the triad of infantile spasm, corpus callosum agenesis, and chorioretinal lacunae. So this syndrome is due to the neural migration disorder. So the corpus callosum agenesis is never an isolated disorder. It's always associated with one or more of the following features, like a periventricular or subcortical heterotopia, where there is a clump of abnormal neurons. There will be asymmetry of cerebral hemisphere, and there is a study which showed that the infantile spasm will be exulated to the side of the larger hemisphere with hemiplegia to contralated to the larger hemisphere, and the intraparenchymal, which is which is not very common, unlike a posterior fossa, which is more common. And this is especially present at the posterior end of the choroid plexus in the region of third ventricle or the pineal gland region, points more towards this syndrome. And there may be altered ventricular cortex, solid tumors of the choroid plexus like papilloma can also be present, and there may be cerebral microglyria, and also polymicroglyria has also been present. And other findings like costovertebral rib anomalies, which may present as scoliosis in later age, can also be present. The chorioretinal lacunae, in the absence of one or more of the above typical characteristics, the diagnosis is formed by the pathognomic chorioretinal lacunae. And these are whitish or pinkish lesion with size ranging from 1/10 to several this diameter. And these result from the thinning of the sclera and the choroid. And they are usually bilateral, but sometimes unilateral cases have also been reported. And there was a study conducted by McGregor, which showed that the worst prognosis is associated with the lacnosis. The other eye abnormalities which can present in this syndrome may be coloboma of the optic disc, the retinal pigment epithelium may be hypopigmented or depigmented. There may be persistence of primary vitreous, microphthalmia, and anterior synechiae. And case reports, this is a rare genetic malformation which causes refractory epilepsy in the children and profound mental retardation and developmental delay. Around only 4,000 cases have been reported worldwide. And this case report has been presented in Indian Journal of Ophthalmology with the classic triad of infantile spasm, the chorioretinal lacunae, and the corpus callosum agenesis. And this report has been presented in AAO. And the first picture showed fundus photo of the left eye, which is septoptic with an optic disc hypoplasia with the chorioretinal lacunae. And the second picture shows a lacunae, peripapillary lacunae with retinal hypopigmentation. And this case report showed a multiple cortical dysplasia along with the chorioretinal lacunae. So, though the triad corpus callosum and infantile spasm and chorioretinal lacunae forms a triad, the corpus callosum and the infantile spasm may be present in many of the syndromes. So, this chorioretinal lacunae is a constant feature present in all the cases, and along with the presence of other cerebral pathology like an intraparenchymal forms the diagnosis. So, thus, in conclusion, Riccardi syndrome should be kept in mind while investigating a female children with a recurrent lesion, which is refractory to the routine antiepileptic medication with a mental retardation and profound developmental delay, and a fundus examination by an ophthalmologist can be of immense help in the diagnosis of this rare genetic disorder. Thank you, everyone. These are my references.
Okay. This is Dr. Gitu, isn't it?
Yes, sir.
What was the age of the patient when you examined that patient?
She was 22 days old, sir.
22 days old. And the photograph you have shown is of the same patient, or it's a
It's the same
photograph?
patient, sir.
So how did you take that photograph?
Sir, with red cam filter, sir.
Which one? Red
With
cam.
the red cam, yes, sir.
Okay. You have an access to red cam.
Yes, sir. In our pediatric department, sir. We used to go and take, sir.
Okay. Because that was a very good picture of retina. That's
Yes, sir.
why I wanted to know how did you take that.
Yes, sir.
Okay. So you said it's a pathognomonic chorioretinal lacunae. What do you mean by lacunae?
So these lesion which occurs due to the thinning of the sclera, the lesion which occur due to the thinning of the sclera and choroid, and
Sclera.
yes, sir, and which present along the plane of the retina. So the retinal vessels don't bend at the periphery of the lesion.
Okay. So it's a well-known triad of the spasms and the dysgenesis. So if the patient comes to you for fundoscopy, then it is pathognomonic. Otherwise, just you are substantiating the diagnosis on MRI, which is the most diagnostic feature or most diagnostic investigation in case of this syndrome.
So the MRI which shows an corpus callosum agenesis.
Yeah, right. Sir.
Yeah.
Penkes.
Yes, sir. How many children are there in 2020-21 in the world who are suffering from this disease?
Sir, around 4,000 cases have been reported.
No, around 4,000. No. Today, sir, I am asking you in 2021, how many patients have survived?
I'm not sure, sir, but the median age is 8 years, sir. Survival age.
Survival age is
8.8 years, sir.
Yeah. So that is why I'm asking you how many patients are there in 2021 in the world. There are only 300 to 400 patients which have survived.
Okay, sir.
Until now.
Okay, sir.
Now, once again, I will ask you where is the lacunae? Between the sclera or choroid, or between the choroid or the retinal pigment epithelium?
Sir, between the choroid and retinal pigment epithelium.
Yeah. So what do you, how will you see? What is the size, shape?
It may range from 1/10 of the disc diameter to multiple size the disc diameter.
Size, shape. Whether it is a round, whether it is a square, whether it is a line.
Yes, sir. A round shape, sir.
Yeah. Okay.
Yes, sir. Thank you, sir.
Can we go to the next one?
Yeah.
Dr. Monisha Apte, are you there?
Yes, sir. Am I audible, sir?
Yeah. This is an unusual case of metallic intraorbital foreign body removal and integrated approach, correct?
Yes,
Please.
sir. Is my screen visible, sir?
Not yet.
Is there any problem with the screen sharing?
Is it visible?
Yes.
Good afternoon, everyone. I'm Dr. Monisha Apte, and I'll be presenting an unusual case of a metallic intraorbital foreign body removal and integrated approach. A 16-year-old male had come to our casualty who was referred from a primary health center with an accidental trauma to his right eye with his own kada, which is a metallic wrist brace, while playing volleyball. The patient came with an intact brace which was stuck firmly below his right eye since 12 hours, causing pain and swelling. On examination, the vision was 6.6 for distance with a near vision of N6. As you could see in this image, the end of the kada was seen entering through the lower lid, causing a linear 3 cm by 1 cm entry wound with surrounding soft tissue swelling. There was no apparent globe rupture on examination. The pupils were normal sized, reacting to light. Ocular motility was, however, full, free, and in all gazes, but was slightly painful in downward gaze. The fundus examination was within normal limits. The other end of the brace was seen resting over the skin temporarily. Examination of the left eye was, however, normal. This was the X-ray orbit which was done for this patient, along with a CT orbit and a 3D reconstruction of the midface. CT orbit showed a linear undisplaced fracture of the lateral wall of right orbit. The foreign body was seen along the floor of the orbit with the end impinging within the lateral wall of the orbit at the junction of the floor and lateral wall. The 3D reconstruction of the midface was also asked for so as to understand the anatomical orientation of the foreign body with respect to the surrounding structures and whether there was any damage or not. As this was an emergency case, an MLC was done and we decided to remove the foreign body under general anesthesia with plastic surgeon and ENT surgeon on standby. The entry wound margin was extended like a subciliary incision for better exposure. The foreign body shaft was freed with blunt dissection from the surrounding soft tissues, the floor of the orbit and the periorbita. However, we faced a difficulty of removing the foreign body in toto because the knob of the foreign body was lodged within the lateral wall and the floor of the orbit, because of which we could not pull out the foreign body. The foreign body could not be pulled out by any force also because of its restriction due to the zygomatic bone, its curvature, and if we happen to pull the foreign body, it would cause damage to the surrounding structures. Thus, we decided to cut the foreign body into two halves using an H-rod cutter, which is an instrument available in orthopedic surgeries for cutting K-wires and shank pins. So we use that instrument and we cut the metallic foreign body into two halves, and thus the stuck fragment was then we could able to easily remove from the cavity. So this was the fragment which was impinging inside the orbital wall, and the knob was measuring around 5 millimeters. So we inspected the cavity on removal of the foreign body, which showed a circular defect in the lateral wall of the orbit. Similarly, there was a unicortical fracture in the infraorbital margin, which was extending up to the infraorbital foramen. So we took a plastic surgery consultation on table and decided to manage the fracture conservatively. The infraorbital nerve was intact. Force duction test was performed, which was normal for all recti, especially the inferior rectus muscle. Then we cleansed the wound thoroughly with betadine and closed the periorbita and orbicularis with 6-0 Vicryl, and the skin closure was done with 6-0 ethylone. Post-operatively, the patient had a best corrected visual acuity of 6.6 with a near vision of N6. The sutures were intact. The wound was healthy. There was no bleeding or oozing out from the wound. The ocular motility was full, free and painless, and rest other parameters were normal. So as we can see that ocular motility is a major cause of treatable visual impairment and blindness. On literature review, we found that sports and recreation activities alone was responsible for around 37 to 52% of ocular injuries, mainly affecting young children in 58 to 70% of cases. These are certain signs and symptoms requiring immediate ophthalmic referral, where in our case, the patient had an embedded foreign body which demanded urgent removal. These are certain excuses by sportsmen for not wearing eye guards, as sportsmen feel that they are experienced, as a result of which they would be protected. If any sportsman is wearing glasses, they would feel that the glasses would automatically protect them. Eye guards, however, are uncomfortable and they distort vision. And most of them feel that mandatory eye guard wear doesn't look cool on them. So they don't wear it, hereby making them prone to ocular injuries. How to manage such cases? 90% of injuries can be prevented by using protective gear. We have to use such multiple specialities of expertise in tertiary referral center to deal with such rare cases, as each case is unique in presentation and the approach towards such case has to be tailored accordingly. Prompt and effective management is essential along with removal of foreign body because this helps in preventing complications such as blindness,
You have 1 minute left.
intracranial infections. What was unique about this case? There was no damage to vital structures. Patient possessed good postoperative vision as the optic nerve was intact. There was no globe rupture despite the location of the brace being so close to the globe. Removal of the brace in toto was challenging in our case because of its shape, lodgement of its tip within the bone, its proximity to the globe and surrounding structures. We had undertaken a multidisciplinary approach for removal of the brace, and prompt and effective management was undertaken. Thus, my case highlights the effectiveness of timely intervention using multidisciplinary approach in a tertiary care center, which helps aiding better postoperative cosmesis and visual outcome. Multidisciplinary management, however, is not recorded frequently in literature because of its rare occurrence and lack of public access to tertiary referral centers. These are certain examples managed in our institute for which multidisciplinary approach was obtained. These are my references. Thank you.
Penke sir, this time you go first. Hello.
Yes, sir.
What was the end like? The foreign body was blunt at the end which went in the orbit?
So the end was blunt.
Okay. Okay. So this patient was, I think, involved in volleyball when he played.
Yes.
When he was injured.
Yes.
Suppose a person or a sportsman is playing volleyball and the second one is playing lawn tennis. In which patients will you advise goggles? Or in which sport it is more essential?
So both volleyball and lawn tennis pose a moderate risk of injury. So I think we would prefer wearing goggles in lawn tennis rather than volleyball.
Why not volleyball?
So because in lawn tennis, the ball would directly have an impact on the eye. And whereas in volleyball, most of the time, the patient would not directly have an access to the eye. And the size of the ball is also larger, and the speed with which the ball comes in lawn tennis is much faster than that of a volleyball.
So wearing of glasses wouldn't have prevented this kind of injury. This is a very, what you say, unusual kind of injury.
Yes, sir.
No amount of precautions would have. Okay. Penke sir?
Yes. Can you hear me?
Yes, sir.
When you will not remove the intraorbital foreign body?
Sir, if the foreign body is very small in size, if it's not affecting vision, or if it is close to the orbital apex or something, so we would prefer to leave the body alone. If the foreign body is inert, so we would prefer to leave the foreign body alone, because removing them will cause more trauma than leaving it alone.
Yeah. Okay. Thank you.
Suppose it's a brass foreign body or a iron foreign body, which is not affecting vision or movements. Will you remove it or will you keep it like that?
So we will remove it because it will have its toxicity in the eye. So we will remove it.
What kind of toxicity?
It will cause siderosis.
And brass one?
Brass contains copper, so it will cause chalcosis.
Okay, it's all right.
Thank you, sir.
Next, Dr. Veena Patil.
Yes,
She will
sir.
be presenting on serpiginous-like choroiditis, a case report. Please go ahead.
So my screen is visible?
Yeah.
Good afternoon, everyone. I'll be presenting a case report on serpiginous-like choroiditis. Here we have a 35-year-old female. She is housewife, resident of Pune. She came to us with the chief complaints of gradual, progressive, painless diminution of vision in the right eye since 2 months, profound worsening since last 3 weeks. On examination, the vision in the right eye for distance was counting finger at 50 centimeter. Near vision was less than N36. The anterior segment was within normal limit.
Coming to the left eye, the distant vision was 6x, near vision was N6, anterior segment was within the normal limit, and there was no RAPT noted. Then we did a dilated fundus evaluation for this patient, and we could see a grayish-white, ill-defined lesion noted at the superior arcades, both temporal and along the nasal quadrant. There is a macular involvement seen. Hyperpigmented and hypopigmented area suggestive of RPE atrophy could be seen as an old scar lesion inferiorly. Looking at the history and the fundus findings, we came to a clinical diagnosis of serpiginous-like choroiditis. Coming to the, then we went ahead and did a fundus fluorescein angiography for this patient with the early phase showing complete filling of arteries and capillaries with early laminar flow in the vein. The dye appeared to line the venous walls with actual hypofluorescent strip. The midface, in the midface, laminar venous flow was seen, and there were heterogeneous areas of hypo and hyperpigmentation. The late venous phase with complete venous filling and reducing arterial fluorescence. Active margins could be appreciated in the later phase with leakage. In the late phase, the hypofluorescence lesion is turned into hyperfluorescence with late phase leakage, hyperfluorescence of the disc, hyperfluorescence of the scarred lesion. Coming to the systemic investigation, we went ahead and did the complete blood count, wherein we could find that there was increase in WBC count with raised ESR. The serological evaluation for HIV and HBsAg was non-reactive. Immunology, C-reactive protein was raised. X-ray, AP, and lateral view was within normal limit. Quantiferon TB gold test was positive. Montauk's test was strongly positive. Coming to the management plan, thinking of serpiginous-like choroiditis, which has tuberculosis as a very common etiology, we referred the patient to a physician, wherein physician started her on ATT, that is tablet isoniazid, rifampicin, ethambutol, and pyrazinamide. ETT kills the microorganism, decreases the antigen load, minimizes the inflammation, and reduces the hypersensitivity reaction, thus eliminates the recurrence of inflammation. Also, after 1 week of starting ATT, systemic steroids in the form of oral prednisolone, 1 mg per kg per day, was started and tapered slowly. Through 1 week follow-up, there was a slight improvement in the vision from CF 50 centimeter to CF 2 meter. The eye was quiet. We could see a resolving choroiditis. Here is the pre and post treatment montage photo, wherein the pre-treatment we could see active lesions with ill-defined borders, which was elevated, and there were no pigmentation, whereas post-treatment we could see there is a resolving phase wherein there is reduction in the activity, flattening of the lesion, pigmentation, and well-defined borders could be seen. Here is the autofluorescence image. Change in the appearance in autofluorescence with improvement in the activity noted. The hyperfluorescence has healed to stippled and granular phloem. Coming to ocular tuberculosis discussion, Mycobacteria slender rod that sometimes show branching filamentous form resembling the fungal mycelium, hence called Mycobacteria, meaning fungus-like bacteria. It resists decoloration, thus they are called acid-fast bacilli. Aerobic, non-motile, non-capsulated, and non-sporing. The essential pathology in TB is related to the ability of the bacilli to survive and multiply within the macrophages. The production of a characteristic lesion, that is avascular granuloma, central zone showing giant cells with or without caseation, the peripheral zone showing lymphocytes and fibroblasts. Due to its global prevalence and its devastating morbidity and mortality, it was called as white plague, the captain of all men death. Coming to the ocular manifestation of tuberculosis, we have a widespread clinical appearance spectrum of anterior uveitis, intermediate and posterior uveitis. Anterior uveitis comprising of chronic granulomatous anterior uveitis with mutton fat capes, precipitates, iris nodules, cataract, and extensive broad-based posterior synechiae. Intermediate uveitis with snowballs and pars plana exudate, that is snow banks seen along the peripheral vascular sheathing with cystoid macular edema. Posterior uveitis with manifestations as retinal vasculitis, serpiginous-like choroiditis, choroidal tubercle or granuloma, subretinal abscess, and panuveitis. We have certain rare manifestations like endophthalmitis, panophthalmitis, and neuroretinitis. Coming to the distinguishing features between serpiginous and serpiginoid-like choroiditis. Serpiginous choroiditis is geographical,
You have 1 minute
helicoid,
left.
yes ma'am, peripapillary choroidopathy seen in healthy patient, 2 to 2nd to 7th decade of life. With autoimmune etiology, there is no gender predilection, usually bilateral, chronic, and progressive, increased frequency with HLA-B27 and retinal antigen. Whereas in serpiginoid choroiditis, it has a centripetal spread. Immunocompromised patients are seen more with 5th to 7th decade of life preponderance. The etiology being tuberculosis. Females are more affected, usually unilateral to begin with. There is no association found with HLA-B27 or retinal as antigen. Thank you.
Okay. And what was the other eye of this patient? Absolutely normal?
Yes, the other eye was absolutely normal. Vision was 6/6 and there was no activity noted anywhere, and patient was non-symptomatic for the left eye.
Can you please show me the color picture of the pathology and the next fluorescein angiography one by one?
Yes, sir.
One after the other.
So this is the
Color picture. Next.
picture. This is the fluorescence angiography.
Okay.
Early phase. We have the mid phase.
Okay. Okay. It's all right. What is the arm to retina circulation time?
So it is around 10 to 15 seconds.
All right. So what was the vision of the patient after treatment?
So she improved minimally, like from counting finger 50 centimeter to counting finger 2 meters. Since the macula had some old lesions, scarred lesions, the visual improvement was not beyond counting finger 2 meters for the early second week after starting the treatment with steroids and ATT.
You said steroids were started and tapered.
Yes, sir.
What
We have
exactly
started.
did you mean? How much were started for how many days and when did you start tapering them off?
So she was started on prednisolone, 1 mg per kg per day.
Methylprednisolone?
No, prednisolone, sorry. Tablet prednisolone, and she was a 60 kg. She weighed 60 kg at presentation, so 60 mg was started for 2 weeks.
When was the dose? The dose was given single dose or a divided dose?
So it was given as OD dose, sir, in the morning.
Why?
So because giving steroid as a loading dose in a higher range, it is said that the inflammation subsides, and it is very convenient for the patient also to take the medication. Along with steroid, she is also taking ATT. So there are 4 other drugs also that she has to take. So we started on steroid as OD dose.
Did she have any active tuberculosis?
Sir, systemically, I mean, there was no, it was just an ocular manifestation of tuberculosis. There was no
Did
foci
you
infection
did
in the lungs.
did you look? How did you look for that?
So we went ahead and did a chest X-ray with APN lateral view, which was absolutely normal, and she did not have any lower respiratory or upper respiratory tract infection.
Absolutely normal chest X-ray.
Yes, sir, it was absolutely normal.
So, what kind of manifestation of tuberculosis is this?
So this is a posterior uveitic with choroiditis manifestation of tuberculosis.
Oh, okay. Okay.
Thank you, sir.
Thank you, sir.
What is the differential diagnosis of your case?
Sir, the differential diagnosis could have been an autoimmune etiology and serpiginous choroiditis, or it could be toxoplasmosis, sarcoidosis, APM-PP. These were my differential diagnosis. But since Montux came out to be strongly positive, and her quantiferon TB gold test was positive, so we narrowed down our DDs and came tuberculosis as the cause for choroiditis.
This patient was having a cataract.
No, sir, she doesn't have any cataractus changes.
If he develops, if he or she develops the cataract,
Yes, sir.
what that cataract is known as?
That is a complicated posterior subcapsular cataract, sir.
Can you tell me the various signs of complicated cataract?
So the various signs of complicated cataract would be a posterior capsular cataract, which is a breadcrumb appearance. There could be polymorph. There could be synechase and anterior uveitis. Synechate, and the pupil will be non-dilating. There could be iritis in the anterior segment.
Okay. Why did you select this case for presentation?
Sir, we have been treating tuberculosis since like 50 to 60 years, but still TB is causing a lot of mortality and morbidity, and ocular manifestations of tuberculosis still are persistent. And only the developing countries like ours, we are having tuberculosis in such a large proportion. And I thought it is like even in the coming
No,
from
whether
upper.
choroiditis is a known manifestation of tuberculosis of the eye. Why did you select this case? Is it a rare manifestation, or
So
what did
no,
you have?
yeah, sir, this wasn't a rare manifestation, but this was like the only manifestation she had. There was no other pulmonary or any other form of tuberculosis, and she was a very healthy to look to at her. She was a very healthy female. So coming to the diagnosis of clinically looking at her, it was very difficult to imagine that she could have a tuberculosis in her eye, not elsewhere. So I thought this could be a rare case.
So how will you know whether the patient responded to steroids or anti-tuberculosis drugs?
So it goes hand in hand, sir. ATT as well as steroids have an active role in causing a decrease of inflammation. So this is more of a hypersensitivity reaction to the tubercular protein.
So
Very much.
why anti-tubercular drugs were given?
So because she turned out to be strongly positive to Montaux and quantiferon, there will be some amount of bacilli which will cause activity, and we had active lesions in the superior and nasal arcade. So it would be very beneficial to the patient to start on ATT as well as on steroids.
Okay, ठीक है.
Thank you, sir.
That's all. Okay.
So we move to the next one. Dr. Nikita Das.
Yes, sir, I'm here. Sir, can you hear me?
Yeah. The study on knowledge, attitudes, mental health status of patients and healthcare workers of ophthalmology during COVID-19 post-lockdown phase at tertiary hospital. Please start.
Sir, are my slides visible, sir?
Yeah.
Okay. So good afternoon, everyone. I'll be presenting on a study on knowledge, attitudes, and mental health status of patients and healthcare workers of ophthalmology during COVID-19 lockdown phase at a tertiary hospital. So I have no financial interest to disclose. So I would like to say that COVID-19 is a very infectious virus that causes acute respiratory distress syndrome, and it can also be asymptomatic but lethal. So during the initial phases of this pandemic, general public and healthcare workers were in a lot of confusion that led to a social stigma in society, that led to hiding of illnesses and non-healthcare seeking attitude among the masses. To prevent the spread of the disease, the government had imposed a nationwide lockdown on 24th March 2020. But despite that, by the time the lockdown restrictions had eased, the total cases had already increased to more than 5 lakhs. So in a populous country like India, the degree of awareness is very much essential among the general public, is very much essential to prevent the spread of the disease, because when the general public becomes aware about the nature of the disease and the means taken to prevent the spread, only then it is more fruitful. And healthcare workers being at the front line are always exposed to getting infected. And since it was an unknown disease at that time, that led to various degrees of mental disorders. So this study was undertaken to evaluate the knowledge, attitude, and mental health status in relation to COVID pandemic among healthcare workers and the general public. It was a cross-sectional questionnaire-based study wherein we took demographic data and awareness about the disease among healthcare workers and general public, and used the PHQ-9 questionnaire to assess the psychological impact. The data was recorded in MS Excel spreadsheet, and SPSS version 23 was used for data analysis. A p-value of less than 0.05 was considered to be statistically significant. So a total of 240 participants were included, with the median age of patients being 41 years and that of healthcare workers being 27.5. So in the healthcare workers group, the male and female were equally distributed, whereas the proportion of males were slightly higher in the patient group. Now, coming to the comorbidity profile, among the participants, 43% had multiple comorbidities. Now, coming to the general awareness on COVID-19, the healthcare workers were aware on all the aspects of COVID-19, whereas, but in the patient group, we saw that Although they were aware about the contagious nature of the disease, preventive measures and symptoms of the disease, but only 55% could say that it was caused by a virus. And electronic media was the most common source of information of COVID-19 for patients. Coming to the patient's perspective of all these efforts, the majority of patients, they agreed to maintain social distancing. But despite that, 69% said that all this led to a increase in the waiting time. And 52.5% said that they could not access healthcare services due to the lockdown. Now coming to the perception of ophthalmic emergency, 67% of patients stated that vision loss was a more common ophthalmic emergency, followed by red eyes and pain. As per the healthcare workers, 77.5% of patients were triaged before examination, but only 55% were cooperative enough to wait. 65% of healthcare workers reported difficulties while using face shields and examining patient on slit lamp. And the main reason quoted was fogging. And 52.5% of healthcare workers agree that telecommunication can be a feasible option for communication among patients during the lockdown. Coming to the mental health status, we saw that severe depression was more commonly noted in healthcare workers, whereas the patients, they mostly suffered from mild depression or no depression. And in relation to the socioeconomic status, lower socioeconomic status had more chances of developing moderate depression, whereas upper socioeconomic status, they had more chances of developing mild depression. So coming to the factors that are responsible for depression in patient, we found that occupation and like those having non-salaried occupations or daily wages, they had more tendency to develop depression, and those who did not practice preventive measures on regular basis had more chances of developing depression. Now, majority of people were aware of the contagious nature of the disease, and this was comparable with the findings of Pandey et al. But still, despite that, 52.5% were unaware of the asymptomatic nature, and 80% were unaware that it could affect eyes. And our study showed that 52.5% of healthcare workers suffered from moderate to severe depression as compared to only 17% in the patient group. This was similar to the findings by Rahman et al. So it has been reported earlier that the reasons for poor mental health status among the healthcare workers are working in the high-risk departments, fear of isolation and putting family members in danger, household problems, and medical insurance. So therefore, there is a necessity, it should be necessary to motivate and counsel healthcare workers, and as well as come up with some sort of pay protection facilities or medical insurance and other such policies to protect both healthcare workers and individuals during the COVID-19 pandemic. So our study still had its limitation because it was a single center study. So there were underestimation of certain issues faced by general public in other parts of the country. And healthcare workers only were ophthalmology staff, so there can be variation in findings among other healthcare workers. And lastly, PHQ-9 is a screening tool and should be supplemented with clinical diagnosis. So I would like to conclude by saying that awareness among general public and measures adopted by them are very much instrumental in controlling the spread. So it is very essential to make the general public aware of pandemics of such magnitude, and hence a holistic approach should be undertaken when tackling pandemics of such magnitude, failing which we will only cause unnecessary mental stress to healthcare workers as well as the general public. So these are my references. Thank you.
You said only ophthalmology health personnel were included in the study.
Yes, sir, we did it from an ophthalmology perspective. So just to see that
why other healthcare workers were not included?
So we actually wanted to see only from an ophthalmology side, whether it is any difference or not. And since we are more involved in closely examining patients, like medicine people or skin people, they can see the patients from at a distance also. But in ophthalmology, in order to have a proper diagnosis, we need to examine them closely. For using slit lamp and all these
ophthalmology patients are not non-COVID positive patients. Those medicine, anesthesia, and gynecology, they have to treat the non-COVID positive patients also.
Yes, sir, but we included only those that are COVID negative mostly. Like if like during those time, our OPD was being screened. So if there were any symptoms of COVID, then they were not allowed to come to the general OPD. So we were
So
actually,
all these healthcare workers were not involved in COVID management.
no, sir, some of them were involved, but they were posted in a cycle basis, periodically postings.
Okay.
But our general OPD was totally for non-COVID patients, sir. So those patients that used to come for the general OPD, they were, sir, non-COVID, sir. They were screened for COVID. If any patient was COVID positive, then they were not allowed to come to the general OPD, sir.
So still you said 50% of healthcare workers were suffering from depression.
Yes, sir.
How did you determine they were suffering from depression?
Sir, we use the PHQ-9 screening tool.
What is that?
Sir, it's a patient health questionnaire. It has 9 points, and basing on the score, we categorize people whether they are mildly depressed, moderately depressed, or severely depressed.
So it is so simple to diagnose
But
depression.
it's not a diagnosis, sir. Like I stated in my limitation, it's not a diagnostic tool. It's just a screening tool.
So it's a subjective thing.
Yes, sir. It's a subjective thing.
It's not a clinical depression you're talking about.
Not exactly, sir. Not clinical depression, but you can say yes. Subjectively they were depressed, like as per the scale.
Because depression is a big word.
Yes, sir.
Cannot use it very lightly. Clinical depression and mood swings or
No, sir. No, sir.
healing
Like
glow.
I stated in my limitation, it's not. It needs clinical correlation, but we won't say that it's. This is actually the scale itself. It writes mild depression, moderate depression, and severe depression. On its scoring.
Can you elaborate on that? Those criteria. There are 9 criteria. You said, no?
Yes, sir.
What are those?
Sir, sir, can you give me a moment? I'll just see the questionnaire. Sir, actually, it has several questions like how you have been feeling and for the past 2 weeks, whether you want to eat more or eat less, whether you are concerned about something or not. Sir, that kind of, sir, it has. So the questionnaire are like that.
Okay. Sir, Penke, sir.
Yeah. So which persons are more affected? Doctors or paramedicals?
Sir, we considered them as a whole, sir. We did not exactly differentiate between doctors and paramedical staff. We considered them as a whole. Healthcare workers, we took them as.
Oh. Now, what is the main aim of your study to present in ophthalmic conference?
So that despite all this lockdown also, and there can still be like a gap in awareness among the general public, and yes, and actually what happened that in our state, it was after the post lockdown that the peak started increasing. So probably that's why we had more like patients who had depression, like more healthcare workers were depressed.
What was the period of your study from 24?
So July to November, sir.
July to November. So
Yes,
after the lockdown were relaxed.
Yes, sir. It was after the lockdown phase was relaxed. So at least we would have expected a fall in the patients or at least more awareness among the patients, but still there were lacunae.
What about the attitude of the patients and healthcare? What was the attitude of the healthcare workers? How did you evaluate the attitude?
So we had given them questions on how often they used to wash hands, how often they used to change masks, and whether they followed the AIOS guidelines or not, because there was a guideline by AIOS on how often you should be changing masks, how you should be sterilizing your instruments in an ophthalmology OPD. So that was how we judge them on, assess them on.
Was there any question regarding their stay arrangements and their food arrangements?
No, sir, we did not include them because they were being supplied by our hospital. stay arrangements for COVID-19 like workforce?
No. Those who were doing COVID duty and those
Yes,
who were
sir. They
not
were
doing
being
COVID
supplied by
duty.
our hospital. So it was a single center study. But so in our hospital, all of those who were doing the COVID duties, they were given separate rooms.
Okay. So what is your final conclusion? Can you repeat that?
So my final conclusion would be that sir, awareness among general public and measures adopted by them are very much instrumental in controlling the spread. So that's why it is very much important that we make the general public aware about these kind of disease.
No. Regarding knowledge, attitude, and mental health status of the patients.
Yes, sir.
What was the final conclusion of the study?
Sir, so we should be taking a holistic approach when tackling the pandemics of such magnitude.
Okay, take it. It's all right.
We move on to the next one.
Yeah, right.
Dr. Goyal, Yashas Goyal, are you ready?
Good afternoon, sir.
Efficacy of epsilateral simple limbal epithelial transplantation for large primary nasal pterygium. Please go ahead.
Yes, sir. Yes, sir. Sir, should I share my screen now?
Yeah, start, please.
Sir, just give me a moment. Sir, is my screen visible?
Yes.
Okay, I will start now, sir. Everyone, I'm Dr. Yashas Goyal and I'm presenting a paper on the efficacy of ipsilateral focal simple limbal epithelial transplantation for primary large nasal pterygia treatment. Extension of pterygium onto the limbus and invasion of cornea is attributed to a limbal stem cell deficiency. In the past 3 decades, considerable surgical success has been achieved after the recognition of the role of stem cells in pathogenesis of this disorder, but no surgical technique entirely prevents recurrence. The gold standard for treatment has been pterygium tissue excision followed by conjunctival limbal autografting. It is not prudent to use nascent conjunctiva to cover large areas of bare sclera following large pterygia excision, as it damages the healthy ocular surface. So a technique of simple limbal epithelial transplantation SLET was reported by Sangwan et al. In 2012 to treat the limbal stem cell defect in ocular burn patients. A modification of this procedure was described by Bogantis in 2015 to provide replacement of conjunctiva and limbal stem cells after pterygium excision, thus preserving the virgin conjunctiva. We undertook a study to analyze the efficacy of modified SLET with human amniotic membrane transplantation in patients who had primary large nasal pterygia to preserve virgin conjunctiva and to replace the lost limbal stem cells. Our aim was to assess the outcome of focal SLET with amniotic membrane grafting for primary large nasal pterygia treatment. It was a prospective interventional study conducted at Sri Aurobindo Institute of Medical Sciences, Indore. And it's an ongoing study, but we have completed our 1-year follow-up period. So materials and methods, we conducted the study on 38 eyes of 38 patients with primary large nasal pterygia who were recruited after institutional ethics committee clearance after obtaining due written informed consent. Our inclusion criteria were patient presenting with more than or equal to grade 2 primary nasal pterygia, pterygia width of 5 mm or moderate limbus, no association with any other ocular surface disorder, and patients consenting for study and at least a follow-up period of 12 months. Our exclusion criteria were patients presenting with recurrent pterygium, any associated ocular surface disorder, any previous history of ocular surgery, and history of hypersensitivity reaction to blood components. So this is a figure depicting the different grades of pterygium. So grade 2 is a pterygium tissue between limbus and pupillary border. Grade 3, pterygium tissue reaching the pupillary border, and grade 4, the tissue which has crossed pupillary border. In our surgical technique, we prepared the patient in a sterile manner, gave a subconjunctival 2% lidocaine block. Then the conjunctiva overlying the pterygium tissue was nicked parallel to and 1 mm away from the limbus. Then it was undermined along its entire length and the subconjunctival adhesions were released. The tissue with the underlying tenons was cut with tenotomy scissors. Then pterygium was excised and reflected over cornea and removed from it by reverse peeling technique. And then a smooth keratectomy was done by a number 15 blade, as we can see in this figure. The area of bare sclera was measured and with calipers, and a human amniotic membrane graft of size 2 millimeter larger than the size of the defect was placed over it and tucked under the free edges of conjunctiva. This was held in place with the fibrin glue. 15 number blade was used to create a 2 into 2 millimeter strip of healthy limbal epithelial cells, and from these were taken from the supratemporal quadrant of the same eye. This tissue was cut into multiple pieces by Varna scissors, as we can see here in figure G, and these were placed in the limbal area over the amniotic membrane graft, and then with their epithelial side up and then secured. A soft bandage lens, contact lens, was placed over the recipient eye. So this is the last figure where we can see the soft BCL over the eye and the air bubble beneath it. So our post-operative regimen consisted of topical antibiotic, corticosteroid, and lubricant from the very first post-operative day, every 4 hourly. We followed the patients up on day 1, 7, 15, 30, and then 3 monthly up to 12 months. The soft BCL was removed on post-operative day 7. All the post-operative complications and recovery patterns were documented, and outcomes were assessed using appropriate descriptive analysis. So this is an image showing most of the patients in our study were females, 68% of them. And this is an image showing the limbal width involvement and clinical grading used for the extent of pterygium. Most patients, as we can see here, presented with a grade 2 nasal pterygium, and the most common age group of presentation was 46 to 60 years of age. Then in this figure, we can see, in this chart, we can see that there was no correlation between increasing limbal width with the grade of pterygium, as maximum patients who presented with a limbal width of more than 8 millimeter had a grade 2 nasal pterygium. And this implies that rapidly growing pterygia showed more linear than angular growth. Indications for surgery, most of the patients, 55% of them had cosmetic complaints, followed by foreign body symptoms in 24%, and 16% had watering. So there was a marked resolution in post-operative complaints by post-op day 7. And we can see this is a figure of, these are the pictures of a patient who completely resolved by post-operative day 30. So this is a table enumerating the complications that we encountered in our patients. Of note, which were managed either medically or surgically. Most of the complications like amniotic membrane edema or subamniotic membrane hemorrhage were managed by either increasing the frequency of corticosteroids or increasing the lubricants. In one patient, there was loss of stem cell lenticules and BCL on the follow-up day 7, and the patient also gave history of eye rubbing. He was managed with regrafting of amniotic membrane with stem cell lenticules and by increasing the frequency of post-operative steroids and lubricants. So this is the patient now, 1 week after his resurgery, and we can see the BCL and the graft in place. In one patient where there was non-compliance with topical medication and who had missed his all follow-up consultations, he presented on post-op day 45 with actual recurrence of the excised pterygium tissue, as we see in this figure. This patient was immediately planned for resurgery, and a revision of focal slit procedure was done. On subsequent follow-up, the patient did not show any signs of recurrence again, as we see the patient at 3 months after resurgery. So in summary, in 58% of patients, we had a very satisfactory outcome where no other intervention, either medical or surgical, had to be done apart from the regular post-operative medications. 39% of patients, we had a satisfactory outcome in which some form of medical intervention was required. We had an unsatisfactory outcome in only one patient who had to be taken for complete revision of the procedure. So in conclusion, I would say that ipsilateral focal slit with the human amniotic membrane grafting is an effective alternative to autography for surgical management of primary large nasal pterygia. Patients experience less discomfort after human amniotic membrane transplantation, and they have a reduced recovery time as no bare areas are left, as are left with conjunctival autografting. So focal slit combined with human amniotic membrane grafting for primary large nasal pterygia showed a low rate of recurrence in our study at 1 year follow-up. It was just one patient.
Doctor, your time is up.
Yes, ma'am. These are the last slides now. Okay. The current gold standard of CLAV becomes challenging when size of pterygium is large and sufficient donor graft cannot be obtained without disturbing the ocular surface morphology. Preservation of virgin conjunctiva is also prudent for success of future pterygium or glaucoma surgeries. Autologous has become a benchmark for treating LSCD in ocular surfaces damaged due to chemical burns and other causes. As pterygium also is a disorder of LSCD, a modification of the technique that was described by Sangwan was employed by Hernandez-Bogantes in 10 patients. Sati and all also presented a study comparing the efficacy of mini-slit versus Clow in primary pterygium treatment, where they included 40 participants with grade 2 nasal pterygium. But none of these previous studies assessed the limbal involvement of the pterygium tissue. The human amniotic membrane is preferable because it also has characteristics and anti-inflammatory and anti-fibrotic properties. These make a human amniotic membrane an ideal substitute in pterygium over conjunctival autografting. Grafting with just the amniotic membrane alone leads to a higher rate of limbal autografting. Yes, sir. So an important advantage of our procedure slit is also its repeatability, as human amniotic membrane is used rather than nasal conjunctiva, and only a thin strip of ipsilateral healthy limbal tissue is used in the procedure. Focal slit is an excellent candidate for revision surgery in patients with recurrence. So we would recommend focal slit with human amniotic membrane grafting can be used as primary surgical treatment for large nasal pterygia for a good anatomical and functional outcome and preservation of virgin conjunctiva for future surgeries. Further randomized controlled trials in multiple centers with longer follow-up periods could validate the results of our study. Thank you.
Okay.
We are running short of time. Please, we will have one more presentation actually.
Okay.
In the other sessions, people have already logged in.
All right. I think. How did you secure the mini slit, Mr. How did you secure the limbal stem cells on the
Yes, sir.
amniotic membrane?
Sir, by fibrin glue.
Okay. Okay. What are the drawbacks of amniotic membrane grafting?
Sir, we have seen that just amniotic membrane grafting leads to a higher rate of recurrence. That is why we combined the procedure with limbal stem cell grafting also.
Okay. Okay. Sir?
What is the pre-operative vision and post-operative vision of the patient? You have not mentioned anything.
Yes, sir. Sir, most of these patients did not have any complaints regarding to vision. In our study group of 38 patients, only
But
2
sir, you have
patients.
said that it is a very large pterygium involving more than 2 millimeter of the cornea, and it is bound that there will have some changes in the diffraction.
Yes, sir. Due to corneal astigmatism, but the main concern of the patient was, the cosmesis and foreign body sensation and watering.
So you have assessed the patient only for cosmetic purposes, not for scientific purposes.
No, sir. We did a complete assessment of the patients, but the complaints of the patient were only pertaining to those problems. That is why those problems were highlighted.
You see, in ophthalmology, you have to see always the vision. Remember. Okay.
Okay. Next.
We go with the next speaker, please. Dr. Darshi Patel, are you ready?
Yes, sir, I'm ready.
Please go ahead.
Yes, sir.
Last presentation.
Dr. Yashas, please stop sharing your screen.
Dr. Goyal, please stop sharing your screen. We have to give this all by 1:30. The next.
Is my screen visible, sir?
Yes, yes. Please go ahead.
Yes, sir. My study is on base of comparison of endothelial cell count via specular microscopy, patients of PEGS, primary angle closure glaucoma, and primary open angle glaucoma. The study was performed in Department of Ophthalmology in Jeemers Medical College, Sola, Ahmedabad. The study aims to evaluate the influence of PECs, open-angle glaucoma and angle closure glaucoma on cornea and potential use of quantifiable corneal characteristics as clinical markers to risk stratify the patients. 100 patients diagnosed with either PECs, angle closure or open-angle glaucoma were diagnosed and included in the study. Endothelial cell count was measured using specular microscope in these patients. PECs is characterized by the production of an accumulation of extracellular granular fibrillary material in many ocular tissues. Studies report that in patients with PECs, corneal endothelium shows different features like reduced cell density, higher variation in cell size, and lower percentage of hexagonal cells. Glaucoma is a group of disease characterized by specific pattern of optic nerve neuropathy and retinopathy. Increasing evidence demonstrate glaucoma-associated corneal endothelium loss. Direct compression mechanism due to elevated intraocular pressure, cell toxicity after a long time exposure to preservatives, and glaucoma surgery have been reported to be the possible mechanism. Materials and method. This is observational study carried out in tertiary care center in 80 eyes of 80 patients of the age group of 40 to 50 years of age. The patients having acute corneal disease, contact lens wearer, past history of any intraocular surgery or laser treatment, and corneal dystrophies were excluded. Methodology. Patients were divided into 4 groups: 20 eyes with PEC syndrome, 20 eyes with open angle glaucoma, 20 eyes with angle closure glaucoma as cases, and 20 eyes as controls. Complete eye examination was performed and specular microscopy for endothelial cell count was done. Results. This chart shows the comparison of average endothelial cell density between controls, open angle glaucoma, angle closure glaucoma, and PECs. This shows that the lowest endothelial cell count amongst these patients were observed in angle closure glaucoma, followed by PECs patients, followed by open angle glaucoma. This table shows the standard deviation in recording of the endothelial cell count in these patients. This chart shows the comparison of endothelial cell count between males and females in each age group. As depicted in the chart, females have lower endothelial cell count even in control group. Discussion. The angle closure is characterized by opposition of peripheral iris against the trabecular meshwork, resulting in obstruction of aqueous outflow. The end condition of primary angle closure glaucoma includes the fundamental criteria for any glaucoma: damage to the optic nerve and concomitant loss of visual field function. Hence, the screening strategies for epidemiologically detecting this disease in advanced stage of open angle glaucoma becomes very important. Patients with open angle glaucoma had a reduction in corneal endothelial density and an increase in average endothelial cell area compared to aged matched healthy controls. Possible explanation include direct mechanical damage, elevated IOP, cytotoxic effect of hypotensive eye drops, impaired endothelial metabolism. Correlation. High IOP directly damages the physical barrier function of corneal endothelial cells and affects the function of endothelial pump, leading to changes in aqueous humor dynamics. The cause of lower endothelial cell density in patients of PEC syndrome is pseudoexfoliation material appearing in early stages of disease, which settles on the endothelium, penetrating it in the direction of Descemet's membrane and breaking the connections between individual six-sided cells and resulting in local accelerated apoptosis of the cells. Other factors include accumulation of PEX material causing the reduction of number of cells within the layer of corneal endothelium, include hypoxia of the anterior chamber, changes in the fibroblast of the endothelium. This is a comparison of our study with previously published data in angle closure glaucoma. Present study shows mean endothelial cell count in the range of 1700 cells. Begar, Sehota, MJ, and Han respectively shows 1500, 1597, 2200, and 1700 respectively. Comparison of our study with previously published data in open angle glaucoma. In our study, the endothelial cell count, mean endothelial cell count was in the range of 1800s, while the other three trial studies shows in the range of 2200 to 2700. Conclusion. Corneal endothelial cell density was found reduced following an acute attack of angle closure glaucoma. This research shows that in eyes with PEC syndrome, both with and without glaucoma, endothelial cell density was statistically significantly lower than in control group. Patients with open angle glaucoma have lower endothelial cell density than healthy controls of the same group, attributed to the mechanical damage from elevated IOP and toxicity of glaucoma medication. Thank you, sir.
Sir, any questions?
Yeah. Your endothelial cell count in established glaucoma, cases of glaucoma, and pre-perimetric glaucoma. Is there any conclusive study?
Difference? I'm sorry, I did not get the question, sir.
Yeah. Suppose you have to diagnose the glaucoma as early as possible to prevent further damage to the eye.
Yes, sir.
Can you diagnose the glaucoma by doing the endothelial cell count in pre-perimetric stage?
Sir, before perimetry, if the intraocular pressure is raised or an endothelial cell count is
Intraocular
decreased.
pressure is borderline. For example, it is 22 millimeter of mercury. Can your
Okay, if it is-
endothelial cell count can
is
tell us
reduced.
something regarding that your patient is having glaucoma or not? Or yet you have
Sir,
to
we
study?
cannot definitively say that they have glaucoma because a lot of condition causing decrease in endothelial cell count.
Yeah.
So we have to further evaluate. It could direct us in the direction for diagnosis of glaucoma.
And still you have to study more to say that perfectly.
Yes,
that
definitely. Yes, sir. It is. It can be used to screen the patients so that further
Only.
evaluation can be performed.
Okay. Sir, from your side.
Okay, thank you so much.
Okay. I thank all the judges for nicely judging the presentations and all the presenters also. And I request the moderator of the next session to take over. Thank you, Dr. Atnu, sir.
Thank you, Dr. Penke, sir. Nice to see you after so long after the
Yes,
camp.
ma'am.
Thank you, Dr. Atnu, sir. Thank you, Dr.
Thank you.
Pankaj. Thank
Yeah.
you so much. Thank you, and congratulations to all the speakers. Thank you so much.
Thank you, ma'am. Thank you all the
Thank you,
judges.
Sumit. Thank you. So I
Thank
must
all
tell
the
you
participants.
that Sumit has done all the hard work for these papers with my residents, and congratulations, Sumit. Thank you so much.
Thank you, ma'am. Thank you for the opportunity.
Okay.
Over to you.
Thank you. So I think the next session is with Dr. Karobi, madam, and Dr. Nikhil Nashta, and I'm just waiting for them to join.
There.
Yeah,
I'm
Nikhil
here,
is
ma'am.
there. Good
Yes.
afternoon.
Good afternoon, ma'am. Good afternoon.
Afternoon.
Hi, Ma. Good afternoon, ma'am.
Good afternoon. Nice to see you.
Nice to see you, ma'am. Thank you so much, Dr. Atnur. Good afternoon, Abha, ma'am.
Good afternoon.
Good afternoon, Atnur, sir. Thank you. Hi, Sabya Sachi.
Hi, ma'm.
So, my mic was on because I was trying to interrupt and tell people that, he's not only a scientist. Please come and watch him in the afternoon. That's why my mic was on, but I didn't want to interrupt.
I know. Ragini, if they can tell in all the other halls also which are finishing to join the concert.
I'll do that, ma'am. I'll do that. Thank you, ma'am. Hi, Jagannath. Hi, Ruchita. Hi.
Hi, ma'am.
Tell, ma'am.
All of them have come ready and prepared, So shall we start?
I think we'll start, ma'am. Okay.
Ma'am, it's all yours.
Thank you very much, Ragini.
So I'll welcome everyone.
Nikhil,
Yes,
we
ma'am.
are back again with another edition of the mini concert. This is the third in line, and I hope you'll enjoy this as much as you'll have enjoyed the previous ones. Before we start, as a prerequisite, I would like to enlist your cooperation and help in trying to get Dr. T.P. Lahane elected as a vice president. I can assure you that he is going to be the most capable vice president ever, and then a president thereafter. You see the number of activities and the amount of work that he has put in for BOA, MOS, and for Bombay Ophthalmologists Association in general. The amount of activities that he has encouraged and he has propagated this, the numbers have grown over a period of time from tier to tier, and the activities and the performances of the society have also sort of gained wings under his leadership. So I would suggest that he is one of the most valuable persons whom we can enlist as our future vice president. So this is an appeal to one and all that please elect Dr. T.P. Lahane as your vice president in the current oncoming AIOS elections. Over to you, Nikhil.
That was a very nice way you put it forward, ma'am. And I would like to echo the same sentiments that we have to and we must vote for our very own Padma Shri Dr. T.P. Lahane sir. So as I begin today, I first of all welcome all of you to the third edition of the mini concert of the BOA MOS Summer Focus Virtual Symposium. As we have seen, the sessions keep getting better and the concerts also keep getting better. Many thanks to all our delegates who are showering so much love. Ma'am, so much love. You have to hear this. We had an outstanding 22,000 hits on YouTube for the last two sessions in general. So
that's a clap for all the participants
all
and
the
the way they have
participants.
performed.
This is for the scientific and everything together. 22,000 hits is a very big number. And I really say Kamal hai. So beauty of a virtual conference like this is an ability to view it at your leisure, at your time, similar to a podcast. And I would like to reiterate here that this conference would not have been possible without the vision of Padma Shri Dr. Lahane sir, Dr. Ragini ma'am, and everybody who's worked behind the scenes, especially Dr. Swapnesh Samant, Dr. Preetam Samant, and the entire BOA team. So I salute to this future forward team and for accepting all the challenges and putting on a beautiful conference for us. So one more round of applause for that. With that, we can.
This team, that team, we are all one
We
big
are all
family.
sorry.
BOA,
Our
MOS,
family,
AIOS.
yes.
We are a family of ophthalmologists who serve. We are
Yes,
one
yes.
family.
Well
I stand corrected.
And also, like listening to Sabya Sachi or now everybody else, and you two are hosting this, make us forget the difficult times that we are going through. So this is an important part of our lives, and I must tell everybody that this was taught to me that this is important by only one and only Karobi, ma'am.
So sweet. Thank you so much. It's a stress buster, and then get ready to eat your food and as well as sway along with us. I hope you will like our choice of participants and their numbers. So first we would like to call on Dr. Jagannath Boramani. Dr. Jagannath Boramani is a very senior ophthalmic surgeon. He's an anterior segment surgeon, cornea refractive, deals with more with small incision cataract surgeries. But this is something which I came to know only recently, that he sings very well too. So without wasting much time, let's go over to Jagannath and hear him perform. Jagannath, over to you.
Okay, thank you, Karim. Start again.
Start again, Jagannath.
Yeah.
So, ma'am, while he starts the song, his song echoes the sentiment that we all will feel after the lockdown when we see human interaction. Tumko dekha to ye khayal aaya. That's what the song is about.
Jagannath, is
Yes.
there some problem?
No, just give half minute.
Yeah, sure.
Yeah. It will start in half minute. Just wait.
So even the song selections by our participants and the performance they put up keeps in mind the situation that we are in, Like this was the most apt thing. And even the ones that follow are similar. So it ties on very well together, actually. So, we ready, sir?
Or should I screen share for you?
Hello.
Hello?
You can take up the next song. I'll come second in.
Okay.
Yeah.
Vishram, are you ready with your song?
Yes, ma'am. I can play that.
Okay, let's go over to Vishram. Vishram is an accomplished keratoplasty expert. He is from Thane and he's associated with the Jupiter Hospital. And apart from being a very good friend, he's also a great singer. So let's go over to him and hear his song for today.
Thank you very much. Thanks, Dr. Karopi, for giving me this opportunity. And I just hope that you like this number. It's a very positive and a fun-filled and a very energetic number. So I'll just share my screen. Just give me a heads up if you are able to hear the sound and see the video as well. Hello friends, I'm Dr. Vishram Sani and I'm an ophthalmologist specializing in cornea and refractive surgery, practicing in the city of Thane, Mumbai. I'll be presenting in front of you a lively, lovely number from the film Mere Jeevan Sathi, sung by Shobha.
That was excellent, Vishram. We really enjoyed it. And the thing is that if Jagannath is ready,
I'm ready.
Yeah.
I'm ready. If it doesn't come from my end, no, then you start from there.
Okay.
Let me try.
Nikhil, do you have anything to say?
I would like to say that Itne Sapne Lekar Aaya, and it was really a mesmerizing, dreamy performance. And now we'll hear Dr. Jagannath sir.
Yeah, start. आके गया Dr. Nikhil, you can start from your side.
Okay.
Yeah.
तुमको देखा तो ये ख्याल आया, जिंदगी धूप तुम घना साया। तुमको देखा तो ये ख्याल आया, तुमको देखा तो ये ख्याल आया, जिंदगी धूप तुम घना साया। तुमको देखा तो ये ख्याल आया। आज फिर दिल ने एक तमन्ना की, आज फिर दिल ने एक तमन्ना की, आज फिर दिल को हमने समझाया, आज फिर दिल को हमने समझाया, जिंदगी धूप तुम घना साया। तुमको देखा तो ये ख्याल आया। तुम चले जाओगे तो सोचेंगे, तुम चले जाओगे तो सोचेंगे, हमने क्या खोया, हमने क्या पाया, हमने क्या खोया, हमने क्या पाया, जिंदगी धूप तुम घना साया। तुमको देखा तो ये ख्याल आया।
So this was really, really amazing, and it was well worth the wait. So third time lucky, and it was a beautiful, beautifully sung song, sir. Very, very nice.
Video was very high resolution. I think that was causing a lot of jerks. Audio was coming smoothly.
We could hear it very well, sir. It was superb, superb.
That was a lovely song, Jagannath. We really enjoyed it. Though the mood was slow, but it was a beautifully sung song. So, congratulations. And as Nikhil said, third time was the lucky time for us. Now, moving over quickly to Dr. Aban Movdawala. We are going to do something now which is a little away from songs. That is, she's going to deal with her Mad Hatter stuff. She's a very senior anterior segment surgeon over the last 40 years, practicing in Santa Cruz, Mumbai. And along with her practice, she also writes poetry, skits, and she likes to do the semi-classical music and Italian music. So over to you, Aban. I think I'm going to share the screen for Aban. So just give me a minute.
Ma'am, I would just like to add
Jagannath,
here.
it was so beautiful. Dr. Vishram, very beautiful, very nice.
Thank you, Dr. Agini.
So I'll just say a few things about Aban ma'am's performance. That she has captured this very nice parody which explains about COVID as if it's an unwanted guest. COVID auntie has come to our house to stay and we don't want her. We are happy with breakfast in bed, but abhi bahut ho gaya. We don't want breakfast in bed anymore. So this is like Atiti Devo Bhavo, Atiti tum kab jaoge? To ja COVID ja. That is her gist of the whole thing.
Just a moment.
So if you hear very properly, she even talks about getting accustomed to it. So we should not. Just have a look at it.
This is a parody on the total lockdown written in April 2020. Apropos, I'm accustomed to her face from My Fair Lady. Damn, damn, damn. I've grown accustomed to the dawn that brings melodious birdsong. But I miss the hurry-scurry of a normal morn and the hurly-burly of the ticking gong. The smiles, the frowns, the ups and downs are second nature to me now, like breathing out and breathing in. I was running when the lockdown came. Surely I could be that way again. But I've grown accustomed to the kids cooking. Like Master Chef, it's looking. I'm accustomed to the sounds of silence, but miss the ear-splitting cacophony, a riotous symphony. I've grown accustomed to the lockdown, accustomed to its voice, accustomed to its face. Locked in a fifth floor flat, the stuff of folklore, with not a rupee in the till and a bill collector knocking at the door. Kids are always a scolding. I keep seeing red. Beg me to stay locked in, so I have breakfast in bed. How simply frightful, how humiliating, how delightful. How poignant it'll be on that inevitable day, when I'll storm out of the house and out I'll stay. This COVID is an unforgiving un, the sort who could, ever would, take a position and never budge. A non-forgiving un. But we'll never take Corona back. If she were crawling on her knees, let her promise to atone, let her shiver, let her moan. We'll slam the door and let the evil virus breathe. But I've grown accustomed to this lockdown place, rather like a habit. One can always break. And yet I've grown accustomed to the trace of something in the air, accustomed to her face. Thank you.
Thank you. That was indeed very nice, Aban, and like hats off for creating stuff like that. What do you say, Nikhil?
I think it was really well summarized. It was really, really amazing. Like we said, Atiti Devo Bhavo is now Atiti Tum Kab Jaoge. It's like that.
Jao Bhava.
Wonderful, ma'am. Wonderful, Aban, ma'am.
I know it is like, if you had seen that movie Sri tum kal aana, so you tell Pratik tum kal aana, and that kal never comes.
Yeah.
Okay, we move on to our next participant, who is none other than Rujita from Pune. Rujita is now the secretary of the Pune Ophthalmic Society, and apart from being an anterior segment surgeon, she is an excellent dancer. So, view it for yourself. I will start screen share, and you have fun with her performance. Nikhil?
Yeah, ma'am. So before we go ahead, I'll just tell you, she's from Pune, but she's captured a Punjabi spirit so well. And I personally love all things Punjabi, whether it's their chicken or their chats or their Chandigarh wala vibes. So in this mix up of two Punjabi popular songs, she's going to become a Morni and tell us all, Mere saath aaja nach le. So let's give it off for her. That was simply too good, huh? Very, very nice.
Thank you.
Excuse the little lag which was there, but I think even the lag helped us see your movements in details. I mean, we know you've done it fast, but the thing is that the lag helped us to see all your movements to perfection. So that was a very good performance, Rujita.
Very beautiful, Rujita.
Thank you.
Shall
Thank
we
you.
move over to the next participant? The next participant is
Nishita.
Nishita. Yeah, this is Nishita Beke, who's also from Pune, who's a pediatric ophthalmologist and a strabismus surgeon. And she is a semi-classical singer. And she is now... Are you going to screen share, Nishita, on your own? Nishita, are you there?
Mute. It's muted.
Please unmute Nishita.
Okay.
This is one of my favorite songs.
It's a dance number. It's a very nice song.
So, ma'am, before we go ahead with Nishita, I want to say she's a pediatric ophthalmologist and squint specialist. So, diplopia, na? So her song is also diplopia.
Yes.
It's a duet.
Yeah.
But ek se bhale
Yeah.
do ya do se bhale ek, that we got to figure out. She is so good in her singing that she couldn't find the partner that matches up. So this is a duet with her own self. It's something very unique. So let's look at this.
Go ahead, Nishita. can't hear you. Can you all hear the audio?
No.
The audio is not.
The audio is not audible.
It's not audible, Nishita.
Audio is not audible.
Nishita,
Maybe
the audio is
disconnect
not
your
loud.
headphones. Disconnect your headphones.
Okay, I have disconnected my headphone.
And start from the beginning.
Start it again, please.
Okay, can you see my screen? Yes.
Yeah. Enlarge your screen.
Can you hear now?
Yes, I can hear your voice.
But not the song. Okay.
No, not the song as yet.
Nishita, when you share your screen, there are two boxes, optimize for video and optimize for audio. Unless you click that, you will not be audible.
So from where should I click?
When you just click share screen, look at the bottom. There are two small boxes. One is for optimized audio. One is for optimized video. Not on this. The Zoom share.
Okay.
Once you go to the Zoom and share screen, what the window pops up, and you can see those two things.
Yeah.
Are you able to see? Tick off both of the.
Can you just play from your side, please? Optimize video clip. That is the.
Yes. Optimize for video and optimize the audio. Yes, both of them need to be clicked. Then you select the file that you want to share and then share.
I have optimized the video, but I am not doing how to optimize the audio.
Can I?
Just try once, otherwise, can you share from your side?
Yeah,
Ma'am, I think let's us share it.
You'll have to stop share.
Yes, ma'am. I've stopped.
Okay.
So as I was saying, her duet and her duet is with her own self. It's something very unique that she's done, and it's beautiful. Once we start sharing, we'll know. It's very nice. Even the song selection is really, really nice.
Can you all see the screen?
Yes, we can, ma'am.
Yes, ma'am, we can see.
Yeah, can you all hear?
Yes, we can hear, but we can't see the video. Can't see.
Can you see the video?
No.
Probably enlarged. There are lots of. It's your desktop or something. So probably if you open it, you'll be able to see.
Getting the audio.
Can you hear and see? Just a minute.
We can hear it, ma'am.
Dr. Vishram sir can help with this also probably.
Can you all see and hear now? No?
We can hear, but we can't see.
We can't see.
What is happening? Can you all see and hear?
Can hear it, ma'am, but we can't see it. We'll hear it, ma'am. We'll hear it.
Was it visible in the latter part?
No, ma'am. It wasn't visible, but we could imagine in our mind's eye how she sung it, and it was really, really, really nice.
It was beautiful. Her voice is so beautiful. But if we can
Thank you
play
so
it, we
much,
can play
Ragini
it
ma'am.
again later or next time or something. Nishita, you are wonderful.
Yeah, I know. And
Thank
the
you so
whole
much,
idea
ma'am.
was that she's done it with herself. It's a mirror image of herself, and it's really
Yeah.
well done, you know. So
It
moving on
was.
to the next.
If you say yes next time or whenever you have time, we'll repeat it, ma'am.
We will.
Oh, ma'am. Thank you so much. Thank you so much.
Welcome. We'll move on to our next participant. That is none other than Murlidhar from Karnataka, Bangalore. And he's
This song is playing, ma'am.
no, I think this has
Screen
started.
share. Yeah.
Who Sabyasachi has started sharing?
No, ma'am. It's from your laptop, I think.
Whose laptop?
Your laptop.
Ma'am,
ma'am.
your laptop only.
My laptop.
Your laptop.
Your media player has gone on.
Okay. This was another song which was sung by Nishita and Sachin. So we'll hear that next time. And moving over to Murlidhar. Murlidhar is a renowned vitreoretinal surgeon, a senior vitreoretinal surgeon from Karnataka, Bangalore. And apart from being a fantastic VR surgeon, he's also a fantastic singer. Murli, would you be sharing it or would you want me to share it?
I can share it.
Yes,
I'll try
I can
sharing.
share it.
Can you see that now?
Yes, we can.
Yes, sir.
Thank you,
Yes.
Dr. Murlidhar sir, for being with us.
Thank you, Ragini madam, for the opportunity.
रिम झिम गिरे सावन सुलग सुलग जाए मन भीगे आज इस मौसम में लगी कैसी है अगन रिम झिम गिरे सावन सुलग सुलग जाए मन भीगे आज इस मौसम में लगी कैसी है अगन रिम झिम गिरे सावन जब घुंघरुओं सी
I think the music has. Can you hear it?
No, no.
I think the music has stopped, Murli.
Stop.
कैसे देखे सपने नयन सुलग सुलग जाए मन भीगे आज इस मौसम में लगी कैसी है अगन रिम झिम गिरे सावन महफिल में कैसे कह दे किसी से दिल बंध रहा है किसी अजनबी से महफिल में कैसे कह दे किसी से दिल बंध रहा है किसी अजनबी से हाय करे अब क्या जतन सुलग सुलग जाए मन भीगे आज इस मौसम में लगी कैसी है अगन रिम झिम गिरे सावन सुलग सुलग जाए मन भीगे आज इस मौसम में लगी कैसी है अगन रिम झिम गिरे सावन थैंक यू
Murli, it's always fun to hear you. And as usual, you really rocked us.
Ma'am,
with
you
your
know
song.
what? Sir sang so well that in this heat of May, I got a monsoon feeling. I got that cool vibe of, the
Really?
barish. It
I
was
think
really
all of us experienced that.
took me to another world altogether, sir. So amazing. Hats off.
Thank you so much,
Thank you
Murli.
so
That
much,
was
so
wonderful.
much.
So beautiful. These are beautiful songs. Well done, sir.
Very, very nice.
Ragini madam, thanks to BOA for the opportunity. Thanks so much.
Don't worry, you'll always keep getting opportunities.
With Karobi Ma there and keeping everybody enthusiastic and alive, I think this program has become a brand, and I think it's going to be there always with all our programs.
At least I know that I'm having a lot of fun.
All of us are having, ma'am.
Yeah, good. So we move on to the last performance of the day, which is none other than Sabyasachi. Sabyasachi has sang for us before on the 9th of May, but he had given me 3 songs of which we couldn't play one. So the thing is that we said, why should we be deprived of his beautiful singing? Over to you, Sabyasachi. Sabyasachi needs no introduction. He is a favorite VR surgeon from Mumbai, and he runs his academy also. And Nikhil, you'd like to add a few words for Sabya?
Yeah, I just want to say that, yes, ma'am. Just like we are always there for each other, Sabya is everybody's friend, and he's singing in this Ke Tera Yaar Hu Main. So we don't need to worry. He's always there for us.
Thank you so much.
Hello, over to you.
Thanks, ma'am, for the opportunity. Thanks, Nikhil. Also.
तू जो रूठा तो कौन हंसेगा तू जो छूटा तो कौन रहेगा तू चुप है तो ये डर लगता है अपना मुझको अब कौन कहेगा तू ही वजह तेरे बिना बेवजह बेकार हूँ मैं तेरा यार हूँ मैं तेरा यार हूँ मैं आजा लड़े फिर खिलौनों के लिए तू जीते मैं हार जाऊं आजा करे फिर वही शरारतें तू भागे मैं मार खाऊं मीठी सी वो गाली तेरी सुनने को तैयार हूँ मैं तेरा यार हूँ मैं तेरा यार हूँ मैं तेरा यार हूँ तू नचदा मैं फिरा हंचुआ तो बचदा मैं फिरा जाते नहीं कहीं रिश्ते पुराने किसी नए के आ जाने से जाता हूँ मैं तो मुझे तू जाने दे क्यों परेशान है मेरे जाने से टूटा है तो जुड़ा है क्यों मेरी तरफ तू मुड़ा है क्यों हक नहीं तू ये कहे कि यार अब हम ना रहे एक तेरी यारी का ही सातों जन्म हकदार हूँ मैं तेरा यार हूँ मैं तेरा यार हूँ मैं तेरा यार हूँ मैं तेरा यार हूँ मैं
Thank you, Sabyasachi. That was beautiful. We've become more your yar than anybody else for
It's
doing this
beautiful.
class.
What a way to say, end the session today.
Exactly.
Very
So
beautiful.
we
Very
wish to thank all the participants for their wonderful participation and the time that they have spent in preparing this and executing it and sending it over to us for viewing. Little technical lags may have been there, but don't worry. Everybody has really enjoyed this, I hope. So with this, I give it over to Nikhil and Ragini for their final comments.
It was a
Thank you so
wonderful
much for the
session.
opportunity. Thank you so much. You're welcome.
Thank you all, and we will meet you all again in the evening for another wonderful, wonderful session. Dazzling Divas. That is the session we are all looking out for.
That's in KANSKI Hall only, no?
Yes, ma'am. I think we will leave the hall now because the next session is slightly delayed. So see you all in the evening. Thank you so much. Take care.
Thank you. Thanks all.
Bye-bye.
Thank you. Thank you, everyone.
Thanks, Ragini.
Should we start our next session now?
Yes, sir.
Okay. Good afternoon and warm welcome to all of you. All judges and participants have joined. I think yes. First of all, I would like to thank Team BOA for giving me the opportunity as a moderator of this session. Let me introduce first myself. I am Dr. Nilesh Gundevar, Secretary Hingoli Ophthalmic Society and private practitioner at Hingoli. Now I will introduce our today's session's eminent judges. Number one, Dr. Gauri Bade Bangar Madam. Madam is Assistant Professor at Rural Medical College, Loni. Our second judge is Dr. Dilip Kumar Kumare sir. He is Professor at Government Medical College, Chandrapur. Our third judge is Dr. Srikant Deshpande sir. He is Professor and HOD at Terna Medical College, Navi Mumbai. Should we start session now, madam?
Yes, sir.
Let's start our session. Now I will call our first presenter, Dr. Ishita Dikshini. Do you ready with your presentation?
Yes, sir.
Start.
Is it visible? Is it visible, sir? My screen.
Not.
Share screen. 1 minute, sir. Hello.
Yes, it's visible.
Sir, my screen is visible. Okay.
Yeah.
Good afternoon. I'm Dr. Dakshini Ishida from Nagari Eye Hospital, Ahmedabad. My paper presentation topic today is to study a case of atypical Cogan syndrome. Introduction. The Cogan syndrome is a rare inflammatory disease of unknown etiology. It affects the young adults and it is characterized by recurrent eye inflammation, sensory neural deafness, and audiovestibular symptoms. Its typical form present as a non-syphilitic interstitial keratitis, which is associated with audiovestibular dysfunction. Most of the patient can present with a bilateral eye redness, photophobia, or eye pain. The interval between the onset of ocular and audiovestibular manifestation in typical Cogan syndrome is usually less than 2 years. In addition to ocular and audiovestibular symptoms, various systemic manifestations, which include aortitis and necrotizing vasculitis, have been reported in patients with this syndrome. In atypical form, other ocular lesions have been described, which includes episcleritis, scleritis, retinitis, glaucoma, optic neuritis, and papilloedema. Usually, there is a delay of more than 2 years between the onset of typical ocular and audiovestibular manifestations. This case report describes a 66-year-old male with signs of scleral thinning and melting with associated scleromalacia perforans. Patient developed isolated vasculitis also. There was a hearing loss with tinnitus, which led to suspicious of the diagnosis. Patient had weight loss. There was no associated rheumatological abnormality and no interstitial keratitis or interstitial uveitis. Aims and objectives of this paper is to study a rare case of atypical Cogan syndrome with its unusual presentation, diagnosis, its management and treatment, and to study importance of immunosuppression and oral as well as topical steroid as treatment to prevent the relapsing and remitting course of the disease. Case details. A 66-year-old male presented to our OPD with symptom of pain, redness since 1 year. Patient also complained of hearing loss and tinnitus and weight loss. Patient developed isolated vasculitis. The examination revealed best-corrected visual acuity of 6/36 in both the eyes. The biomicroscopy revealed the scleral thinning such that the underlying uvea was almost visible. Intraocular pressure and fundus examination were unremarkable in both the eyes. Multidisciplinary evaluation was performed and the ancillary test excluded infections and autoimmune diseases. Diagnosis of exclusion helps here. The patient was treated with the eye drops of dexamethasone 1 milligram per ml and with a steroid oral steroid and topical lubricants, topical and systemic non-steroid anti-inflammatory medication with partial improvement. After recurrent episodes in this patient, pulse therapy was steroid and methotrexate were performed to control the disease. And it was noticed that when the patient becomes non-compliant to regular treatment, there was a worsening of symptoms. An increase in the scleral thinning was noted over the time with increase in the pain. Patient was later given 6 doses of injection cyclophosphamide and 2 doses of injection rituximab 500 milligram, which helped symptomatically to the patient after we have done the rheumatological reference. This picture shows the left eye showing the scleral thinning in the supratemporal aspect. Discussion. The patient of atypical Coggins can present with atypical ophthalmic features like conjunctivitis, episcleritis, scleritis, uveitis, papilloedema, and retinal vasculitis. Ophthalmic manifestation can precede the audiovestibular symptoms by months to years, which may delay the diagnosis of disease. Atypical Coggins syndrome tends to be more aggressive and it has a worse prognosis. The vestibular symptoms have sudden onset, characterized by vertigo, tinnitus, imbalance, nausea, and vomiting. So, Coggins syndrome is a diagnosis of exclusion since there are not laboratory tests which can diagnose the syndrome. So, it is necessary that we have to exclude all the other causes of the eye disease, such as infectious or other autoimmune diseases. In the present report, as a confounding factor, the hearing impairment could also be related to the age of the patient, and it may raise the question about whether this is in fact an atypical Coggins syndrome, but audiometry can help here, which will show the sensory neural deafness. The treatment is performed with immunosuppression. The use of prednisolone, methotrexate, cyclophosphamide also plays important role in relieving the symptoms. Conclusion, the scleral thinning and scleromalacia here described in this report, it is an atypical finding. The multidisciplinary evaluation plays an important role for the early diagnosis. Time between the onset of signs and symptom and the diagnosis directly influences the prognosis and quality of the life of the patient, and for this immunosuppression plays an important role. Thank you very much.
Any questions? Any questions?
What is the take-home message of your presentation, Dr. Ishita?
Sir, it's that atypical Coggins syndrome is a diagnosis of exclusion. So we have to rule out all other inflammatory and infectious causes in eye. And by the performing the laboratory test, blood test, and audiogram or ECG for atrial fibrillation or that, it is we make the diagnosis by diagnosis of exclusion, sir, because there is not any confirmatory sign or laboratory test which will confirm this diagnosis.
Okay. Thank you.
Thank you, sir.
Any more questions from judges or audience? Should we go with second presenter now? Now I will call Dr. Kinjal Patel to present her case. Dr. Kinjal Patel.
Dr. Ishita, please stop sharing your screen. Dr. Ishita, please stop sharing your screen.
Hello. Hello. Hello.
Hello.
Yes, you are audible. Yeah, my screen is visible. No? Yes. Yes. Good afternoon, everybody. Myself, Dr. Kinjal Patel, first year resident. My topic is current trends in glaucoma management at a tertiary eye care center analysis. Introduction. Glaucoma is a chronic, irreversible, multifactorial, progressive optic neuropathy. It is a most common cause of blindness worldwide and yet the most common cause of preventable visual disability if treated at a right stage. Primary open-angle glaucoma is the predominant type of glaucoma which is characterized by the glaucomatous optic nerve damage, retinal nerve fiber layer thinning, characteristic visual field losses, and open anterior chamber angle and increase intraocular pressure, whereas the primary angle closure glaucoma has increased the resistance to the outflow because of the damage to or the obstruction of the trabecular meshwork by the peripheral iris, preventing the aqueous humor from reaching the outflow channels. Intraocular pressure is the principal known and modifiable risk factor for the development and the progression of the glaucoma. Hence, the reducing intraocular pressure has been the mainstay of the glaucoma treatment, and its lowering by 20 to 40% has been shown to delay or halt the progression of the glaucoma. IOP reduction by medical, surgical, or laser therapies are the only clinical proven treatment. So, early diagnosis and the treatment is essential to hold the progression of the disease. Here, my aim is to study the current trends in the management of the various types of primary glaucoma in a tertiary eye care center. My sample size is 1072 patients. Retrospective observational study conducted at a tertiary eye care center for 3 months. Retrospective study of data of patients visiting the glaucoma clinic at a tertiary eye care center was conducted. Data collected over a period of 3 months were analyzed from 1072 patients. Primary glaucoma were divided into the primary open angle and the primary angle closure glaucoma. On the basis of the data obtained, analysis of the treatment modalities with a medical, surgical, and laser therapies was done in a POAG and PSCG patients. The following bar chart shows that the following pie chart shows that the in POAG patients there are 3/4 number of patients undergone the medical management, whereas in a PSCG patients pie chart showed that the more number of patients required the both laser as well as the medical management. The following bar chart shows that in the PSCG patients there is the almost the same number of the male and female patients, whereas in PSCG patients there is a male preponderance. In age, there is PSCG patients are more seen in 40 to 49 years of age, whereas in POAG patients are more in the 50 to 59 years of age. Out of 1072 patients, 600 were POAG and 472 were PSCG. Among the POAG patients, 75% patients were well managed by medical therapy, whereas 15% undergo surgery and 9% were kept under observation. In PSCG patients, 45% were given both laser therapy as well as the medical therapy, and 42% were well managed by the only laser therapy, and 11% has undergo surgical management. A study published in 2015 shows that the medical treatment was the mainstay of treatment, whereas 16% required surgical intervention in POAG patients. In our study, we also observed that the 75% was medically treated and 15% requires the surgery. Another international study done regarding the number of the trabeculectomies and the cataract operations, where they observed that the number of the cataract procedure has continues to rise as trabeculectomies has fallen progressively. In our study, we also observed that the medical therapy appears to be the mainstay treatment for the POAG patients. A prospective study on the 70 chronic PSCG patients who already underwent the peripheral iridotomy were observed for the 6th year, which shows that the 65% were controlled medically and 35% required surgery. In our study, we observed that the PSCG patients required medical treatment post laser peripheral iridotomy, which appears to be the mainstay treatment for the PSCG patients. The complications involved in surgery and cost reduction of anti-glaucoma medications has driven the patients for the choice of the medical management and the better achievement of the target IOP. Our limitations is small sample size, follow-up of patients was not taken. conclusion of my study is the current trend is indicative that the medical therapy appears to be the mainstay treatment for patients with POAG, and a large number of proportions of PACG patients require the medical management post-laser peripheral iridectomy. My take-home message is the better achievement of target IOP by a newer glaucoma medications have made them the first choice of the glaucoma management. These are my references. Thank you.
Any questions from judges? Any question from judges to Dr. Kinjan? No. Should we move with third present? Yes, sir.
Thank you, sir.
Thank you. Thank you, Kinjan. Our next speaker is Dr. Sanjana Chipre. Please present your screen.
Am I audible?
Yeah.
Is my screen visible, sir?
Yes, yes, ma'am.
So good afternoon, everyone. I first of all want to thank you, BO and MOS, for presenting me this opportunity. I am Dr. Sanjana, and I'll be presenting a rare case report of Listeria keratitis post-keratoplasty and a novel approach. I have no financial interest in the study. So coming to the case report, a 17-year-old female presented with pain, redness, diminution of vision, and mucopurulent discharge in left eye since 15 days. Patient was a follow-up case of left eye therapeutic keratoplasty done 1 year back for a proven perforated fungal corneal ulcer. Patient gave no history of usage of glasses, no history of contact lens use, no history of ocular trauma, and no history of foreign body entry in the eye. The family history was not significant, and general examination was within normal limits. Since the preoperative culture revealed filamentous fungus, post-operatively, the patient was started on following eye drops: natamycin 5%, carboxymethyl cellulose 0.5%, moxifloxacin 0.5%, atropine 1%, and prednisolone acetate 1% was added after 2 weeks of clear graft. On clinical examination, the right eye visual acuity was 6/6, and rest of the anterior segment examination was within normal limits. The left eye unaided visual acuity was hand movement close to face. Rest of the anterior segment findings can be seen in this picture, where we can appreciate lid edema, circumcorneal congestion, a 9.5 mm corneal graft with sutures in situ, a 5/3 mm corneal infiltrate at 6 o'clock. We can also see ill-defined superior border with focal cellularity. Iris showed iritis and loss of normal pattern. On fundus examination, the B scan was within normal limits. Coming to the next part, corneal scraping of the ulcer was sent for gram and Gemsa stain, KOH mount, blood agar, and chocolate agar. Provisional report on day 1. The left eye corneal scraping showed no organism on KOH mount, gram stain, and Gemsa stain. Since pre-operatively, the culture revealed filamentous fungus, post-operatively, the patient was again started on amphotericin B 0.1%, fortified ceftazidime 5%, and topical steroid was discontinued. The patient did not respond, and ulcer rapidly deteriorated over a period of 3 days. Increase in size of keratitis by 2 mm was noted on day 7. On day 13, that is after extended incubation culture, growth of gram-positive bacilli, which were later confirmed as Listeria monocytogenes, were seen. The patient was started on gentamicin 1.4% eye drops, but despite it, the keratitis progression continued with further decrease in visual acuity over the next 72 hours. After exhausting the available and reported treatment with no clinical improvement, we started to dig a little deeper. That is when we stumbled upon an article by Thornings, which highlights use of broad-spectrum antibiotics like piperacillin tazobactam for Listeria monocytogenes. Immediately, addition of fortified topical piperacillin tazobactam 5% eye drops was done, and within 48 hours, the ulcer began to heal. Gradual response was achieved in 3 weeks. Final outcome was complete scarring and opaque graft, and no recurrence was noted 6 months from infection on last follow-up. Coming to the discussion part, Listeria monocytogenes is a rare cause of keratitis. It is a gram-positive bacillus. It is a facultative anaerobe, a non-sporing bacilli. It can grow at temperatures below 4 degrees Celsius, hence it can spread through canned refrigerated food. The incubation period may range from 5 to 70 days. Listeriosis is spread through milk, cheese, raw meat, fish, and raw vegetables. The risk factors includes pregnant women, old age, immunocompromised status. It can also spread from past to fetus and can later on lead to abortion and stillbirth. Listeriosis affects chest, abdomen, bones, and joints. It can also cause septicemia, meningitis, and death. Listeriosis is more commonly found in animals like sheep, poultry, horses. It's very rare in humans. And ocular listeriosis is very, very, very rare. Till date, only 8 cases of Listeria keratitis have been reported in literature. The first case was reported by Holland in 1987. He used gentamicin for management of Listeria keratitis. The final visual outcome was 660. Following his footsteps, all other cases were also treated with the same drug. Out of 8 reported cases, 7 of them received gentamicin. But look at the final outcome. 2 cases lost their eye, 2 cases underwent keratoplasty, and the rest of the cases were left with residual scarring. What does this tell us? It only teaches us that Listeria runs an aggressive, unusual clinical course and is poorly responsive to antibiotic therapy. What was different in our case? In our case, the patient was very young. She had no risk factors, no trauma, no systemic immunosuppression, but local immunosuppression was present due to use of topical steroids. The patient did not respond to proven therapy with gentamicin. So to conclude, this is what was known about Listeria before. Listeriosis is most commonly seen in animal handlers. Immunocompromised individuals and old people are at a greater risk. Rare incidence and extended incubation for Listeria growth delays its diagnosis, and the gold standard therapy is gentamicin. What does my study add to the literature? It tells us that possibility of Listeria should be kept in mind regardless of age of the patient. Compromised cornea of healthy individuals is a risk factor. Repeat culture if there is high degree of clinical suspicion and if the previous culture report was negative. Treatment with gentamicin may not always work. Addition of piperacillin tazobactam in resistant cases of Listeria keratitis is helpful. Listeria keratitis, though rare, but has an aggressive course. These are my references. Thank you.
Any question from judges? Any question from judges? No.
It was a good presentation. But why the patient, what was the source of infection, or possible source of infection?
Sir, I took a detailed history. I asked her if she had poultry or any other animals. She gave no such history, sir. And I think the immunosuppression was the only cause. She had no other.
Why did she develop fungal ulcer in first place?
Sir, the patient was a follow-up case. Actually, she had come from Uttar Pradesh with a diagnosed case of fungal ulcer, and she was referred for therapeutic keratoplasty.
Okay.
Yeah, so it was a proven fungal ulcer case, and since she had iris prolapse and perforated corneal ulcer, we underwent with TKP. So,
was it associated with GIT symptoms?
No, ma'am. The patient did not have any systemic features. We also did a physician reference, and it was all negative. The blood culture was also done. It was also negative for Listeria.
Okay.
Thank you, Sanjana.
Thank you,
Our
sir.
next speaker is Dr. Nisar Shirke Rani. Dr. Nisar. Dr. Nisar.
Dr. Nisarg, we are not able to hear you.
Should we go with the next speaker, ma'am, then? You want time? Is our next speaker is ready, Dr. Neha?
Yes, sir, I'm ready.
Okay, then you start.
Okay, sir. So I need the screen sharing to be.
Yeah.
Good afternoon, sir. Can you see my screen, sir?
Yeah.
Okay, I'll start right away. Good afternoon, everyone. I'll be presenting a case report. So Anton syndrome is an uncommon condition characterized by denial of visual loss, also known as visual anosognosia, associated with confabulation. It was first described in 1899 by Gabriel Anton. My case report is of a 23-year-old man who presented to the emergency department of a tertiary care center with a history of hollow-cranial headache for 1 month, which was aggravated over the past 2 days, and it was associated with multiple episodes of vomiting and sudden visual loss also for 2 days. He was brought to the hospital after he developed altered sensorium. There was no other significant negative history. At presentation, he was found to be drowsy, irritable, and was not obeying commands with a GCS of 7/15. He was found to have bradycardia with a heart rate of 47 beats per minute, respiratory rate of 18 per minute, and blood pressure of 130/80 millimeters of mercury. Oxygen saturation was 98%. His vision and extraocular movements could not be assessed at this point because of his obtunded states, but bilateral pupils were 1.5 millimeters in size, round and briskly reacting to light. Fundoscopy demonstrated the presence of bilateral disc margin blurring. Preliminary investigations, imaging on CT showed a third ventricle space-occupying lesion with hydrocephalus. A screening COVID-19 RT-PCR was done, which was found to be positive, and the CT thorax showed a CORAD score of 1/25. The MRI brain with contrast was done, which showed a well-defined hyperintense lesion in the third ventricle, causing bilateral lateral ventriculomegaly. As we can see in this image, there is a well-defined round homogeneous lesion seen in the region of the foramen of Monro. The scan also showed obstructive hydrocephalus with dilatation of bilateral lateral ventricles. The patient then underwent an emergency right ventriculoperitoneal shunting under general anesthesia with appropriate PPE and aseptic precautions on the same day as presentation. Post-operatively, he was managed in a COVID isolation ward. His vitals were stable and bilateral pupils were briskly reacting to light. Once the patient was fully oriented, a visual assessment was performed. However, he denied any loss or blurring of vision and stated that he was able to see all the objects around him. However, he was also noted to not be fixing on the objects that he intended to see. So he was referred to the ophthalmology department at this point, that is post-op day number 2. A visual acuity examination demonstrated bilateral no perception of light with bilateral inaccurate projection of rays in all quadrants. However, pupils were briskly reacting to light with no anisocoria, and extraocular movements were seen to be present on verbal commands. So repeat MRI brain with contrast was done, which showed an acute non-hemorrhagic infarct of the bilateral PCA territory, including the bilateral occipital lobes. As we can see here, there are areas of diffusion restriction in the left more than the right occipital lobe. And a comparison of the pre-op and post-op scan shows the right VP shunt in C2 with significant decompression of ventricles and hydrocephalus. So our acute obstructive hydrocephalus. Clinical features of the denial of blindness by the patient suggested a diagnosis of Anton syndrome, which is classically seen in cortical blindness. He also had mild COVID-19 on CORAD stadium. He was discharged in a stable condition on dual antiplatelets, that is aspirin and clopidogrel, and seizure prophylaxis with Levipil. After 2 months, he underwent the definitive management of right frontoparietal craniotomy with the transcallosal excision of the colloid cyst. He remains on regular follow-up with the ophthalmology department. At his last visit in March 2021, that is 6 months from diagnosis, the visual acuity was found to be bilaterally hand movements close to face. The remaining ocular examination was normal, that is bilateral pupils were briskly reacting to light, and fundus was normal with no disc edema. He was able to perceive light and identify the person at near distance. Anton syndrome is a rare disorder characterized by the denial of visual loss and confabulation seen in cortical blindness. The exact mechanism remains to be elucidated, but it's hypothesized that patients with damage to the primary visual cortex bilaterally also have damage to their visual association cortex, which contributes to the lack of insight into their condition. Patients with this condition strongly believe in their visual aptitude, despite having an obvious deficit, which is manifested by walking into walls, falling over objects, or even describing objects that are not present.
Cerebrovascular disease is the most common cause of cortical blindness leading to Anton syndrome. Hence, it's primarily a disease of the elderly who have multiple vascular risk factors. However, a handful of cases have been reported even in younger age groups with non-vascular etiologies. So our patient demonstrated the classical description of Anton syndrome, but he was unique as he was a young patient and the underlying etiology was a cyst-related acute hydrocephalus with intracranial hypertension. The pathophysiology behind this is a transtentorial brain herniation as a result of the raised ICT, which impinges on the posterior cerebral artery as it traverses the tentorial incisura. This results in the non-hemorrhagic PCA territory infarct. Existing literature on the rehab of patients with Anton syndrome is limited, but
You
it
have 1
poses a
minute
challenge.
left.
Thank you, ma'am. But it poses a challenge because of the denial of the deficit by the patient. A satisfactory recovery of visual acuity has been reported in a handful of cases that have reversible etiologies such as cortical hypoperfusion and hypertensive encephalopathy, wherein correction of the causative factor led to resolution. However, in our patient, the presence of bilateral occipital lobe infarcts would suggest that he would be unable to fully regain his visual acuity despite the small recovery we have seen in 6 months. So in conclusion, PCA strokes can be challenging to identify, and on several occasions, patients may not even be aware of the subtle manifestations of this condition, making the diagnosis even more difficult. This case is hence presented for its rarity of a combination of raised ICT and cortical blindness. It emphasizes the need to have lateral thinking regarding events that may occur after making the primary diagnosis and starting treatment in order to be able to dynamically alter the management strategy and institute early treatment. These are my references. I would like to thank my mentor and HOD, Professor Suhas Bhakar sir, and also to BOA Summer Symposium for giving me the opportunity. Thank you.
Thank you, Neha. Judges, any question for Neha, Dr. Neha?
Was the patient given steroids after surgery? I mean, steroid.
The steroids were started actually when he was admitted in the ward post-operatively, but they were started and tapered and stopped before he was discharged.
Okay.
Thank you, Neha.
Okay, thank
Judges,
you,
should we take Dr. Utkarsh Rai? He is requesting to take his earlier because of his COVID duty.
Excuse me.
Okay.
Hello.
Yeah.
I'm Dr. Nisarga. I was fourth.
Yeah. Just wait. Yeah, you are four. But Dr. Utkarsh is requesting. He has some COVID duty.
It's okay.
Dr. Utkarsh, are you ready with your presentation?
Yes, sir, I am.
Yeah. Go on. Go on now.
Yeah, go ahead.
So can you see my screen?
Yes.
Okay. Good afternoon, everyone. I'm going to present a case report on primary malignant zone B cell extranodal non-Hodgkin's lymphoma of the orbit. I have no financial interest in this presentation. To begin with, primary non-Hodgkin lymphoma of orbit is a rare presentation. The primary extranodal lymphoma is defined when a solitary extranodal site of lymphoma with or without involvement of the contiguous lymph node at the diagnosis is present, or when the main cause of the disease.
Presentation, dear. You're not able to see the presentation.
Is not shared yet.
Okay.
It's not visible.
Can you see the screen?
Not yet.
Is it visible now, sir?
Not yet.
Tech team, can you please help Dr. Utkarsh?
Dr. Utkarsh, you just sort out your problem.
Sure.
Till now, we should take Dr. Nisarg Shirke Rane ma'am's.
Okay, sure.
Dr. Nisarg. Dr. Nisarg, are you ready with your presentation? Dr. Nisarg Rane.
Dr. Nisarg Rane.
Dr. Nisarg Rane. Should we go with ma'am next presenter then? Dr. Rahul Lokhande, are you ready with your presentation?
Yes, sir.
Yes, go ahead then.
So, sir, is my screen visible to you?
Yes, go ahead.
Am I audible, sir, clearly?
Yes.
Okay, sir. So, good afternoon, everyone. Myself, Dr. Rahul Lokhande. I am going to talk on a topic of multidisciplinary and challenging management of a rare case of non-tubercular mycobacterial scleritis in a chronic renal failure patient. So, scleritis is a painful chronic destructive inflammatory disease of the sclera associated with systemic diseases or infection. The majority of the cases are because of autoimmune condition, whereas infectious cases accounts for 5 to 10% as per Western studies, whereas 17% as per Indian literature. The infectious causes are mostly because of exogenous inciting factors such as trauma or surgery. A very few cases are endogenous in origin due to the systemic diseases or immunocompromised state of the patient. The incidence of infective scleritis is mostly due to the bacterial causes followed by fungal, whereas the Indian cases showed that fungal predominance. Among the bacterial causes, Pseudomonas is the most common cause as per the Western literature, whereas a multicentric study by Lan et al. Shows 75% of the cases of infective scleritis are because of tubercular etiology. Atypical mycobacterial tuberculosis is a rare cause. Amongst those, Mycobacterium chelonae is the most common cause. They do not often respond to the commonly available antibacterial therapy, so require surgical debridement, long-term topical and multi-drug parenteral therapy. The initial clinical presentation of infectious scleritis could be similar to the autoimmune one, so differentiation is a challenge without relevant laboratory investigation. A 50-year-old female, known case of chronic renal failure on hemodialysis, was referred to our center with history of right eye recurrent painful red eye, partially responding to topical and systemic steroids since 2 months. So we asked for the history. There was no history of ocular trauma or surgery. There was no rheumatological or connective tissue disorder. So the patient had given past history of catheter-related infection, which was treated by amikacin, and she developed ototoxicity. We have done detailed workup for the autoimmune scleritis, but the serological workup was negative. On ophthalmological examination, her best corrected visual acuity in right eye was 618 and N8, whereas in left eye it was 69 and N6. Her conjunctiva show presence of congestion and chemosis, whereas sclera show presence of abscess on temporal to the limbus, whereas cornea show Dallon temporally and pigments on the endothelium. Whereas lenticular changes show bilateral cataract, right eye more than left eye, and fundus was normal. This is the clinical photograph of the patient showing that conjunctival congestion and chemosis inferiorly, and round nodular yellowish white lesion, which is measuring about 3 by 3 mm, and cornea shows presence of Dallon at 9 o'clock to 8 o'clock. We also confirm our finding with the help of ultrasound biomicroscopy, which also reveals to be a scleral abscess. So we performed a scleral abscess deroofing with scleral biopsy and conjunctival autograph. This is a clinical photograph after conjunctival deroofing and conjunctival autograph. So during the scleral biopsy, we have sent the infective and necrotic material with the pus for microbiological examination and histological examination. Microbiology revealed to be rapidly growing non-tubercular mycobacterial infection. The organism was Mycobacterium chelonae. it was susceptible to trimethoprim, sulfamethoxazole, amikacin, and clarithromycin, linezolide, and fluoroquinolones. So based on that, we have started her on topical eye drops, fortified amikacin eye drop 2.5%, and fortified clarithromycin eye drop 1 hourly, and atropine eye drops 3 times per day, and gatiploxacin eye ointment once at night. After a week or so, there was poor response to the topical treatment, and considering the systemic comorbidity of the patient, we have decided to give subconjunctival injection of amikacin. We have given 0.5 ml of subconjunctival amikacin till the time we get the clearance from the nephro team and infectious disease team. So after getting clearance, we have started her on alternate day regimen of tablet Bactrim, single strength, tablet rifabutin, tablet clarithromycin, and tablet linezolide, along with the monitoring of the complete blood count and renal profile every monthly. So after 2 months of slow recovery of scleral abscess reduced significantly, but the patient developed corneal infiltrate. We can see on clinical picture. And on ultrasound biomicroscopy, there is significant reduction in the scleral abscess. The corneal infiltrate, we have sent a scraping for microbiological examination, which was found to be fungal etiology. So we have stopped all the local antibiotic eye drops and started her on natamycin eye drops 8 times per day, atropine eye drops 2 times, and topical lubricants. So patient recovered after 1 month with best corrected visual acuity of 6/18 in right eye with near vision N8, and in left eye it was 6, 9, and 6. These are the clinical photographs. We can see the scleral abscess is almost healed, and cornea show presence
1 minute left.
So atypical mycobacterial scleritis commonly occurs most commonly in immunocompromised individuals. Several cases of non-tubercular scleritis have been described in the literature following pars plana vitrectomy, scleral buckling, and pterygium excision. Presence of hard or soft silicone scleral buckles promote the development of glycocalyx and biofilm formation. Topical mitomycin and beta irradiation after pterygium excision reduces the ocular surface immunity and increases the likelihood of non-tubercular scleritis. There are only 2 cases in the literature which are found to be because of non-tubercular mycobacterial scleritis without any inciting factor. Among all non-tubercular mycobacterium, M. chelonae is the most common organism. Non-tubercular mycobacterial ocular infections have been increasing in prevalence over the past few decades. They are known to cause periocular, adnexal, and surface and intraocular infections, which are recalcitrant to medical therapy. These infections can potentially cause detrimental outcomes, in part due to delay in diagnosis. So, concluding, the infectious scleritis is because of myriad organism. Trauma, history of previous surgery, and systemic illness are the most common associations. Principle of the treatment includes mycobacterial microbiological identification, surgical debridement, appropriate antimicrobial helps in complete resolution. Whereas if corticosteroids are given before the infection, controls and before the control of infectious scleritis worsen the condition. Infectious scleritis should be considered when there is no inciting factor present in an immunocompromised patient, and multidisciplinary approach with the long-term systemic treatment is recommended to improve the clinical outcome in case of infective scleritis with immunocompromised patient. Ocular surface and corneal toxicity is expected in long-term topical treatment of fortified antibiotics. These are my references. Thank you.
Thank you, Rahul.
Thank you, sir.
Any questions from judges, sir? Okay, we'll go ahead with your next presenter, Dr. Nisar Rani. Are you ready with your presentation now?
Hello.
Dr. Nisar.
Hello.
Yes.
Can you hear me, sir?
Yes. Yes.
Give me a second, please. Hello.
Yeah.
Is my screen visible, sir?
No,
Hello.
it's starting, but yeah, now it's visible.
Okay.
Go ahead, please.
Good afternoon, everybody. I'm Dr. Nisarga. I'm going to talk about the impact of COVID-19 pandemic lockdown on the eye emergency at a tertiary care hospital. COVID-19 pandemic 2020 led to a nationwide lockdown restricting the movement except the medical emergencies. The entire medical workforce was engaged in COVID-19 management, which left the ocular and other medical field emergencies neglected. The decision of the extent of the urgency was left to the individual doctor, leaving them without any clear guidelines, which made a huge impact on the visual prognosis in cases of ocular emergency. How justified was that? This study describes the impact of COVID-19 related lockdown on the pattern of presentation of the ophthalmic emergency and emergency surgery performed at a tertiary care hospital in India. This is a retrospective observational study conducted at Tertiary Care Dedicated Ophthalmology Hospital from March 24 to June 24, 2020, including 267 patients. All the ocular emergency requiring surgical interventions were included. The patients of the polytrauma were not included in this study. To reduce the transmission of COVID-19 virus, we implemented the new safety protocol guidelines provided by All India Ophthalmology Society. Demographic data and detailed history regarding the urgency, its nature, circumstances were obtained from all the patients. Snellen's chart, intraocular pressure, slit lamp examination, 90-day examination, and indirect ophthalmoscopy was carried out. Radiological investigations like X-ray, orbit, CT scan, MRI, required blood investigations and systemic evaluation were carried out from case to case. Patients were then classified on the basis of the treatment they received, medical and surgical. RT-PCR was done in all the patients who underwent ocular surgeries. Out of 267 patients presenting to us, 93 were managed surgically or were managed medically. 174 patients were managed surgically. Majority of them were males. Maximum patients came from the urban areas. More than half of the patients belong to the pediatric age group, that is less than 15 years of age. History of ocular trauma was present in 135 out of 174 surgically managed cases. 50% cases were attributed to the indoor trauma, playing with the objects, blunt or sharp. Workplace-related trauma was recorded only 9%. Ocular trauma due to road traffic accidents was least, that is 2%. Only 15 cases, that is 11.11% out of 135 ocular emergency cases presented to us on the day 1 of trauma. The most common surgical indication was open globe injury, followed by post-traumatic cataract. The most common type of surgery performed was cataract extraction with or without IOL implantation for hypermature cataract, lens-induced glaucoma, traumatic cataract. These are few of the pictures from the cases we performed during the lockdown. COVID-19 happens to be one of the biggest crises causing unpredictable circumstances worldwide. In India, the nationwide lockdown 2020 led to majority of the standalone private practitioners to close their practices, due to which many ophthalmologists working in a large institute and government hospital had to deal with the ocular emergency during the time of pandemic. In current study, we observed that the traumatic pediatric emergencies were found to be the most common. Indoor trauma was found to be the commonest cause. Urban emergencies presented more as compared to the rural emergencies because of the lockdown. Pellegrini et al., Madhushekar et al., Aditipai et al. Conducted similar studies and found the increase in the eye injury from the violence and home activities during the lockdown period. Comparison of my study with the above 3 studies is enlisted in this table. Limitation of this study: many patients were lost to the follow-up owing to the travel restrictions which were implemented and inter-district transportation being stopped. Delay in the management leading to an altered prognosis still needs to be evaluated. From this, I would like to conclude that majority of cases of the ocular trauma were observed in the pediatric age group less than 15 years of age, which might be attributed to the children being at home. Late presentation at the hospital owing to the limited transportation facilities because of the lockdown period, which might have hampered the visual prognosis. My take-home message to all from this is that more wide-scale studies need to be conducted for the ophthalmologist to understand the patterns in the eye emergency visits during the unpredictable circumstances, which can provide an insight to the potential toll of COVID-19 on timely ophthalmic care. Healthcare systems should be well equipped and accessible to effectively sustain the emerging trend of non-COVID-19 emergencies. The use of tele-ophthalmology and other new modalities such as mobile clinic reaching the socio-economically underserved population both in urban and the rural areas still needs to be explored more. These are few of my references. Thank you.
Any question from judges? Dr. Nisarga? Okay, we'll move on to our last presenter, Dr. Utkarsh Rai. Are you ready with your presentation? Dr. Utkarsh.
Yes, sir.
Yeah, go ahead. Yeah, go ahead.
So is my screen visible?
Yeah, now it's visible.
Good afternoon, everyone. I'm going to present a case report on primary marginal zone B-cell extranodal non-Hodgkin's lymphoma of the orbit. To begin with, primary non-Hodgkin's lymphoma of orbit is a very rare presentation. The primary extranodal lymphoma is said when a solitary extranodal site of the lymphoma with or without involvement of the contiguous lymph nodes at diagnosis is present, or when the main bulk of the disease is located at the extranodal site. The ocular non-Hodgkin lymphoma represents around 10% of the orbital tumors, which is less than 1% of all NHL, and around 5 to 15% of all extranodal non-Hodgkin lymphomas. For orbital lymphomas, it is the mild lymphomas which account for majority of the lymphomas rather than the B-cell lymphomas. To begin with, a 37-year-old male presented to our ophthalmology OPD with bulging of his left eye since last 9 months. He had swelling of the left upper eyelid for last 2 months, which was associated with redness and watering from his left eye. He also complained of restricted eye movement in the left side for 1 month, which lost about a year. Upon examination, his best corrected visual acuity was 6 and 6 in both eyes with the help of corrective lenses. He had swelling of the left upper eyelid, and the conjunctiva showed hyperemia with marked chemosis, termed as a Salmon patch. The swelling per se was non-tender, soft, and ill-defined, present superolaterally in the left orbit, which was not fixed to the skin and was non-reversible. It had no impact on with bulging or straining. The extraocular muscle movement of the left eye were reduced in the lateral grades, and Lute's exophthalmometry, when done, showed axial proptosis and had a value of 20 mm in left eye compared to 18 mm. Ultrasound B scan was performed, which showed homogeneous mass in the upper outer quadrant in the left eye, size of 3.6 to 1.8 centimeter, and retroocular extent and scleral involvement. Ultrasound Doppler showed the mass with no retroorbital collection of mass. Rest of the findings were insignificant. A CCT was corroborated the findings with lobulated hyperdense soft tissue density mass and locality in the left orbit with left lateral infiltration. It showed moderate homogeneous post-contrast enhancement, and there were fine bony sclerosis and osteolysis in the left lateral orbital wall. An FNAC was performed which showed high cellularity, monotonous population of lymphoid cells, and robust centrocyte immunity. Cells were very large and pleomorphic. Their high nuclear cytoplasmic ratio with and inconspicuous nucleoli. Very few mature lymphocytes were seen with background RBCs present. The biopsy thus confirmed a B-cell extranodal marginal zone non-Hodgkin's lymphoma. An HRCT of abdomen pelvis was performed, which revealed secondaries in the inguinal region of the patient. Unfortunately, immunohistochemistry could not be done as was not affordable to the patient. Rest of the blood, viral markers, thyroid, liver, and renal functions were within normal limit. The patient was initially managed with artificial tear fluid and antibiotic eye drops. He then underwent chemotherapy with R-CHOP cycle, 1 cycle, and CHOP regimens given at 3 weekly intervals, which was then followed by external beam radiotherapy. This is the treatment modality, which started with prednisolone, rituximab, cyclophosphamide. hydroxydonorobropin, oncovin, and prednisolone. He was then followed up every 3 monthly for about 2 years, and then 6 monthly for the next 3 years. He was then advised to come for follow-up every year annually. At the second follow-up after 6 months, doctors had reduced drastically, left lateral rectus thickening had regressed, and the UM movement had normalized markedly. BCVA still maintained at 6 and 6 with the help of corrective lenses. Why this case report was presented? The orbital non-Hodgkin lymphoma usually present in the elderly age group in the 7th decade. The case reported here presented in his mid-30s. More than 2/3 have only primary orbital NHL, where less than 1/3 have systemic involvement, as seen in this case with Ingana secondaries. Radiotherapy usually quite effective in localized disease, but massive tumors of systemic involvement warrants the use of chemotherapy. The visual prognosis is usually excellent in cases with only orbital involvement. However, the overall prognosis for life is variable, with a 5-year survival rate being 60%. There is a 60% chance of developing a systemic lymphoma within 5 years. To conclude, though rare, a primary orbital non-Hodgkin lymphoma needs due consideration in younger cases too, with slow-growing unilateral prognosis. And after imaging and diagnostic biopsy, it should be promptly staged and treated for better prognosis and survival rate. Lifelong follow-up is needed to monitor for complications, detect any recurrence of the tumor or any secondary tumor formation. Thank you for your patience.
Thank you. Thank you, Utkarsh. Judges, any questions? This is our last presenter. Judges, any questions for Utkarsh? Dr. Utkarsh? Okay. Thank you all judges, Dr. Gauri Bade madam, Dr. Deepak Kumare sir, and Dr. Srikant Deshpande sir for
Thank
your
you, sir.
valuable time.
Thank you, sir.
And thank you all the case presenters who have presented excellent presentation, and all the best for their results. Now I will declare that the session is concluded. Thank you all.
Thank you.
Thank you, sir.
ஸ்டார்ட் வந்து 3:17 சொன்னான்னு வச்சுக்கோங்க. இதை ஆன் பண்ணி விடணும் இங்க 3:45.
ഇത് പറയണം എനിക്കൊന്നും മനസ്സിലുണ്ടായി പറയണം മെയിൻ സബ്ജക്ട്സ് മാത്രമല്ല MITs എന്ത് മെയിൻ സബ്ജക്ട് എല്ലാ എക്സാംസും അങ്ങനെ പറ്റില്ല ഒരു ഓപ്ഷനേ ഇല്ല ഇന്നലെ പഴയതായിരിക്കും അതൊരു കേരള ടീച്ചർ ന്യൂസ്മാര് വന്ന് എടുക്കുമായിരിക്കും
மீட்டிங் ஐடி சொல்லுங்க மீட்டிங் ஐடி என்ன பேசலாம் கேட்டிருக்கீங்களா கேட்கணும் சார் மீட்டிங் ஐடி சொல்லுங்க 963 உத்தம இருக்கு 963 ஆமா சார் ¿Cómo se la ven como que es un
So
Good afternoon, everyone. Welcome, Dr. Jairam sir, Dr. Meenu ma'am, and Dr. Shukla sir. Very warm welcome on behalf of BU and MOS in this free paper session. Dr. Saket Patil sir. Good afternoon.
Yeah. Good afternoon, everyone. I welcome you all to the KANSKI Hall. We'll be having free papers on retina, UVA, and trauma. Let me introduce. Shall I start the introduction, sir?
Yes, please. I think we should, with the permission from the respectable judges, we can start the session. Shukla sir, is that okay? Jairam sir?
Yeah, it's okay.
Yes, Meenu ma'am will start the session. Good afternoon, ma'am.
Yes,
good afternoon.
Yes, sir. Saket Patil sir, you can start the session.
Yes, sir. I'll start with the introduction. Let me introduce Dr. Ajay Shukla, sir. Sir has graduated from Maulana Azad Medical College, Delhi, and he has done his post-graduation from Delhi University. Sir is closely associated with NPCP program, and his interventions have significantly reduced blindness, significantly cataract-associated visual impairment in and around Wardha district. Our second judge, sir, is currently professor and dean at MGIMS Medical College. Our second judge, Dr. Meenu Ramakrishnan Madam, she is MBBS, DO and DNB from St. GS Medical College and KM Hospital. Madam is HOD at the KJ Somaiya Medical College. She is successfully running eye donation and keratoplasty center at KJ Somaiya Medical College. Our third judge, Dr. Sakaram Jairam. Sir is graduation. Sir has done his graduation and post-graduation from Kurnool Medical College, Andhra Pradesh, and sir is currently associated as professor in Ashwini Rural Medical College, Solapur. Today we have in all 8 speakers. All the speakers will get 6 minutes for paper presentation and 2 minutes for question session by the judges. Shall we start with the first paper?
Yes,
yes, please.
Yeah. I request Dr. Sahil Agrawal to start his paper. His topic is the delivered globe in a delivered newborn. Dr. Sahil.
Sir, I think Dr. Sahil has not joined the meeting yet. I am trying to contact him. Meanwhile, Dr. Sanchit Balgat is there. Dr. Sanchit, you're there?
Yes, sir.
Yeah. Can you please share the screen? We will start with the second presentation.
Yeah. Dr. Sanjit's topic is case of choroidal tumor with exudative retinal detachment in a child with Sturge-Weber syndrome.
Shall I start, sir?
Yeah,
please.
Good afternoon, everyone. Today I am going to discuss a case of diffuse choroidal hemangioma in a child with Sturge-Weber syndrome. A 9-year-old female presented to our OPD with complaints of progressive severe diminution of vision in her right eye since 2 weeks. There was no history of pain, redness, or watering, no history of any spectacle use. Patient is a known case of Sturge-Weber syndrome and has history of 3 episodes of seizures 5 to 6 years back, which were associated with a fever. There is no history of consanguinity and no significant birth history. In her ocular and external examination, we found that she had a port wine stain on the right side of her face, extending up to her lip. And in her ocular examination, we found that her vision in the right eye was finger counting 1 meter, perception of light was positive, and PR was accurate. In the left eye, her vision was 624, improving to 618. Tension in both eyes was 14 mmHg. Other than the port wine stain, There were no significant anterior segment findings. In the posterior segment, we found that there was a diffuse, thickened, and large lesion associated with an exudative retinal detachment overlying it and extending beyond it, as you can see in these two pictures. In the right eye, there was no significant finding in the left eye. These findings were confirmed by us on B scan, where we found there was a thickened large mass at the choroidal level, so along with a retinal detachment extending beyond over it and beyond it. We also had an external radiologist perform the B scan, and at that point of time, his provisional diagnosis had been choroidal lymphoma. However, we had found no literature relating choroidal lymphoma to Sturge-Weber syndrome. FFA showed a lacy early hyperfluorescence, which went on to increase in the later phases, and this was suggestive of a choroidal hemangioma. We wanted, because of the earlier diagnosis of choroidal lymphoma or other secondaries, we wanted to confirm if it is an hemangioma or a secondary. So we got an MRI done. The MRI showed diffuse thickening along with the exudative retinal detachment, and it was high present in both the T1 and T2 weighted scans, which confirmed our diagnosis of a choroidal hemangioma. In further management, our patient has been advised external beam radiotherapy, considering the patient's age, the size of the tumor, and presence of retinal detachment, also considering the patient's finances. And she will be undergoing the same in the coming week. Patient has already been started on oral propranolol at a dose of 30 milligram per day in 3 divided doses, which has been seen to be effective in multiple reported cases. As a part of the discussion, we have found that children with Sturge-Weber syndrome usually have diffuse choroidal hemangiomas, and the presenting age is also very similar to what we found in this 9-year-old child. However, because of the initial confusion whether it's a lymphoma or a hemangioma, we had some diagnostic as well as therapeutic questions. With the B scan, then we got an MRI done, and with the MRI, we were able to rule out secondaries or lymphoma or any other pathology, and were able to confirm that this was indeed a hemangioma. Because of the financial implications of photodynamic therapy, with a verteporfin dye being really expensive, and considering that it was large, so it would need multinodal, like multiple points of photodynamic therapy, we consulted an ophthalmic oncologist, and he has suggested that the best option would be to go ahead with an external beam therapy. We have also started a patient with oral propranolol, as I mentioned before, and we will be reporting it in our further presentations or publications whether how the effect of both these therapies was. These are my references.
Over to the judges, please, for the questions. You can stop sharing your screen, Sanchit.
Should I share it again, sir? Okay.
You can stop sharing the screen.
Dr. Sanchit?
Yes, ma'am.
Yeah, Dr. Meenu here.
Good morning. Good afternoon.
Good afternoon. Did you do any systemic workup for this patient? Like, since you were thinking of a lymphoma or other metastasis, any other systemic workup you have done for this case?
Yes, ma'am. We have done an overall. We sent her to an oncologist at our hospital, and we got an MRI brain also done. The MRI brain is showing right diploic veins dilatation, but since the neurologist said that since they have not had an episode of seizure since in the last 5 to 6 years, nor any other neurological abnormalities, so they said they don't want to do any treatment at this point of time, but they will be monitoring the patient, ma'am. But no other site was noted of neoplasm or cancer was noted anywhere else in the body, ma'am.
Okay, any blood workup?
We got our routine investigations done, ma'am. CBC, ESR, and
Harish,
other blood profiles done, ma'am, but nothing significant came up on that either. No anemia or anything.
Okay, thank you.
Thank you, ma'am.
Hello. Any other questions by the
Dr.
judges?
Sanchit, Dr.
Yes.
Sanchit,
Yes,
did
sir.
you keep that patient for glaucoma follow-up?
Yes, sir, we have. We are monitoring her intraocular tension regularly, sir. But at this point of time, there is no raised IOP.
Hello, Dr. Sanjay, Dr. Shukla here.
Yes, good afternoon.
Have you been able to get a pediatric or neurological evaluation of this child done?
Yes, sir. Yeah.
Because these are the children who are prone to develop seizure disorders, which are very well known in almost 40 to 50% of these children.
Yes, sir. We have got a neurological evaluation as well as an EEG done, sir, and there was no abnormality noted on the EEG.
Thank you.
Shall we move on to the next presentation?
With the permission from the judges, may I add a question here?
Yeah.
So Dr. Sanjit, you had shown a diffuse kind of a choroidal hemangioma here, which was large. So the size exactly is not mentioned here. Suppose it would have been a smaller choroidal hemangioma of 12 by 6 millimeter by 6 millimeter, then what, with this kind of exudative retinal detachment, what would be the preferred treatment that you would have asked patient to go for?
Photodynamic therapy would have been preferred treatment, or if since the patient would not be so affording, we could have done a plaque brachytherapy as well, which has both of which have shown good results. Of course, both of them have their significant share of side effects. But if the patient had been affording, we could have done a photodynamic therapy. But in this scene, I think we could also do a plaque brachytherapy.
So for the nodular kind of a choroidal hemangioma, the plaque brachytherapy is the treatment of choice because it has minimal side effects and the radiation is very local. And the dose for such a small, like the one I mentioned, 4 to 6 millimeter tumor is also needed very less, which will reduces the chances of any further radiation retinopathy. So for any kind of a small nodular, the plaque brachytherapy is the way to go.
Yes.
Thank you. Nice presentation.
Thank you, sir. Thank you, ma'am.
Next, Dr. Saket, sir, over to you.
Yeah. I'll call upon the next presenter, Dr. Archana Bhuvanendran. The topic is to study the etiology and management of ptosis in patients between 20 to 50 years of age. Dr. Archana?
Yes, sir. Am I audible, sir?
Yeah.
Yes, yes.
Any problem sharing the screen, Dr. Archana?
Yes, sir. I couldn't share.
Try once again. Okay, now we can see your slide. You can start, Dr. Archana. Dr. Archana, we can see your slide. You can start presenting, please. Dr. Archana? Dr. Archana, can you hear us?
Initially, your voice was coming now. I think.
Dr. Archana. She has muted the
we are
meeting
unable to
and
get
she's
her.
trying to share. Dr. Archana. Technical team.
Yes, doctor.
Can you please stop sharing the screen of Dr. Archana? We will move on to the next presenter.
One second.
Yeah, it happened already. Dr. Khushbu is there? Dr. Khushbu? Dr.
Yes, sir.
Khushbu, yeah,
Yes.
are you ready? Can you please start the presentation?
Yes.
Dr. Khushbu's topic is acute proptosis with orbital compartment syndrome due to bilateral pansinus mucopyoceal, an unusual occurrence, management, and result.
Sir, is my screen visible?
Yes, ma'am.
Yeah.
Good afternoon, everyone. Today I'm presenting a case of acute proptosis with orbital compartment syndrome due to bilateral pansinus mucopyoceal, which is an unusual occurrence, management, and result. I have no financial disclosures. Just let me give a brief introduction regarding the mucocele. Mucocele is an epithelium-lined mucus containing cystic lesion, which has potential to gradually expand and fill the sinus completely. The incidence of mucocele in general population is 0.4 to 0.8%, and it can involve paranasal sinuses, oral cavity, appendix, gallbladder, or lacrimal sac. When the contents of the mucocele become infected, it is termed as mucopyoceal. Among the paranasal sinuses, the most prevalent one is the ethmoid, and then frontal, sphenoid, and the least prevalent one is maxillary sinus. Mucopyoceal generally present with the displacement of the globe, diplopia, ocular pain, headache, Horner syndrome, or hypopituitarism. A 37-year-old Indian female presented to our OPD with the chief complaints of forward protrusion of left eye for 1 week and the complaint of diminution of vision for the same duration. The forward protrusion was associated with the intermittent fever, bilateral frontal headache, and mucoid nasal discharge for the same duration. Patient had a past history of FEST for chronic allergic sinusitis associated with bilateral sinonasal polyposis 1 year ago before the time of the presentation. There was no history of diabetes mellitus, hypertension, ocular surgery, or trauma. On examination, visual acuity was 6.6 in right eye, and left eye it was 6.18. And left eye abaxial proptosis with hypoglobus was present, and there was resistant to retropulsion. In left eye, extraocular movements were limited in all gazes, and Hertel's thermometry showed 28 millimeter of proptosis in the left eye. There was bilateral frontal and maxillary sinus tenderness were present. Grade 2 RAPD was present in left eye, and fundus examination was normal. On anterior rhinoscopy by our ENT colleague showed bilateral inferior turbinate hypertrophy. Systemic evaluation was within normal limits, except the CBC count showed mild leukocytosis. Radiological investigation, CT scan of the orbit shows a heterogeneous mass which was rising from the frontoethmoidal sinus and infiltrating the left orbit, causing the indentation of the globe, as we can see in figure A by the arrow, the indentation of the globe and the tenting of the optic nerve in figure B. MRI of brain and orbit showed peripherally enhancing areas in bilateral nasal cavity and the involvement of all the sinuses, the maxillary sinus, the frontal sinus, and the ethmoidal sinus, bilateral ethmoidal sinus, as we can see in figure C, along with the sphenoidal sinus and the coronal section showing the involvement of the frontal sinuses. And there are bilateral erosion of lamina papyracea and posterior inferior wall of the frontal sinuses. The lesion also extended behind bilateral orbit. In the left orbit, it causes the significant mass effect with the depression of the extraocular muscle and the resultant proptosis. And in the right orbit, it causes the significant mass effect on the medial rectus muscle, as we can see in this figure C. Now, coming on to the differential diagnosis, the first differential in our case was pansinus mucopyoceal. Then a second differential was bilateral fungal mass, and the third differential was bilateral sinonasal malignancy. Now, coming on to the treatment, first, initially we started the patient on the empirical antibiotics. Then The patient underwent an endoscopic guided wide bore needle aspiration of pus along with the exploration and biopsy. The pus and straw colored fluid, which we got with the 16-gauge needle, we sent for microbiological examination and which were non-revealing of any organism. Biopsy tissue was also sent for microbiological examination as well as for histopathological examination. Microbiological examination was non-revealing of any organism. Histopathological examination showed mucosal tissue lined with ciliated columnar epithelium and an underlying scattered seromucinous gland and the mixed inflammatory infiltrate composed of lymphocytes, neutrophils, and macrophages, which are consistent with the finding of the mucobiopsy. Now, my final diagnosis was acute proptosis secondary to bilateral pan-sinus mucobiopsy with orbital compartment syndrome. At 2 weeks follow-up, the patient proptosis was relieved and the BCVA was 6.6 in both eyes. Extraocular movement was full and free in all cases, and there was resolution of RAPD in the left eye. As per discussion, bilateral pan-sinus mucobiocele is a rare entity, and traditionally mucocele has slowly expansile nature and generally presents later in a course. However, in our case, it presented with acute proptosis with orbital compartment.
You have 1 minute left.
To the best of our knowledge, such kind of occurrences hasn't been reported previously. Mucocele usually accompany the path of least resistance, which often leads to orbital extension. MRI is considered as the best gold standard investigation for diagnosis. However, investigation of choice remains CT because to rule out any bony erosion. Endoscopic orbital decompression should be considered, and the primary etiology should be targeted to relieve intraorbital pressure in such cases. Now, the learning points in my cases is mucobiopsy, specifically paranasal, should continue an important differential, constitute an important differential in the case of rapidly progressive proptosis, especially with the patients having history of sinus surgery. Rapidly progressive proptosis with orbital compartment syndromes indicate the development of mucobiocele and needs urgent intervention for preventing any loss of vision. And endoscopic exploration and decompression provides definitive diagnostic and therapeutic intervention in these cases. These are my references. Thank you.
Shall we start with the question answers?
Yeah, Dr. Khushbu?
Yes, ma'am.
Yeah, this is Dr. Meenu here.
Yes, ma'am.
So in this case, did you do only a CT or you did an MRI also?
Ma'am, we did both CT and MRI. First, we did with CT and then we did an MRI.
Okay, so it was a plain CT and a plain MRI?
No, ma'am, it was contrast enhanced CT and contrast enhanced MRI. Both were contrast enhanced, in which we see the hyper intense lesion on the two dotted images.
Yes, yes.
Yeah.
Dr. Shukla, sir, any questions?
Dr. Khushbu, what are the chances of recurrence in these cases?
Sir, in such kind of cases, generally the reported recurrence of mucobiocele is considered as 4 to 8% in normal cases. However, in our cases, as we targeted the primary etiology, so we expect less chance of recurrence in such kind of cases.
Yeah. Did the vision recover in this patient?
Yes, ma'am. The vision recovered. BCVA was 6.6 after the orbital decompression.
Any questions, Dr. Sakaram, sir?
Will the face surgeries make this mucosal common? Is it a predisposing factor for the mucosal stroke? Face surgeries making wall weakening and hello.
Sir, your voice is not clear. I'm sorry, sir.
Voice is breaking, sir.
Hello.
Can you please repeat the question?
Hello.
Yes.
We can hear you, sir. Can you please repeat the question?
This
I think there is some problem with the network. Dr. Khushbu, you can stop sharing your screen meanwhile.
Okay.
Can we move on to the next presentation, sir?
Yeah, I think Dr. Saket sir, Dr. Archana is ready with the presentation. So Dr. Archana, you're there?
Yes, sir.
Yeah, okay. We'll be sharing your slides from our computer.
Right. Yeah. Please, Dr. Archana.
Good afternoon, sir. My paper for today is study on the etiology and management of ptosis between 20 to 50 years of age. Purpose of this study is to study the etiology of ptosis between 20 to 50 years of age, management of various types of ptosis, to assess the outcome of various surgical modalities in the management of ptosis. Materials and methods are, this is a prospective study of 30 patients with various types of ptosis conducted at Orbit and Oculoplasty Department, Regional Institute of Ophthalmology, IGMOR, Chennai for a period of 1 year. Methodology, patients were evaluated with detailed history, complete general examination and ocular examination. Surgical choices were based on the visual acuity testing, anterior segment evaluation, ptosis evaluation, and posterior segment evaluation for all operated cases. Ptosis evaluation includes examination of head posture, vertical palpebral height, margin reflex distance, lid crease level, levator palpebrae superioris action, Bell's phenomenon, Marcus gun jaw winking phenomenon, ice pack test, fatigability test, strabismus evaluation, and extraocular muscle motility. Based on clinical examination, a clinical diagnosis is arrived and further investigations are done to aid in etiological diagnosis. Patients will be treated accordingly, and if managed surgically, then the outcome of surgery is also assessed. Pre and post-operative photographs were taken and documented for comparing outcome of surgery. Incidence of ptosis among all age groups. Up to 19 years, it's 51%, 20 to 50 years, 33%, beyond 50 years, 26%. Etiological incidence of ptosis among 20 to 50 years. Congenital contributes 37%, aponeurotic 26%, myogenic 13%, neurogenic 10%, mechanical and post-traumatic each contributes 7%. Age distribution between 20 to 50 years of age. 20 to 29 years, 44%, 30 to 39 years, 33%, 40 to 49 years, 23%. Sex distribution between 20 to 50 years of age with ptosis. Here we can see male 70% and female 30%. There is a male predominance. Laterality of ptosis. Unilateral cases are 77% and bilateral contributes 23%. Degree of ptosis. Moderate is most common, contributes 46.70%, and severe 43.30%. Mild contributes 10%. Management of ptosis between 20 to 50 years of age. 30% of cases were managed medically, and 70% of cases were managed surgically. Management of congenital ptosis. Frontalis sling was done for 11 patients of congenital ptosis with poor levator function with Fox pentagon technique. The affected eye was operated in the study. This is the preoperative pic of the patient, and the other one is the postoperative pic. Uncomplicated cases were 63.6%. Uncorrected cases contributes 27.3%. Under correction contributes 27.3%, and exposure keratitis 9.1%. Management of aponeurotic ptosis. Levator aponeurotic advancement surgery was done for 8 patients with aponeurotic ptosis with levator function. The technique that was used was transcutaneous approach. Here is a preoperative picture of the patient and postoperative picture. Uncomplicated cases were 75%. Under correction and lid peaking was 12.5%. Management of mechanical ptosis. In the study, 2 cases were there. First case, excision biopsy was done, which on histopathological examination turned out to be squamous papilloma. Second case, calazion-induced mechanical ptosis, for which calazion incision and curettage was done. Management for neurogenic ptosis. In the study, 3 cases of neurogenic ptosis were there. First case, leptomeningeal carcinomatosis infiltrating the third nerve, and the patient was on chemotherapy. Second case was posterior communicating artery aneurysm, for which aneurysmal clipping was done in the neurosurgical department. Third case, microvascular ischemia due to diabetic etiology, and MRI brain turned out to be normal. Hence, patient was managed medically and symptomatically by occlusion of the affected eye. Management of myogenic ptosis. Out of 4 myogenic cases, 3 turned out to be myasthenia with positive IcePack and fatigability test and anticholine receptor antibody positivity and was managed medically by acetylcholinesterase inhibitors. Other case was diagnosed to have chronic progressive external ophthalmoplegia and was prescribed crutch class. Management of post-traumatic ptosis. There were 2 cases of post-traumatic ptosis. First one, traumatic third nerve palsy with traumatic optic neuropathy, and patient was started on intravenous methylprednisolone 500 mg BD for 3 days, followed by oral prednisolone 1 mg per kilogram body weight. Second case, mild traumatic ptosis due to elevated dehiscence and traumatic iritis, which was managed medically by topical cycloplegics and steroids. Discussion. Most of the patients were operated in second and third decade, and most common ptosis was simple congenital ptosis, and most common surgery was levator resection through transcutaneous approach. Of congenital ptosis, most had poor levator function. Frontal sling was most common surgery done. Congenital ptosis were more common than acquired ptosis. In acquired ptosis, aponeurotic was most common. Ma'am? In acquired ptosis, aponeurotic was most common cause, followed by myogenic ptosis. Moderate ptosis was most common type, followed by severe and then mild ptosis. Conclusion. Among the middle-aged population, incidence of ptosis was found to be more common in the age group of 20 to 29 years, indicating the need for cosmetic correction among this group. Congenital ptosis and aponeurotic ptosis are 2 broad groups which account for majority of ptosis between 20 to 50 years of age. The congenital ptosis incidence was more in 20s, while aponeurotic was above 35 years of age, indicating etiological significance. The most common acquired ptosis was aponeurotic, followed by myogenic, neurogenic, traumatic, and mechanical ptosis. Surgery forms the main treatment of choice. Frontal sling surgery is the most common surgery done for congenital ptosis. Aponeurotic advancement surgery is the most common surgery done for acquired ptosis. Thank you.
Yeah, thank you, Dr. Archana.
Thank you, sir.
Now questions. Dr. Shukla, sir, any questions?
Dr. Archana.
Yes, sir.
Yeah, great. Yes, sir. Dr. Jairam, sir. Yes.
Dr. Now, traumatic ptosis, before you go for surgical intervention, how do you want to wait?
Yes, sir. Observation can be given.
What is the time gap would you like to traumatic? Yeah.
If there is no sign of strabismus or no sign of strabismus, amblyopia, or abnormal head posture, we can wait, sir. And in case of mild ptosis, we can wait, sir.
Okay.
So at your center for congenital ptosis, you do only unilateral sling as a routine? Dr.
No,
Archana?
ma'am. Bilateral can be done, ma'am. But according to the levator action, levator function.
Okay.
In this study, only one eye is operated, sir. Only affected eye is operated in this case, in this study, ma'am.
Okay. And in your myasthenia patients, have you ever done a CT scan to look out for any etiology for the myasthenia gravis?
Yes, ma'am. CT chest can be done for ruling out thymoma, ma'am.
Yeah. So do you routinely do that for myasthenia patients?
Actually, ma'am, in our center, we don't routinely do this, ma'am.
Okay.
Because patients, mostly patients are from poor economical status, ma'am. So we don't used to do, ma'am, routinely.
Okay, thank you.
Dr. Archana, any comments upon the visual status or the evaluation of tear film in these patients?
Actually, sir, in the study, it was not done, sir.
Okay.
Okay, Sumit, sir, any questions?
No, sir, nothing from my side.
Yeah. Shall we move on to the next presentation? Dr.
Yes, sir.
Zainab, are you ready?
Yes, sir. Good afternoon, everyone. I am Dr. Zainab Boharwala, first year resident ophthalmology. Today I am going to discuss how big the iceberg really is alarming results at World Glaucoma Week Screening Program 2021 at the Tertiary Eye Care Center.
Can't hear you, Dr. Zainab.
Yeah.
We can see the slide.
Am I audible?
Yeah.
Yes.
Hello.
Yes, you can go ahead. Yeah.
Good afternoon, everyone. I'm Dr.
Unable
Zainab
to hear.
Bohadwala, first year resident.
Not getting your voice.
Yeah.
Keep your device near your face and try to talk little loud and be in a better net connection than you are at present. Try once more, otherwise we'll wait for some time. Take another speaker and start again with me. Try again once, Dr. Zainab. Dr. Zainab, you're there? We can see the presentation. Presentation is not a problem. The voice is the problem. Dr. Zainab. Dr. Zainab. Is Dr. Priyanka Jawahar there? Okay.
Yes.
Yeah. Technical team?
Yes, doctor.
Can you please stop sharing screen of Dr. Zainab so I can tell another presenter to present instead?
Okay, doctor. Okay, one second.
Please. Yeah, Dr. Priyanka, you can start presenting, please.
Good evening, everyone. Is it visible? Am I audible also?
Yeah, very
yeah.
good.
Thank you, sir. Today I'm going to present the correlation of grading of chronic kidney disease with their ocular findings. So introduction, the chronic kidney disease is an irreversible and progressive loss of renal function leading to end-stage renal disease. It is an alarming global health problem since we are in the approach of non-communicable diseases. In India, diabetes and hypertension account for about 40 to 60% of CKD cases. As per the recent ICMR data, the prevalence of diabetes in Indian adult population is 28% and hypertension is 17%. Therefore, CKD is expected to increase and will be the key population to address. So aim of my study is to estimate the proportion of CKD patients with ocular manifestation. It is a hospital-based cross-sectional study. All participants were referred to the Department of Ophthalmology who were diagnosed to be chronic kidney disease, were examined from October 2018 to March 2020. The methodology used was cross-sectional based study. Was carried out in a tertiary care medical college and hospital under the Department of Ophthalmology and Nephrology after the approval of Ethics and Research Committee, where all patients diagnosed with CKD above the age of 18 attending the OPD, and the patients who were on dialysis were also included in the study. Around 111 patients were obtained, who were obtained after valid written and informed consent. Patients were enrolled in the study. History of the patient, like name, age, sex, occupation, socioeconomic status were taken. They were thoroughly examined for visual acuity using Sneller's chart for distance and Jaeger's chart for near. Anter-segment examination was done using slit lamp biomicroscopy, and for posterior segment examination was done using direct and indirect ophthalmoscopy after pupillary dilatation. Fundus photography were taken if it was available. Okay, data entry. Our study participants were included after proper evaluation and grading of chronic kidney disease by nephrologist. After explaining and getting proper consent, they are broadly classified into 3 groups based on their estimated glomerular filtration rate. So the stage 5 is if the patient has less than 15 GFR. So the frequency of patients were 15, and stage 4 was 30 to 15 GFR, and stage 3 was 60 to 30 GFR. So they were segregated like stage 3, 4, and 5. So the anterior segment and posterior segment findings were tabulated. So mostly they were normal. The anterior and posterior segments were mostly normal. So the most common anterior segment abnormality that was found was the cataract, the next one was conjunctival pallor. Other things that were found were pterygium, pingingula, and ephica, pseudoephica as such. And for the posterior segment, again, it was normal, but the most common finding was hypertensive retinopathy, and there was diabetic retinopathy and a combination of diabetic and age-related macular degeneration, diabetic with hypertensive retinopathy. And you can see in this picture, the first one shows severe non-proliferative diabetic retinopathy. The second one is a grade 3 hypertensive retinopathy. And the third picture is a combination of diabetic and hypertensive retinopathy. So discussion based on the visual acuity, we divided the patients into 4 groups. That is, group 1 with 39 participants whose visual acuity was ranging from 6.6 to 6.18. Group 2 with 38 participants whose visual acuity was 6.24 to 6.60. And group 3 with 29 participants whose visual acuity was ranging from 6.60 to 3/60. And group 4 with 5 participants whose visual acuity was less than 3/60. And there was no participants with no perception of light. So we correlated between the grade of CKD with visual acuity. The severity of chronic kidney disease was correlated with best corrected visual acuity. On applying correlation analysis, a Pearson correlation between the 2 variable outcomes. That is, one outcome is CKD severity, and the second outcome is best corrected visual acuity scores. And it was shown that it is strongly significant. This shows that the severity of CKD increases, the visual acuity is more affected in these patients. And on correlating between 2 again variable outcomes, that is estimated glomerular filtration rate and best corrected visual acuity, again shows that good eGFR rates had better visual acuity. So the summary shows we actually segregated into 3 groups, stage 3, 4, and 5. And the most common age group was 51 to 60 years, which had 38 participants with a mean age group of 60 years. And the most common participants were males, that is 78, and the others were females, that is 33. The ocular manifestations were tabulated, and the patients who actually had less than 3/60 was found to be a patient with both a mature cataract. There were 3 patients with AION and 1 patient with glaucomatous optic atrophy. So the severity of CKD directly reflects on the patient's vision. Hence, a routine eye checkup is to be done for these patients, as early detection and treatment will result in good visual outcome. If not, the patient might end up in permanent visual disability, which will hamper his or her daily activities and quality of life. So these are my references. Thank you.
Shall we start the questions?
Dr. Priyanka.
Yes, sir.
Have you tried to correlate these things with the duration of diabetes or hypertension or severity of diabetic retinopathy in all these 3 groups?
No, sir. Duration was not taken. We just took the values of the patient, but duration, if we take it, will be a much difficult analysis to do. So we thought we'll take whether they're having diabetes.
It is very simplistic to sort of correlate the visual acuity and the severity of CKD, because somewhere down the line,
Yes.
one has to take into account the cause for diminution of vision.
Yes, sir.
It is going to be a regression analysis which has to be done. It cannot be simply extrapolated to the vision. That's
Yes,
what my observation is.
Yes, sir.
Dr. Priyanka, you have correlated the CKD with cataracts. Do you say?
Yes,
Do
sir.
you want to say that it has got any cataractogenic effect? Do you mean to say? Is it
No,
having
I
any
would say like
cataractogenic?
they get early presentation of cataracts. So like,
But the age
like
group you have
correlating
taken
with
is
other
51 to 60, which is
60 is
normal age. Around you have taken the age group of 51 to 60, I think. Yeah, in that age
No,
group,
sir.
it's
We
common.
took above the age of 18, sir. But the most common population was 51 to 60. But we found like there was 45 to 50 years, there were a lot of cataract patients in this CKD group and compared to other normal patients with
You have
diabetes
shown
and hypertension as well.
you have shown the association as 27% or something. It could be a natural aging process. Is it associated with CKD or not? You didn't clarify it. Okay.
Yes, sir. That as sir told, regression analysis should be done
Yeah,
for that.
yeah,
Sir.
that's right.
Yes. Sir.
Yes. Regression analysis and maybe should have. Hear me?
Sorry.
Can't hear you, Minu ma'am.
Hello.
No voice.
Yes, ma'am.
Regression analysis thing that should have been done because not regression analysis cannot be compared.
Your voice is breaking, Minu ma'am.
Maybe you should have had a control group.
We can't hear you, ma'am. Shall we start with the next presentation?
Yeah,
No,
you
ma'am.
can go ahead.
Thank you, sir, for this wonderful opportunity. Thank you.
Yeah, Dr. Zainab.
Yes,
are
sir.
you
Yes,
ready?
sir. Yes, I am ready.
Yeah, okay.
Please start.
Yeah. Good afternoon, everyone. I am Dr. Zainab Dohodwala, first year resident of ophthalmology. Today, I am going to discuss how big the iceberg really is, alarming results at World Glaucoma Week Screening Program 2021 at a tertiary eye care center. Glaucoma, as you all know, is a leading cause of irreversible visual loss, defined as a disturbance of structural or functional integrity of optic nerve that can be arrested by adequate lowering of intraocular pressure. It is divided into various types, such as primary or secondary open angle or angle closure glaucoma, of which POAG is most common, which is usually asymptomatic in its initial phase and associated with extensive damage at the time of diagnosis. World Glaucoma Week is a global initiative to raise awareness on glaucoma, of which we took advantage this year and organized a glaucoma screening camp at our institute. My aim is to report the result of a glaucoma screening program at a tertiary eye care center during World Glaucoma Week 2021. This is a retrospective observational study conducted over a period of 1 week from 8 to 14th March 2021, during which 945 out of a total of 1,421 patients who visited a tertiary eye care center underwent a complete comprehensive eye examination. Detailed history of the patient was taken that included age, sex, family history of glaucoma, history of any systemic illnesses, history of ocular surgery or trauma, history of any past or present medications. Those undergoing contact procedures were tested for COVID-19. Examination included visual acuity, intraocular pressure using Goldman declination tonometer, slit lamp examination, gonioscopy, and optic disc examination using a 60 diopter lens. Staging of the glaucomatous damage was done into mild, moderate, and severe, taking into consideration the cup disc ratio. Suspects were then subjected to visual field analysis. Various definitions used to classify the patients into specific categories are as under. For primary open-angle glaucoma, open and normal appearing angles on gonioscopy with typical features of glaucomatous optic disc and visual field defects corresponding to optic disc changes. Ocular hypertension was diagnosed with intraocular pressure more than or equal to 21 mmHg without any evidence of optic nerve damage or visual field abnormalities characteristic of glaucoma. Normal tension glaucoma included those with intraocular pressure more than or equal to 21 mmHg with evidence of optic nerve damage or visual field abnormalities suggestive of glaucoma. Primary angle closure suspects included those with occludable angles in absence of peripheral anterior synechia and normal intraocular pressure, disc, and visual fields. Primary angle closure glaucoma included those with occludable angles with elevated intraocular pressure and optic nerve and visual field damage. All patients who visited the tertiary eye care center and were willing to take part in the screening program and those who tested negative for COVID-19 rapid antigen tests were included in our study, whereas all those with signs and symptoms of COVID-19 were excluded. Of the 1/3 of the total patients who were screened, 1/3 of the patients had glaucoma, of which 14% were the newly detected cases. This is the graph that shows the various types of glaucoma that were encountered in our study population, of which POAG was the most common subtype, followed by PACG and PACS. We also found that the number of previously diagnosed and the newly detected cases of PACG were almost similar, signaling towards PACG being missed during routine clinical practice. This is a beautiful graph that showed that the majority of cases that were newly detected of POG as well as PACG were in the early stage of the disease at the time of diagnosis. Age distribution in our study populations showed that the majority of cases of POG were in 51 to 60 years of age group, while that of PACG were in 41 to 50 years of age group. Gender distribution showed that majority of POAG cases were males, whereas no such gender difference was noted for PACG. 15% cases of both POAG and PACG were hypertensives, whereas 5% were diabetics. Thus, the proportion of newly diagnosed glaucoma in our study was 14%. 16% of POAG and 70% of PACG were in the early stage of the disease at the time of diagnosis. This is almost comparable to an international study in 2020, where the proportion of newly diagnosed glaucoma was 10%, with POAG being most common. Here, 40% of POAG and 66% of PACG were in the early stage of the disease. According to Valor Eye study, the prevalence of PACG was found to be several times that of POAG, whereas in West Bengal glaucoma study, the ratio of POAG to PACG was 10:1. The same for our study was found to be 2.6:1. In Arvind Comprehensive Eye Survey, the persons with 40 years or more were examined, and the age group with majority of POAG cases was found to be 40 to 49 years. In our study, we had examined all patients without any age limit, and the majority of POAG cases were in 51 to 60 years of age group. We also found that 10% of patients were less than or equal to 40 years.
1 minute left.
Of age, of which 7% were POAG. Positive family history of glaucoma was found in 36 patients, of which 31 were POAG and 5 were PACG. Limitations are small sample size and long-term follow-up of the patient not included. My conclusions are the proportion of primary open-angle glaucoma is more in our study population. A changing trend towards younger age group being affected in primary open-angle glaucoma is seen, and the burden of undiagnosed primary angle closure glaucoma can be reduced by comprehensive eye examination. Such glaucoma screening camps at institutional level should be promoted for early diagnosis and intervention to prevent irreversible blindness. These are my references. Thank you.
We'll move on to the judges.
Dr. Zainab.
Yes.
You have not shared any data pertaining to the age distribution of the patient screened, though you have said there was no cutoff, that no patients were excluded. Where we would have interested to know that what was your younger age group distribution like of the total sample. Because most of these studies which you are quoting have included patients which were aged more than 40. In your case, in this screening program, you have not described the age distribution of your patients.
Yes,
Can you share any observations related to that?
Yes, sir. I have included patients of all age group, but I haven't categorized the patients of less than 40 years of age.
No, because if that was a substantial number, then it would have probably substantiated that the things have that the PSEG is being noticed in the younger decades or the younger age as well.
Yes, sir.
And
What
did
I
you
found was
did you
that
care to do when you have done all these investigations? Have you included pachymetry data also?
Sir, it was a screening program over a week, so we didn't take into consideration the pachymetry in this group, but
Because
like,
normally in the screening programs they are not doing the pachymetries. You have done extensive glaucoma workup for your patients. So I was just wondering whether you have done pachymetry also, and did this help you in putting down your results?
yes, sir, but it wasn't the focus of my study. I hadn't considered pachymetry, but I would definitely add it in further follow-ups of the patients.
How many of these patients were already operated? Can you give us an idea of the known glaucoma patients which you came across, which were already diagnosed? How many of them were already operated? Any observations to that effect, or were all the patients only on medical treatment?
No, sir. I hadn't taken that into consideration. The number of patients.
Last thing I would like to point out is that one would be interested in knowing the visual status of these patients as well as the lens status of these patients. How many of them were really pseudophakic, were already operated for lens? Because that has a bearing on the management of PSEG.
Yes, sir.
Anyway, nice attempt. Please carry on.
Any other questions?
Yes. Dr. Zainab, can you hear me?
Yes,
yeah. Do you have any details on how many of those patients actually had raised intraocular pressure amongst the ones you screened?
Yes, ma'am. I have categorized the patients on the basis of that. Those with ocular hypertension had more than 21 mmHg of pressure. With normal tension glaucoma, those were less than 21, and others had raised IOP.
No, not based on the type of glaucoma.
I haven't like categorized the patients on the. Sorry, ma'am.
Right. Go ahead. It's okay. Yeah. It's all right. Thank you.
Oh.
Dr. Jairam, sir. Any questions?
No.
Thank you, sir. Dr. Rushil, are you ready?
Yes, sir.
Yeah, please start presenting. Dr. Rushil's topic is assessment of optic nerve head parameters in pediatric glaucoma patients.
Hello?
Yeah, you are audible.
Yeah. Good afternoon, everyone. My topic is assessment of optic nerve head parameters in pediatric glaucoma patients. I am Dr. Rushil Ambani, and second-year resident from Nagari Eye Hospital. Aim is to evaluate the severity of pediatric glaucoma on the basis of glaucoma probability score based on heat-bulb retinal tomography. Pediatric glaucoma may be broadly divided into primary and secondary. Primary glaucoma includes congenital open angle, juvenile glaucoma, glaucoma associated with other abnormalities. Pediatric glaucoma is responsible for between 4.2 to 7% of childhood blindness in our country. Clinical features may vary greatly according to age and subtype of the disease. True congenital glaucoma patients may present with corneal haze, large asymmetrical eyes, ophthalmos, severe photophobia or blepharospasm. Juvenile open-angle glaucoma may present very similar to that of primary open-angle glaucoma, but in much younger age group, which is 5 to 35 years. This is the difference between both of them. Generally, congenital open angle glaucoma is sporadic, while as juvenile open angle is autosomal dominant. Both are generally bilateral, and genes involved are CYP1B1 gene in congenital open angle, and juvenile TIGR or myope phenotype is involved. Herbal retinal tomograph provides details regarding disc area, cup depth, cup size, rim stiffness, and RNFL curvature. Neuroretinal ring thickness is provided in 6 sectors, and Moorfield's regression analysis is provided. Latest version of HRT, that is HRT3, provides operator independent value of glaucoma probability score. This is the image showing report of HRT3. It provides easy method for comparison quantitatively and also eliminates intra and inter-observer bias. Also, it was found to be highly reproducible diagnostic tool, with image quality being the main factor influencing reproducibility. This was a cross-sectional observational study of 31 patients at a tertiary care center. Severity of glaucoma was studied on the basis of HRT3 parameter glaucoma probability score. All patients of primary congenital glaucoma with approval by the parent were included. Any secondary cause or associated factors were not in exclusion criteria. Results of 31 patients selected with diagnosed case of glaucoma, average age of presentation was 14.96 years, average RNFL thickness was 0.229, mean GPS scores was 0.725. 94% had bilateral presentation, whereas only 6% were unilateral. About 64.5% patients were male. 18% had GPS less than 0.5. 30% had those between GPS 0.5 and 0.8, and 52% had a GPS score of more than 0.8. Less than 14 years age group had a mean GPS of 0.746, and whereas more than 14 years age subgroup had a GPS of 0.712. Discussion: 52% patient had glaucoma probability score of more than 0.8, which means significant disease progression. Also, age group of less than 14 years had higher mean glaucoma probability score. This may point towards lack of awareness and overall inability of the system to diagnose and manage each child on time. Gupta and others compared severity of patients presenting with juvenile open angle glaucoma with the help of perimetric parameters and compared it with associated factors. Dice and others in a large-scale study found that 59.37% patients of pediatric glaucoma to be female with 91% bilaterality. Our study shows more percentage of patients to be male. The differences may be ascribed to small study group and different geographical location and even some social issues in presentation. Reddy and others, Yip and others, and Jindal and others individually studied and compared effectiveness of MRA and GPS in glaucoma patients and found GPS had a higher sensitivity and concluded that it may be effective screening test for glaucoma. Elenkar and others recently showed that GPS can be used to predict which glaucoma suspects will go into show visual field and cup changes. They also found this to be consistent with clinical evaluation of respective patients. Our study focuses more on pediatric age group, whereas where the use of other modalities like standard perimetry, applanation, and other forms of tonometry are non-effective or non-reliable, or making it very difficult. So this is even more difficult to diagnose the condition. So to conclude, more than half children had glaucoma probability score more than 0.8, which is a sign of advanced disease. Majority of the patient visit late with advanced disease. My take-home message is emphasis must be given to the newer diagnostic modalities along with detailed clinical examination to reduce the burden of childhood blindness, and HRT is a non-contact and child-friendly modality for assessment of glaucoma. Limitations include small sample size and lack of long-term follow-ups. Thank you, everyone. These are my references.
Any questions, judges?
Dr. Rushil,
yes, sir.
You were able to acquire the scans in all the patients you intended to, and how long did it take to acquire a scan in a particular eye?
Yes, sir. Actually, in very young patients, about 5 years, some of them were not cooperative, so I had to exclude them, and the quality of scans were not reliable. But in the rest of the population, rest of the my selected patients, I did not face much difficulty for the same.
Because your average age, mean age is around 14 years.
Yes, sir.
So is
Yes.
this a tool which is going to be effective in first decade of life or for the pediatric age group?
Yes, sir. Sir, I think.
And more so in advanced. Yes, please go ahead.
Yes, sir. Actually, I think
The second query which I had is, in the children who had the corneal edema and all, is it possible to acquire these scans with the gradable images?
Yes, sir. That definitely would be a problem for the same, because the media would be a bit unclear. So the quality of scans and the scoring would be difficult by the equipment. Sir, I
How
think.
long does it take to acquire a scan?
Sir, about with good patient cooperation, it would take about one minute or so.
Okay.
Yes, sir.
Thank you.
Yes.
Dr. Rushil,
Yes,
Dr. Meenu here.
Yes, ma'am.
Yeah, have you included any post-operative patients like congenital glaucoma? Any of them were operated? Have you taken them in the study?
No, ma'am. Actually, I have not taken them, not differentiated them and taken that aspect into consideration in my study. But I think it would be a good addition to the study.
Yeah, because as they say that maybe the parameters change after surgery also. Maybe there is some improvement.
Yes, ma'am.
Okay, thank you.
Thank you, ma'am.
We have taken very small group for the study, and in that also, because of non-cooperation and bad pictures, we have excluded. So it won't give you any conclusion, I believe.
Yes, sir. Sir, actually, I think in much younger population, for the congenital, I did face a problem, sir. You're correct, sir. But for juvenile open angle glaucoma, sir, the ones which were included, classified under GOAG, these results seem to be promising, sir. Hello.
Any
Hello.
other questions? Shall I call upon the next presenter? Any other questions? I request Dr. Sahil Agrawal. Dr. Sahil, are you ready?
Am I audible, sir?
Yeah, you're audible. Your slides are not visible.
Is it visible right now, sir?
Yeah.
Very good evening to everyone. I'll be presenting this case of a delivered globe in a newly delivered child. I have initial disclosures to be made. The objective was to report a clinical features, evaluation, and management of globe luxation presenting right at birth following a normal vaginal delivery. To the best of our knowledge, this is the second report in the world literature of globe luxation at birth. An 18-year-old baby was brought to our emergency with protruded right eyeball. The birth history was an uneventful, normal vaginal delivery. On examination, there was unilateral protrusion of the right eye since birth, conjunctival chemosis and congestion. There was a total exposure corneopathy, a dilated pupil present, and the lids were not visible. Fundus examination, however, was within normal limits. So we were confused as how to proceed. The questions to be answered were, firstly, was the child systemically good enough to undergo anesthesia for a possible examination anesthesia and a possible surgery later on condition? Then, was it true proptosis or was it a blephron? We could also not rule out the possibility of luxation of the globe with retraction of the lid. Thinking about proptosis of a bird, we could all think of was an orbital teratoma, encephalocele a retropulpal mass like capillary hemangioma or a retropulpal hematoma, and craniosynostosis. Encephalocele is basically a rare congenital abnormality with a defect of the cranioorbital bones, thereby causing a protrusion of the meninges or the brain per se inside the retropulpal space. They present soon after birth, have soft tissue mass which can be palpated. This mass, along with has a visible pulsation present. This is proptosis with minimal congestion, and the proptosis would increase with the child crying. A congenital orbital teratoma, on the other hand, is a rare tumor again, which grows rapidly with a progressive unilateral proptosis. It again presents at birth, have a soft tissue mass which can be palpated. There is destructive proptosis and exposure keratopathy present. However, there is no visible pulsation or an increase in the size of the mass with crying, like in the case of encephaloceles meningocele. An orbital hematoma is seen commonly with the forceps delivery or difficult labor. There is associated scalp hematoma, marked chemosis of the eyelids, and diffuse chemosis of the conjunctiva as well. There will be associated restriction of the extraocular movement. Craniosynostosis is again a rare autosomal dominant disorder in Crouzon syndrome, wherein the fusion of the cranial sutures causes a cloval skull and thereby shallowing of the orbit, causing luxation of the protrusion of the globe. There is associated parrot beak nose or hyperteloidism in such cases. We could also think about an orbital lymphangioma, which is present right at birth, though again very unusual, with a soft tissue mass and marked chemosis. And on imaging, there will be fluid levels seen. So in our case, there was no visible skin chymosis or scalp hematoma. So a irritable hematoma was ruled out. Neither was there any possible visible pulsations, which ruled out encephalocele or meningocele. So to proceed further, we decided to do an imaging, but which one? We went ahead with an NCT because it is rapid, does not require contrast, is easily accessible at our center, and can demarcate the bone window very well. On the CT, there was no bony defect present. There was no mass lesion, no hematoma, no tissue herniation. So this ruled out encephalocele meningocele, irritable hematoma, irritable mass. So what the questions that remained still answered were, was it true of lid, or was it really a luxation of the globe? Luxation of globe with traction of lid will have the anterior displaced eyeball, which is usually within when the equator of the globe protrudes beyond the retracted eyelids. The globe in such conditions is well formed if it's not traumatic. There is marked congestion present along with proptosis and a total exposure keratopathy. However, ablepharon is the congenital absence of eyelids with exposure of cornea, keratinization of the conjunctiva or pinnacle with minimal protrusion but not proptosis, and the globe will not be formed. So all these three characteristics were not present in our case. So we kept the suspect of a globe luxation and went ahead with examination and anesthesia and planned for a reposition of the globe and tarsorrhaphy later on. This is a short video showing. So the newborn male child, 18 hours old, presented with forward protrusion of the right eyeball. Completely exposed and collapsed globe with corneal haze, diffuse congestion, and mid-dilated pupil. The child was immediately taken up for surgery 4 hours.
We have 1 minute left.
So that the contamination all around the globe, which is already present, is not prolapsed along with the globe inside the orbit. Later on, cause cellulitis like picture. To prolapse the globe back, the lower eyelid is pulled behind, and the globe is slowly prolapsed into the orbit. Similar procedure is done for the upper lid, and thereby we had a reposition globe. It's again very important to clean the trapped upper surface and the epithelial surface as well as the conjunctival epithelial surface regarding both palpable and bulbar areas. Towards the end, a temporary suture tarsorrhaphy can be placed. This helps in providing a support to the globe and preventing again globe luxation towards the end. So, globe luxation can be divided on the basis of into three categories: spontaneous, voluntary, and traumatic. This is a case of traumatic, which had very good outcomes in the post-operative period we had done.
The time is up, Dr. Rushi.
So, to conclude, this was the 18 hours of life, and this was the 24 hours of life. In our present case, even though there were no signs of periorbital hematoma, we hypothesized that due to manual pressure of the temple region during delivery, there was prolapse out of the globe, as the bones in newborns are very pliable in orbits. The eyelid, through a protective structure with a thin fold of skin, and yet at sometimes it can strangulate the eye, and a timely intervention thus can help us. Thank you so much.
When did you see this case? How long back?
Sorry, sir?
When did you see this case exactly?
This was in 2019, sir. Just in the pre-COVID area, so October, sir.
How are his milestones?
See, he was totally normal, sir. At birth, he was totally normal. He was examined by a neonatologist before taking him up for the EU and thereby the surgery, sir. He presented right at birth, sir, 18 hours from the birth, and we had taken up the surgery somewhere around 21st or 22nd hour on the very same day, sir.
Has the baby come for follow-up?
Ma'am, we had follow-up till February, ma'am, but after that, COVID happened in March, and we don't have any further follow-ups since, ma'am. I'm sorry for the same.
Okay.
Dr. Sahil,
sir,
if you will scan the literature more carefully, you will come across the way and means if you are suspecting luxation of the globe in a newborn. What is missing in your presentation is you have to take care of the cornea. And what is suggested in there is that you need to put a contact lens there, and it is always advisable to give a firm pressure over the cornea, and globe spontaneously at times goes back because of the edema which is there in the conjunctiva. It is getting trapped with the lids, and it more often than not happens because of forceps delivery. Fortunately, in your case, it was a NVD, but usually with forceps application, this is a possibility which has been reported more often. And the simplest first step to be done is put a contact lens over the cornea and give firm pressure over the eyeball backward. It goes back automatically.
Right, sir. So in our case, sir, we hypothesize that probably during the birth, when the head is being pulled out, a gentle temple over the bones of the peribulbar area would have caused, because they are very pliable in case of bone, that must be the extrinsic pressure. That in case of forceps delivery is the same thing, but that's more in amount. Yeah, that must have caused the prolapse of the globe, sir.
Anyway, very well presented.
Thank you so much.
Thank you so much.
Sir.
Shall we call upon the next presenter? Dr. Rajdeep Kaur.
Yes, sir.
Yeah. Are you ready with the presentation?
Yes, sir. Sir, I'm not able to share the screen. Previous presentation is already here.
Technical team, can you help us with this?
Dr. Sahil, you need to stop sharing your screen, please. Good afternoon, Maniar sir.
Hi.
How are you, sir?
I'm fine. Is that Sumit?
Yes, sir. Yes, sir. Warm welcome, sir.
Okay, thank you. Do tell me how long are we going to take here? I have no hurries. I'm just inquiring. That's all.
Sir, there is a last presentation, sir. It will take 6 minutes plus 2-minute questions, sir. 8 to 10 minutes.
There's no hurry at all. There's no hurry at all.
Okay. Yes, last one. Yes, thank you, sir.
Yeah.
Shall I start?
Yes, please, Dr. Rajdeep.
Good afternoon, everyone. Thank you, respected judges, for the opportunity. The title of my study is To Study Glaucoma Awareness, Knowledge and Attitude Towards Screening in Patients of Western Uttar Pradesh. Introduction. As we all know, glaucoma is defined as chronic progressive optic neuropathy characterized by optic nerve damage, visual field loss, and retinal ganglion cell damage and death. Of the several types, two most common are open angle with slow onset and angle closure with acute onset. India is the second largest home for glaucoma cases with more than 65 million population affected worldwide. It's irreversible cause of blindness, slowly becoming public health program. Second leading cause after cataract, also known as silent thief of sight due to no symptoms in early stages, making it so vicious. Blindness is acknowledged at utmost public health issue in India, home for billion people, and India has become first country to give 100% public funded program. By understanding risk factors, awareness for prevention and early recognition, we can stop the glaucomatous field damage. Vision 2020 Right to Sight is a global initiative for blindness control, and glaucoma was one of its major concern. It had provided eye care programs for prevention of avoidable blindness. Glaucoma campaigns are expensive due to specific cutoff levels, large number of suspect cases, and due to low education and socioeconomic status, there is always late presentation. Various studies have shown high prevalence of undiagnosed patient, reason for which is lack of screening and awareness. Prevention of blindness act as a major tool for national programs, but only few publications have checked into awareness level of glaucoma. This study aims at understanding awareness, knowledge, and attitude of the general population towards screening. Purpose of this study was to study glaucoma awareness, knowledge, and attitudes towards screening in Western Uttar Pradesh, and to study effect of age, gender, literacy, and residence on all of these parameters. Material and methods. This was a descriptive study carried out for the period of 1 year, and patients and their relatives between 18 to 60 years were included. All new diagnosed cases undergoing treatment or not willing to participate, or patients of unsound mind were excluded. Methodology. Patient and their relative who attended outreach camps were subjected to detailed history, systemic and ocular examination, and then were subjected to brief open-ended questionnaire. So this was a validated questionnaire which was translated in layman language to them. The initial 4 questions were about glaucoma awareness. Next 6 questions were about glaucoma knowledge, and last 3 was regarding the screening if they've undergone in last 1 year. So this was the protocol which we followed. Eligible participants who provided consent, they were asked whether they've heard about glaucoma or not. If they've not heard the term also, they were categorized into unaware population. And if they said yes, then they were subjected to next following questions. The observations were, first, for the glaucoma awareness questions, increase with age, glaucoma increased with age, 77% of them said yes. Anyone can have glaucoma, 48.5% said yes. Treatment is possible, 49.5% said yes. And whether if blindness from glaucoma can be prevented, 51% said no. About next 6 questions, which were about the knowledge, majority of them answered related to glaucoma knowledge as no. Then these were the 3 main parameters which we studied. First was screening, attitude towards screening, any awareness. 45% said yes. Knowledge, only 32.5% had knowledge about glaucoma, and only 63.5% were aware of the term glaucoma. Then we compared age, educational qualification, gender, and residence with awareness. We found significant association with age. For example, 51 to 16 years, 30% of them were aware, and significant association was seen with educational qualification. The more they were educated, like graduates, 44% of them knew, and illiterate, 87% had no awareness. And gender, we also found significant association. 81% of male knew, 63% female knew, and significant association with residence was also found. Urban population was 41% aware, and rural 90% had no idea about glaucoma. Then we compared all of the parameters with knowledge. Significant association with seen with age, 51 to 60 years, 32% had some knowledge, and from 61 to 70 years, 26% had knowledge. There was no association of gender with knowledge. Yes, this parameter also showed good association with education. The more people are educated, the more they had some knowledge. And illiterate, 94% had no knowledge, and the urban population had more knowledge, and rural 94% had no knowledge about the disease. The last parameter was screening. So we did not found any association of age with screening. Gender, male had undergone 76% knew about screening, female 44%, and same association was seen with education as well as residence. There was this same study, Ravery and Kakkar, reported 0.7%, only 0.7% knew that glaucoma was an asymptomatic disease. They did not find any relationship between gender and awareness. They found relationship between awareness and age, and that awareness and knowledge was better in individual with higher education, which was the same observation that we made. Conclusion of my study is that importance should be given to the fact that glaucoma is a disease with few or no symptoms, and early detection can help in preventing blindness. So we should encourage mass media should be used, and health awareness classes should be arranged. So knowledge and awareness of the disease can be spread, and it can help in preventing blindness due to glaucoma, and it should be detected in its pre-perimetric stages. Limitation of my study was interviewer bias could not be completely eliminated as individuals' expression, language, and style of explanation affected the response of the patient. These are my references. Thank you.
Any questions, judges?
Dr. Rosdeep,
Yes.
you have taken all these parameters and did study it. Do you find any difference between your results and the data available with the rest of the world, rest of the India? You have taken
Yes,
the
sir.
Western, yeah?
Yes, sir. This is the data about national, and there have been various national and international studies have also been conducted, and same relatable data have been found in international studies also. That people, due to its insidious course, people are relatively unaware of the disease and are less aware about the screening also.
Dr. Rajdeep,
Yes, sir.
whatever observations you had regarding the awareness
Yes.
as well as the knowledge, do they go hand in hand with the attitude of the people in the Western UP? How did you comment upon the attitude of the people toward the screening? What was your criteria for that?
Yes, sir. Sir, the majority of the population did not even know the term glaucoma. So the people who knew only knew because of anyone in the relation or their family members. And the attitude which we found towards screening was not appropriate because they are not aware of the disease.
You mean to say that if you increase the knowledge and awareness, the attitudes will also change?
No, sir, that also depends upon various cultural and religious practices also. Especially we have, here we have rural population. So they have their different cultural and those kinds of beliefs also. So it depends on those parameters also. But personally, what we saw that if they have some kind of awareness that it can lead to blindness or some knowledge about the disease, that may bring a change in their attitude also.
But this is not something which is reflected out of your study.
Yes, sir, it wasn't. But it,
okay,
it was seen. Yes, yes. Thank you, sir.
Meenu ma'am, any questions?
No, no questions.
Thank you, ma'am. Shall we close today's session?
Thank you, sir.
I thank all the presenters for innovative papers and judges for the wonderful discussion. Dr. Sumit and Dr. Tejal for the excellent support. Results will be informed by mails. Shall we close this presentation, Dr. Sumit?
Yes, yes. Thank you, Dr. Saket, sir. Thank you, all the judges.
That is not fair. You're keeping these people on edge for at least one more day. That's not fair, yeah.
Thank you, Randeep. Good evening, Maniar sir.
Thank you,
There
Jairam. Some surprise element, some suspense.
Thank you, Minu. Thank you, Sumit. Good evening, sir. I was listening. Yeah.
Thank you. Thank you.
Thank you, Dr. Maniar, sir.
Thank you.
But you people are not giving more mark that I see your paper. You are giving less mark. You more mark to the student.
All India.
Okay, sir.
I think Rajdeep, you stop sharing your screen. The screen is still.
I'd like to welcome my.
Doctor, technical team, can you please stop sharing of the last?
Hi, Malik, madam.
Hello, Toklane.
Hello, Rao.
Hello,
Good evening, ma'am. Good evening, sir.
Hi, let's have your video on video sharing so that at least we can see each other. And
yeah, my video is on.
Someone's presentation is shared here.
Technical team, can you please?
That you will have to remove.
Technical team, can you please help me?
The screen is shared by someone.
That last screen share.
Last, if she's there. Otherwise, technical team will have to stop this.
Glaucoma paper power. This shared this.
One second. Hello, Manjari.
Hi everybody, good evening and welcome to you, my co-host Mr. Geetanjali Sharma. is not
Namaste, sir.
unknown to you. She hails from Pune.
Okay.
She's much better looking also. And other than ophthalmology, she has a penchant for writing poetry. And I think a topic like this, where it says, I inspire you. And I've gone through the list, and hats off to the think tank at BOA for putting up such a wonderful show. Never mind it's on 5 o'clock, never mind it's in Hall D, as long as it's there to start with. And we look forward to seeing this as a, prime time Saturday 11 o'clock show in the future conferences. But without much ado, Gitanjali, all yours. Your first two presenters are Dr. Tatya Rao and Dr. Viraj.
Thank you, sir. Thank you, Dr. Maniar, sir. A very good evening to all of you. It is actually my honor to host this along with Maniar, sir, this session of inspiring life stories of great personalities. Dr. T.P. Lahane, sir, Padma Shri Dr. T.P. Lahane, sir, has been, I call him Deepastambha, he knows that. My poem says, Gurucha Rupi, Deepastambha ha asawa, Ayushya Marga माझा, Ujaduni Sajawa.
Wow.
Dr. Lahane, sir, is DMER, Mumbai, Maharashtra State. He has been Dean of JJ, HOD of JJ, a great visionary, a great teacher. He has trained so many students and they are everywhere. He has reached to each and every corner of Maharashtra to give vision to poor and needy people. And now, in this era of COVID times, in the last wave as well as in this second wave, the way he has done the work, it's amazing. ना तूफानों से ना सुनामी से हारे, खौफनाक लहरों से ना डरे, ये तो हमारे दीप स्तंभ है, मार्ग दिखाते चले, रोशनी से भरे. It's my pleasure and privilege to request Padma Shri Dr. T.P. Lahane sir to present his inspiring life story for all of us. Thank you.
कुछ भी बोलो, दोस्त तो मेरा है.
हाँ?
कुछ भी आप बोलो, दोस्त तो मेरा है.
And Dr. Maniar, student मेरा है. मैं भी थोड़ा क्रेडिट ले लेती हूँ ना.
ठीक है. All yours, sir.
All yours. मंजरी, तू क्यों चुप बैठी है? So thank you, Gitanjali. Thank you very much. Gitanjali is always like this. I really admire you, your knowledge and everything. Ranjit, as you know, he is my best friend, inspiration, guide, support every time. Malik madam has taught me, and my sister Manjiri has joined. So thank you very much for this. This is the, I think, the thinking of Dr. Agini, and it was also thinking of the Topnes, Pritam and everybody. I think this is a very good idea that on two sides, two computers are running, where one side he is saying DME, other side he is saying trauma, so many things are going on. And here now we are away from ophthalmology and speaking something out of ophthalmology. So here it is my rebirth story. Let us begin. Now, what is this rebirth? Everybody knows, but yes, my life divides into the two parts. That is a 57-95 to 95 till date. This is my rebirth, and as you know, the rebirth is given to me now 57 and 95. See, I was my first photograph, I think they took in the when I was in the 11 and this PUC. Till that time, there was not a photograph of mine because I was studying in the. Now this is the photograph of mine, first MBBS, where I was in first MBBS. That time, this is my photograph in first MBBS, and this is the earliest level of my photograph. So before that, there was no any photo of mine. Now born in Dharmapuri, that is my village, to the my father Punlik Rao and mother Anjana Bai. My father is no more. Now on 26th May, it will be 2 years. Now the Anna and Mai, I think they were illiterate, but completely literate and inspired me throughout my life till today. So I think their blessing, because of their blessing, I am there. And I think I love them more than anybody in the world. So they are my favorite people. I love them too much. This is my school, Kamdhani Vidyalaya Makega. This was the school in my village. Because of that, I could learn something. And I took the SSC. After the SSC, I took the science, and that was in the Vaidyanath. That was in the Parli Vaidyanath. I went there, Government Medical College, Aurangabad. In Parli Vaidyanath, another thing I want to I was there. They earn while learn. It means I was earning 30 rupees per month by watering the plant. So I was watering the plant for 2 years. I was learning, and I was getting 30 rupees. This earn while learn. Now this is the medical college. That is my alma mater here. I passed from this medical college MS also and MBBS also. So here I think these are my gurus. One more guru is remained, that is Dr. Maria sir, and this is Lemare sir, who is no more now. Wangikar sir and Karandikar sir, and Maria sir is also no more now. Now this is the 98 and 80 milestone in my life. I married with my wife, and you can see the my father-in-law who is in the cap. That is a Raghunath Ramunde, who was no more after the 6 month my marriage. After my marriage, so my first kid, Siley and Sapna, and then the SRTR Medical College I joined as a lecturer. After passing my MS, I joined as a lecturer there in SRTR Medical College. And when I was working there in medical college in the 1991, I was diagnosed as the uh, chronic renal failure, and my blood pressure was 260 by 140. So I think so that was the, you can say my weight was 39 kg, and I was unable to. I was really on the dialysis and so many things. So I think the another thing is, now this is the, because I was ill, I came to JJ Hospital only for my surgery and my treatment, because there was no dialysis. So that time I think I was called, I was told to my doctor that you can't go for the transplant. And later on he told me yes, I can go for the transplant. And my mother came forward. She told me, I am going to give you the kidney. My father, my sisters, my wife, my son, brother, everybody was ready to give the kidney. But lastly, my mother's kidney got matched, and that matched kidney on 12th of February. Now I celebrate my birthday. That is the birthday, because my actual birthday I don't know. So my birthday, second birthday only I celebrate on the 12th February. So that is my birthday. So, and then after the kidney transplant, I thought my mother, who devoted me, gave me kidney, devoted her life. She is illiterate, but whenever I am doing anything, she should hear something good about me. And after that, I think I started work. Now this is the starting. I went to Israel, and in the Israel I was with the Blumenthal to learn about the SICS. We were there for near about more than 10-12 days, and this Israel trip taught me Blumenthal technique. After that, Blumenthal came thrice to Mumbai and operated in JJ Hospital. Now this is my teacher. When I came in Mumbai, then I was doing FECO, and it was very difficult to do. KK Mehta came forward, and he sat in the operation theater till 13 surgeries were carried by me. And Natarajan, the second my friend, who is always with me whenever there is any complication. Before the retina surgery started in JJ, he was there to support me from 1995 to 2004. He was supporting me. And after that, now you can see my department, they are sitting here on the your right. You can see everybody from my department, all are maximum are honorary, expert, and also the full timers. In the other pictures you can see the patients who brought me the roti and chutney. So that is the patient who brought me roti chutney. And in other, this one, he brought me the, you can say, the some fruits. So he came there, and I was really this one. If you want alone, fast, walk alone. But if you want to walk far, go always together. So that is my theme of life. So one person can't do anything. And with me, Dr. Ragini joined, and you can see this now. Because Ragini joined, the team has joined, and now 67 people working together tirelessly from, I think, 1998 till today, that is 24 years. And I think because of that, here you can see the every patient who treat gives a blessings which are invaluable. See, always it is asked to me that how you can operate. I will tell you, myself and Ragini, when we operate near about 2000 cases in the Anand one, and when we examine after that post-operative cases, that time we feel how we might have operated 2000 cases we have operated. It means that was at that time we were tired or not. But operated patient, to examine operated patients, we get tired. But to operate the patient, we never get tired. I don't know where from the energy comes, but this energy, it is not in only one place, but all over Maharashtra. You name the district, and in that district we were there. We operated the patients, and I will tell you, by the God's grace, no complications. Everybody has given the spectacles, and we follow the patient. Three follow-ups. We give the spectacle, and after that our camp is over. So they become friend in the three follow-ups. Now this is the student. I am a lucky person where the students love me. That may be UG, that may be PG, and that has given us again this. This is my brother. On my right side, we are eating the mangoes. That is also in the our farm house. There we are just you can say by the stone. These mangoes were taken away, and then we are eating. You can see I am a habit of cooking, and another is my habit of reading. So these are the, you can say, hobbies that I always having, so that sometime I give it to them. Every Sunday, today also I cook. Other is the fitness, because I am a diabetic. So I do exercise from near about 26 years. Every day, minimum 10,000 steps I walk every day, because that is what, because I have got the secondary diabetes also. And if I am not walking, I am on the prednisolone, cyclosporin, azathioprine. I am taking 50 milligram azathioprine, cyclosporin 75, and the prednisolone 5 milligram. And because of that, I will have to keep fit. Otherwise, I will get big central obesity, and that will press my kidney. So I keep my me fit. I also drive the cycle from Mumbai to Thane 3 times a day, 3 times a week. Go to Thane, come back on the bicycle, and because of that, I think I keep myself fit. Now this is the family. I think the love of the family is the biggest. So everybody in the family, I think my all sisters, my brother, my daughter, my son, everybody, I think my wife, they take care of me every day. Now this is the my childhood, the kids. When once I go home, then I am not mine, so I am theirs. So at that time they will be with me, and then till I am there, they will not leave me at all. So once I enter inside the house, I forget everything, and then I start playing with them. Now I was not an administrator, but I learned administrator. I became a dean, and later on I became a joint director, and now a director. So looking after the all medical colleges, and now I am a now nodal officer of the COVID. So in that nodal officer of the COVID also, I am just there for the human resource. Mobilized last time near about 20,000 human resource last time, and now 10,000. It means I'm just on the toes to mobilize nurses, mobilize technicians, mobilize doctors. That may be Ayurvedic, that may be homeopathic, that may be allopathic, that may be MBBS, super specialty, or PG, whatever. But I will have to mobilize these doctors, and then I will have to appoint them from PSC to super specialties. So that is I am doing it. And another thing is the all the labs. There are 509 labs. So I am taking the review of all the labs every day, and all the medical college hospitals where these serious patients are getting admitted. So I conduct near about 6 VC every day and attend minimum 2 VC of the government of Maharashtra or government of India. So my day starts at 8 and finish at 10 today also. And after that also I operate every day. That means on Tuesday, Thursday and Saturday, minimum one surgery I do today also. And if you do good work, I think I was bestowed upon the coveted award of the Padma Shri in 2008. The journey was not an easy, but was not impossible, because here, as the my village Makega, from that Makega village I came, and now I become at the highest post of the medical education, the DMER. But yes, now it is helped by me, by every person in my life, and because of that I think I could do it. Now see, if you have got the willpower, definitely you can move the mountains. Only thing is that requires willpower, but that should be a continuous willpower. What happens, our willpower is there, but in between the willpower, we lose the willpower. And because of that, it is very difficult. So I think continuous willpower will help you always, keep you inspired. And I am always asked how you get inspired. This is my inspiration. These are the patients who are operated, and you will see myself, then Ragini, we are sitting just here, and you will see how the patients are happy. This happiness in there, you can see on the faces. Illiterate people, the thing that they are not having any selfish motto, and after that also see the happiness in their faces. This happiness every day inspires us, and I think I must give credit, maximum credit to Ragini, because Ragini operates with me one, but operates more than me, minimum 1,000 cases every year. But after that also I will tell you, everything managed by her. And I think the such type of woman who is doing such a work I have never seen. She has done maximum surgeries in the you can say in world, and after that also no ego, nothing. She is doing work, hard work means hard work, and I think that is what is inspiring me. So this is my story. Thank you very much.
Thank you, Dr. Lahane sir. Ragini, you also come take a bow, please. And some things are ordained, Tatyarao. Some things are ordained by the good Lord above. They are not in our control. Your illness, your transplant was ordained, but what you made out of your life after that, that is entirely to your credit. That whatever you have achieved in your second innings has been simply stupendous. It's the stuff of legends. Thank you. And the second story that we are going to hear today is no less inspiring. A brave, courageous young lady. I don't want to get ahead of myself. Viraj, you there?
Yes.
Viraj, where
I am there.
Viraj, so nice to see you. I have tears in my eyes. You go ahead, please.
No, please. I'm wonderfully pleased, all of them. And my ophthalmology, I long to be back. Unfortunately, I lost speech also, but slowly coming. And amazing lecture by Lahane sir. Amazing talk, and I hope so. One day I follow Tatya sir. Wonderfully salute to you, sir. So, Lahane sir, how are you? And I am inspiration for you. Yes, sir. So, my story. Ragini, yeah. Sir, Lahane sir, Ragini sir.
Hello, Viraj.
Hi, how are you?
Hi, Viraj. Hi, Viraj.
Hi, how are you?
Hi,
So pleased, huh? So pleased to see you, sir. Both of them, huh? Yes. So, my story beyond ophthalmology, but rebirth. I think so. I am also rebirth. My started 3 years ago. Huh? Yes. So, so now, first of all, my friends, all of them, thank you so much for supporting me still, and gratitude for all of them, seniors, my friends, and what to say. Thank you so much for supporting me. And thank you for letting me speak. Yes. So, beyond ophthalmology and my life. Let's lesson 1. I know. So, hard life, but slowly, I am beginning to rise. Yes. And slowly, but certainly, hard work, the therapy, speech, so on, I still learn daily. But exciting, isn't it? My life is no less. Yeah, my friends. So, counseling, I must tell you, counseling I learned so hard way. Counseling doctor I am, and a patient also now. So doctor and patient and link up, important, so important now. Counseling is must. Chair time is needed. Talk your patients, patiently hear their voice. Even corotoconus, myopic patient, RP, stroke patient, paralysis, whatever. But listen patiently, and never lose hope. Please, never lose hope and perseverance. Please, let's say perseverance. I am going to do it. Yes, attitude is so important for all of that. Huh? Depression, oh, why me? No. Strong, no. I will do this. Yes. So, uh, never lose ophthalmology, please. Or where is dance, music, whatever. But I passionate. You are, and all of them passionate. Please do it. Do it for yourself. Yes. And cherish small joys, but counseling is needed. And family, friends support me, and still date. PRK, my PRK, laser, all of that I am currently doing. Yes, little, but important. I do it still. Yeah. Now, my father is example. Everest, Mount Everest climbed my father. So I know that no impossible for all of them. Yeah. So cherish your moment right now. please, one advice, only one advice, enjoy. Small joys, please enjoy. Keep working, yes, definitely, yes, but enjoy moment. And I know that all of them and you on him, all of that pandemic is right now going on. Wait, patience. All boat is sailing one boat only. So, Sate Marine, English, sail do together and sail rightly. My friends, thank you. I need not speak or go more. Thank you so much, Lahani, Ragini, all the then. Adios, my friends. I hope so. Next year, better and better. I hope so one day. Yeah. Thank you and gratitude. Thank you.
Viraj, it is never adios. It is till we meet again.
Yes,
and give everybody a big hug.
Yes,
Yes.
you are so sweet and so beautifully you spoke, Viraj. It's so inspirational and nice.
No, but I am trying to speak. Issue
Yes.
is.
Yeah.
Yeah.
Because yours is a story that is going to, I think, it's going to mimic Dr. Lahane's story because there is a lot that you are going to achieve in life
Yes.
after the event that you've gone through, after the suffering. And we have to say that it's not just your courage, hope, conviction, and the other virtues you mentioned, but also the family support.
Yes. Family is so important.
It's
Yes.
everybody,
Fighters.
and the prayers and the well wishes of, I think, the entire ophthalmic community. So with that, Geetanjali, can you take over now and guide us through the other lovely, inspiring stories of Dr. Sunaina and Manjari?
Yes.
Yeah, go ahead, please.
Dr.
Thank you,
Lane
sir.
sir has
Thank
come.
you.
Would you like to say anything to Viraj?
Yeah.
Thank you, Viraj. Thank you very much. Thank you. Welcome, Viraj.
Thank you, sir.
Thank you very much.
Thank you. Pranam. Thank you.
Thank you.
And do you, I think that there's, Aditya had shared, I'm sorry to interrupt again, Geetanjali. Aditya had shared some lovely videos of the children
Yes.
who learn driving.
My children.
Learning driving before they learn the Pico control. They're learning the car control.
Yes, I am blessed actually.
I know. Aditya, later on, maybe just search that video and put it on for us later on. Well, Geetanjali,
Sure.
continue with that. Yeah,
Yes.
Geetanjali, please.
Thank you, sir. It's now my pleasure to introduce Dr. Sunaina Malik, madam. She has always been my role model. The immediate past president of Maharashtra Ophthalmological Society. She is a founder honorary secretary of Aurangabad Ophthalmic Association, and she is the first lady president of Marathwada Ophthalmological Society. So these leadership qualities, madam, I have always looked at you, and you have been my inspiration for your leadership qualities. She is an excellent teacher. For last 41 years, she has been a PG teacher and has taught in GMC, Aurangabad, Nanded, MGM, everywhere. But more than that, what I love is her poetry, her dance, her enthusiasm. She is a marathon runner, 5 kilometers marathon. Madam, am I right? Yeah. So I would just like to say a few lines for you. सुंदरता और बुद्धिमत्ता का संयोग है आप। सुबह की पहली किरण की प्रसन्नता है आप। एक पत्नी, एक माँ, एक दादी और एक डॉक्टर। साक्षात सरस्वती माता का रूप है आप। Over to you, Sunaina ma'am.
Thank you so much, Geetanjali, for those lovely words. I can't begin to thank you enough. I think you people honor me a lot.
Ma'am, you are our inspiration and we have seen the journey, ma'am.
Yes, yes.
And thank you so much, Ragini. And I'm really honored, and humbled to be amongst all of you, such great people with such beautiful stories. I hope my story you will also like. And I was really impressed by hearing Viraj. So young, and she is struggling so hard, but she's not giving up on it. And that's what should happen. So, this is about my battle with breast cancer, all because of a node. And why that? Because it all started with a node. I dedicate this talk every time I give it to my husband, who stood beside me like a tower of strength. I don't think I could have done it without him. Though he says I am the strong one, but I think I get my strength from him. It all started with a painful, tender lymph node in my right axilla, near the tail of the breast. That itself should have made me suspicious. This happened in mid-December 2016. I had just come back from a function and I was changing my clothes. And as I put up my hands, I felt a pain in my right axilla. So I investigated, I palpated and found the lymph node. My husband was lying in bed and he's a surgeon. So when I told him, very typical of surgeons, he said, pain is good, and turned over and went back to sleep. I was so angry with him. I thought to myself, just imagine if your wife is a doctor, that means you should not even get up, look at the note, say something more, just say pain is good and that's it. But the very next day, he called in an oncosurgeon at home who found nothing, absolutely nothing. So the oncosurgeon told me to start antibiotics and NSAIDs, which I already had. And within 3 days, this node reduced in size, but it was still there. The pain disappeared. So we relaxed. And I did ask my husband, should we do a mammography? But typically, again, he said, no, it's very painful. There's no need for it now. So we just forgot all about it. But I think this was God's way of nudging me, and I ignored the nudge. Then again on 10th or 11th of February 2017, exactly about 2 months later, the node reappeared. Same painful, tender node. And this time, I don't know what got into me, but I made up my mind. No tablets. I want to show an oncosurgeon. And 13th February, Monday evening, we went to an oncosurgeon, and immediately on palpation, he said, there's a small lump in your right breast just below the areola. I think I was actually expecting it, so it didn't really jolt me. The very next day, 14 February, I got my mammography and ultrasound done, which showed a lump of about 3 centimeters in the right breast and 2 lymph nodes in the axilla. After this, once the diagnosis was done, everything moved like an express train. I didn't even have time to think about things, and the treatment was started and everything went on perfectly well. So 15th February, I got my FNAC and TrueCut biopsy done of the breast lump. And 19th February, Sunday, I remember it was because we had just had on Saturday, I had hosted our Daring Drishti Dames kitty. I was the hostess for that. We have a ophthalmic kitty of ladies in Aurangabad. I was the hostess, and I did not tell anybody about all of this. And they all got the shock of their lives when they came to know that I had been operated also. On 19th February, we got the telephonic report of it being IDC, invasive ductal carcinoma, stage 2, grade 2. When I told my children and my daughters-in-law, I have 3 sons and 3 daughters-in-law. My daughter-in-law who's in the USA, the middle one, she started crying over the phone. So I told her, please, Shweta, don't do that. I'm trying to be strong. You have to keep me strong. Don't make me weak. On 21st February, Tuesday, we did the PET scan, which confirmed the earlier findings. Thank God. This was a big relief. And we had a family holiday booked for Kurg from 25th February to 2nd of March because most of our birthdays and anniversaries fall during this period. But I was adamant. My husband wanted us to go on the holiday and come back and get operated. But I said, no, I will be so uncomfortable throughout the holiday. All the time, I will keep on thinking that the lump is growing. Though medically speaking, as a medical person, I know it will not be. But still, I don't want to keep it in my body a day longer than necessary. And I could see from my surgeon's face also that he too was against delay. So we cancelled all the bookings. Thankfully, my children also agreed. They said holiday is not important. Your treatment is more important. And we opted for a modified radical mastectomy, which with axillary clearance, which was done on 23rd Feb. Now here, I'll just tell you a small thing. My surgeon offered me a lumpectomy. But my husband and I had already discussed this. And he had told me that if you go in for a lumpectomy, you will need radiotherapy afterwards. So I thought the less the better. So I told my surgeon, just take it all out. I don't want anything to remain in my body which can become cancerous later. So I was discharged the very next day, thanks to being a medico, with the drain and its bag. And then I was moving around the house with my drain and bag. I'll just show you what it was like. This photo of mine is with the drain. That's my little granddaughter in 2017. And this is my drain, you can see. And this is how I used to hide it. I used to carry this bag, put the bag in it, because the length of the pipe was not such that it would go under my kurti. So I was wearing these short tops. And this is me at a mall. One day before my drain was to be removed, because I knew that the third day I was going to start my chemo. So I asked my doctor, can I go and see a movie? I love movies, I am passionately fond of seeing movies. So he said, of course, ma'am, you can. So I put the bag in that, my drainage bag in that bag, and I went and saw a movie. I'm at a mall. And this is after coming back. And then the next day, this was removed. And the third day, my chemo started. This is my birthday, which comes on 2nd March. So my surgery was on 23rd Feb. Obviously, I could not go out. This is my fitness freaks group, my group of friends from Talwalkars. We are so passionate about each other's birthdays. We celebrate them. So Dr. Malik said, since you can't go out, let's have them come over home. So we always have celebratory breakfasts whenever anyone has a birthday. So they all came home and we celebrated my birthday at my place. This is 11-day post-op. We had a meeting of the Aurangabad Ophthalmological Society. Remember, I was president of Aurangabad Ophthalmological Society then. And we had to form the organizing committee for the 2018 MOSCON. So my attending this meeting was very important. So my secretary, Dr. Rajiv Mundra, such a dynamic person, he spoke to me and said, ma'am, once your chemo starts, you won't be able to come out at all. So let's keep this meeting this very day. As usual, Dr. Malik, surgeons are really bindas, and that's what I learned from him. He said, why not? So this is how I went and I spoke, and we had the meeting. I was appointed organizing chairperson for MOSCON 2018. And see, I haven't even started my chemos, but I was so sure that I would be organizing chairperson of the MOSCON 2018 that I agreed to take on the responsibility. It never once entered my head that I may not be able to make it, because I had this strong belief that I am going to come out of this thing. I am going to defeat this cancer. I'm not going to allow it to defeat me. Then we started with the chemo. People had terrified me so much about the chemo. We started on 23rd March, my first chemo of cyclophosphamide and epirubicin, 3 more chemos of the same combination at intervals of 23 to 25 days. And, I had already prepared my mind for what would happen, because I think if you're prepared for the worst, then it doesn't hit you that hard. So I told one of my best friends that I know I'm going to lose my hair and I'm ready for it. But when it starts falling, I'm not going to wait till it falls slowly. I'm just going to get my head shaved completely and move around bald, or I'm going to buy a nice smart wig and move around. But in either circumstance, I'm going to look smart. So she started laughing and crying at the same time. And she said, how can you think so far ahead? I said, see, it is something which is going to happen. Why should I not prepare my mind for it so that I don't take it so hard then? Then my hair started falling after 17 days of the first chemo itself. So as I had said, I got it all shaved off. I bought myself a nice smart wig from Delhi because I got it shaved off. I got it shaved off at Vaishno Devi. In between my first and second chemo, we went to Vaishno Devi for our annual trip. You can see my hair is all matted up like a sadhu's, because when hair is dead, this is what happens if you wash it. So I got it shaved off at Katra after coming back. And these are my photos with the wig. I think I should look pretty good, even if I say it myself, you know. And I moved around like that for so long, so many months. And then eventually my hair started coming back. And in between, after my third cycle of the chemo, there was this VIP syndrome. We are bound to have it. Sudden development of thrombophlebitis on my left side. It was terrifying. The venous Doppler showed thrombosis of all major veins around the chemo port, around my chemo port, because I had a chemo port put in on my left side. But luckily, the thrombosis was going towards the arm, away from the heart. And my chemo port was still patent. It was not blocked. So I was started on anticoagulant therapy to be continued till the end of chemo. These are the side effects. Your nails become black, they turn inside out. It looks horrible, but I knew it will go away. Once I am off the chemo, it will go away. There were 4 cycles of CE and then 12 more cycles of another newer drug, paclitaxel, which is bound with gamma globulin at weekly intervals, every week. This was easier on me, lesser side effects. And after 4 to 5 cycles, I developed peripheral neuropathy, hyperasthesia in the fingers, which was very painful. And it scared me because I'm an ophthalmic surgeon. How am I going to operate? You know, that thought would keep coming in my mind. How will I operate if I can't even hold the instruments? But I said, okay, let's take it one day at a time and see what happens. 1 week after the 12th chemo, so altogether 16 chemos were there, 4 plus 12. This was on 18 September. My chemo port was removed, anticoagulants were stopped, and I was started on a hormone tablet, anastrozole, once a day to be continued for 7 years. This is a photograph of my chemo port. I have still kept it because I want it to be there as a reminder to me. I must never forget what I've gone through. At the same time, I'm so happy that I came out of it. The lessons that I learned were you need your spouse, no matter how much you may fight with them or not. But at the end of the day, you need them. Family support is extremely important. As Viraj also mentioned, without your family around you, you cannot get through something like this. But at the same time, you discover your own inner strength, you know. And I think my biggest strength was my positivity. I stayed positive through the whole process. I never once gave up because I knew that I am going to come out of it. But you learn patience also, and you learn to take it one day at a time. So I always give a big thank you, firstly to God, then to my husband, my doctor who was wonderful, my immediate family, and my friends and colleagues who were so supportive. There was a time in between after my third chemo when my mouth was hypersensitive. I could not take even a slight bit of chili powder. My meals were prepared separately. So she sent me a special dabba of mutton curry with no chilies in it. I can never forget that, how much they took care of me. Then, of course, after it was all over, this is MOSCON 2018, we had a wonderful MOSCON 2018. I loved organizing it along with my colleagues. I think AOA was like a huge family organizing this MOSCON. And then the high moment of my life as President MOS 2019-20. And I think I had a wonderful year as a president. In spite of the lockdown, in spite of everything, we could do so much during this 1 year. I think maybe I could not have done as much if it had been a regular year. That is what someone once told me. If you had been president in any other year, people would have forgotten you. But now they will always remember you. I said, you are so right, absolutely. And you know, my funda is, I've always believed in living life to the fullest. You must love life and live it. You know, that's why I say, I love you, Zindagi. And I continue to do so. The sword of recurrence is always hanging over your head. But so what? Enjoy each day that you get. Who knows whether the next day is going to come or not? But enjoy the day that you've got today. That's what I tell people. Why are you thinking of tomorrow and being sad today? Enjoy today at least. And the aim of this presentation actually is not to make me into somebody very Mahan or something like that. But even if one person in this audience takes home the message that cancer is not to be feared, it is to be fought and defeated, I think my job is done. And once again, I will thank Ragini for including me in this and giving me a chance to share my story. Thank you all so much. I wish there was no cancer, but since there is, we have to fight it. Thanks a lot.
Naina ji, that was really inspiring. Ma'am, you are a tough cookie. You are a really tough cookie. That's and I'm sure you must have prayed a lot too.
Yeah, I did, of course.
Yeah.
But you know, Dr. Manyar, I have always believed that I don't need to go and sit in a temple to pray.
No, not really, not
Pray
really.
from anywhere, because God is listening to you from everywhere.
Exactly.
And
He is within. He is within.
within us. And you know, even in between my chemos, I was going to the clinic and attending to my patients. So I think my work also kept me going.
Even Biraj today attends the clinic with all her limitations. She's performing surgery.
I saw that.
No, yeah.
So these are really fantastic tales of human courage. And again, Ragini and team BOA, think tank, hats off. Gitanjali, all yours.
Yes, thank you. I also wanted to say the same to Dr. Ragini. This is extremely beautiful that you have organized this today. We are all getting so much of positivity. Viraj, Sunaina madam, Lane sir, everyone. And now I would like to introduce, or rather present, my dear friend.
Gitanjali, I got this idea from your Deepasang, so you are the inspiration behind it. And I remember the same thing when my friend Salil Gadkari was alive. I was sitting next to him and I've heard Sunaina madam talk, and I miss him today.
Yes.
And I know everybody's story, but I myself am going through and I'm getting so inspired. I hope.
Yes. Surely, everybody is so inspiring. And Dr. Manjiri Manekar Oak, she's my very dear friend. And welcome, Manjiri. We are very eager to hear your story. She's an anterior segment surgeon. She's the director of Amaya Eye Hospital and she's consultant at Fortis Mulund. She is a very innovative person. She has developed many innovations in ophthalmology, whether it is instrument or surgical techniques, and she has received many awards for that. What I best like about Manjiri is her positivity. And I believe, Manjiri, that comes to you through your studies of Bhagavad Gita, because I myself read Bhagavad Gita and you also read, and she's reading for many years and most of the Bhagavad Gita is by heart by her. She's also a classical singer and she has learned singing for more than 8 years. She's an excellent poet. And she has got a different talent. You know, she writes a poem in Marathi and the same poem she can write in fluent English.
Yes.
And she sends me her Marathi poem and an English poem, and it's wonderful. So it's wonderful to have Manjiri here. Manjiri, I have seen you write since when you came to Mumbai from Miraz. She came from a small place, but she got her name done in Mumbai. So that was a great dynamic lady she is. So I've written a few lines for you. जिंदगी एक जंग है, लड़ना है दोस्तों. जिंदगी एक जंग है, लड़ना है दोस्तों. मुश्किलें आएगी, ना डरना है दोस्तों. कभी इस पार तो कभी उस पार, ये तो दस्तूर है. चलते रहो, कभी ना रुकना है दोस्तों. That's what Manjiri is. She has never stopped in her life. She has always continued her work. And I know all her family and they are all inspirational to me. So Manjiri, welcome. And we are very eager to listen to your story, inspirational
Just
story.
one word here, one word sideways, edgeways, as you make it. Another hallmark of Manjari is her rank or sheer humility. Both feet grounded firmly on the ground, and she has no airs about her. It's the humility of the person that shines through when you meet with her. Despite all her achievements and everything, she is humble, totally humble. Yeah, Manjari, all yours.
Unmute yourself, Manjari. Unmute yourself. You're muted.
Manjari, will you please unmute yourself?
Tech person, can you help her? Maybe she's not able to unmute. Manjari,
Yes,
unmute.
doctor. Yes, doctor. Wait.
In the bottom, madam, there is a red mic cross. You just have to unlock.
Actually, she's done a lot of presentations. Manjari, at the bottom, there is a mic. Click on it.
Left hand side, bottom. Left-hand side, bottom.
Left side, bottom screen. On your screen.
Be a small mic.
Manjari, when you joined, probably you have not joined with audio. Is that it?
Yes, she hasn't joined with audio. She's not able to unmute.
Who's there at Nuvero Tech?
Audio, I think.
1 second, doctor. 1 second.
Or maybe does she need to leave and rejoin with audio? I don't think so, really.
I must take this opportunity to thank Manjula Didi and Sai for all the work that they're doing for the program. Ma, I'm re-inspired by you. Manyar sir, you are guru, hats off. And Gitanjali, I'm so happy that you are the president of POS, so I found such a close friend in you.
Thank you. Now I'm immediate past president, and like Sunaina madam, I would say that I was really fortunate to be president during the lockdown year, because I could do so many activities and so different activities during the year. Otherwise, I wouldn't have done just the physical CMEs and seminars or a conference. But here I could do innovative webinars, like you said, Deepa Stamba. And since we are talking about inspirational stories, we had done one beautiful program about blind people who are blind, but still they are doing great work. And till Manjari is, doing with her mic, I would like to share this small incident. During that webinar, in the beginning, we all say, कि चलो अभी 3 seconds में start होने वाला है, 3, 2, 1. So one of the, our invitees, that blind lady said, am I looking good? Because I don't know. I can't see in the mirror. Oh my God, in those 3 seconds, I really felt what I'm going through. I couldn't be in the same mood throughout that webinar. It is so true, we don't realize this many a times. And she was on the screen, she could not see, but she presented her story so beautifully. So these are the inspirations in life. And I feel this last 1 year of my being president of POS, I learned so many things and so many positive things. And today's program, thanks to you, Ragini, for giving me this chance, listening to Viraj, listening to Sir, Sunaina Madam. It's so much positive energy I'm getting.
When we were making this, Swapnesh came up with just 2 names, Manyar sir and Gitanjali.
Oh, so nice.
So nice of you.
I think Manjari, leave and come back. Leave the meeting and join again.
Maybe,
permission.
sir, I think till Manjari finds the problem sorted out, you can go to the next speaker if we can.
Hello.
Am
I audible?
Yes, yes.
Am I audible?
Yes, we were just waiting.
Yes, Manjari, you're audible.
Yeah.
Great.
I'll share my screen.
Yes, please.
Yes.
We have 2 poets in the group today, Manjari and Gitanjali.
Is my screen visible?
Yes, you are visible.
No, your screen is not yet visible, Dr. Manjari.
Not yet visible.
You go on share screen. After that, click on your presentation. And again, there's a share screen to the right. Then again, click on that. And your screen becomes visible. I think thanks to last 1 year, I've become very familiar with Zoom.
Zoom, yes.
All of us.
All of us are very,
Your screen is not visible, Manjari.
Not visible yet?
No.
No.
Go on share screen first.
Yeah.
And then click on your presentation.
Yeah, I'm doing that.
And then again share screen. Not on the bottom one, on the side, red button. There's a red button on the side.
No, the share screen, that green button.
Yes, then click on your presentation.
And
again,
and on presentation.
presentation or double click. And again, there's a red share screen to your right, to the right of your.
Yes, correct.
Now you've started. Yes. Now, choose your presentation. Yes,
Is it visible
perfect.
now?
Perfectly. Go ahead, start.
One second. Thank you for giving me opportunity. Sunaina madam, it was just a reflection of myself I saw in you. I'll start with a poem. Wise enough to celebrate, own me, my tiny spot existence, is that me? Blunt reminder of my insignificance in vast creation, just happenstance. Ego vanished, feeling of nothingness, humility crowns, tranquil sweetness. Wipe of misunderstandings and ill fate. No, not too late before turns into hate. Don't burn yourself in fear unknown. Let's deal with the worries on our own. Never splurge on unwanted conflicts, will camouflage into enmity and deceits. Unknown weird form of greed attires if you let loose your mammoth desires. Differential knowledge of need and wants, save futile expense turning into debt. Unwanted thoughts, my head spinning, my brain lost into negativity hovering.
Manjari, start your slide. Yeah. Yes.
Is it visible?
Yes. Perfect.
Unwanted thoughts, my head spinning, my brain lost into negativity hovering. Flame my undue pride called false ego, enlighten life brighter, just let go. Me too tiny in his grand kingdom, let me celebrate my renewed wisdom. A war had begun against a powerful enemy. It was long back in 3rd of December 2009 at Tata Memorial Hospital, a journey of pain, endurance, courage, and conviction started and conclusion unknown, where the journey had just begun. Armed with great army of medical and surgical expertise and skill of medical professionals at Tata Memorial Hospital. Diagnosis was done in the last week of December and surgery was planned the last week of November, and surgery is planned on 3rd of December 2009. Conservative surgery was performed, lumpectomy with complete axillary clearance with removal of 24 lymph nodes. But suddenly, emergency exploration needed. Re-exploration was done at 8 p.m., 8 a.m. On 4th of December. Rare happening at the expert hands of Dr. Rajendra Badwe. It happened profuse bleeding at the site of surgery with hematoma. I was almost in a state of shock with severe hypotension. This emergency exploration was performed under local anesthesia, means almost no anesthesia. GA was prohibited because I had food in the evening. Here, let the warrior within you fight for you. Guided meditation helped me throughout the surgery, which was my training in yoga and Brahma Vidya helped me. Secondary procedure took much more time than the primary surgery. My anesthesiologist was surprised to see the endurance, and my surgeon exclaimed, Manjari, you are one of my bravest patients I have ever witnessed. And my favorite talk to myself, pain is essential, but the suffering is optional. And here I wrote, guided meditation. I'm an ardent yoga follower since 1991 and following Brahma Vidya for last 2 decades, which helped me to do pain control throughout the surgery. And here I wrote in Marathi, Vedana. I'll just read the last first line. प्रत्येक तीव्र वेदना अन्मुखता अभिशाप आहे वेदना उत्स्फूर्त जरीही प्रतिगती निश्चलती आहे वेदनेला पार जाता जेत सागर कलह आहे वेदना जरी नियम असली साहणे ते शक्य आहे आय जस्ट रीड द लास्ट 2 ट्रान्झास स्वीकारता ती सहज दिव्य एक प्रचिती आहे वेदनेतून मुक्त होता ते असे वरदान आहे अनुभवाचे मापते ओलांडता तो स्वर्ग आहे परतून तेथ पाहता संपूर्ण तो निश्वास आहे वेदना माझा गुरु my teacher. Pain is my teacher. When I was posted for surgery on 3rd of December, I asked my surgeon, when can I perform my surgeries? He just casually. When I heard Sunaina madam's talk, surgeons are always like that. Next week, you can post your surgery. I took it literally and posted my operations on 8th of December. When this ritual of two surgeries done on consecutive days of 3rd and 4th, I realized that I am with beautiful accessory called drain in my right axilla with a bag and huge dressing at the operation site, which made my right hand almost immovable. But I didn't postpone my surgeries. I put a sterile autoclaved bag over my new ornament and performed surgeries. At this point of time, I felt lucky that I am left handed. It seemed like a never ending war. Post-operative rehabilitation, physiotherapy, exercises, or ritual lasted for a very long time. My surgeon put me on post-operative exercises since day one because he had to make me ready to go through the ordeal of extensive radiotherapy, which required complete extension of my right arm at 180 degrees. At this point of time, I was unable to move my hand even 10 degrees. He asked me to do the exercises 10 times a day, and I followed religiously. Success was waiting in the dark corner. After surgery, I had just 15 days in my hand to prepare myself for chemotherapy. I was given rapid chemotherapy with 2 week cycles, so that Friday I used to take chemo and continued working, including surgeries since Monday onwards. My first post chemo used to be really bad. First week of post chemo used to be really bad as far as symptoms are concerned, and drop in the cell counts used to happen since fifth day onwards. They used to reduce almost to minimal levels again to regain to minimum required level to give a further dose of chemo. Filgrastim growth factor was given for five days for each cycle. So 40 injections I administered myself uh, each time, and there used to be a suspense every time. Chemotherapy cycles, 4 plus 4, 8 cycles. Second half of 4 cycles was much tougher because docetaxel was chosen over Taxol group in Taxol group because I wanted to continue operating throughout this period, and docetaxel supposed to have less side effect of tremors in hand, but I had severe peripheral neuropathy. But still, I continued operating my patients even during that period. If I can do during this time, I can do any time. That was my principle. Here I was started on target therapy of Herceptin because I was HER2 positive, and this medicine was under trials then. So I was taken under trial for this medicine. Total 26 injections were given in a period of 1.5 years, and last stage of these injections caused cardiomyopathy, which was recovered later. Then ordeal of radiotherapy started. Session started immediately after chemotherapy. Till then, extension movement of my right arm was complete 180 degrees. Total 25 plus 6 cycles, 6 cycles of advanced treatment was real. Grueling sessions ended in 2 months. During this period, I got infected with H1N1 virus, and like now, COVID virus. Then swine flu epidemic was going on, and my viral titer was very high. And still I was very eager to finish up my radiotherapy, but the treatment was discontinued for a period of 1 week. I used to take early morning appointments and then come back to my OPD at 11 o'clock regularly. Destination achieved, but journey had just begun. My association with Tata Memorial Hospital is deep rooted. This hospital is second home for me with more than 100 visits. A long war felt like never ending at that moment of time. It has witnessed many highs and lows, almost a feeling of losing all over again. But this incessantly continued for long 2 years with moments of desperation, dejection, pain, intervene with triumph, joy, and success of becoming a part of life all over again. DMH gave me myself back, completely new me. Life is a full circle. Confidence and conviction epitomizing me that can venture into complete darkness, totally unknown, and come out triumphant at the end of dark tunnel to see the bright light again. It taught me how much you can push yourself against all odds, one step at a time. My initial question mark, why me? After learning this biggest lesson of life, I said, why me not? My outlook towards my patients completely changed. I'm more compassionate now. I can understand them better in my OT when the roles are set back, again having experienced when the roles were reversed. And during this phase of time at in 2010 Sangli Moscow conference, um, I was honored with award for innovation of LASIK marker, and where Lane sir was instrumental in giving me this award. Thank you, Tata Memorial Hospital, and all who were part of my journey, my family, friends, relatives, well-wishers, known and unknown, who always prayed for me. I got the opportunity to work for some charitable projects with TMH as a Rotarian. I was overwhelmed with emotions of gratitude and joy, and truly it was a bliss. It's my time to give back to institute who made me stand on my feet again in all wakes of life, physically, emotionally, and spiritually, much stronger, much better, ready to face all adversities and adventures, and which is called life. What made me so? Brahma Vidya. I knew just basic then. Now I'm a qualified Brahma Vidya teacher, yoga and meditation since 1991. But I am more disciplined now. I have taken Bhagavad Gita Santha at Gita Parivar, Vivekananda Kendra, and my aim is to learn by heart all 700 shlokas by December 2012 by 21. Now I'm examiner for Bhagavad Gita recitation competitions also, and I'm doing graduation in Sanskrit language. And for the first exam, I scored 100%. I have learned. I was intrigued by this occult science, so I have learned basic astrology, palmistry, numerology, tarot card reading, etc. during this lockdown period. And as Gitanjali introduced me, I have interest in classical music. I've learned a bit of it for 8 years, and now I'm learning music therapy, means use of music as a therapy. That course I'm doing just now. Here I end my talk with my one of my poems. Infinite flames of grim, dull failure, ashes burnt and shed some tears. Success waiting in dark corner, lashes taken, but no surrender. Life pristine, precious that inhaled in one go, decay unseen, exhaled. Eagerly awaiting to unfold destiny, deceit, dejection, just not following. Accept all comes in arduous way. Keep all those forfeits far at bay. Despair to dwindle, reward candle of hope to rekindle. No chance let go to vanquish hate. Allow flow of love, never too late. Burn to dust your red flaming ego. Just learn to conquer it in one go. Folded hands spray the pious fire, only to accept his deed superior. Reaching out to the final goal, let me acknowledge Super Soul. Thank you so much.
Thank you, Manjari. Thank you. Thank you. That was truly inspiring. That was really inspiring. And, it's these tales where you want to go back to work, you want to rehabilitate yourself, the courage, the self discipline, the amount you are willing to push yourself, and then branch out into newer fields like Sanskrit, Bhagavad Gita, and music therapy. Other than that, it's amazing. Very recently, I came across one post which says just the chanting of Om, just the word Om, whether it's in the OT or it's anywhere else, is enough to relax your patient. And Cyrus and Divyang may not agree, but they say that it helps you to reduce weight also. So Gitanjali, I am going to now introduce two hulks who have now become hunks. Cyrus Mehta was never unfit. He was always fit, but he was a little fat and plump.
A little.
That goes with the history. I mean, there is a genetic history there with the Mehtas that, well, a little flabber here and there, flab here and there is, it's normal. So, Cyrus, what was your secret? What was your motivation? Why did you want to do this?
Yeah. So, shall I start my talk now, sir?
Yes, sir.
Yeah. So, I've been hearing all these really inspiring stories, and I've got lots of stories of my own, but some of them are private because then otherwise it's not. That's why it's called private life, because it's not for public consumption. But anyway, so here is the part that is public, called the close the door lockdown transformation. So let's start, and thanks very much to Ragini for having me here today. And otherwise, I wouldn't be here. She invited me, so that's why.
Just go back to the screen. Huh?
Thank you,
I have,
Cyrus. Thank you. It's a
I have
pleasure
shared the
to
screen.
be inspired.
No, you have shared the screen, but go to full screen.
Yeah. Done? All
yeah.
right.
Yeah.
So, let's start with a little way back. So I was always a biker. Ranjit knows this. And Dr. Kirit Modi knows this. Even Dr. Rumi Jangir knows this because they have sat on the motorcycle. And this was, the Bald Me was 2001 that was my first foreign motorcycle. And I was always a biker. I used to go behind Dongri, and for 50 rupees, I used to give my college ID card in 11th standard because, of course, I didn't have a license. Now I was 17 years old. And we used to hire this 100cc bike. Then me and my friends, we used to take it to Marine Drive and ride it up and down until that 1 liter of petrol for 7 rupees got over. So that was the idea of fun in those days. Then we gave it back there and took the college ID card back. They never asked, there was no Aadhaar card, PAN card, no other proof. If he ran away with a bike, he would have to come looking in the college for me with the ID. So I was always a biker by heart. I had a lot of magazine covers like Motoring Magazine, Autocar, and Fast Bikes did an article on me called SOS, The Science of Speed. Again, that's me. You can see me about 93, 94 kilos and learning to race on the right. That was probably about 12 years ago. And this is a picture with Ricky Gadsden, world drag racing champion, and my younger son, who's now 6 feet tall. So that's me racing. I would take the bike to the racetrack because, you can't go as fast as you want on public roads without killing yourself or somebody else. And that's not a very responsible thing to do either. So, but you can go as fast as you want on the racetrack because you can only kill yourself. The public is safe from you. That was a photo shoot done about 4 or 5 years ago. This was the world's fastest production motorcycle. And on the back straight of the racetrack, the bike would hit 330. 330 is so fast that if you sit up, you will be blown off because you will catch air like a parachute. You can see I was about 92, 93 kilos here also. I should really fill out that racing suit. So if you do Hirogiri, sometimes you have to pay the price also. So this is a very nice crash that I had, which ended my racing career. I was knocked unconscious at 150 because I was wearing the helmet, so it saved my life. So there are a lot of stupid people I see who say, I'm just going to the market to buy bhaji and don't wear a helmet. I tell them that if you are unlucky and somebody hits you that day, you will be dead. So better wear that helmet. So this was a video after that the California Superbike School made for me because I was one of the few people who actually had an accident and came back the next year to race again. Because I liked it so much, I felt that, I got to do it one last time. So they made this 1 minute clip for me. So here also I was about, you can see how big I am, about 95 kilos now. So this is the racing school where they actually teach you how to race. Just like you go to medical school to be a doctor, you don't figure it out at home by reading the book. You can't just sit on some vehicle and expect to be competitive or go fast, do stuff like that. You actually have to go to a racing school to learn to race. So let's start the fat loss talk. So remember, no one is born fat. Everybody is born the same size unless there's some congenital malformation. So this is me on the left side. I used to have this big afro haircut. You can see that. But I had thin legs. And that's me with dad and my grandmom and his brother. And we are not a fat family, unlike what Ranjit was saying. You know, it's just fat habits where you eat lots of carbohydrates and you eat a lot of sugary food, and then you get fatter and fatter. And that's me with my lovely wife there. And, you know, I got so fat that at one point people will say, "You're looking like her daddy now." And that was like not a very good thing. So this is how fat I had become. And all my friends were like, come on, you can do it and all. It's not so hard. So when the lockdown happened, I said, now there's no work. There's nothing to do. May, June, July तो कोई नहीं आएगा. वैसे भी इतने नहीं आते थे. अभी और कम आएंगे. So now at least 3-4 hours a day ना थोड़ा exercise कर and make a difference. So I bought this basic bar and some weights, and this was my hall of the second flat at home. So I started exercising in the hall. So this was right in the beginning. Then I realized now that with this much basic stuff now, kuch farak nahi padega. So I need a more advanced setup. So I threw all the furniture out of the hall and I installed the entire gym there. So this is the entire gym that I installed. In the middle of lockdown in May, while everything was shut, they came, installed the entire gym because I think everyone was doing this. So that's me doing pull-ups there. I had already lost some weight by then. And that's my best buddy helping me lift. You'd come over every day. And that's about 250. I got pretty strong by then by lifting about 2.5 months. I was always a bodybuilder for 20-25 years, but I never controlled my diet. So it never really looked good. So this was me after about 3 months where you could start to see the abdominal muscles because the superficial fat gets shed off. And the muscle underneath you can see. The muscle was always probably there, but you couldn't see it because there's too much fat on top. So I needed some kind of cardiovascular exercise because just lifting weights will not keep you healthy. Like what Dr. Lane was saying, that if you don't do the walking and the cycling, eventually the body fat will come back and your heart will never be in good condition. So I decided to cycle. So I bought one cycle and I joined the ranks of all the people that I used to laugh at. I used to see these people cycling on Nariman Point and Marine Drive. And I said, सब पागल है, सुबह सुबह उठ के और काम धंधा नहीं है क्या? इधर उधर घूमते रहते हैं रास्ते पे. And I became one of them, getting up at 5:30 in the morning and going to cycle. I used to never get up at 5:30 in the morning. I used to get up at 9 o'clock in the morning, that too with two alarms. Because otherwise, you know, one alarm would ring and then I would shut it and go back to sleep. Yeah. So then I joined a cycling group and they were training for the triathlon in Italy, end of the year, where they would cycle 80K and run 21K. So they were already pretty good. So I joined them and we did, from Kolaba, we started behind Taj and we cycled till Khandala. That was damn hard because after cycling 90 kilometers to Khopoli, you're half dead. And then having to climb up that Gorghat. So I'm not looking very happy there. So I can honestly tell you this was the hardest thing I've ever physically done. But if you try hard enough, anything is possible. And that's me and the boys climbing up the Gorghat Road. And that's Nigel Smith, friend of mine, who was the British Olympic cycling coach who came and set up my bike and all for me. It's very important to do what is called a bike fit, where you tweak all the measurements and put the seat at the correct height, etc. Otherwise, you cannot cycle long distance without getting some injuries or the other. And my classmates were very impressed with me and they gave me a medal. So that was very good. I never got a medal for doing anything physical till today. This was how fat I was before. And this is what I look like now. And so this is a friend's gym where they did a professional photo shoot. I'm also a consultant now for a bodybuilding company run by a friend of mine. These are all friends of mine. We used to train and all 20 years ago, but then I kind of lost touch. This is one more picture of the professional shoot. This was me 3 years ago when I went to Dubai to operate Hussein Sajwani, who was the second richest man in the UAE at that time, just second to the Sheikh of Dubai. And I was in his palace, and you can see how fat I was there. You can see my big stomach and all. And Hussein had called Donald Trump also at that time when he was president of America. So that's me now. So it's quite a transition from being a fat guy. I've always got the six pack that I wanted. So every time, they say muscles dikhao, so now I have to lift up my t-shirt and not show my biceps anymore. And this is the mandatory towel pick. So any proper self-respecting Bollywood movie star now, he has to take a picture in a towel, like Ranbir, Salman, and also. And if I want to become an actor now, I have to show one towel picture also, because otherwise it just doesn't cut it anymore. Yeah. So how did I do it? It's not so difficult. You have to basically do a lot of cardiovascular exercise and diet. That means you're walking, cycling, HIIT. You have to stop eating all this rice and chapati and potato every meal and remove sugar. It has no reason to be there in your diet at all. And eat less. We have a habit of pet bhar ke khao, means we eat this much food and then expect to be thin after that. And walk 10 kilometers a day and cycle. You have to weight train if you want to look like this. Otherwise, you will just look smaller and more compact, but there will be no muscle to show anyone and no more towel pictures. So weight training is a must. You need a good coach. I never had a coach because I was a professional bodybuilder earlier, so I knew how to do anything. And you have to train hard enough. You have to try hard enough. You can't do 1 hour, 2 hours a day and expect this kind of results in 4 months. I did this in 4 months, and it was about 3 to 4 hours a day of training. Was it tough? Not really, because there wasn't very much else to do, and except make videos, fun videos like this with my friends. So this is 350 pounds. So people always feel you must have done better maar ke kiya hoga, but you have to really give it 100% effort like this. Otherwise, you will not get the results that you really want. So you have to give it 100% effort. Otherwise, you will not transform like this. And that's a picture taken by a friend of mine on the left. Was it worth it? That I think you guys have to decide. I always wanted to have a six-pack once, so I said, okay, ye bhi kar denge. And this is one of my idols from the time I was in school. And he has a very good saying that everybody pities the weak. Jealousy you have to earn. And so you can see the picture on the right. Forget about the muscles. See the look in his eyes. This is a guy who came to America with $20 and became governor of California. So anybody wants to ask me, are very free to ask me. Just DM me on Facebook or Insta or WhatsApp me, and I will tell you exactly what to do. What's next? Well, I'm learning the piano, and I always played the harmonica. So I want to start a band now. So if this lockdown continues 1-2 months more, then I will be done with the piano also. And boys, come here. And these are the two boys who have given me lots of company in the last. This is the small fellow who is now 6 feet tall, and hopefully will join medical school this year if NEET happens. And the small fellow who is in the 3rd standard going to 4th standard. These are the two heroes that I've produced.
So Cyrus,
yes, sir.
What happens to the bouncers that you had employed?
So I have a bouncer in my clinic. You always laugh and all, and Ranjit always laughs when I tell him. But at one time, it was a fashion. It was a fashion. Chalo, hum doctor ko marenge, Now I am one guy sitting in a small clinic. I don't have some big hospital of 50 staff standing around to beat them. So I figured that there's only one door. So if somebody wants to beat me, I can't even run away from the back door. So what can I do? So one day this guy comes and he says, I want a job. And he was a huge, big, muscular guy. So I said, what do you do? He said, my phone answer karega. I said, pehle kya karta tha? So he was the bodyguard of one of these dons at Dongri. So I said, uska kya hua? Koi isko goli maar diya. So I said, now you have no job. I said, okay. So you answer the phones and you work here. That's how I have a bouncer in the clinic who answers the phone. And it has, let's see, once or twice in last 5 years. Generally, all this doesn't happen, in South Bombay. But patients have come with some grievance or the other and start shouting loudly. So he just comes and stands there, and he's 3 times bigger than me and makes a face at them like that. Then they go away.
And the other question, Cyrus, is LinkedIn में profile change किया है क्या?
No, I don't have a profile in LinkedIn. I have a
No,
Facebook. I have a Facebook and Instagram.
Have you added this as one of your traits, which people could then maybe take you up as a bouncer, because Divya is looking for a bouncer.
No. So anytime I get anybody who works in Bollywood now, so they tell me, well, doctor, what can I do for you? And so I always tell them I want to be an actor and I want to act in Bollywood. But then they always say yes, yes, and they never call me back. Yeah. So now I'm going to show that towel picture every time. I say, see, my abs are better than yours now. Okay.
But the towel's got to be white next time. And I'm going to straight to Divya because Nikhil and Karobi have already joined and breathing down her neck here.
Right.
So
Absolutely.
Divya, you have to share your story also from Hulk to
Oh,
Hunk.
Ranjit, we are enjoying ourselves. Don't worry. Carry on. We are enjoying ourselves. Don't worry. We have the whole night ahead of us.
It's only Karobi. It's
Of
only
you, Cyrus.
Karobi. और तो कुछ है ही नहीं.
Enjoy your show also.
Why should I worry? Yeah, Divya, you can unmute yourself.
Yes. Okay. So thank you, madam, Ragini madam, and sir.
So I must, before Divya starts, know what Cyrus ended with. So we never needed a bodyguard when Divya was there, because I remember one day we were traveling by second class to a camp and there was some shore gulla, and this Divya goes and says, "Kya hai? Mera laane sir hai." So Divya was that bulky.
So sir and madam knows me since last 20 years.
This is like saying, "Mere paas maa hai."
Yes, absolutely.
Karobi, you can take inspiration.
So
Asude.
Planning to.
Sir, can you hear me?
Yes.
Yes. So I'll start my presentation.
Yeah.
So behind every strong person is a story that gave them a no choice. So this is a photo 18 years ago when I done my post-graduation with sir and madam. We were in Varanasi. Madam, I'm always a foodie, not eating food properly and not taking care of myself. Sir always used to tell me, "Kota kami kara, run, everything."
So look at you now, look at me then, and look at me now.
So this was I was before. I was around 120 kg, 115, 119. This is my 6 years back photo. Is this? So with the practice, what has happened? I was getting myalgia, irritated because of the obesity. At the age of 37, I got diabetes, elevated uric acid, cholesterol, dyslipidemia, and I was very upset about it. I was on a medication for 3 years. Then I decided to take some great action and start working out. So time to take action. This is a gym I have made in my clinic. So my journey started with the modification of the lifestyle at the age of 40. Consulted doctors, nutritionist, health trainer. Their advice, as Cyrus said, cut off carbs and unhealthy food. So everything I listened, and then I made my plan. So this is my ongoing journey. Now I am 82 kgs and working every day. Saumil is my gym buddy. My wife, me and Saumil starts at morning 5, and that is our time, me time. So my regime is, I discontinued my wheat dairy product, keep myself well hydrated with the alkaline water, weight and muscle training, gym 6 days a week or 7 days a week, intra-workout hydration, increase protein fiber diets, and I am very much fond of intermittent fasting to avoid insulin spike. So I have done that and I love it and I do it. This is what I am right now. This is always I keep the record as sir and madam taught us to check. So this was my weight have gone down to 67.8. Then it has gone, my skeletal mass was around 31 kgs and fat was 15.5. At present, I don't have a record, but at present I'm 82 kgs. My skeletal mass is more than 40 kgs and my fat is around 11 only. So I increased in skeletal mass in my body. What is the takeaway? importance of proper trainer is very much important. I have got 5 trainers. I have consulted so many people, and especially focusing on the muscles. And the trainer is very important to avoid the injury and maximum output. Training in a group help motivate each other, like Somil, my wife, my friends also do together. Proper rest, good 6 hours sleep is very important. Healthy homemade food, which I was not taking, and all this help to increase the IGF-1 level in the body. Now I'm shifting out the 1 or 2 points. People think how to lose the body fat. So according to the internet, people are doing it also, like detox water, 10 minutes ab exercise, fat diet, DRAP, crash diet, which I don't believe. According to the science, be in a calorie and cut your calorie deficits, strength training, less but definitely required cardio, focus on a quality sleep, and as Lane sir taught us from day one, consistency. Perfection se zyada consistency is very much important, and patience is the key. Progress take time. This is my schedule of the intermittent fasting if you people want to take it. So in nutshell, main objective is to build the muscles, improve body composition, losing excess fat. Building muscle is the far more superior than losing the fat, because the metabolic active tissue, the muscle is a metabolic active tissue, and which once you increase the lean muscle mass, your metabolism goes up. So my skeletal muscle weight was around 40. Now my BMI is from 21 to I am right now on a 24 BMI. More strength, better the quality of life, better the posture, less risk of problems like osteoporosis and arthritis. So when I was 38 and 39, my HbA1c was around 7.4. I was on a heavy diabetic medicine, phenobarbital for a uric acid, and a statins for a cholesterol. Since last 2.5 years, I'm not on any medicine. My HbA1c is coming 4.5, 4.2. I repeat my HbA1c every 3 months, 4 months, and I'm not on a single medicine right now. The resistance training is very much important at the age of after 40. The reason for that is the skeletal muscle has to be breathed. This is a breathing, like cardiac muscle is the skeletal muscle. So all this cardio endurance exercise which we do, which will take care of the your cardiac and vascular system, and muscle system will really make you anti-age. The type of training that is endurance based, that is running, Zumba, walking, and strength based is a weight resistance training. Base training option will be combination of the resistance training plus low intensity endurance based training. I do walk 20 minutes a day, 4 times in a week. Why strength training is important? It burns more fat. It prevents injury, because once your muscles get strengthened up, your injury is prone and your movements become faster. You strengthen the bones, because the bone mineral density has been increased with the weightlifting and the resistant exercise, which will go into a bone loss, which happens after the age of 40. It's a stress reliever, because the endorphin takes care of your stress, anxiety, everything. Building confidence, once you lift the weight, you're powerful, so you feel strong and powerful. These are my trainers. Viraj is my guru. So in my ophthalm field, like my 15 years of career of practice, my gurus are Dr. Lane sir, Ragini madam, my team, Dr. Anis, Preetam and Hema. And for my this second life, that is apart from ophthalmology, for my training, there are 5 people very much important in my life. There's Mr. Viraj, which is in the center. He's my trainer. Sachin, he's my trainer. There's Ashim, Kanishk, and Mahesh. These are my trainer who makes my plan. What is my tomorrow workout plan? What is my food plan? How much calories I'm going to take? And now it's become a very passion for me. And me and my wife has joined recently since last 6 months, she is doing training with me. So it's not about the perfect, it's about the effort. And when you bring that effort every single day, that's where transformation happens. And that's how change occurs. Thank you.
Thank you, Divya. Can I share a small secret of yours that you told me, if you don't mind?
Yeah, please, sir.
I believe Divya has now got a certificate from the wife. I will not go into all the details of that certificate, but one point there is that he looks younger. What all else she has written there, मैं नहीं बताऊंगा. This is a public forum, so we can't discuss a lot of things here. But thank you. And another way to lose weight very fast, na, is first measure yourself in pounds. Like
I thought it was you have to get a girlfriend.
Yeah, the Cyrus is right.
Only 68 kilos. So
Ranjit,
I have just a change in nomenclature. And there you are. You have a weight reduction. Karobi, where are you?
Divya, how big is your arm now?
So I am right now.
I'm about 16 and a half now.
So almost same 16.
Yeah. Okay. Not bad. You are doing well.
Not too bad. So Nikhil, Karobi, all the best to you, and Ragini, Lahani sir, thank you, BOA, thank you very much.
Thank you all.
Yes, thank you. Thanks a lot, Dr. Ragini, Dr. Lahane sir, everyone. Thanks.
Thank
It
you,
was
everybody.
pleasure.
Thank you
Yeah,
for
enjoyed.
sharing your inspiring stories. Thank you so much.
Thank you all.
Thank you.
Any question from sir?
और दिव्यांगान को देखा है तो करबी को बोलना है कि ये दोनों लोगों ने वजन कम कर दिया है करबी जी. तो ये दो लोगों का जो मुझे लगता है कि दोनों को देख के करबी is also going to reduce next year.
Yes, sir, definitely.
From pounds to kilos.
Karobi Ma is perfect just the way she is. She is perfect.
अरे ये क्यों परफेक्ट बोल रहे हैं कि इसका वजन बढ़ रहा है ना तो अच्छा है तेरे को परफेक्ट किया तो इसको वजन कम
नहीं,
करो तो
don't say anything about my Ragini.
इतने होशियार लोग हैं देखा क्या?
Oh God. Definitely, sir. We will always try.
Yes, definitely. 12 बजे रात में खाना खाने का क्या? अरे Cyrus and Divagan, congratulations.
Sir, thank you. Thank you.
I also reduced by 7 kg.
Yes, sir. Sir, you because of
stress.
मैं रोज 10,000 स्टेप चलता हूँ every day.
Yes, sir. Yes, sir. We know that, and we are your followers, sir.
Yes, you will have to because you are my student.
Yes, sir. Yes, sir.
Divyagan, I am not happy. I have lost a eating partner. Huh?
Hey, madam, I eat now 2,400 to 2,800 calories. I am eating everything.
But then, are you allowed a vada pav? Are you allowed vada pav or no?
Yeah, I eat vada pav.
Yeah, cheat day is allowed one.
You can't eat that.
Yeah, cheat day is allowed.
I can eat vada pav. I can eat jalebi. I can eat everything.
Yeah, everything.
You just have to walk that much more after that.
Yeah, you have to
So
do the.
Karobi is anxious to take over.
Yes.
Yes.
Thank you, everybody.
Thank you, everyone, for joining. It was pleasure.
Thank you for having us. Thank you,
Ragini ma'am, thank you, Dr. Manyar sir, thank you, Malik madam, thank you, Divyagan, thank you, Cyrus, thank you, Viraj, Dr. Lahane sir, thank you so much, everybody. Thank you, Manjari. Thank you for sharing your inspiring stories.
Thank you, Ragini madam. Thank you for calling all of us.
I can. No, I can't see your screen.
Ruby ma'am?
Yeah, just a moment.
It's all yours, ma'am.
Yeah, I know. I just lost that connection. 1 minute. I saw your screen, Nikhil.
Ma'am, is my screen visible?
Yeah, your screen is visible.
Okay.
Nikhil, what do you do?
Sorry?
Nikhil, now let the actual divas arrive.
Yeah, so I'll just start now.
But my ma is no less a diva.
No. See, now the
So,
thing is,
ma'am-
that before you start, Nikhil, I want to say a few words. Okay. Now the thing is that for me, there is only one Laman Diva. Okay. And that Laman Diva is full of sincerity, hard work, efficiency, dedication. She is a fantastic surgeon and she's done maximum surgeries, cataract surgeries, and she is also shouldered all the burden of the scientific committee for the last 15 years of BOA. Now, any guesses who that person is? Nikhil, the question is to you.
Ma'am, the divas are right here, ma'am.
No, but this is the
It's
biggest
none other than our very
diva.
own Ragini, ma'am.
Yes, exactly. She has been a diva and she will continue to be a diva. It is not about looks. It is not about, it's about how many people you touch in this life. And she has touched so many. Okay. For me, she's a diva in the true sense of the word. What do you
Thank
say?
you, ma'am. This is, I'm so touched by this, ma'am. Thank you so much.
You
I
deserve
second
it.
that, madam. Though I'm
Yes,
not
yes,
part of
yes.
this, I just second that.
Aditya,
Good,
Gitanjali, you are a part of everything that we do. We are a part of each other. We are
Karobi.
Yes.
Ragini was crowned as beauty queen in her school, St. Mary's.
Oh my God, that is news.
Yeah.
No, but she's still beautiful.
Yeah, she is, of course.
What is Dr. Lane saying that she needs to lose weight? She doesn't need to lose anything. Okay.
So, ma'am, before we go further, I would also like to say that for me, both Ragini ma'am and Karobi ma'am are true blue divas because they are beautiful within and so humble, always ready to help out anybody who asks for help, and even if they don't ask for help. So, you all have literally handheld me in my BOA journey, and I am forever indebted for that. So, these are my true blue divas.
Okay, but Nikhil, one word. I can see you sandwiched between us and you're squashed in between, you know?
So, sir said you'll have to lose weight.
I know you're getting super squashed. And this is a stud, you know? We should see the stud's face also, you know?
And Nikhil is very chupa Rustam. He's sharing all the flyers with me, and he didn't share this one.
No,
Yeah, this was a surprise, ma'am.
This was a surprise one, you know? And Nikhil, please show your stud photograph.
I will. Later, ma'am. Later. Let's get on with the show first.
Okay.
So I'll just introduce the show. So welcome to the most glamorous session of the day. The one session that all of us have been eagerly waiting for from the word go, especially all the guys. I can feel the hearts are racing. This session is called Dynamic Surgeons to Dazzling Divas. Now, the motto for all of these super achiever women is, why should I choose when I can have it all? Isn't it? So that's the motto these women live by. Now, who is a diva? A true diva is one who knows there's more to life than just glue on lashes or red lips. True beauty comes from inside of you. So these four beautiful women, all of them, they are outstanding eye surgeons, doting moms, devoted wives, dutiful daughters, and now dazzling divas also. So that's my introduction of the dazzling diva, ma'am.
Okay. Can I quip in?
Yes.
I want to say a vote appeal for sir. Okay.
Please.
This is one iconic person who needs all the support that we can give him from Maharashtra and all over, because he has favored a lot of people all over India. And I think he deserves to be a vice president in the truest sense, because he's going to lead all India to greater heights. And I want to say that day when all India also grows in its abilities to do much, much better work than it has already achieved. So, a small vote appeal. Please, sincerely, in numbers, come and vote for Dr. Lahane when the voting link comes on. Okay, over to you, Nikhil.
So, ma'am, without further ado, we will put our hands together and welcome this girl gang of ours, Dr. Archana, Dr. Reshma, Dr. Rajni, Dr. Sujata, and Dr. Mridula. Our first participant today is Dr. Archana, and what do we say about her? Character, intelligence, strength, style. All of these things make her very, very beautiful. So over to Archana, ma'am.
Thank you so much, Nikhil. So I'm greatly good.
She's an anterior segment surgeon from Mulund, and apart from doing her work so well, she's also won the title of 2020 Diadem Mrs. India. And over to her for her journey.
So I'm greatly honored today. Good evening, everyone. I'm greatly honored today to be present here. And thanks to BOA, thanks to Ragini ma'am, thanks to Karobi ma'am for having me here. So for me, a real queen is the one who fixes other queens' crowns without telling the whole world. And for me, that real queen is Ragini ma'am. And I dedicate this phrase for her. So as we start, we've done a fun video. So first I will share that fun video. All four of us just done a fun video. Is the screen visible?
It's visible.
Yes, it's visible.
मेरी से परनीत आ जाओ ना तो सही ऐसी मन की है सच्ची तुम हो सितारों की परे हुई गलती सॉरी हमने गाया तुम क्यों सुनी किसकी मर्जी जो थी अब तो आए जा हमको ले जाए जा 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 हमरी से परनीत आ जाओ ना तो
That was fantastic, Archana. I mean, suddenly you're practicing ophthalmologist and you turn around and oh wow, that's a look. So after this, I think you all will be starting on your individual journeys through this. So whom do we call on first? I think Archana is the first person. Who
Yes, ma'am.
Archana is the first one.
I'll share my screen. Just a minute.
Ma'am, they wear their surgeon caps in their crowns with equal ease, huh?
Yes, I know.
Such a beautiful work-life balance, really.
I know. Where's your crown, yeah?
मेरे को क्राउन में ये सिर्फ टोपी पहना है मैम
किसने टोपी पहनाया है तुमको?
और इधर इतना डैज़ल है ना मैडम कि मैं चश्मा भी लेके बैठा हूँ. Too much glamour.
They have dazzling crowns. You have
Absolutely.
a dazzling
Archana, are you
crown.
ready? Should we?
Oh, yeah, mute on my. Is it visible?
It's visible.
Yeah.
And you're looking great. She's become so emotional. No, she's like that only.
Oh, ma'am, actually I've done audio visuals. I don't have.
Secret before you start. What is this with Mulund? All the divas come from there only.
I want to dream. I want to take in height. I also want to set my feet firmly on the ground, but I do not want to stop. Hello, everyone. My name is Dr. Archana Chaudhary, winner of Diadem Mrs. India 2020. I am a professional eye surgeon based in Mumbai. As an independent working woman, I always put significant value in finding the perfect balance in my daily life, one that enables me to commit to my professional responsibilities as a doctor, fulfill my duties to my family, as well as pursue my own growth, my fitness, and my own ambitions. I come from a defense background with my father, my husband, as well as my father-in-law being a part of Indian Navy and Air Force. I always have had a strong personality. My journey into the world of glamour began during my MBBS days, where I organized full-fledged fashion shows as well as participated in them. These events were huge hits then. Even now, as a professional, I'm still active in organizing and anchoring annual cultural shows for my doctor friends in my city. Last year in the lockdown, I also won a couple of dance shows held online. So, my very old lifestyle patterns have helped me in preparing for my pageant journey. Being a work-life balance enthusiast also allows me to set some time aside for my passion and do what makes me truly happy. I love to express myself through dancing, and I enjoy doing Bollywood fusion and contemporary style of dance. Yoga and daily workout has been a vital part of my fitness journey. I've also been going to high altitude treks since a few years now, and this is something that I look forward to. It is something that gives me the thrill and adventure that I seek in my life. So when I think retrospectively, what must have really helped me in winning the crown, I've always been very honest with myself, and this is something that I've always followed in my life. I like to start with small steps when it comes to setting goals. So these small steps are what help me to achieve new heights and achieve bigger and better goals. Moreover, these small achievements actually give me more joy and more happiness. My journey with Diadem Mrs. India has been wonderful and memorable experience, one that I will always cherish.
I found a love for me. Darling, just dive right in. Follow my lead. Well, I found a girl, beautiful and sweet.
My journey with Diadem Mrs. India has been a wonderful and memorable experience, the one that I always will cherish. Apart from being crowned as Miss India, I was also awarded as the winner of People's Choice Award, and another prize was the National Costume Round, where I showcased the theme that an Indian doctor fights COVID like a goddess, and I'm so glad that I was a part of it. Just being in the same room with all these beautiful and wonderful, strong women has been an accomplishment in itself. I made so many friends for life and I gained several new inspirations in life. Every woman was an inspiration. The bond that we shared, created by our mutual experiences as mothers and wives and professionals, will last forever with me. The best part of this was I just had to be myself and I had great fun in doing this.
Fabulous feel. I'm just feeling on top of the world right now. I can't define it in the words. It's a feeling that I waited for so many years.
I have been honored to represent my beloved country, India, at the international pageant this year. Here, I will not be Dr. Archana Chaudhary. I will be representing India. And I'm truly blessed and honored to have been given this opportunity. I'm also a jury and mentor at Mrs. Maharashtra 2021 beauty pageant to be held in Mumbai. Along with that, I was recently a showstopper at the India Fashion Runway Season 2 at ITC Maratha at Agra. And I will be a showstopper again at the Asian Couture Runway in August this year.
Mrs. India Legacy 2021.
I firmly believe that beauty comes with a purpose. To me, it is more than about physical attractiveness. It's about using the platform to become someone that can bring transformational changes to our society. In our country, menstrual health has been ignored too far too long. Menstrual awareness and management in India is one cause that is very close to my heart. And for the same, I have partnered with Masik Satya. It's an NGO that works to improve sanitation support, menstrual hygiene facilities for the underprivileged women in our country. To me, success is not what you achieved. It's not the number of medals or trophies on your desk, nor even it is your bank balance. It is the number of people you have touched, positively affected, and the number of people who are yours and will stand with you. I look forward to achieving a good amount of people who will stand and walk with me in this journey of life. This is me, Dr. Archana Chaudhary, and my journey from being an eye surgeon to Diadem Mrs. India 2020. It has been truly magical, and I'm ready to take on to the next challenge that life has in store for me.
Thank you.
Thank you, Archana. I was
Thank you,
feeling
ma'am.
left out without any headgear, so I went and bought my own Greek god look, Greek goddess look.
This is so nice, ma'am.
I know. So I'm not feeling so
Adding that
left out
glamour
now.
quotient.
So, ma'am, Archana said that she's a showstopper, but I can tell you there's no stopping her anymore. She's going to go there and make it happen. She's really an amazing journey.
Can you stop your screen share?
I can stop my screen share. I was just preparing it because we shouldn't.
This is
Just a minute. I will.
So that's it. We go on to the next participant, who is none other than our own Rajni. Rajni has featured last week also. And as you know her as a dancer, as a painter, but she has won 2 titles, one of Mrs. Mulund in 2016 and another one in 2021 of Mrs. India. And the good thing was that she went through all the finals and semi-finals, finals, all the rounds, and she has finally won. So it is a great achievement for her. Let's see her journey too.
Hello everyone. I would like to thank Ragini ma'am.
I will share it from my screen, ma'am.
Yeah, you do.
Okay.
Can you hear me?
Just a second.
Yes, we can hear you.
Yes, ma'am. I'm just putting it on. Okay. Can we see my screen?
Yes, we can.
Okay.
Okay, you're playing it? Can you rewind this, Nikhil? We can't hear.
Can't hear?
Can't hear. Can you rewind it and play it again? I would like to speak after you.
Nikhil, start from the beginning, and the audio is not this. Remove your headphones or.
I'm not on headphones.
Don't unmute.
I am not on anything.
Don't.
I am not unmute. Everything is on, ma'am.
Okay. Why can't we?
You can't hear the video at all?
No, we can't.
Sorry, I missed the last part of Rajni.
No, she's getting.
I will start it again. Everything is on, ma'am. Everything is on.
Volume.
In the screen sharing, there is one more mute and unmute. Audio.
Okay.
Stop screen sharing.
Okay, I'm just starting it again, ma'am. Just see. Yeah. Can we hear it? Yes? No?
Can't hear.
Let me hear. I'm sorry. I'll do it again. I can hear it very loud. Anything I should do here? I'm hearing it very loud. Optimize for video clip, share sound. Okay. I'm starting it one more time. Just check, ma'am.
Yes, we can hear now.
Another star, you fade away. Afraid our aim is out of sight. Wanna see you alive. Where are you now? Where are you now? Where are you now? Was it all in my fantasy?
I don't know. That's all we have.
You were the shadow to my light. Did you feel us? Another star, you fade away. Afraid our aim is out of sight. Wanna see us alive. Where are you now? Where are you now? Where are you now? Was it all in my fantasy? Where are
Okay, I think, ma'am, that's all that we have.
Nikhil, I'll try to play from my side. You
Yeah,
can go
because I
ahead
think
with.
the videos come half. We'll go ahead with the next one.
Okay, you can go ahead. I'll try to play it from my side.
Yes, please. Ma'am. Karomi, ma'am. So this was about Rajni. Rajni is having coffee in one hand and confidence in the other.
Yes.
She's actually in Kamched right now. So she's having some issues transferring her files. So she is going to try again. I apologize for that. We will try one more time. Ma'am, let's move on to the next speaker. Dr. Reshma.
Dr. Reshma. Yes, our very own Reshma from Juhu, practicing anterior segment surgeon, and recently won her title. Come, let's see her journey from glam, from de-glam to glam. No, she was
Ma'am,
always.
for Reshma, she's so easy with all this glamour and style and everything. It's just like, let me adjust my crown and get the day started. So it's as simple as that, you know. Natural born talented. So Reshma, all yours.
Thank you so much. Thank you, Ragini ma'am. Thank you, Karobi ma'am. Thank you, everybody, for this platform. And Nikhil, are you going to show this? So again, we have just put up a video. So I would be showing that first. And Nikhil, are you doing it from your end?
You can share it from your end. If you can't, then I'll do it. Yes.
Okay.
I've got Reshma's with me, so I can do it also.
Yeah, ma'am, please.
Reshma, are you trying first?
Yes, ma'am.
Okay.
India records 46,951 cases and 212 deaths in a matter of 24 hours.
Let's quickly take you through the overall numbers of coronavirus cases across the country. 14,792 as of this minute.
Hi, I'm Dr. Reshma Javeri, a 45-year-old ophthalmologist from Mumbai. In school, I was a very average student with an inferiority complex. But my family believed in me, and it was my mother's vision to see me become a doctor. As I pursued medicine, I found self-belief. I am bold, brave, confident, and dream of a world that celebrates a woman who gives birth to a voice the same way she gives birth to a child. The support of my husband and 2 children ensured that I never stopped chasing my dreams of becoming an eye surgeon. Free eye checkup camps and surgeries for the underprivileged followed. I felt a sense of serving the people of my country. Until now, it has been a beautiful balance between professional and personal life. Traveling with my family or dancing with my daughter has been my greatest passion. The word vision has become an integral word in every context of my life. I am really grateful to Mrs. India World and Mrs. Mohini Sharma for this prestigious platform where I can enhance people's vision and transform lives.
One, two, and three. I'm just demonstrating, okay?
जिंदगी का ये खड़ाने एक सांस में चढ़ाने हिचकियों में क्या है मरना पूरा मर
Congratulations, ladies, for making it so far. You all are now the semi-finalists, and the aim is to get the crown back to our country. I am super excited to see you all on the 23rd of January at the finale, and I can't wait to see who gets crowned that night. So once again, ladies, congratulations. And
आप हैं हमारी top 20 Mrs. India Inc. Mrs. India World 2021 powered by the President Daman finalists.
Good evening, judges. My name is Dr. Reshma Javeri, number 22. Thank you.
Merry Christmas. Could you please go ahead and ask a question?
Hello, so do you believe that India is ready for modern concepts of homosexuality, live-in relationships and divorce?
Thank you so much for that question, ma'am. I believe that India has a culture and a tradition that we have been following for years from now. But with being a 21st century modern contemporary woman, I believe that we definitely need to have a more broader perspective and accept all forms of, it is a form of love, it is a form of recognizing each other as a partner, and I would definitely think there is no problem with that. Thank you so much.
Beyond giving agency. Any guesses? Contestant number 22.
Reshma has recently participated in international pageants, if I'm not mistaken. Mrs. India, yes or no?
Thank you so much for
Wow,
patiently.
Reshma, that was really something. What grace and confidence you were walking with. I mean,
So much, ma'am.
it was magical. Very nice. Congratulations to all of you who have won titles. And Nikhil, do you have anything to say regarding the ramp walk and the general performance?
So thoroughly enjoying this session. That's the first thing I want to say. And these women are so confident, the grace and poise with which she did the whole thing. And like she said, perseverance can help you achieve your dreams. That's what she said in the end. We all need to learn so much from that. So much, really.
And it's not a question of being skinny or, having the perfect figure. It's actually a balance between your attitude, your poise, your attitude, the way you walk, the way you talk, how you project yourself, and also this how confident you are, while doing this. And that is what I feel I've seen in all these people who have been doing the ramp walk. And I'm so glad they are all ophthalmologists, because it just puts now Mulund was one and next is ophthalmologist.
And before we go ahead, I want to also say these are the divas walking the ramp, but the session before that, they had the real life inspiration stories. So we have Dr. Sunaina Malik ma'am here, Dr. Manjari ma'am here. Their stories were also so heart touching, I tell you.
I know.
Hats off to all of you, women power. Huh?
No, they really come through a very hard time, and
I think there's a lot to learn. We feel our plates are full. Like, as a man, I feel I'm earning money, I'm doing this, I'm snappy with my wife, but y'all are something else altogether. Ma'am is saying something.
Ragini, yes.
I agree with Karobi Ma, because, when we put this session together, it is not about them looking beautiful or them having some perfect figures. It is not about that. It is not superficial. I know each and every one of them personally. I've known them for many, many years. And what about them is that they are mothers. They're very hardworking. In the COVID lockdown, they've done all the housework. They've brought up children with their online classes. Each and everyone has children, grown-up children, families to look after. They've gone through the pains of their families. And like you said, it's not about thin or fat or anything. It's just about doing something so different from being a surgeon and yet excelling. And I think Karobima, it's our duty to give them a platform, because they have excelled in a field which is completely not theirs. This is not theirs. They are just like us, surgeons tying their hair back, crying with the patients, looking whether the vision is 6/6, looking after their children. And yet they chose a field which probably the COVID let them rethink that probably these were hidden desires, which they also wanted to. And I think every ophthalmologist is an artist that we have been seeing in one nice, beautiful group that Harshul runs. And you very well said that it's not about their external beauty or their figures, which of course they see. It was the hard work because they knew that in such a pageant, if they have to win, they have to have the particular credentials that such type of pageants cater to. So that's the hard work, I would say, because, and what you said is so correct, and I'm so emotional about all these things. And I'm so proud of our Mumbai and Maharashtra girls who have got such a huge platform at a national level. So, you are too good at putting things into word, and I'm overwhelmed.
No, and the thing is that the idea was yours. It was a perfectly novel idea, and it is something like which has to be given credibility. And we thank you for giving that credibility to all of them because, see, not many of us knew who have won pageants. But this also tells us that apart from ophthalmology, they are doing a lot more.
Can I just say something?
Yes, Sunaina madam.
As you said, beauty is not about being skinny or being fat or being the right size, There's nothing like the right size. It's within you. And it is about being comfortable in your own skin. I always tell my junior colleagues that when they ask me, hey, ma'am, how do you carry off this particular dress or wearing that thing? Or now my short hair, I love it.
Look at the glow on your face.
My beautician keeps telling me,
that speaks volumes,
I said, no, I've had long hair for long enough. I want this change. I want to be this way now. So you must have the confidence to carry it off. I think, and that's what all these girls have. Sujata, I'm so happy to see Sujata here today. I'm loving this, and I think y'all are inspiring me to try for Mrs. India next year.
Oh,
wow! And you'll win it also, I'm sure.
Definitely.
Madam, you'll definitely win.
Hands down. So, Gitan, ma'am, very true that though the two sessions were so different from each other, they're not different at all.
Yeah,
because it is all about strength, perseverance, hard work, and following your heart.
And willpower.
Willpower.
Absolutely.
Ma'am, I'll go on blabbering. Please take over, Karobi, ma'am.
No, there's one thing I want to say is that many a times you said that this could be something which was there in your mind, You wanted to become a diva, you wanted to win a title. But I'm sure they have gone through a lot of rigors where their family is concerned because sometimes we may be confident, but the family members are not confident. And to make them aware that there is some substance which I can project is one big feat that they have accomplished as women of today. Okay.
Ma'am, you Karobi ma'am, Gitanjali are divas. Absolute divas.
I'm next to you, one small diva.
Just to talk about that, my husband, every morning since the time I have joined this, he would wake up in the morning and he'll say, "Good morning, Queen. I can see you with that crown." And the support that I have received from them, it was really very nice.
I know it was mind over matter because he's instilled it into your head, and so he's a good husband. Okay, we move on to Sujata.
With me, no, madam. Yes. My wife says I'm only hasi ban. Tu has mat hasi ban kar degi tera.
No. A smile surgeon has to smile.
Reshma had just put on the chat box sometime back that she's ready with her presentation.
Yeah, Rajni ma'am, she'll come now. Yes, Rajni, please.
Rajni, sorry, Rajni.
Okay, I'm in Township, Lonavala now, and since there were a few internet issues, I asked Nikhil to play, but now I think I can play. Before starting my journey, I would like to thank BOA, Lahane sir, Ragini ma'am, Karobi ma'am, Nikhil for all your help, for giving me this platform to showcase my journey here today. I'm so thankful to everyone for the appreciation I keep receiving. And I believe that every one of us, I think all the women are indeed achievers and all of us are queens. some of us have had our crowns, some of them have an invisible crown. That is the only difference.
Well said, well said.
Thank you, ma'am. So I'll just start my screen sharing for my journey now.
You do that.
Can you all see it?
We can't hear it, Rajni.
We can't hear it, Rajni. We can see it.
You can't hear it, but you can see it?
Yes.
Yes, we can see it. If some call is coming in, just shut off that call.
It's saying unable to play audio while on call.
Okay, I think y'all can go ahead with the other contestants then, other participants. I'll play this once again sometime again now.
Okay.
Okay. So sorry for that.
No, it happens. These troubleshoots are
So
always
sorry
there.
for that. I'll try something.
We go over to Sujata.
Do it, Sujata.
Yes. Yes, Ragini was saying something.
Rajni, that she will be successful in troubleshooting.
Okay.
So
Yeah, go ahead, Nikhil.
with Dr. Sujata, I've seen her video and it's really, really touching. I feel the correct words for her are wear the crown, be the crown, own the crown. Sujata, you are the crown. That's what I felt.
Nikhil, that is true.
No,
Thank you so
well
much.
said.
Yeah.
Good evening, ma'am. Thanks, Nikhil, for those kind, wonderful words. They will be, engraved there in the heart and always remembered. I'll always cherish this. Thank you so much. Good evening, ma'am. Thank you, BOA, and thank you, Karobi ma'am and Ragini ma'am, Sunaina ma'am, Manjiri ma'am, and hi, all my other divas. Actually, I was just telling Ragini ma'am that we are the divas, the smaller versions, and you all are the bigger lights that spread so much of light to everyone's life. I'll run my video, and because as always, I guess I get the seniority. That's why I didn't take the time to make a video. So I'm just running the videos that I have and just compile them. I don't have a background score. I don't have any commentary running. So I would be sharing my incidents as and when the video is running. I hope that's okay with you all.
Sujata, before you start, a small introduction of yours. Sujata is an anterior segment from St. George's Hospital. She's a medical teacher for the last 20 years, which is very good to her credit. She's won many titles, that is with Mrs. Medico is in 2019. The recent one is Lokmat Women's Achievers Award in 2020. She has been sort of sought after by all the toothpaste companies. That is the Colgate Beautiful Smile in 2007, Pepsodent Mom in 2005. She loves to read books and she writes essays and poems, and her hobbies are listening to music. So over to you for your journey.
Thank you, ma'am. Yeah.
Can share your screen.
Yes. My journey is part of the girl next door. I have never dreamt of participating in any pageant. It was that crown that every father put. That's what I was. Thought of myself as a beauty material. I always wanted to be a doctor. The pageant happened by circumstance. I will continue this journey
Sujata, the
for the
voice is
Mrs. Medical.
breaking.
Sorry, ma'am?
Sujata, talk, but your voice is breaking. That's what madam is saying, but talk.
Oh, okay, ma'am. I'll let this video run through and then I will. It was for our fun round where we would perform a dance. The group had to actually have a choreography. Was my audition actually. The story is I had got and was running as an audition and I just went and gave the audition and I rushed back and I got called is that I was selected as all the friends, all of the officers, international stars, as came it and they were all there. And all of them have got some title or the other. And yes, my favorite sari round. I'm always so fond of them, and I always talk to Karuna about the saris that they always did. These were the top. We were the top five. The ex had us for a walk. This was on the day of the audition that I went. This is my journey from my apron to my crown. So I started with just participating in get-togethers and all that, and I got this call from China for walking for the KANSKI. So the golden symbol. I had never planned to walk the ramp, so I went retrograde actually. I first went and walked with professional models in NSCI with thousands and thousands of people watching me with no formal training, nothing, walking alongside the big stars. We had Malishka and all the actors and actresses and the topmost models walking alongside, all dressed up. And here I was introducing myself as a doctor working in a government hospital. Now that's a big thing that, for people to recognize a government hospital into the glamour, because I mean, we know, ma'am knows how they run through the OPDs and how they are dressed. So from that stage, for them to actually believe that someone is walking the ramp coming from a government medical college was something really noteworthy. And it has been such a great experience because I realized my potential only then that, yeah, actually, if you believe in it and if you want to do it, you can achieve what actually paid for my journey. So that led to the and medical they had selected for this privilege. So this was for the next Mrs. Medico because ours was the first one. So I was invited there for the second one. That's my... So that's all that I had to show and speak about. And I know, I mean, there isn't much of a... I think the only thing that came to my mind in participating is, a girl next door can also be a diva, a queen, if she so decides to. So nothing can stop you. I eat whatever Ragini ma'am knows. I enjoy eating pastas and pizzas and pani puris and everything. And the only thing my personal belief is like when we go for say amusement park, when we plan a journey, I'm the one who always says, let's go to the hardest, the most difficult right first. And my kids and my students and everything, why that first? Ma'am, let's go step by step. Let's go to the smaller ones and then go for the bigger ones. And I say, no, let's go to the bigger one. If once you've had that, the others will seem very easy and very simple. So I guess that's how I try to deal with if I get an opportunity. I don't look at it as a hurdle. I just say, okay, let's give it a try and see. If it works, I have so much more that I can tackle so many other things. But if it doesn't work, I have nothing to lose because I have got the experience and I can work on the smaller battles that I have to face. That's my general motto in life, and that's how I deal with any kind of task that comes my way. Yeah, that's it.
That indeed was something, Sujata. I mean, the thing is that you are the senior most amongst these.
Yes, ma'am. That's why I got the.
No, I mean it is creditable because the thing is that you have made it at this. You had the confidence to go ahead with it, and you made it to the top. So that is really something which we have to give a clap for. Really great.
And can I say something? Sujata, your answer to the final round question, I think you should tell now. It was fantastic. I mean, you won the contest, your beauty, everything, but that answer was the best part of your contest.
Thank you so much. I was very honored to have friends and colleagues from Pune. Of course, none of them knew that I was participating because I had just gone for fun. And my own colleagues who had worked with from BJ, even they didn't know that I was working there. I was walking the ramp here, and it was a pleasant surprise to have them there. And they were in support, and and we had contestants who were local Puneites, and they had the entire IMA supporting them. But I had my Oftal, who was very much there backing me up there. So the final question for the top 5, I was asked, people consider doctors as God. What was my take on it? And I answered that question in a way that we don't want to be called God. I mean, I can't frame it exactly the way I spoke then because it was all extempore. But the crux of it was that since people consider you as God, then they leave you no scope to make any mistakes. You can't. So they always. That's the reason the violent attacks and the expectations of public towards you is much more. So we want to be treated like humans. So humans can make mistakes. We always try our best to give our best treatment wise and from all aspects. But being a human, and the science can't give solutions to everything. Like as we realized in this COVID times also, that we've done all the possible efforts to try and treat patients, but sometimes we are successful and sometimes we aren't. So kindly treat us like human beings and not as God. डॉक्टर देव नसतो, डॉक्टर हा एक माणूसच असतो, त्यालाही भावना असतात, त्यालाही फिलिंग्स असतात. So and of course they're very empathetic and they also feel touched by patients' pain, and even they don't sleep when they have bad success in their own cases. That's what was my last.
Great.
Ma'am,
sorry, yeah.
Congratulations, Sujata. I know you for so many years, more than 25 years, since the time you gave your MS exams, and it has been a wonderful, wonderful, wonderful journey.
Thank you, ma'am. You've been part of my ups and downs of my journey, and you've seen it all.
I have just got the video from Rajni, but the thing is that...
Ma'am, I have it. If you want, I could try to share it now. I've downloaded it again. Shall I try it, ma'am?
Yeah, please try it.
We have time, right?
Yeah, we have time.
Thank you. Thank you so much.
Okay, I'm just trying. Just tell me if it works, please. You're able to see it?
The shadow to my light, did you feel us? Another star, you fade away. Afraid our aim is out of sight. Wanna see us alive. Where are you now?
You can't go back and change the beginning, but you can start where you are and change the ending. Namaskaram, Kochi. Ningale Kandadil Santosham. I am Dr. Rajnima Shilkar, an eye surgeon by profession, living in the city of dreams, Mumbai. So representing my beautiful Maharashtra. 40 years of my trip around the sun has taught me to be assertive about my ideality and to be larger than life itself. My goal in life is to pull everything that I do with charm and conviction. Through this contest, I believe I can inspire many other women, which in turn will get them empowered. So, standing in front of eminent personalities, today I wish to not only win this crown, but also the hearts of all you people sitting here. Thank you so much. Have a wonderful evening.
She's just a girl and she's on fire, hotter than a fantasy, lonely like a highway. She's living in a world and it's on fire, filled with catastrophe, but she knows she can fly away. Oh, she got both feet on the ground and she's burning it down. Oh, she got her head in the clouds and she's not backing down. This girl is on fire. This girl is on fire. She's walking on fire. This girl is on fire. Looks like a girl, but she's a flame. So bright she can burn your eyes. Better look the other way. You can try, but you'll never forget her name. She's on top of the world, hottest of the hottest girls. Say, oh, we got our feet on the ground and we're burning it down. Oh, got our head in the clouds and we're not coming down. This girl is on fire. This girl is on fire. She's walking on fire. This girl is on fire. Everybody stares as she goes by, 'cause they can see the flame that's in her eyes. Watch her as she's lighting up the night. Nobody knows that she's a lonely girl, and it's a lonely world. But she gon' let it burn, baby, burn, baby. This girl is on fire. This girl is on fire. She's walking on fire. This girl is on fire. She's just a girl, but she's on fire. She's just a girl and she's on fire, hotter than a fantasy, lonely like a highway. She's living in a world and it's on fire. catastrophe, but she knows she can fly away. Oh, she got both feet on the ground and she's burning it down. Oh, she got her head in the clouds and she's not backing down. This girl is on fire. This girl is on fire. She's walking on fire. This girl is on fire. Looks like a girl, but she's a flame. So bright she can burn your eyes. Better look the other way. You can try, but you'll never forget her name.
My
This
God.
is this is perseverance.
Amazing.
This is perseverance. I knew. I told her she could do it.
Yes, she proved it. But what an amazing kind of it's that sureness, confidence, the way you ramp walked, and your eyes spoke volumes, you know, when you were answering. It was too beautiful, Rajni. We loved
Thank
seeing
you
it.
so much, ma'am.
Thank goodness the video ran.
It worked.
Thank you very much.
Okay,
So
now
well done, Rajni. So well done.
Thank you very much, ma'am. Thank you so much.
Nikhil, I think you're dying to say something.
I'm saying, ma'am, ये सब तो जलवा देख लिया. You have something to show us.
Yes,
Something, some
I have.
trick up your
Okay,
sleeve.
I'll just yes.
So Rajni's things was that one of her co-contestant had a eye problem and she helped her also. So she kept the competition aside and did that. That was really.
Okay, now who
Yep.
do you see on the screen? Can you see my screen?
Yes.
Yes, you see my Goldie Baba. He's my little cat boy. Okay. Now the thing is that he was also watching. He's sitting here and he's watching the Diva program, and he's very impressed by the Diva program. You know. So, but he told me a secret. So I have to share the secret with you. He said that, Mama, it is fine that they are doing beautiful ramp walk, but then you must teach them how to catwalk because cats walk the best. So I told him, okay, have you done it? He says, no, but my friends have. I'm a male cat, I don't catwalk, but my friends have. So I said, okay. So he said, I'll show you a video of my friends who will catwalk and show it to your friends also. So I'm going to show you a video of actual catwalk. So in your grooming lessons, you'll learn from these cats.
Yo, raise up the walk, light it up to the beat. Come on, जलवा जिस्मों का है ये जलवा, जिस्मों का है ये जलवा, शोहरत भी दे ये जलवा, मकसद भी दे ये जलवा, दिलकश लगे ये जलवा, दिलकश लगे ये जलवा, नशा ही नशा ये जलवा, मजा ही मजा.
Okay. So this
Ma'am.
was the secret.
Ma'am, don't be so catty. Yeah.
Oh my God. Nikhil, why don't you just go and take a cat nap afterwards?
How can I? No, my eyes are wide open, ma'am. I can't take a nap now.
Then I'll give you some catnip so that you can go to sleep after the program. You know something? One of my friends, he got hit by a catapult today.
Really? And then what happened, ma'am?
He developed a cataract.
So we should operate him, ma'am. Send him to me for cataract surgery.
Now, you don't get catatonic at the thought of a cataract, okay? Just chill and enjoy the program. Now, enough of cat talk.
Okay, ma'am. Okay, ma'am.
Okay.
That banter was superb. It was too good.
Karogi ma'am's brainchild.
Okay. So now we are on to something more interesting. We've seen all these 4 divas, they have ramped walk for us. But now is there a round of questions, and those questions are going to be asked by none other than Nikhil Nasta.
No, ma'am, you're going to ask the questions. You're going to ask the questions.
See, all 4 of them will be given 3 questions. We have a list of 12 questions, which are going to be, I'm going to ask you to pick up a number. So whichever number you pick up, Nikhil will ask you the question, and you have to give a quick round of answers, right?
Okay, it's a rapid fire. It's got to be quick. Okay, we are running out of time also.
Right. And the thing is that after that, there'll be one question for all of you, and whichever is the best answer, Ragini is going to be the judge, and she's going to crown that person the super crown.
Okay, so all 4 contestants unmuted, and let's start with Archana. Anything between 1 to 12. What's your number?
9.
9. Okay, 9 your lucky number. So you're hosting a live show. You're performing at a live show. Would you rather sing? Would you rather dance? Or would you rather speak something?
I'll start. I think I'll dance.
I knew she would say that.
Shuffling.
Okay,
all right. Moving on. Rajni, what number are you selecting? 9 is gone. Okay, Rajni is still. Sujata, please. What number?
3.
3.
Sorry. 3. Okay, 3. So the question on 3 is what irritates you the most? Loud people, messy food, or unpunctuality?
Loud people.
Loud people. Okay, well done. Now Reshma, any number? 1 to 12.
7.
Sorry?
7.
7. Okay. So the question for 7 is, what's your dream car? A Ferrari, a Mercedes, or a BMW?
Can I get all of them?
All of them. That's nice. That's lovely.
Don't be greedy.
I told you now they want to say I want all of it. So
yeah.
Fine. Okay. Now coming back to Archana again. So
Rajni has not come back again?
I think she's losing network. So we'll just make it very fast. We're running out of time now. Right. So Archana.
Yes.
Choose a number again.
Okay, 1.
1. Okay, number 1. What extreme sport would be the one that you would love to try? Paragliding, bungee jumping, or scuba diving?
So I have done scuba diving. I think paragliding, and what is the third one? Sorry?
Bungee jumping.
Yeah, I would love to try. I've done paragliding also. I would love to try bungee jumping right.
Good.
Okay, excellent. So Sujata, what about you?
I'll push you over.
Number 6. Number 6. Okay.
Sorry. This is fun.
This is fun. Okay, thank you. So Sujata, your question is. Yes. What
makes you cry? Okay. Is it a love drama, not getting what you want, or sex?
Love, ma'am, love. Love has the answer to everything. All kinds of emotions can be expressed just by
No
love.
explanations, only answers.
Come on, Reshma, what's your question number?
2.
2. Okay, the question number 2 is, what color would you like to wear on a girl's night out? Would it be black, red, or blue?
Red. I'm a total red person.
Red. Okay. Great. Rajni's back. We'll ask her 2 questions. Rajni, pick a number.
3.
3's gone.
3's gone. Okay. I'll give you 4. Okay. You're going for a friend's trip. Would you go to the mountains? Would you go to the beaches? Or would you take them to your ancestral home in your village?
To the beaches.
Beaches. All right. And you'll walk the... Okay. One more number for you. One more question you missed, Rajni. One more number you gotta pick.
Okay. So 6.
No, choose 5.
She's picking both side numbers.
Okay, so 5. You and your best friend disagree on something. What are you going to do? Will you ignore? Will you confront? Will you compromise?
I'll confront and compromise.
Okay, not bad. So the last questions now for everybody, starting with Archana.
Yes. It's for everyone.
No. There's one last round.
Okay.
Now you ask the question, they've forgotten the numbers.
Chalo, so I'll ask you.
Yeah.
Who do you run to for advice? Friends, family, or blogs?
Family. Family.
Okay, okay. Coming to Dr. Sujata, you have to convince someone to do something for you. So will you bribe them with gifts? Will you exchange the favor with them? Or will you threaten them till they have to agree to you?
Exchange a favor.
Perfect. And Reshma, your question is, someone cut ahead of you in line. Will you push them? Will you fire them? Or will you politely request them to go back in line?
I would politely request them, for sure.
Perfect, perfect. And the last question for Rajni is, it's your self-pampering day. You want to go to the spa, you want to get a makeover, or you want to be in bed with chocolate?
Or with something else.
Be in bed having
Chocolate and chocolate.
Be in bed having chocolates.
Perfect, perfect, perfect. And ma'am, the last question which will crown them.
Yeah. Now this is a hypothetical question because obviously you all have all won titles and your husbands have all agreed to send you all. But suppose say you wanted to do this desperately and your husband was unhappy allowing you to go for the Diva show. What would you do? Would you go or would you not go? And why? And Ragini, you hear properly because you're going to crown.
So you all can raise your hands and answer. Huh?
Yeah.
Archana first.
Who's me? Who's answering?
Yeah, Sujata, go ahead.
Ma'am, actually, this is a real life story for me. My husband actually wasn't very keen, but I so believe that I wanted to test myself and see how it was. I did convince him, and I did manage to convince him. He wasn't keen initially. He said, "If you want to do it, I will not stop you," but I'm not too keen on that. Basically, he being into a public figure, so it was a little difficult for him to accept the fact that I'm going to get into the glamour side of it. But yes, I did manage to convince my entire family and I went for it. And the first person who actually congratulated me was him. He was on top of the world and he was so happy to have let me live my dream and achieve it too.
So all's well that ends well.
Yes, ma'am.
Right? Now, okay, Archana, what about you?
Yes, ma'am. My husband has supported me totally for this. And my children also have supported me and they've pushed me into it. My in-laws had a little problem. My husband, in fact, has even convinced them to do it. But in case the question is, hello, am I audible?
Yes.
So in case the question is that if he wouldn't have agreed, I wouldn't have gone because this is not the end of the story and my family comes first, whatever it is. My family always comes first.
Reshma, you?
Yes, ma'am. So even my husband was very supportive, but in case it was an option for me, I would still would want to go. I would have gone because I think this whole platform was a lot about not only my own self and making me better, but if I believe, I just thought that, if I'm going to be happy, I'll keep people happy around me. And also it was a lot about collecting money for the cancer patients. If I was a participant in it, not that I couldn't do otherwise, but this really motivated me doing this. So I think I would have convinced him at the end of it and he would have let me go eventually.
You, Rajni.
Okay, so my husband had been very supportive in the entire journey. But in case if he wouldn't have been supportive, I would have convinced him like anything. In fact, I would have taken him all along, shown him that these pageants are not objectifying or subjectifying women. In fact, they are a platform to step up women, and not only women, but many other people around. So definitely it's a great platform when they see their own spouses, representing their state and now representing India. So I think I would have convinced him.
Would it involve using any vials to cajole him?
Chocolate, she said it before.
Chocolates and well. Okay, where's Ragini? Ragini, you have to declare the winner.
I have disappeared because, ma'am, this whole thing was so close to my heart from the time they won.
Yeah.
For me, they are all winners. For me, you, me, Manjari, all of us are winners. The first step outside your comfort zone is winning. So I think all of us here are wrong. I mean, we will not be able to decide amongst these four because I'm so glad that they got the platform. I know that, you know, they are wonderful. Each of them is different and so similar to each other, so similar to us. And they live the lives that all of us do. But the first step outside their comfort zone was the crown.
Crown. Very well said. So all four of you are winners.
And they are inspiration to many others.
Definitely, definitely. Now let's move on. We go over now to Mridula Bhave. Mridula is expert. She is just a moment. She's going to talk about diet and nutrition today. She has her own NutriChef enterprises, which she's established, and she's customizing healthy food solutions for the last 5 years. She's a consultant phaco-refractive surgeon from Lakshmi Eye Institute, and her hobbies involve trekking, scuba diving. So I wish she was in that round, so she would have picked up scuba diving.
Yes, ma'am.
So Mridula ma'am is talking about calories to curves. So let me tell you, the best curves on anyone's body is a smile, right? It straightens a lot of things. So that's definitely going to be there, and they'll smile when their calories are in control, as she will tell us how. And I feel, you know, it's I wish mosquitoes could, instead of sucking blood, suck out calories. तो रात को मैं थोड़ा सा पतला हो जाता था रोज.
You don't become like you already are enough. They should come and bite us then, you know.
Fine. So Mridula ma'am, over to you.
This is a typical
Thank
smile
you.
surgeon speaking.
Thank you so much. Thank you so much to the organizers, BOA, Karubi ma'am, Ragini ma'am, Nikhil, for having invited me here. And after attending all the talks since evening, Manjari ma'am, I heard Dr. Cyrus Mehta, Archana, Rajini, I know them so close. They're so close to me. Sujata and Reshma, I've never met, but it's been so inspiring to hear your story and see you walk through the glamour world. Absolutely.
It's
I'm
wonderful
bowled
to
over.
have you, Mridula, and it's so good to see you again after the lockdown and such a long time. And I remember us going together on a trip, and it's been so long. I think we should do all this again.
Yes, ma'am.
Way to go,
Definitely.
Mridula.
Thank you, ma'am. Thank you so much. I'll share my screen.
Yes, please do.
So,
So before Mridula starts, I have a message from Dr. Goyal sir that Dr. Nikhil is the only Krishna among all the gopis. He said, please share this message.
He messaged me also, ma'am, and that privilege, I'm thoroughly enjoying it. Huh? Thank you, ma'am, for having me here.
This is thank you to Goyal sir.
Thank you.
I'll proceed.
Yes, proceed.
Is the audio it's audible?
Yes.
You might want to remove your headphones. We can't hear your presentation. Your headphones, you'll have to remove your headphones. Yeah, no, your headphones, put it on computer audio.
Was made not only delicious, but also healthy.
Start from the beginning.
Balanced, packed attractively.
Remove your headphones. Mridula, remove your headphones. We can't hear anything. Yes. You are audible. This is not.
There will be a button on top where your screen sharing is to share audio and to optimize video. You'll have to click on that. Right on top, where the screen sharing is now. You want me to share it? Should I share it for you? Okay, I'll share. Ma'am, can I share it for her?
Yes, yes. Even I have it, so if you don't get it, I'll do it.
Okay, I have it right here.
1st July 2017, Doctor's Day, saw the dreams of one doctor becoming reality when her startup, Nutrition Enterprises, came into existence. Her dream of venturing into the food industry arose from her passion for outdoor activities like trekking, scuba diving, high altitude mountaineering, paragliding, and many, many more. Food was the link between her knowledge of medicine and fitness. The journey of creative innovations thus began, where food was made not only delicious but also healthy, nutritionally balanced, packed attractively, and home delivered to the client's doorstep. Ably supporting in this endeavor are her friends, well wishers, and staff who share the same vision of serving health on a platter. Over the last 2 years, we've conducted various activities like the recipe competitions, workshops on central obesity, osteoporosis, and achieved targets in terms of better blood sugar level controls, weight loss, better HbA1c levels, and better lipid profiles. The journey is long with challenges to face, obstacles to overcome, and more dreams to chase.
Wow, Mridula, I need you desperately.
Do we have time for the presentation?
Yes, yes, go ahead.
Anytime, ma'am. Do we have time for the
Yes,
presentation?
yes, go ahead with your presentation.
Visible?
You are visible.
The presentation is not visible?
No.
One second. Yeah?
Yeah, now it's visible.
Okay. So, good evening. And as we walk through this journey of calories for curves, let us first understand that nutrition, as we all know, plays a vital role in our appearance. And that's the reason why this talk has been included in today's uh, evening talk. Why is this not moving?
It's not advancing?
It's not advancing. I'll use the.
Yeah, just use the cursor.
I'll use this. Okay.
Yeah.
We as ophthalmologists are sedentary workers, and as the first wave, the second wave of this pandemic has further added to the limitations of physical activity, we have started noticing these tires around our abdomen. The first thought that comes to our mind is to lose weight. Weight, I think, is the most overrated parameter of health. Having a healthy lifestyle should be the goal. Being active should be the goal. And weight will fall in place. Our body structures are genetically predetermined to be either ectomorphic, mesomorphic, or endomorphic. For example, Sonakshi Sinha is an ectomorph, while Alia Bhatt is an endomorph. So if Sonakshi decides to lose even half her weight, she can never become Alia Bhatt. So we need to focus on health. And if we focus on health, then getting this hourglass appearance of our waist will come as a byproduct. Getting our weight into its target will come as a byproduct. Weight should be appropriate for age and our genetic makeup. It should be compatible with our metabolic setup, your HbA1c levels, your glucose tolerance, your blood pressure, your lipid profiles, your hemoglobin. And that's the reason there is no role for a crash diet. And finally, weight should be something which is acceptable to be you. It should not let you be on a perpetual diet and not feel the need to go on a crash diet. So, talking about our plate, let us understand we all know that our plate should be half full of vegetables which are non starchy, one fourth with lean proteins, and one fourth with healthy carbs. Let's dissect each one at a time. Coming of talking about carbs, say no to simple carbs, say no to sugars, but complex carbs is something that we should incorporate in our diet. They could be in the forms of various uh, like maize, it could be corn, it could be jowar, it could be ragi, it could be the root vegetables like sweet potato, it could be the starchy vegetables like the raw banana. Now, these complex carbohydrates will keep us filled for a long time and will cause slow release of sugars. Talking about proteins, we have proteins coming from different sources. It could be dairy, it could be poultry, there are legumes, there are pulses, there is tofu, there is soya, there is eggs. Now, what is important is we have a mix of different proteins in our diet so as to be so that all the essential amino acids become available to us. It is very important to have your meal plan in place right from breakfast. For example, uh, a South Indian breakfast is the most ideal. The idli or the dosa batter itself has got 30% of proteins and 60% carbs. Had it along with the sambar, and you are having your pumpkin, there is your drumstick, which is giving you the micronutrients and the fiber. So, if you have had maybe an omelette and a paratha for breakfast, maybe for the lunch, you could include a jowar roti and a soya because your proteins in the morning have been from eggs. For lunch, you can have soya or you could have paneer. For the night, you may have a dal chawal, so your carbs are coming from rice. So you rotate all your pulses, all your legumes, and in addition to that, you also rotate the vegetables. Now, this is very important to eat the rainbow. As refractive surgeons, we are used to the warm and the hot colors. So we have a variety of colored vegetables and fruits. Incorporating them into our daily diet will not only provide vitamins, which are vital, but also the essential macronutrients as well as the micronutrients. For example, moving from yellow to red, we have the carotenoids, the lutein, and the zeaxanthin, which are ample supply of vitamin C in most of the citrus fruits. The greens are rich in iron. The, the violets and the blues and the dark reds have anthocyanin, which is an anti-malignancy antioxidant. The whites, the radish, the cauliflower, although not very colorful, but have isoflavonoids, they have the capacity of having an anti-inflammatory effect. Fortified foods are very important to me because I use them left, right, and center when we have to customize meals, like adding a palak puree or a beet puree to a dosa batter will not only enhance its nutrient contents as far as iron is concerned, it will also increase the fiber. You could add pomegranates to your salad, or you could add moong sprouts as a garnish over your upma. You could add corn, cauliflower, green peas, and carrot into your upma, thus increasing its fiber content. And along with the upma, maybe you could have a soy milk, so your proteins are also taken care of. Hence, food fortification is the need which we all need to consciously look into our diet. Coming to certain processes, steaming is one of the best type of uh, method of cooking as compared to boiling. In boiling, we are losing out on all the micronutrients. As against this, steaming is going to preserve the micronutrients and develop certain habits very consciously, like a simple habit of eating slowly and chewing your food well will reduce your calorie intake up to 10%. And as Nikhil said, not worried about the parabolic curve around your waist, but the only curve that matters is your smile, because that is what will show to the world how happy you are from within. That is what is going to give you the glow on your face, and that radiant smile is going to take you forward. Thank you.
That
That
was
was
fantastic, yes. And Mridula, as I said before, I really need you.
Anytime, ma'am. Anytime, ma'am. I'm
Over to
always
you.
available.
That was really, really nice. And now we have they have workshops for us on ramp walk, style etiquette, how to eat, and things like that. So the first one is about walk. Rajni is going to tell us about how to walk with confidence. Ma'am, they say that when you walk in a room, na, you walk like you own the room because that creates a first impression. It introduces you even before you open your mouth and speak. So it's all about the walk, I think. So Rajni is going to show us how to walk the talk. Are we sharing the
It's your
screen?
persona which
Sorry, ma'am.
shows. It's your persona which shows in your work.
Yes, ma'am, absolutely. So she's teaching us how to
Absolutely.
walk talk. I'll be sharing screen.
Hello, everyone.
I
Today
hope it
I'll
helps
teach you
everybody.
how to walk on the ramp just like a model. So, there are mainly two types of ramp walks, the pageant ramp walk and the runway ramp walk. We won't be getting into the details of the runway ramp walk. In any ramp walk, always practice walking on a straight line. You can do your poses and walk back on that straight line. Always keep your stance one leg in front and the other leg at 2:30 p.m. This is a ramp showing the mid ramp and the head ramp. This is the pageant walk I'm showing y'all, which is more graceful, elegant. We look at the audience, have an eye contact, give a pose at the head ramp, wait for 5 seconds, look at the audience, twirl back. While going back, you can wait at the mid ramp, look back, take a half turn, go back to your original place. This is a twirl which I'm showing you once again. This is my footwork of half turn and double half turn.
You'll have to rewind it, Nikhil.
I'm showing you
Rewind.
hand ramp
Rewind,
poses.
rewind. Yeah.
This is my footwork of half turn and double half turn.
You have to go back.
I'm
Move
showing
back.
you
Yeah,
hand
this is from
ramp.
half. This is
This
half.
is
You
a
have to go
twirl
back,
which
go
I'm showing
back,
you once again.
go back.
Have an eye contact,
This is all I
just like a
have.
model.
Yeah, it starts from
There are mainly two types
first.
of
Yeah.
ramp. Pageant
Yeah.
ramp walk
Just
and the
rewind it a
runway
little.
ramp. We
Rewind it
won't
a
be
little.
getting into the details. Hello everyone. Today I'll be teaching you how to walk on the ramp just like a model. So there are mainly two types of ramp walks, the pageant ramp walk and the runway ramp walk. We won't be getting into the details of the runway ramp walk. In any ramp walk, always practice walking on a straight line. You can do your poses and walk back on that straight line. Always keep your stance one leg in front and the other leg at 2:30 p.m. This is a ramp showing the mid ramp and the head ramp. This is the pageant walk I'm showing y'all, which is more graceful, elegant. We look at the audience, have an eye contact, give a pose at the head ramp, wait for 5 seconds, look at the audience, twirl back. While going back, you can wait at the mid ramp, look back, take a half turn, go back to your original place. This is a twirl which I'm showing you once again. This is my footwork of half turn and double half turn. Here I'm showing you hand ramp poses. Unless you practice these poses, sometimes you can just land up into very awkward poses. So this is one thing you all should practice. Another pose here. Now you can also look over the shoulder. It depends upon which side your hair is. If your hair is on one particular side, look over the other shoulder. These are some right and wrong head ramp poses. Now, in a casual round ramp walk, you have to be more energetic, more peppy. You can show your naughtier side, of course. A twirl is almost a must here. Look back at the audience. Now this is the two half turns which I showed you all. Now how can this ramp walk help you in your everyday walk? Even your everyday walk can be really graceful once you learn how to ramp walk. This is how it is. This is the practice of ramp walk. You go 1, 2, 3 and turn. You go 1, 2 and turn. You go 1, turn. You go 1 and turn again. These are more head ramp poses which I'm showing you all. This is a ramp walk which I'm showing, which you can do when your outfit is long and flowy, like this. It looks beautiful. Now for you to be comfortable on those high heels, you have to practice well and good enough on these high heels. You can do something like this, just turn and turn and turn on high heels so that you're comfortable enough.
Okay, I'm sorry, you couldn't see that? We couldn't see it?
We could see only the last two pictures are missing. It's okay.
Because ma'am, I couldn't take your call. I was wondering if, you know.
No, the last two pictures are missing. It's okay.
I was
no
not
problem.
calling you up, Nikhil.
I got a lot of missed calls.
Oh, I
Okay, ma'am. Let's move ahead,
don't wanted
ma'am.
to talk to you.
Okay, so Rajni, thanks for teaching us how to walk. Now the only walk I do now in lockdown is walk from couch to fridge, fridge to couch, and that's the only walk I do. Now I'll walk as a half twirl, full twirl karke I'll go there.
I don't walk, I roll. I roll from bed to bathroom and bathroom to bed.
I just hope that this tutorial is of help to others. That's the only thing.
I know we can't manage it with the normal footwear. Forget the 5 inches.
Ma'am, moving
Okay,
on, who do
move
we have
over.
next, ma'am?
Move over to Reshma. She's going to talk to us about eating and sitting etiquette.
So she's telling us something about body language. Body language affects not only how others see us, but sometimes it also changes the way we see our own selves. So over to Reshma.
Thank you so much, Nikhil, and that's so true. I think so many times we don't realize how we sit and how we are eating, and when we are in a group, we just kind of need to be aware of some things. It's a very short video. I'll try and screen share right now. Just one second.
Hi, my name is Dr. Reshma Javedi, and today in this video, I'm going to show you different ways how to sit. And I was running far away, would I run off the world someday? Nobody knows. And I was dancing in the rain, I felt alive and I can't complain. But no, take me home where I belong. I can't take it anymore. I'll show you some table etiquette. If you wanna run away with me, I know a galaxy and I can take you for a ride. I had a premonition that we fell into a rhythm where the music don't stop for life. Glitter in the sky, glitter in my eyes, shining just the way you like. If you're feeling like you need a little bit of company, you met me at the perfect time. You want me, I want you, baby. My sugar boo, I'm levitating. The Milky Way, we're renegading. Yeah, 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 yeah. I got you, moonlight, you're my starlight. I need you all night. Come on, dance with me. I'm levitating. You, moonlight, you're my starlight. I need you all night. Come on, dance with me. I'm levitating.
energy, I see it's written in the stars. We can go wherever, so let's do it now or never, baby. Nothing's ever too far. Glitter in the sky, glitter in our eyes, shining just the way we are. I feel like we're forever every time we get together, but whatever, let's get lost on Mars. You want me, I want you, baby. My sugar boo.
Yeah.
My God.
Just very few, but
You taught us so many nice things and you did it so nicely.
thank you so much, ma'am.
I have lots to learn from this because I to eat, just हाथ से anyhow. That's how I eat. So मेरे को तो सीखना पड़ेगा अलग से.
Okay. And then we move on to who's left now?
The last talk of today is Dr. Archana, and she's coming to us with makeup, a tutorial on that. So makeup na, actually, now we have filters. Filters are all great. They fix things in a jiffy, but great makeup is even better. So Archana is going to teach how to do makeup.
Yes, so this is an everyday wear makeup, and I'm sharing the screen. Again, it's an audio visual, so I won't be talking. It's visible, ma'am?
Yes, it's visible.
Okay. We will be doing
Yes, visible.
on everyday wear
Visible,
makeup,
audible.
especially for the working women. So as we have less time in the morning, I call this makeup as wake up and makeup. So there are do's and don'ts. We'll talk about the do's. Cleansing the face, toning, moisturizing, and then priming the face. The next do's in the makeup would be that first we start any makeup from the eyebrows to the eyes, then to the face, and lastly to the lips. And the don'ts would be that we do not use, since it is an everyday wear makeup, we do not use any loud colors like the reds and the maroons. We usually go with our skin tone, that is the Indian skin tone, the nudes, the eyebrows now, and this is the MAC eye pencil, and it has a brush. So first I will be brushing my eyebrows upwards like this, and then with the other end that has a color, I will be giving some shape to my eyebrows and filling in the color. I'm going to be putting some eyeshadow on my eyes, and I'm using this Huda Beauty nude makeup. Important is that since this is a day makeup, I'm just using some browns. I might sometimes also skip this. So I'm just going to be using some brown shadow. And in case, again, from my clinic, I want to go for, go out somewhere and directly I'm going from my clinic or my hospital, then I can use, on my same base, I can use some glitter. So this will act as a base. So basically I'm using this brown and little bit of this nude color. I'm just going to be placing it on my upper lid. So I have finished the same thing in my other eye also. Here the important thing is that the inner side should be the light color and the outer side should be the darker color. So it looks very subtle, as you can see. It's a very day wear eyeshadow that I have put on. Now I will be doing the next step, and that is using a liner. So I am using again the MAC black liner here, and I will be starting from the center of my eyes to the end, and again coming back again, starting point, and merging it with my center. And same thing I will be doing it on this eye. Wait for a minute to let it dry. The next step is going to be using some kajal. For the day makeup, I like to use a more brownish color than using a black. So I would just take some brown color and gently dab it on my inner lower lid. I have to put in the mascara. Again, now this is optional for the day wear. So finally, eyes are done. And we go into the next step. That is applying a bit of base on the face. So there are two ways that I
I do it. One is this is the professional makeup by Makeup Studio. That is the whole palette to do your face. The other thing is this is by MAC is a foundation. So now I'm just using this foundation because I'm doing my day makeup. And on the back of my hand, I'll take a drop or so, and then I'll gently dab it on the places that I need to conceal. So since I have issue with my dark eyes circles, so I'm going to be putting it more over there, and then I'll gently put it over my face, and then with this beauty blender I'm going to be blending it all over. Just I'm going to be taking this loose powder. Again, it is by Huda Beauty. It's by Huda Beauty. And this is the palette of the brushes that we need to use, different brushes. I'm going to be taking this brush, this brush, and gently taking in the powder and spreading it all over my face. So this will help the makeup to set in, and then it will stay the whole day. The next step is going to be the blush on. Again, it's an optional thing. The blush on needs to be put on the cheek, so we can just do like this and then, or just smile. When the blush on is applied, gently just dab it, not much. Also, I'm going to be using the highlighter now, since I'm almost done. So before, the last step is again the lips. So before I do the lips, I'll be using a bit of highlighter to give that glow. So the highlighter is used on the places where the light falls in, like the tip of the nose, the forehead a bit, and just area above you, above the blush on. And maybe a bit on the cheeks, maybe a bit on the chin. Sorry, not cheeks, but chin. Done. So now is the lipstick. So I've got two shades. So I've got two shades today here. This is by Shimmer, and this is a very local thing that I liked a lot, Smashbox. And this is a nude shade, and I love this shade. So I'm going to be using this. First, make the outline of the lips.
Oh, Umania, oh, Umania, oh, Umania,
Okay, so very
Umania, oh, Umania, oh, Umania, oh, Umania, aha, Umania, Mande Chapapunda, Femini.
I had fun making this video.
That was really nice, huh? Very
We had
interesting.
fun learning.
I had amazing fun making this video.
Nikhil is going to give the tips to his wife now.
Arey, no, I want to share one photo of mine. I'm feeling a little girly and left out. So ye dekho, this is what I do. Guys build biceps, but you all are building the world. So I think you all are doing a better job, है ना? हम लोग तो बस ऐसे selfie लेके we feel good, but I think you all are balancing everything so well. Ma'am, hats off for having this session, Ragini ma'am. This was
Archana, how do
really,
you
really
manage this with onset of presbyopia? How do you put the liner? I always have problems.
Still lucky. I'm still lucky. I'm still lucky, ma'am. Not yet. Because I'm myopic around 0.75, so the near vision is still not that a problem for me.
I struggle with the liner.
Archana, one quick question for you. Makeup or 15 minutes more sleep?
Makeup or sleep? Dono ma'am, dono chahiye.
Or 15 minutes of extra sleep?
So makeup is just about a 2 minutes thing to me, and sleep is very important because sleep is beauty.
So 2 minutes extra sleep.
Ma'am, if you don't sleep, you'll need the makeup to hide all these dark circles.
Well said. That was very interesting. And I think you taught us quite a bit.
Yes, ma'am.
And I think with this, if there are no other additions, we should draw the session to a close because
I would like to say a few lines what I've written down in my book. It's for the whole session that we had today.
Please do.
Yeah. So this is a poetry that I penned down. It's called ख्वाहिश. It says, वो बातें वो मुलाकातें अक्सर याद आएगी. ये बातें ये मुलाकातें अक्सर याद आएगी. वो शिकायतें वो शरारतें अक्सर याद आएगी. वो लम्हे वो पल जो हम रोक पाते साथ आप सबके हमेशा रह जाते. इतनी खुशियां हमने आपसे समेटी दुखों का हिसाब भूल गए. इतनी खुशियां हमने आपसे समेटी दुखों का हिसाब रखना भूल गए. परेशानियां अगर भूले से आ भी जाती तो आप उन्हें कोसों दूर छोड़ आए. मायूसी और तन्हाई, which is so true right now. मायूसी और तन्हाई अब सिर्फ किताबों में मिल पाते. आप सबके होते क्या वो हमें ढूंढ पाते. आपसे बिछड़ना मंजूर नहीं पर जाना कायम है. Talking of anyone from this platform, आपसे बिछड़ना मंजूर नहीं पर जाना कायम है. हमारी याद आपके दिल में रहे बस यही छोटी सी ख्वाहिश है. हमारी याद आपके दिल में रहे बस यही छोटी सी ख्वाहिश है. Thank you.
Sujata, everybody will dream of you all today here.
Right, my husband is waiting for me to go back.
No. Don't expect your husband to dream.
He'll get nightmares.
Yes, so dreams are
All your
fulfilled,
boyfriends
madam.
will dream. Nikhil,
Ma'am, I think
you're
it's
going
a
to
wrap.
have enemies today because you are in the midst of all the.
I was the lucky one. Yes,
Yes,
absolutely.
you're the
Thanks
Kanhaiya
to
Gopis.
my two mothers here, I was the lucky one, the chosen
Yes.
one. I think the take-home message for everybody is always keep your head, your heels, and your standards high, isn't it?
Yes.
Can we take one picture before we go?
Please do
No,
a selfie. Yeah,
one
sure,
message
sure.
I want to give.
And they want a
With
picture, so they give a good smile.
With all due credit to you, Nikhil, and all
मैं
the
अपना
males.
कैप पहनता हूँ. Okay, मेरा crowd.
Nikhil, are you taking the selfie?
Yes, I am. I am.
Before everybody, Nikhil, 1 minute. Before everybody disperses, there's one message with due credit and credibility to you and all the males. I feel women are dasbhuja. They can handle a whole lot more than you men can. And on this note, I'm going to stop.
Hello,
Okay,
sorry,
I'm
ready for a
I'm
selfie?
going to wear my headgear.
Please, wear it.
Yes, I'll start doing
Ragini ma'am has her.
That's it. I'm going to do a belly
Ma'am
dance.
needs nothing. She has a halo always. Ma'am doesn't need anything.
Invisible crowd.
Hello. 1, 2, 3. Biggest smiles. Cheers. Got it. It's going to go up now. Thank you so much. Thank you, ma'am. Thank you, all the ladies.
Thank you, everyone.
Thank you so
Thank you.
much.
Thank you, everyone. Excellent program.
Thank you, everybody.
Thank you, everybody. Thank you so much. Thank you,
Good night.
Karobi ma'am and Nikhil, for making this session such fun and bringing life to the session. And I think that our women have won the crowns, but getting this from their home page, I think that is one more crown to the crowns that they have won, and we are so proud of them. Keep flying higher and be always happy.
Ragini, hats off to you after
Thank you,
a long
Ragini.
trying day.
Thank
You're
you.
still looking fresh and happy.
Yeah.
Thank you, Ragini. Thank you, Karobi.
Thank you, ma'am.
Thank you, Manjali.
Thank you,
Thank you, ma'am. Thank you, everybody.
एक मिनिट
We'll have to retake the picture.
थँक्यू सगळ्यांना पाहत होतो पण आमचा बाकीचा दुसरा तो सेक्शन चालू होता त्या रेटिनाचा त्याच्यामुळे तो आता तुमच्या आधी 5 मिनिटं संपलाय तर तुमच्या
Ma'am, we'll
सगळ्यांना
retake the
पाहून
picture, ma'am.
तुमच्या इकडे एका डोळ्याने बघत होतो उजव्या डोळ्याने इकडे डाव्या डोळ्याने तिकडे त्यामुळे तुम्ही सगळेजण तुमच्या ज्या सक्सेस आहे तुमच्या सगळ्यांचं मनापासनं अभिनंदन आय एम प्राऊड ऑफ यू मला तुमच्या सगळ्यांचा अभिमान आहे
आम्हाला पण आहे तुमची अभिमान सर
मला पण आहे तुमचे अभिमान सर सुंदर मराठी बोलल्याबद्दल तुझं अभिनंदन
सर तुमचा एक डोळा तिथे, एक डोळा इथे होता, एक कान पण तिथे होतं, एक कान पण इथे होतं.
हो, दोन्ही दोन्ही इकडचा भाग तुझ्याकडे, इकडचा भाग इकडे असं होतं.
कान पण तसंच होतं.
नाही, याच्यामध्ये सुजाता, अर्चना, मंजिरी, रजनी, रेश्मा, गीतांजली, मंजरी दोघी तर आहे दिसतातच मला. आणि फक्त एकटाच हा होता निखिल नाश्ता है ना. गोपीमध्ये एकटाच कृष्ण आहे असं यांनी सांगितलं, विनोद गोयलने रागेने सांगितलं मला, ते पण ऐकलं.
सर बरं झालं तुम्ही आलात आता.
हो सर, तुम्ही बरं झालं
कसं
आलात.
तुम्ही एवढं सगळं करताय तर मी कसं येणार नाही होत. संपत नव्हतं तिकडे, मी चेड करत होतो ना सेशन. रागिनी हुशार आहे, शेवटच्या सेशनला मला ठेवून दिलं. तिला वाटत होतं मी इकडे येऊ नये, माहितीये का तुम्हाला. तुमची माझी भेट होऊ नये असं तिला वाटत होतं. काय सांगा आता मी असतो तरी तू चांगली बोलली असतीस, काही प्रश्नच नाही, बोलायला काय लागतं.
नाही सर तुम्ही आलात, एकदम जान आली इथे.
मला आनंद वाटला तुमच्या सगळ्यांना भेटून, एकदम खुश झालो.
एक गाणं म्हणू आपल्यासाठी, एक गाणं म्हणू आपल्यासाठी.
मन मन मन
आप आए बहार
थँक्यू Karobi. Thank
And
you.
all the best for the Vice President's post, sir. We are all with you, sir.
Yes.
चांगलं वाटलं मला.
We all are with you.
तुमच्या सगळ्यासाठी एक म्हणतो, चंदन सा बदन चंचल धीरे से तेरा ये मुस्काना.
अरे तू
He loves this song. He loves and
So you sing so beautifully.
This is his favorite song. He put when he finished the 100th surgery because he likes it, and then he shouldn't get tired and do some more. So I think he sang this song, which is his favorite for his daughters, for his sister.
ऐसा है कि ऐसा है, रागिनी डायरेक्टली बोल दिया डॉटर एंड सिस्टर्स, वो सब
public photo
सर म्हणा ना पूर्ण गाणी.
नाही नाही, पूर्ण मला येत नाही, पण मला हे गाणं आवडतं. मी जेव्हा विद्यार्थी होतो तेव्हा मी म्हटलं होतं.
एक अंतरा गा. रिअली
आपण सगळे मिळून गाऊ, चला म्हणा. चंदन साबदन
चंदन चितवन धीरे से रायु मुस्काना
दोष न देना
हो जाए अगर मैं दीवाना
इतके एकत्र गायलं सगळ्यांनी की दोष देने वाले लोग इतना कुछ.
But I didn't realize that he sang the whole paragraph, that it has meaning. कोई Pritam was saying that this session will be well attended, but jokes apart, it is not superfluous, it is not superficial. This session is all about a lot of depth, a lot of love, and a lot of respect for what these girls have done.
Nikhil, sir, here, take a picture of all together.
Yes, Nikhil.
Yes, I'm ready. So
Yeah.
ready? We'll all smile, yeah?
1 minute. Now we'll take a. Ragini कुठे आहे? Now take a picture.
चलिए, 1, 2, 3, all ready, yeah? Smile.
Smile.
Yes.
Got it. Thank you so much.
Thank you very much. Thank you. Really enjoyed.
Lovely Sunday evening, and thank you very much.
Lovely Sunday evening. Really enjoyed.
Thank you, sir. Thank you, madam.
Thank you, sir. Thank you.
Bye, everyone.
Bye, everyone.
Bye, Nikhil.
Good night.
Good night.
Thank you so much.
Good night. Thank you.